Morning, Dr. Satyan.
Health, happiness, harmony and peace. Health, happiness, harmony and peace. United in care of diabetes. United in care of diabetes. डर से मधुमेह के खुशियाँ ये गुम न हो, सेहत की बात हो, मुस्काने कम न हो, ऐसी ही सोच से आए हैं साथ हम, दिल में विश्वास है, करना है दूर गम. ग्लोबल डायबिटीज फोरम, ग्लोबल डायबिटीज फोरम.
Good morning, everybody. Thank you for joining us for this wonderful day, the day 2 of Global Diabetes Forum. We have got a battery of speakers and chairpersons who will be imparting their knowledge at this time. And over to Dr. Shikha for taking us through this session.
A phonetic good morning to everyone. Thank you, GDF, for giving me this opportunity to introduce such esteemed and accomplished chairpersons. Dr. Ashwin Mukundan, he is MBBS MD, consultant diabetologist based at Kerala. Dr. Alok Modi sir, he is MD Internal Medicine, FISH, FACP, PGDL. He is a diabetologist and clinical cardiologist based at Mumbai. Over to sir.
Ashwin sir?
Yeah.
Would you like to?
Yes, sir. Yes, sir. Very good morning to all. Happy to be here sharing the screen with the legends. And on the right note, on a bright Sunday in Kerala, I should say, we are starting with a very happy topic. The topic itself is happy, smiling kids and happy future. As the theme song of the GDF rightly reminds us of these things. We have an elegant speaker. To start with, Dr. Dhruvi Hasnani. Let me introduce her first to you. She's an MD, fellow of Royal College of Physicians, UK. She's a fellow of American College of Physicians. She has done a PG diploma in diabetes from RSSDI. She's an ISPAD fellow, pediatric diabetes consultant diabetologist in Rudraksha Institute of Medical Sciences, head of the department clinical research in RIMS Ahmedabad, treasurer in RSSDI Gujarat chapter, winner of Torrent Young Scholar Award for Diabetes, faculty for National Diabetes Educators Program, speaker at numerous international and national conferences, 10 international and 25 national publications, reviewer of Pediatric Diabetology Journal and Journal of Diabetology, investigator for clinical trials. So we have the right speaker to begin with. Yes, that's all about our first speaker, Dr. Dhruvi Hasnani. I welcome her for her first talk. I hand over the session to Dr.
Thank you, Dr. Ashwin. It was very, very humbling to have you introduce me. Thank you to Dr. Saxena sir and Dr. Raka sir for the kind invitation for the Global Diabetes Forum. It has been a wonderful day yesterday when we were discussing so many topics related to academics and research and the enthusiasm that all of us had in emphasizing on the fact that we have to come together, we have to make a difference in how we are managing people with diabetes instead of calling them diabetics. So we are starting our second day for the Global Diabetes Forum by talking about kids, by talking about pediatric diabetes, and by talking about how can we keep their faces smiling by, having an appropriate channel of management for type 1 diabetes. So with that, I'm going to start sharing my screen, and we are going to talk about clinical evaluation of type 1 diabetes in primary care setting. Well, I practice in both peripheral area of Ahmedabad, and our institute works both in the urban as well as the rural settings. So now it was a very, very meaningful of the Global Diabetes Forum to have been incorporating the primary care setting, wherein most of our people with diabetes or with any complaints are going to report to first. So let's start by talking a little bit about the epidemiology of type 1 diabetes, which is not quite evident. And Dr. Saxena sir was just highlighting the fact that previously, when we are talking on the international platforms, everybody produces their own data, and we still lack the leadership when we are talking about epidemiological or demographic data when it comes to pediatric and type 1 diabetes. And I'm very glad to say that all of us, all the faculties present here, are working in their own way for making a change to the existing system and trying to bring out some amount of data in terms of pediatric diabetes. The available data for that matter is from Sabu sir's paper, with whom I worked along with. And there is one paper from Dr. Kalra sir and Dr. A.K. Das sir, who are stating that it is 3.2 cases per 1 lakh of children. But again, these are very old data from 2015 and 2018. The latest IDF 2019 Atlas is saying that in India, if you talk about type 1 diabetes in kids and adolescents from the age of 0 to 14 per annum, the cases are somewhere between 15.9 per 1,000 kids. Now, when we are talking about type 1 diabetes in the primary care setting, the ADA and the ISPAT, both of them have their own very focused guidelines and very focused stepwise approach. The first thing is that whenever you are in a primary care setting, the available healthcare professional needs to understand how to diagnose hyperglycemia. That is the first thing, how to diagnose whether this child coming to us is having any kind of symptoms or not. And it is very, very apparent that the earlier we detect type 1 diabetes, the further we can keep that child away from complication of DKA or any kind of serious event driven by that ketoacidosis. So the first important thing is educating the healthcare professional or imparting the knowledge about diagnosing type 1 diabetes through some of the classical symptoms, but also through knowing that a pediatric person or a pediatric population coming to them might have non-classical symptoms as well, and differentiate between type 1 and non-type 1. Also being able to identify if there is a facility, a higher facility, and when and how to refer them for detection and measurement of autoantibodies, and trying to understand that it is not just a fasting PPBS, but we have to analyze this child for not just hyperglycemia, but also for growth and also for a systemized and a team counseling and an education process, which I'll be gradually talking about. Now, generally in India, when we are talking about delivering any kind of particular protocols and guidelines, most of them are focusing on secondary and tertiary care, wherein there is availability of specialists, wherein there is availability of all kinds of super specialty facilities. Now, what do we define as a primary care setting? A primary care setting is a first point of contact. They are either general practitioners, they are nurses, and they are healthcare professionals working in the primary care area of, it could be an urban center, urban area geographically, wherein the primary care person or the first contact person is a healthcare professional of a primary degree. we are trying to give a high quality primary care, providing integrated and accessible and equitable healthcare. And this is what together is the updated definition of the primary healthcare setting, along with addressing the individual's health and wellness. And this is going to be the place where the person with diabetes is repeatedly going to visit, along with the patient's family as well as the other community. So we come to the point when we talk about primary care setting, that what are the first essential components that we have to keep in mind? The first thing is insulin therapy. Then comes medical nutrition therapy along with physical activity. Then comes monitoring, of course, that you cannot do anything without insulin and monitoring. They are like the two basic pillars. The third pillar being medical nutrition therapy, and the fourth being diabetes self-management education. You have to empower the kid and the family on how to take care of the situation at home, along with psychosocial support, which of course cannot be, avoided. You cannot neglect the psychosocial part. And I'm sure all of us present here, Dr. Chawla, Dr. Saxena, even Dr. Mishra over here, Dr. Raka, will agree with me when we talk about psychosocial support being one of the mainstays. Now, when we talk about kids and when we talk about diabetes together, there are some very, very unique aspects which we have to keep in mind. We have to talk about different developmental stages. We have to talk about the family dynamics, the grandparents pampering the child, the uncles and the aunts, be the maternal side or the paternal side, coming and showing sympathy. Oh, mera bacha ye, insulin le raha hai and all. You have to target and focus on these people as well to make them understand that it is empathy that you have to show and not sympathy. You have to talk about the neurological vulnerability of the hypo and the hyperglycemia, the changes in the insulin sensitivity which will come along with the physical as well as the sexual growth, and the ability to provide self-care to these teenagers as in when they are transitioning from the parental care to taking care of themselves, and any kind of possible adverse neurocognitive effects of decay if the child is in a rebellious mode, which most of the teenagers most of the time are. Due to the nature of the clinical research in kids, we know that the recommendations are very, very less likely based on clinical trial evidence, and we have to always look upon the real world evidence depending on kind of the cultural differences that are existing all across. Now, what should be our principle and what should be our goal of care? The first goal of care is to eradicate any kind of symptom that the person or the child is having when they come to us. Prevention of any kind of acute complication, be it either hypo or diabetic ketoacidosis. We have to also talk about optimum growth and pubertal development, and we have to ensure a good psychosocial adaptation and functioning, and also prevent the long-term complications. Most of the pediatricians who are involved do not encounter long-term complication, and their focus mainly is depending on prevention of diabetic ketoacidosis or hypoglycemia. They do not focus on the prevention of long-term complications because I guess they do not see many adult type 1 coming along with complications because of uncontrolled or suboptimal control of diabetes since the childhood. So there is a simple checklist for the primary care, and the first point being education, education and education. Second thing, glycemic targets, and educating the person and the family what their targets are depending on their age, and there is always an individualized target. Insulin therapy, what kind of options are available, be it the NPH and regular acting, or be it the insulin pump. The whole spectrum of insulin therapy that is available should be at least given as an option, and the patient can choose, or you can put forward that this is the best kind of therapy according to me as the healthcare professional for you. Glucose monitoring, of course, and now there is again a whole spectrum of technology available for glucose monitoring. Nutrition, hypoglycemia, decay, individualization being a big thing when we talk about education for the primary care setting. Now, again, when we are talking about adolescents, when we are talking about kids transitioning from pediatric care to adult care and in their age category of 17 to 20, you have to talk to them about smoking, you have to talk to them about sexual health, psychology, the comorbidities and the complications that are going to come along with glycemic variability and transitioning to adult care. Now, what should one check? When we are talking about checking at primary care setting, the minimum time period or the maximum time period which you should educate the primary healthcare physician on is a visit once at least every 3 months. And the bare minimum things to be checked are height, weight, blood pressure, assessment of pubertal growth annually, calculating the growth velocity, and this is all apart from the glycemic status of the child that we are talking about. And in a well-controlled child, we all know that we have to talk about the normal growth being to the mid-parental height. Now, a very beautiful chart from the ISPAT guidelines that talks about, charting a very nice growth chart and explaining the parents about where the child is standing in terms of their physical growth. This is a very nice screening list, which I found out and very, very useful when we talk about, having a list in front of us when we are talking about screening the adolescents. Growth every quarter or at least twice a year, weight at every visit, BMI at every visit, blood pressure at least once in a year unless it is elevated. Again, it is on our discretion. Lipid profile 3 months after diagnosis of the child is 12 years or older. If it is normal, we can repeat once in every 5 years. These are the ISPAT guidelines. And again, it can be at the discretion of the healthcare professional. A1C 3 to 4 times a year, microalbuminuria, creatinine, fundus once in a year, neuropathy once in a year, the thyroid and the antibodies every second year if they are normal, TSH every year, celiac antibodies first at the time of detection, every year for the first 5 years, and then if the symptoms are indicative. Again, India lacks the data in terms of screening for celiac disease. Every child with type 1 diabetes, we know, can grow into an healthy adult. And this is an example of Mr. Teddy Ryder from Toronto. He did expire in 1990, but he is the child who received insulin way back in 1922. And this is the picture that we often see in, by the Europeans and the Americans when they are talking about the history of insulin. The minimum things that need to be done, again, we talk about minimum things because we are talking about the primary care settings, and these are the things that need to be done in context of type 1 diabetes: insulin, monitoring, educating the patient on when to regularly come for follow-up, doing these blood tests, A1C, creatinine, TSH, lipid profile, microalbumin of fundus, a foot checkup, a cardiac assessment, and checking the growth and development. Again, this is something which is repeatedly coming because the emphasis remains on this checklist. The management depends on the principle of the insulin therapy, and the dosage again depends on the age, weight, stage of puberty, duration, phase of the diabetes, state of the insulin injection sites, the nutritional intake, of course, the exercise pattern, and the daily routine of the child. Now, as healthcare professionals dealing with type 1 diabetes, we know that we are walking on a tightrope. We have to manage the hyperglycemia and the microangiopathic complication. Likewise, you also have to manage that the child should not fall into a hypoglycemic episode and the neuronal loss, the poor school performances, or any kind of seizures that are associated with the hypoglycemic event. And we are always trying to balance between these two. For the times of COVID, a very, very nice checklist that I found out for the primary care setting, a very nice list of documents, a nice list of medication and supplies, and an extra list of materials that are required for a child or a person with type 1 diabetes, for emergency preparedness, for these unprecedented times like the COVID-19. Education again plays a very important role for the primary care settings, and again they are emphasizing on the explaining the person about what diabetes is, what and how to use insulin, the life-saving skills, recognizing symptoms and signs of hypoglycemia and DKA, teaching them about the meal plan, and also teaching them about the sick day management. The best of diabetes education will fail if we are not giving an appropriate counseling and support. Every kind of counseling session has to be individualized, and depending on not just the geography and the cultural area of the person that the child is coming from, but also on the literacy, on the economic status of the family and of the community. So again, it's a lot of wheels that we are trying to fix together in the primary care setting, and it also is depending on the acute conditions other than diabetic complications, be it fever, be it the studies, be it the partying, be it the traveling, and all of this requires a holistic care. And even for the primary care setup, this holistic care plays a very, very important role, where we are involving an educator, a dietitian, a diabetic nurse, as well as the diabetologist, along with the primary care physician, who all need to come together for the betterment of the child and for the betterment of the future of this child, who will grow up to be an individual contributing to the society in terms of economic, in terms of the social endeavors that the person will bring along. So with that, I'm going to end my lecture today and invite you all to be a part of our endeavors. And thank you again to the Global Diabetes Forum, to Dr. Saxena sir and Dr. Raka sir. I hope I finished in time.
Yeah, Dr. Dhruvi. Dr. Dhruvi, that was a very crisp and a very professionally presented presentation. It was lovely. I've stolen one slide for my presentation with your kind permission. It was so nice. At the onset, let me thank Ashish Raka sir for real happy forum which is running since yesterday, full of happiness and full of josh. Really maja aa gaya. It's really very nice. I'd like to thank the organizing committee for giving me this opportunity to be with the Alight group.
Thank you, Dhruvi, for your flawless presentation.
Thank
Nice,
you,
nice, very nice.
And can we have the
we
next?
are all rooting for the harmony and the happiness that Global Diabetes Forum is talking about.
We have actually touched so many points that I think so it will be a big insight to diabetologists who are practicing and they are afraid of treating kids.
Thank you, sir. Thank you so much.
Do we take the questions right now or later after session?
No, after session.
Okay, sir. Okay.
Should I introduce the next speaker now?
Yes.
So it's an honor to introduce the next Alight speaker for today, Dr. Vijay Jaiswal. Dr. Vijay is a professor and head of Department of Advanced Pediatrics and Neonatology. He has founded the organization called SWEET, which helps children who are living with diabetes. He's also started the congenital hypothyroid screening at the Medical College at Meerut. Besides, he holds some wonderful portfolios, being an executive member of the Grow Society of India of ISPA, UPAP, and IAP of Meerut. He's also been awarded the Best Thesis Award at AIMS at 2018. Has multiple international and national publications.
I would say still stands at 2021 new inputs do not tell the same story as what.
And he has also been the secretary of IAP from 2017 to 19. So Dr. Vijay, a warm welcome to you, handing over the dais to you, and we're looking forward to listen to you. Thank you.
Thank you. Thank you. I congratulate Dr. Raka and the team Global Diabetes Forum as a whole, because you have done a tremendous job from this Herculean task, and the way you have the idea of this GDF and the topics you have selected are really wonderful. I really appreciate, and appreciation to Dr. Hasnani also. She has done a wonderful job, and we have to continue this type of thing. So without wasting any time, once again, thanks. And I'm going to share my screen. Yes, so whether my slides are visible? Just case capsule. Thank you. So before begin my talk, just a case capsule to awaken you that how we are going. So this was a real case, what I have seen. This is a child who 5-year-old referred to endocrine OPD as a recently diagnosed type 1 diabetes with HbA1c 8%, and he started on basal bolus regime, fairly controlled, but lost to follow-up usually, and you all agree with that. Now turn back after 9 months, and what happened that it presented with weight loss, increasing HbA1c. So what went wrong after a successful story on the basal bolus regime? So after taking the detailed history, it's revealed that there is history of altered bowel habits, preferred to cold water. Despite of good appetite, there was again weight loss, and all blood sugars were in haywire and were in high range. So to investigate further, HbA1c, again we have discussed that 11%. TTG, that was quite high, that is strongly positive. Thyroid profile, you can see here that FT4 is very high, and look at the TSS, that TSS is very low. So it means that the child is having two things along with type 1 diabetes, that is the celiac disease and the thyrotoxicosis. Scan was done and it shows diffuse toxic goiter. So GI endoscopy was done, and you can see in the picture that there was clumping of duodenal folds. Since labeling a child gluten sensitive and to stop lifelong wheat, it is always prudent to have tissue diagnosis. So we done the biopsy and it shows mass grade 3. That is a significant disease of the celiac. And later we started the treatment accordingly, that is gluten-free diet, along with this neomercazole, and the patient got relieved, and HbA1c now dropped down to 7.7. So with this, I'm going to start my talk that type 1 diabetes is an umbrella. And so there are so many associations of type 1 diabetes with other autoimmune disorders. So when to suspect, how to act, and how to manage effectively, I'll try to deliver on this. So the incidence is quite high, that is about 15 per 100,000 population, and prevalence is about 9.5 per 10,000 people. Type 1 diabetes often occurs in combination with several other endocrine as well as non-endocrine autoimmune disorder. Recent studies has revealed a strong clustering of type 1 diabetes and autoimmune disease in patient and their first degree relative, and well-known association with this HLA DR34, DQ and DQ8. There are so many antibodies in type 1 diabetes, the mainly that is insulin autoantibodies. Frequently it is present at the onset. GAT we frequently do, that is it is at the time of clinical presentation and may remain for a very long time. Islet cell antibody and zinc transport 8 antibodies are also there. Why I'm talking about these antibodies, that more the antibodies, that risk for associated autoimmune disorder increases much more. I'm not going to bore you with this whole presentation, but to group them together, that is type 1 diabetes antibodies, the main one, and the group of disorder, that is thyroid as well as GI mucosa, and there can be rheumatoid factors also. So autoimmune disease with type 1 diabetes, the commonest is about 15 to 30%, that is autoimmune thyroid disease, which can be hypothyroidism, that is Hashimoto's thyroiditis, as well as Graves' disease. People with type 1 are 2 to 4 times more likely to have this disease than the general population. So when to suspect? So again, when to suspect that the child along with type 1 diabetes is having thyroid disorder, that hypothyroidism, recurrent hypoglycemia with the same management, the child can have symptoms of letharginess, weight gain, cold intolerance, muscle cramp, constipation, dry skin, brittle nails, or irregular menstruation in adolescent girl. So what to do? Screening to be done at a time of diagnosis as well as at least every 2 yearly. Some say that at an annual basis. If TPO antibody is positive, this screening to be done more frequently, can be done 6 monthly or at least annually. Now coming to second that we have discussed, that is celiac disease, the gluten sensitivity, which affects about 1% to 0.5% of the total general pediatric population, but in children and adolescents with type 1 diabetes, the incidence increased. And individuals with highest risk for concomitant celiac disease are females and patients whose type 1 diabetes was diagnosed at a younger age. So it is really important to look for that. And Dr. Dhruv has already told you that when to investigate. So the first 5 years after diagnosis of type 1 diabetes. But in my case, it was wonder that I picked up that even after 11 months of diagnosis of type 1 diabetes. So this is not a landmark that only after 5 years we have to look for that. If you are suspecting that something is wrong, on that the same treatment, the child glycemia is not controlled, then probably we have to look for the another autoimmune associated disorders. So here what is going to there, that is celiac disease to be suspected if patient has chronic diarrhea or growth failure, refractory iron deficiency anemia, recurrent hypoglycemia, so can be there. There can be associated autoimmune gastritis which occur about 10% and which manifest, that is dimorphic anemia, that is iron deficiency as well as vitamin B12 deficiency anemia. So this is autoimmune gastritis diagnosed in laboratory with serum biomarkers. Now again, one more very important issue is that the child's requirement of insulin has been reduced and the child has gone through again that you have all, the child has already seen the honeymoon period, and after honeymoon period, once the child was euglycemic on this basal bolus regime, again the child is having recurrent hypoglycemia and symptomatic hypoglycemia to lieu of even a seizure or something neurological manifestation. So adrenal autoimmunity, which affects about 1 to 2% of adult with type 1 diabetes. Antibodies against 21 hydroxylase enzyme is going to be there. And how it presents that it is non-specific, fatigue, weight loss, decreased appetite. But one thing we have to really see that is there can be hyperpigmentation. So if a child of type 1 diabetes who was initially well controlled going to have symptoms of hypoglycemia recurrent symptomatically, and you have ruled out the honeymoon period, it is required to have check of cortisol level and ACTH. And the disease causes hypoglycemic episode due to glucocorticoid deficiency. Another important issue that is quite cosmetic, that is vitiligo, that is discoloration of the skin, is rare in general population, occurs in approximately 0.5 to 1% of people. Type 1 diabetes occurs in 16 to 20% of patients with vitiligo. So this is really very important, that vice versa, even a vitiligo patient, at least it will be prudent to check for blood sugar or HbA1c if the child is not growing well or he is faltering on the growth chart. Polyglandular autoimmune syndrome, that is a disparate cluster of rare, involves at least 2 endocrine glands and often other organs. So polyglandular syndrome, in which first you can see that there can be so many things, but what I am focusing, that is polyglandular syndrome type 2, which is going to have type 1 diabetes, may or may not be thyroid disorder. But to define type 2 APS, that is Addison's disease, that is cortisol deficiency, is to be masked. So again, this is a group of condition where there are so many antibodies against various endocrine and non-endocrine systems, so that can be taken care of depending upon the symptomatology. Here what we can see here, that association of autoimmune disorder, not only the endocrine part, but non-glandular autoimmune diseases can be there in type 1 diabetes children. Just I'm going to highlight the important point that when to suspect a particular disorder, association in type 1 diabetes. That is, in case of thyroiditis, there can be symptoms pertaining to decreased linear growth. Painless goiter may or may not be there. Fatigue, cold intolerance, bradycardia, weight gain, or hypoglycemia can be there. In Graves, we had discussed that is weight loss, palpitation, heat intolerance, goiter, and there can be in adult population, that is prognosis can be there. Autoimmune gastritis, which can be totally asymptomatic, we have to make the diagnosis depending upon the persistent anemia or dimorphic anemia. And of course, adrenal insufficiency, which can present hypoglycemia, cutaneous changes, that is hyperpigmentation, and so on. And there can some rare association, that is idiopathic rheumatoid arthritis, psoriasis, sarcoidosis, and scleroderma diabeticorum. Who is the most likely to have autoimmune comorbidity? So an overwhelming number of autoimmune diseases were predominantly in comorbidity in women with type 1 diabetes. And this is the study which has been published in Journal of Diabetes. Only primary sclerosing cholangitis had a significant predominance in men in type 1 diabetes. Compared with other ethnicity, white participants with type 1 diabetes were likely to have an autoimmune disease more, that is about 26%, followed by 20% in Asian group. So Asian and white patients had a higher risk for systemic rheumatic disease than Afro-Americans. So what are the take-home messages? That type 1 diabetes predispose children and adults to autoimmune disorder, which can impair glucose metabolism and interfere with insulin therapy. Regular screening for autoantibodies in patients with type 1 diabetes as well as first-degree relative is of most important for the diagnosis and therapeutic procedures of endocrine and non-endocrine immunity. Every diabetic patient should be looked for additional signs and symptoms of suspected associated autoimmune disorder on each follow-up visit. Patient with poor glycemic control, recurrent hypoglycemia, and growth failure should be further investigated for autoimmune disorder. But it doesn't translate that you are going to omit the common problems, that either the child is not injecting insulin, the very common thing. So before embarking on the thyrotoxicosis, a cause of hyperglycemia, it is always better to go step, that is, we have to take the detailed history, we have to take some extra time to talk with the family that how to have holistic approach to manage a type 1 diabetes kids. So thank you very much for your patience listening. And I am very sure that questions are always guaranteed in life. Answers are not always. Thank you so much. Yes, so I hand over to the organizer.
Yeah. Thank you, sir, for the wonderful presentation. It was really an eye-opener for many of us because a lot of things were new and a different perspective to look into a type 1 diabetes patient. I think we have finished on time. Let's see if any questions are there.
No, we'll take questions later on.
Okay, sir.
Okay. Dr. Saurabh has joined. Saurabh दादा आप कार में हो?
हाँ कार में है राका. Thank you for such a nice invite. I have to travel. It is important to reach somewhere, so the car cannot stop. I'll be taking the lecture all throughout, and Sachin is going to back me up with all the slides presentation. So Sachin, do kindly share the slide.
Okay.
Yeah. Next.
Open slideshow.
Slideshow.
Yeah, done.
Yeah. So thank you. First of all, I will thank GDF, the team of Raka, who has started such a nice symposium which is running out. And hats off to all the speakers who have till now spoke. I listened to all the speakers till now. I'm very much happy on speaking this platform. I would like to thank my guru, Dr. Rishi Shukla sir. I would like to thank all the members of your team, Raka, to just have a nice show going on since past 24 hours. You have been working very nicely, all of you. So coming back to the topic today allotted to me is insulin pump workshop and a role of family counseling for insulin pump specifically. Very near to dear my heart, touching topic basically. How can we express our feelings for the family to educate them? So this I'll be sharing my own insights, because I think so it is not data available on net how family should be counseled. It is an experience which a pump educator or a pump physician can share with all of his friends who are still not in that comfortable zone to give counseling. So my words can be a helpful tool to all my friends who are attending the conference. Next. For successful patient and physician's experience, specifically for a successful patient and physician experience, what must we have? Next. A good physician treats the disease and the great physician treats the patient who has the disease. Specifically, we have targeting a disease will have a proper value, but I think so overall control of all the symptoms are more important, and it has to be focused. Next. Next. So this was the design of the first one, and there which are applied on the wrist, and the control was very difficult. And now this is a sleek insulin pump nowadays available, which can be a part of your fashion also. Next. So the role of the physician. These are some important points. If you want, you can have a snap of this also. Insulin dose adjustment has to be checked. Basal rate testing has to be done. Bolus type guidance has to be given. Correction formula has to be used frequently. CAR factor calculation is most important. CAR calculation is one of the important things we all should learn while initiating insulin pump therapy. Avoid overcorrection and of hypers and hypos. Overcorrection means, what I will say, the bolus's distance has to be maintained within 3 hours at least, as possible as it is to be maintained. Overeating, sometimes frequent eatings, you not need to give focus. Otherwise, the whole scenario of total management may sometimes be disrupted. So you must be very much cautious in hyper treating the hypers and hypos. And pump and exercise is an important issue. When you are working, doing some stress work, you are going for any type of physical activity, there the pump has to be understood very properly. What basal rate is going on, that has to be adjusted, taught to the family properly for that child whom we are giving the care, that he is going to the school. He may perform some vigorous activities over there. So the basal rate during the school hours should be a little bit on lower side as compared to the other time when he's in the house. So the physician must see in the pump basal review, basal bolus history, and prime history. Basal review means all throughout the day what has been the basal rate, and accordingly you can take a history of what he has been doing, what type of food he was acting all throughout the day, eating all throughout the day, how was his exercise, and accordingly the basal review, when you see, you can change the basal rate till 48 times a day. That is, every 30 minutes the basal rate can be adjusted. Such a beautiful part of insulin pump therapy for all type 1 friends who come to us for treatment. Then the prime history has to be seen when the priming has been done. This will tell us the amount of consumption and holding or stacking of insulin into the pump and the cannula reservoirs. Next. Yeah, this is an important 5 principles to be remembered. You can take the snap of this slide. Every meal to bolus has to be calculated. Whatever meal you are taking, the carbohydrate value of that meal has to be calculated. The type of carbohydrate you are taking. So to choose the right bolus type is there. As we know, all the smart pumps today have dual bolus giving techniques. There is a squaring of bolus can be done. You can have a rapid acting bolus can be given within 5 minutes, and then you can square the rest of the bolus dose for an event of at least not less than 4 hours specifically. So you have to choose the right bolus type which the insulin pump has to be used. then keep 3 hours or more gap between the boluses. I already told that frequent boluses, there should be a gap of at least 3 hours, and avoid frequent correction of to avoid stacking of insulin. Then treat hypoglycemia with 15 to 20 grams of glucose. This I educate to my all the family members of that friend who comes to us, that when he is found to have hypoglycemia or he is not able to do the things, you do not have to treat with any other carbohydrate source. You have to give glucose, particularly specific 15 to 20 grams of glucose in 100 ml of water, and so that the recovery is fast and it doesn't stay in the body for long. As we know, all our type 1 friends, they have to manage each and every carbohydrate content with the return of insulin itself. So might be the correction may further be needed if you give some other complex polysaccharides or carbohydrates. Next, please. Yeah, patient to follow 5 rules of success. This have to be very nicely educated to the family caregivers. Family caregivers are those people around that child who come to in our OPD. They have to be trained very properly. So change of cannula is within 72 hours. The best recommended from the guidelines that within 72 hours the cannula should be changed for its best successful rates. Site, as I have already told in my previous lectures, M and W pattern, clockwise pattern, the cannulas have to be changed all throughout. Then SMBG should be done before every meal to correct it specifically. If you are not on automatic pump, sensor augmented pump you are not using, not the latest models, then there should be a training of at least checking pre-meal sugar levels, and accordingly the titrations can be maintained. Then exercise carb to be covered with insulin. Each and every meal you are taking, that has to be covered with insulin rather than the carb which you are taking or the carb which you are consuming before exercises. Before exercises, the consumption carb should never be just treated. Otherwise, you will land up into hypoglycemic event while doing exercises. Now, never suspend pump for more than 1 hour. What I recommend, 30 minutes to 45 minutes is more than sufficient. Now we have very smart pumps which can be worn all throughout your day. You can go for bathing, you can go for swimming, deep diving. You not need to remove the pump, specifically when it is required by you. Next. So these are some points which we have to, in a recurrent basis, make the family understand and make them understand, teach them also. It is an important part of family education about insulin pump. Now, the patient diabetes education and pump training, this is an important part which I am specifically focusing on this. This will give us a proper support, and the development of pump technology can be done at your centers also. So patient diabetes education and patient implemented by multidisciplinary team under a direction of an experienced pump expert. This has to be done. You have to have a dedicated team for your insulin pump therapy, which can be a part of your dietitian, can be who is educated to use some androids at your clinic, can be trained properly, which can be directly in coordination with all the friends who are using this therapy. Next. Yeah, must be told. What is must be told to our people? Must be told, patient must be educated on meaning of pump alarms. The pump has the automatic alarms fitted to it. So all my family members who are coming with the friend have to be educated about each and every alarms which is available over there. Then patient's family should undergo the periodic resetting skills and maximize their effectiveness. If you want to maximize the effectiveness of the insulin pump therapy, you have to coordinate and give regular meetings. Regular meetings have to be there. The education with the family and the caregivers has to be maintained very nicely. Now, patient having knowledge and technical ability to make the recommended pump settings change at home has to be experienced by the caregiver itself. As the child, if the child is approximately less than 7 years or something, then he is not able to do the things by himself. The basal rate and the bolus rate has to be managed by the medical caregiver and the familial caregiver, and specifically institutional caregivers where the child is going to study. They should also have a primary education of how to manage the glucose, glucose hyperexcursions and hypos while he is using this pump therapy. So the pump therapy particular manual I used to give, we teach the familial caregivers specifically how to manage in the odd times. So patient family should be trained very properly to handle all the emergencies, and there should be a protocol. Emergency number should be also allotted. Next, please. Must to be done. This is must to be done. The last point has to be pointed out, very necessary. School and hospitals must be supplied with an emergency number by the treating physician, because this pump therapy is not easily available all throughout the globe. So if our friend lands up into any type of emergencies in any hospital, that hospital should be provided with the number of the treating physician, so that the pump should not be deinstalled and the technology should be used at its utmost. Next, please. Now, this is a very important, very near dear to my heart. This was a research paper which I did with Dr. Rishi Shukla sir in combination with the center. This is my work which I had presented in SPAD. I had an opportunity to present my oral paper in SPAD, Hyderabad. Acceptance to insulin pump therapy increases with group installation and group education. Specifically, the work was done by whole of the team, Dr. Rishi Shukla sir, me, Manisha, Dr. Manisha, Anurag Bajpayee sir, all of them were there. Our pump educator, Meena ma'am, was there in this research. Next, please. So the aim was to compare the impact of insulin pump initiation, group installation versus individual installation. Next, please. The process was this: we had certain pre-questionnaires. These are some pre-questionnaires which we asked. Do you know the pump? Have you seen the pump? Do you think the pump is easy? These type of questionnaires were given in this meeting, where an education was given to the pump users as well as the next to the kin specifically. Next, please. And post questionnaires, after giving the proper training, we had these questions answered by them, so that we can exactly see that what was the impact of the training. So the results are like that. Next, please. So results are like that. Only one session was needed to educate the masses about insulin pump. The fear for insulin pump therapy in the peer group, fear was vanished. जो डर है वो गायब हो गया पंप के बारे में, तो वो fear चला गया. They made their peer group. They started asking the questions and doubts in themselves, and that created an immense pleasure with us. Some of WhatsApp groups have also been formed. The same way they are sharing this. So seldomly, if education is propagated in a proper way, and so the fear for insulin pump therapy will vanish, and do it yourself will come to be true. Artificial pancreas is the future of specific type 1 treatment in our part, and I think so this is a lay down stone which my research says a group installation of insulin pump is a better approach rather than individual. Next, please. In the end conclusion, the group installation of insulin pump are superior individual installations. Peer interaction helps in strengthening and learning process and smoothens the insulin pump management. Last slide, please. So in the last, I will say, नापो तो जानो, शक्कर से ज़्यादा मीठी है जिंदगी. Life is more sweeter than sugar. To know. Thank you. Over to you, Rakaji.
Dr. Saurabh, I want to thank you for the way you have presented. You have actually done something very good, that you have been traveling with some urgent work and you kept up your commitment. This, I will say, this is a very nice dedication towards your work. Thank you so much for an excellent presentation. Over to the chairpersons.
I'll just say one thing, Dr. Saurabh. I have been following you over so many conferences. The amount of passion and energy you have, and the amount of happiness you exude is worth. It's really commendable. I want to meet you sometime in person.
ये guru kripa भैया. This is a guru kripa.
I'm
that
talking.
has to be endeavored. You have to have a guru in your life.
I've been following you over so many conferences. I'm waiting for the day you become president of RSS. I'm sure things a lot. It's really wonderful. You have done phenomenal work in a very
so
tough.
If I can answer any of the questions, Raka, if you permit, the questions can be taken at this point.
Yes, definitely.
Do you have any questions?
I think so. I've tried to explain. I had to try to explain all the parts of insulin pump, which I have been trying to give education to my people who are coming to me for getting treated by this therapy. And mind you, just start prescribing for type 1 people. It has been mandatory. It has been a mandatory treatment for all type 1 friends who come to us for treatment. You have to prescribe pump at the first go. He takes or not, it is their call. But you have to preach them and tell them about insulin pump. You have to take 5 minutes of your life and give it to them. It will save their life. With this, I will I will like to end my talk. Thank you.
सौरभ दादा से क्वेश्चन कौन पूछेगा?
क्वेश्चन तुम ही पूछ सकते हो.
All the speakers have done such a wonderful job.
Saurabh, just I want to have a comment on your presentation. It was really an eye-opener to all. And from this podium, just I wanted to highlight that parent selection and your capability as a team to convince them that insulin pump is the answer for the generation on this generation type 1 diabetes management, because now SPAD and all the forum says that the closer the HbA1c near the normal is the key to success, despite of symptomatic hypoglycemia, even in children. Initially, we were a bit liberal in case of type 1 diabetes in children, that thoda sa sugar zyada rahe, kahin hypoglycemia to nahi ho jaye. But this answer is that to have a tight control on euglycemia, you have to be this insulin pump. One more thing, that counseling, unless and until, because the family is going to spend a huge amount on that. So all the alarms, what are they? So prior that to be taken. And one very good concept of Dr. Mishra is that group application. That is really going to take care of so many things, and it is going to create in multiple of your message that how we are going to take care of type 1 diabetes children.
Right, it is right.
It's going to be there. Yes.
It is right. The idea was of my Guruji, Dr. Rishi Shukla sir. We did an experiment with group installation and we got success. 12 insulin pump was installed in a go, and that is a world record specifically.
Yes, Dr. Saurabh, I am also attached to your guru, that is Dr. Shukla, myself, Dr. Anurag Vajpayee, and we have made a team of Grow Society. That is, we are going to take care of type 1 diabetes children and other problems which are going to be associated of endocrine issue in children. So this is a pan-India program, what we are going to do.
Thank you, sir. Thank you.
Thank you, sir, for your wonderful insights. I think our session is going to get concluded. We have little time left if there are any questions. Before concluding, I would like to put a word from myself. As like we were discussing type 1 diabetes, we often tend to forget that the psychological counseling is needed for the parents too. Because rather than the child, the parents are traumatized when they get to know that the child has to take insulin lifelong. We never tend to discuss that, or maybe we tend to focus on the child more and forget the parents maybe. Especially, I wanted to mention few incidents where the girl child's parents wanted to hide the fact that she has type 1 diabetes because that might affect her marriage. So it's a big thing. We need to normalize type 1. We need to put forward like maybe celebrities who has type 1. We need to get more stories out of these in social medias and mainstream media to say it's okay to get type 1. It's not their fault. Thank you.
Thank you.
Yeah, thank you all speakers and chairpersons for this wonderful deliberation and taking ahead. Nirav, let us play the theme song once again, and then we go to the other section, and Dr. Sachin Mishra will take over. Thank you.
Incoming call from Samini Sanhal.
Nirav, can you roll on the slide?
Sir, just a second.
Sachin की slide roll कर देना, please.
सचिन बड़े अलर्ट बैठे हुए हैं. सचिन तुम्हें दर्शन कराने
Good morning, sir. Pranam, sir.
Good morning, sir. It was a perfect start for the Sunday.
Correct.
Health, happiness, harmony and peace. Health, happiness, harmony and peace. United in care of diabetes. United in care of diabetes. डर से मधुमेह के खुशियाँ ये गुम न हो, सेहत की बात हो, मुस्काने कम न हो, ऐसी ही सोच से आए हैं साथ हम, दिल में विश्वास है, करना है दूरगम ग्लोबल।
Well, Dr. Sachin, it's all up to you now.
Okay, thank you, sir. First of all, yesterday when I was there at the sessions, I was saying good evening GDF, good GDF evening. Now today I am saying it is good GDF, wonderful morning today.
Wonderful.
And on this second day of GDF 2022, I just want to thank, first of all, Dr. Ashish sir and Dr. Raka sir for giving us these 2 days related to diabetes education and acknowledgements, and letting all those esteemed seniors in a very compact version and in very nice modules. So moving towards the next session, the previous one was very good. So this is a miscellaneous sessions in which we will be having many things. We will be having sessions on diabetic gastroparesis. We will be having session on non-alcoholic fatty liver disease. We will be having session on diabetes related tuberculosis and retinopathy also. And to chair these sessions, we have Dr. R.P.S. Sibia sir, who is from Patiala, and from Raipur, we have esteemed chairpersons, Dr. Lalit Nihal sir and Dr. Balakrishna sir. And I would request the esteemed chairpersons to kindly go through the sessions now and just acknowledge the speakers. Thank you, sir.
Dr. Lalit, please introduce the speakers so that we can go ahead.
Hello, good morning. Am I audible?
You are
First of all,
audible.
I would like to congratulate Global Diabetes Forum, Dr. Raka, especially for giving me this wonderful opportunity. And we have 2 very interesting topics related to gastroenterology and hepatology. And now, as we are entering the cohesive era of managing diabetes, all of us have to come together, and I would congratulate for this initiative taken by the Global Diabetes Forum. As we know that diabetic gastroparesis is most commonly a missed complication of long-term type 1 or type 2 diabetes. People do regular screening for retinopathies, nephropathies and neuropathies, but we miss the autonomic neuropathy component. And although in a proper diabetes clinic, they have tools to diagnose autonomic neuropathy, but still what is missing is the identification and diagnosis and proper management of diabetic gastroparesis, because not only it is a complication of diabetes, it also affects the glycemic control. So we definitely need to take care of it from both points of view. So for this such an important topic, we have a very eminent speaker, Dr. Dharmendra Panchal. And without taking any more time, I would request Dr. Panchal to start his deliberation.
Fine. Thank you, respected chairs, for the introduction. And again, would like to have heartily congratulations to Global Diabetes Forum and the organizer, Dr. Raka and Dr. Assis, for this wonderful meeting. And it's really being a 2 days of having a good knowledge sharing and learning platform for the all. Here would like to start my session with my again heartily greetings to both of you. I am going to speak on diabetes gastroparesis, the task which is assigned, and will include it in the terms of introduction. We'll have some discussion of epidemiology, what is the pathogenesis, how clinically we can evaluate the patient with gastroparesis, diabetic gastroparesis, what are the diagnostic modalities, how we can manage further, what the current guidelines are saying, and we'll summarize and have a take-home message. To say gastrointestinal neuropathies, particularly these are the diabetic autonomic neuropathy of gastrointestinal tract. It includes esophageal dysmotility, gastroparesis, and diabetic enteropathies, which can be small bowel dysmotility syndrome, diabetic diarrhea, or fecal incontinence. When we say diabetic gastropathies, long back in 1925, it was first reported as delayed gastric emptying by Boas, and 1958, Cassander, they coined the term gastroparesis diabeticorium. To define diabetic gastroparesis, it's a serious complication of diabetes resulting in delayed gastric emptying with associated upper GI symptom in absence of any mechanical obstruction. So this is important. Epidemiology, 1/3 of the patient with gastroparesis are having diabetes, and 20 to 50% of the diabetic population are having diabetes gastroparesis. Though less common in children, mean age of onset is 34 years. Prevalence increases with the age. It is more common in type 1 diabetes than those of type 2 diabetes. It is seen in various studies that delayed gastric emptying is found in around 27 to 65% of the patient with type 1 diabetes, and in up to 30% of the patient with type 2 diabetes. Let me say particularly uncontrolled type 2 diabetes with longer duration of more than 10 years, it is more commonly associated. Even patient with type 1 diabetes with gastroparesis, they are having profound neuropathy, more anxiety, and less reduction in the symptom score with intervention. But autoantibody prevalence in both type 1 and type 2 are not able to predict the severity of gastroparesis. It's found more common in female, where female to male ratio is 4:1. Maybe the causal effect or not known, but it can be because of progesterone effect or dimerization of neuronal nitric oxide synthase, or maybe autoimmune diseases as such are more common in female. This autonomic neuropathy complication may be more common in female. Necessity addict follow-up study has shown that this delayed gastric emptying is associated with the other complications of diabetes, particularly more with severe retinopathy and to a lesser extent with cardiovascular vagal dysfunction. It is associated with higher morbidity, increased hospitalization and emergency department and hospital visits. Let me take you back to some sort of basic physiology. We all know this anatomy of stomach. It's a vagal nerve supply, and this motor event of normal gastric emptying includes there is a contraction of the fundus, and there is a phasic contraction of antrum that we call as peristalsis, along with feedback from the nutrients in the small intestine. And this way gastric emptying occurs in 3 phases. Phase of propulsion, where there is proximal antrum contraction with duodenal contraction. Phase of emptying, where there is middle antrum contraction and duodenal relaxation, and phase of repulsion, where there will be terminal antrum contraction and duodenal contraction. And there are many chemical factors which plays a role, particularly after vagal stimulation. Cholinergic neuron nerve endings, they excite, and this will lead to the initiation of this contraction and gastric emptying mechanism along with CCK. If I say pathogenesis, it will be discussed under these headings, that is glucose gut incretin islet crosstalk, enteric neuropathies, intrinsic mechanism, various neuromuscular pathologies, drug-induced or iatrogenic diabetic gastroparesis, and some miscellaneous etiologies. We all know that whenever we have something, whenever glucose enters to the stomach, small intestine, there is release of gut hormones along with CCK, PYY, and this leads to various cascade of events, and that leads to either affects the gastric emptying. So we all know that GLP-1 and GIP, they both are insulinotropic, leads to increased insulin secretion. Along with increased insulin secretion, there is co-secretion of amylin, and GLP-1 also decreases glucagon secretion, and along with effect of CCK, PYY, it modulates the gastric emptying. Enteric neuropathy, hyperglycemia induced vagal nerve demyelination, which leads to this autonomic neuropathy. It involves both sympathetic as well as parasympathetic factors. Blunt pancreatic polypeptide response and reduced gastric emptying on vagal stimulation results because of this enteric neuropathy. Now we have gastric pacemaker known as interstitial cells of Kegel, and that the term is Kegelopathy, is the most common enteric abnormality which is found in diabetic gastroparesis. And insulin and IGF-1, these two are ICC survival factor, and deficiency of this ICC survival factor, these are detrimental to ICC, and a loss of ICC will lead to this diabetic gastroparesis. Along with that, so these are the mechanism of action, how these interstitial cells of Kegel will lead to depolarization and will lead to contraction. It is also found that loss of expression of neuronal nitric oxide synthase. To be more precise, there is post-translational modification of neuronal nitric oxide synthase, which leads to gastric neuropathy or this gastric paresis. And upregulation of HO1 by hemine increases the HCC and neuronal nitric oxide synthase, and that may normalize this delay in gastric emptying, and that's why insulin IGF-1 pathway or HO1 carbon monoxide pathway, there is a window of opportunity that this can be used to develop the therapies for this gastroparesis. Also, this gut contains this pacemaker cells and enteric stem cells. So we may target this residual stem cell or transplantation of stem cell, which may open up one of the opportunity for further exploration for the treatment of diabetic gastroparesis. There is various neuromuscular pathologies are found in a patient with diabetic gastroparesis, like abnormal connective tissue stroma, thick basal lamina around this ICC, and myocytes, and large empty nerve endings. Also, various iatrogenic or drug-induced gastroparesis can occur. Most common drugs which are used for our diabetic control event, GLP-1 receptor agonist, amylin analog, they also delays gastric emptying. On top of that, some tricyclic calcium channel blockers, progesterone, PPIs, H2 receptor agonists, interferon alpha, L-DOPA, this aluminum hydroxide, which is common in antacids, beta agonists. So various factors, various drugs, they may affect the delaying gastric emptying. Vagal injury after fundoplication for gastroesophageal reflux disease, that may also cause this iatrogenic diabetic gastroparesis. Some miscellaneous etiologies like native autoimmunity in gastric parietal cells in type 1 diabetic is found that can lead to more diabetic gastroparesis, and clogged genes due to variation in circadian rhythm may lead to this diabetic gastroparesis. When we have a patient in clinical evaluation, we should look for certain signs and symptoms, certain scoring system, gastroparesis severity we should define, and we must look for some other complications, and we should go for the management. So common signs, symptoms are nausea, vomiting, early satiety, bloating, postprandial fullness, abdominal pain. There may be weight loss or weight gain, constipation or diarrhea, and wide glycemic fluctuation are characteristically associated with diabetic gastroparesis. One of the popular scoring system is GCSI scoring system, where it is patient-reported symptoms are recorded in 3 subheadings, that is postprandial fullness or early satiety, nausea, vomiting, and bloating. So here patients are asked the questions like nausea, vomiting, retching, stomach fullness, inability to finish the normal size meal, feeling excessively full after a meal, loss of appetite, bloating, visually abnormal abdomen becoming large, and patient is asked to scale it from 0 to 5, where 0 is none and 5 is very severe. But one of the major drawbacks is it doesn't measure the abdominal pain, which is commonly associated. And you can grade between grade 1 to 3, where grade 1 being the mild intermittent symptoms, which are usually controlled by diet modification and avoidance of exacerbating agent. Grade 2 is a moderate severe symptom, but no weight loss. It requires prokinetic drugs plus antiemetic agent. Grade 3 is a refractory to the medication. Patient is not able to maintain oral nutrition, frequent emergency room visits. These are the patients you may have to go for surgical therapy. Complications, it can lead to esophagitis, tear in esophagus, which is known as Mallory-Weiss syndrome. Malnutrition, volume depletion can lead to acute renal failure, electrolyte abnormality, and some hyperglycemic emergencies may occur because of this, like DK or HHS. Diagnosis, apart from clinical suspicion and detailed history taking, some lab investigation, some other imaging studies can help us to look or to rule out other infections or autoimmune phenomena or other factor which can lead to gastroparesis. We may go for some lab studies like CBC, liver function test, renal function test, ESR, TSH, anti-nuclear antibody. But gold standard for diagnosis of gastroparesis is gastric emptying scintigraphy, where radio label solid meal is given to the patient and gastric empty is considered delayed if there is more than 60% retention at 2 hours and 10% retention at 4 hours. So this is the gold standard for diagnosis of gastric emptying. MRI with gadolinium contrast can be helpful, but again, expensive and lack of availability is the issue. SPECT, again, with which IV 99 technetium percentage is given, which accumulates in gastric wall, not in the lumen. And with the computerized parameter and calculation, the regional volume accommodation and intragastric distribution is calculated. But again, drawback is a large dose of radiation and unavailability. One of the simple, non-invasive, easy to perform without radiation exposure test is GEBT, that is gastric emptying breath test, where stable isotope of 13 carbon, maybe carbon octonic or carbon spirulina plantasis, is given, and the rate of gastric emptying of this 13 carbon substrate incorporated in a solid meal is reflected by the breath excretion of 13 carbon labeled CO2. One more modality is wireless motility capsules, again approved by US FDA in terms of smart pill, where gastric time is defined as the time from the capsule ingestion and to rise of the pH from gastric baseline to 4 unit of pH. And normal emptying should occur within 5 hours. So these are the various modality. There is also electrogastrography, where subcutaneous electrodes are planted on longitudinal axis of the stomach, and again, like ECG, EEG, the recording of contraction is measured. Healthy control produces this recording that exhibit uniform waveforms of 3 cycles per minute, which increase in amplitude after ingestion of a meal. But again, validation for diagnosis of gastroparesis is still not there. There is a vast list of differential diagnoses. So gastric paresis or diabetic gastric paresis should be a diagnosis of exclusion. Ye nahi hai, ye nahi hai, ye nahi hai. That's why it is there. So we must be careful when we label for diabetic gastroparesis. Management, most important and most neglected is nutritional management, lifestyle modification, proper glycemia management, and if required, pharmacotherapy for gastroparesis should be considered. Various studies of nutritional management, let me say you, this diabetic gastroparesis is more for solid and less for liquid. So you may opt for this semi-liquid diet, which may give patient helpful, or small frequent size of meals, or considering the portion control, which is as usual one of the nutritional pillar for management of diabetes. Even having less fat meal, or avoiding food that lower the esophageal sphincter pressures. So avoiding caffeine, alcohol, tobacco, stress, avoiding chewing gum. So this sort of lifestyle modifications or nutritional habits can improve mild to even moderate gastroparesis symptoms. Pharmacotherapy, if we consider, various agents are available, still not a single agent which is 100% effective to relieve all the symptoms. So as per symptomatic treatment should be considered. Various prokinetic like metoclopramide, domperidone, erythromycin, cisapride, bithanicol, tegaserod, 5-HT3 receptor antagonist, ondansetron or dolutegravir. Antihistamines have been tried, which are routinely used for this motion sickness. Patient might get benefit from low-dose tricyclic antidepressant even. Drugs which are in pipeline like morphine agonist, again under investigation. Ghrelin agonist, here would like to take a name of this relomorelin. Fortunately, we have been a part of one of the trial with relomorelin for the diabetic gastroparesis, but again, unfortunately, it was stopped globally because of COVID pandemic. Here, it's a...
Dharmen bhai, please, last 1 minute.
Yes, we'll finish, don't worry. So 100-fold, it has a greater potency to reverse the gastric ileus given in the dose of 100 microgram per day. Newer 5-HT4 agonists are also there. Some other surgical therapy, pyroroplasty or intrapyloric botulinum injection, gastrectomy, gastric electrical stimulation. Again, this is one of the methods. US FDA has approved only high frequency gastric electric stimulation for this. Some complementary therapies are there. So guideline says identify the cause, diagnosis, rule out all other factors, exclude it, focus on nutritional and enteric feeding. That should be the first line of management. Pharmacological management, domperidone is one of the preferable, most responsive. If refractory, go for surgical management. This is the last slide and would just like to have everything into it. So anything is not there, just follow this protocol. You will be able to give benefit to your patient with diabetic gastroparesis. And with this, would like to conclude. Thank you. Again, thank you, Dr. Raka, Dr. Ashish, for this opportunity. If we have any questions, queries, or comments, these are more than welcome. Thank you.
Yeah. We need to move on. Question answers will be at last. Niro, please share. Yeah. Lalit sir, please unmute.
Okay, yeah. Can you hear me now?
Yeah.
Okay. As due to lack of time, we had to forego the question answer session on gastroparesis, or maybe we can take it later. I would like to introduce another topic which is extremely important. As we know, the non-alcoholic fatty liver disease prevalence is increasing exponentially, especially in urban population. As we know in Indian studies, in rural population, the prevalence is only 10%, but in some urban studies, the prevalence is going up to almost 50%. And it's not only the development of liver disease in patients with diabetes, but as we know, that fatty liver could be the precursor or the first hit in the development of diabetes. So for such an important topic, we have a very, very eminent speaker. I would like to invite Dr. K.P. Chandra to start his deliberation.
Thank you very much, dear Chairperson, Dr. Lalit. At the outset, I would like to congratulate Dr. Ashish and Dr. Raka for an excellent diabetes forum, Global Diabetes Forum webinar. And I would like to thank you all for giving me this opportunity. I hope my slides are visible.
Yes, visible, sir.
So today what we are going to talk about is a neglected diagnosis in type 2 diabetes. We all know that NAFLD is associated with insulin resistance. However, it is often neglected. We often tend, the way this session has been introduced, that we often tend to look for complications of diabetes. We do retinopathy evaluation, neuropathy evaluation, nephropathy evaluation, but we tend to miss gastrointestinal tract and complications associated with it. NAFLD, we all think that it is something which usually is present in diabetic patient and it is not of our much concern, and let the gastroenterologist deal with it. We need to understand that it is a gastrointestinal manifestation of a metabolic disease. It's not a gastrointestinal disease primary, because the pathophysiology associated in NAFLD is primarily insulin resistance that leads to accumulation of fat, which over the time progresses from NAFLD to NAS, that is non-alcoholic steatohepatitis, and later on cirrhosis. We all know that incidence is increasing and progression of the disease over 8 to 13 years, you can see this steatosis usually gets converted to fibrosis. And the main mechanism or the common link of all these things are insulin resistance. And up to 1/3 of the patients of type 2 diabetes, you will have advanced liver disease. And there are different studies which are suggesting that up to the extent of 60 to 70% of patients with type 2 diabetes will have NAFLD. And the main process of accumulation of fat is adipocyte dysfunction in the background of insulin resistance. At the one side, there is hyperinsulinemia, the other side, hyperglycemia, and in the background of environmental factor, dietary factor, sedentary lifestyle, genetic predisposition, fats gets accumulated, leading to inflammation, apoptosis, and oxidative distress, leading to NAS. And we often talk about end-stage renal disease. Let us talk about end-stage liver disease. So these are dreaded complications of diabetes, which is often neglected. I will start with trying to understand what is the relationship in between insulin resistance and NAFLD. NAFLD is strongly associated with both hepatic and adipose insulin resistance, as well as reduced whole body insulin sensitivity. In patients with NAFLD, there is often 45 to 50% reduction in glucose disposal, which is a measure of whole body insulin sensitivity. And there is impaired ability of insulin to suppress the endogenous glucose production, indicative of hepatic insulin resistance. Subjects with NAFLD also demonstrate a blunted inhibition of fatty acid oxidation. Thus, insulin resistance may be intrinsic defect in NAFLD, and that diminished insulin responsiveness at the level of adipocyte may contribute to hepatic steatosis by excessive free fatty acid flux to the liver. Let us understand how this obesity is associated with NAFLD. Body fat distribution appear to play an important role in pathogenesis of NAFLD. Excessive intra-abdominal fat, via both its strong association with insulin resistance and possibly as a source of free fatty acid, is a key determinant in pathogenesis of NAFLD. Even in lean individuals, the accumulation of fat in this depot is associated with reduced insulin sensitivity. Increased abdominal fat deposition is also associated with insulin resistance, including type 2 diabetes, impaired glucose tolerance. We all know about role of adiponectin. It is associated with insulin sensitivity, and it is negatively associated with intra-abdominal fat, meaning thereby if intra-abdominal fat is increased, insulin adiponectin level decreases, and thus insulin sensitivity decreases. Adiponectin stimulates glucose use and fatty acid oxidations in liver by activating AMP-activated protein kinase. Low level of adiponectin may play a role in pathogenesis of NAFLD by decreasing fatty acid oxidations in liver. Adiponectin level has been found to be significantly lower in subjects with NAFLD and NASH. Adiponectin level has been negatively associated with hepatic fat, and the retrospective way treatment of type 2 diabetes by pioglitazone increases the adiponectin level and is associated with decrease in hepatic fat. So insulin resistance, adiponectin level, abdominal fat, all these things coming together in the pathogenesis of deposition of fat and in liver, that is NAFLD. And thus, when we talk about NAFLD, let us understand that it is a metabolic disorder and metabolic physicians are the right people to treat it. There is also association of triglyceride. It is strongly associated with NAFLD, and this study was done in 256 subjects trying to understand the association of triglyceride with NAFLD. Different parameters. This is a population-based study. Ultrasound was done in healthy population in more than 18,000 of the subject, and prevalence of NAFLD was seen in up to 25% of the patient. And in them, the lipid parameter triglyceride to HDL ratio was independently associated with NAFLD. So these are the metabolic abnormalities that are seen with NAFLD. And insulin resistance is one of the root cause. So in our clinical practice, how to diagnose? I mean, we all are diagnosing NAFLD in our in our clinics, but we often tend to overlook it, stop overlooking it, because it is associated with grave prognosis. The background of NAFLD is type 2 diabetes, obesity, dyslipidemia, high blood pressure, and we all call metabolic syndrome. So NAFLD is one of the untalked or less important, often neglected part of the metabolic syndrome. In obese patient, up to 80% of the patient, in diabetic patients, 70 to 80% of the patient have NAFLD, and almost 50% of them progress to advanced fibrosis. See the odds ratio of diabetes and without diabetes in terms of causation of NAFLD and NASH and cirrhosis, and it is in the range of 1.76 and 2.57. Let me warn you that fatty liver disease is not a benign disease which we are used to. It is associated with increased mortality, both as an isolated steatosis and NASH. So this is a comparison of 6 separate studies and trying to understand how this hepatic steatosis is associated with mortality, and it is seen that liver-related mortality exponentially increased the fibrosis stage, and that led to increase in liver-related, cardiovascular-related, and other cause-related mortality in these patients. So with this background of NAFLD, how it is caused, why it is neglected, let us talk about what is the art of management of NAFLD at this point of time. This is a comprehensive table from different guidelines, and we are trying to understand different drug. I will be discussing about individual drug later on. Metformin has been used. I mean, there is insufficient evidence, but it improves insulin sensitivity. Vitamin E is being used. It can be considered in non-diabetic patient. Similarly, PPAR gamma agonists, pioglitazone, are indicated. Biopsy-proven NASH improvement has been seen. But there are other drugs, PUFA, pentoxifylline, they are not sufficient evidence. GLP-1 receptor agonists, evidence has come up recently. Ursodeoxycholic acid, this is then obeticholic acid, that is FXR agonist. Sufficient evidence is not about the benefits. Silymarin, statins, these are being used by us in our clinics. We'll try to understand, are there evidence for it? So when we start managing treatment of and managing patients of non-alcoholic fatty liver disease, let me tell you all that weight loss is the best and most effective way of treating NAFLD. We have seen that insulin resistance drives hepatic de novo lipogenesis in non-alcoholic fatty liver disease, and weight loss decreases intrahepatic triglyceride content by decreasing hepatic de novo lipogenesis. This is data from a trial with more than 1,000 patients, and you can see the effect of weight loss of 10% on body mass composition and metabolic characteristic. You can see the effect on insulin sensitivity. You can see the effect on LDL cholesterol, HbA1c, insulin sensitivities, glucose. So weight loss is the most effective way in decreasing fatty liver. Let us see what are the results about effect of vitamin E and metformin on fatty liver disease. This is from obese children randomized control trial, and it was seen that both metformin and vitamin E are effective in treatment of fatty liver disease in obese children based on sonographical evidence. Doses used were metformin 1 gram and 1.5 milligram. 1.5 milligram was found to be more effective, and it was also seen that vitamin E 400 international unit daily was seen to be more effective in treatment of NAFLD. Now, some common drugs that we are using in treatment of NAFLD: ursodeoxycholic acid. See the results. High dosage of ursodeoxycholic acid failed to improve the overall histology in patients with NASH in comparison to placebo. So it's a useless drug. Then there is a meta-analysis about use of thiazolidinedone. They were not very much convinced, and at least what did they say, that biopsy-proven fibrosis, there was no significant improvement in fibrosis by TGDs. There is another drug, elafibranor, that is dual PPAR alpha and delta agonist. Let me tell you, this is alpha and delta agonist, a trial, phase 3 trial with more than 1,000 patients. And here also it missed the primary endpoint in achieving NASH resolution in the patient. Then this FXR agonist, I told you, obeticholic acid. FXR is a bile acid nuclear receptor that plays an important role in lipoprotein and glucose metabolism, hepatic regeneration, and regulating hepatic inflammation. Although this drug was effective, but it could not meet the safety points, and thus it was not approved by FDA. It caused pruritus, and there was elevation in LDL cholesterol. Then let us see fenofibrate, that is also being promoted many times for the management of non-alcoholic fatty liver disease. Data was inconclusive. This meta-analysis says that data was inconclusive regarding the effect of fenofibrate on NAFLD surrogate in clinical setting. Fenofibrate treatment as a part of multifactorial approach may be useful in metabolic syndrome and type 2 diabetes. However, insulin sensitizing role may be more important than lipid loading effect of the drug. Now, let us talk about another drug. This is saroglitazole. This is dual PPAR agonist. Its mechanism of action is through alpha and gamma receptor. Activation of alpha and gamma receptors of PPAR. Through its effect on alpha receptor, it improves plasma lipid profile, increases fatty acid oxidation, increases ApoA1, HDL, decreases triglyceride, and decreases inflammation. Through its gamma activity, it improves insulin sensitivity. So it reduces triglyceride predominantly through PPAR alpha agonism, and reduces insulin resistance and controls blood sugar level by PPAR gamma. Some results: it improves glucose metabolism, improves insulin resistance. A randomized control trial, phase 2 trial in NAFLD patients with saroglitazole, the results have been promising. It was, ALT was evaluated, percentage change in liver fat content was evaluated, and percentage of patients achieving reduction in liver fat by 10% and percentage of patients achieving reduction in liver fat by 30% was seen. And over 16 weeks of treatment, significant improvement was seen. And we all know that DCGI has given approval for the treatment of NAFLD by saroglitazar in India. Now let us move to another oral anti-diabetic drugs that we have. SGLT2 inhibitor, we all know it reduces the body weight, it improves the insulin sensitivity. So SGLT2 inhibitors, a systemic review was done, 5 clinical trials were included to find out if it improves hepatic fibrosis and steatosis in non-alcoholic fatty liver disease. Different parameters were used, that FibroScan was used in dapagliflozin studies, then liver fat content through MRS was used in empagliflozin study, liver to spleen ratio was evaluated, and all these studies reported a significant decrease in alanine aminotransferase level. So the conclusion of this systemic review of 5 clinical trial was that SGLT2 inhibitor is associated with positive effect on hepatic steatosis measured by non-invasive modalities. How are this beneficial effect of SGLT2 inhibitor on NAFLD in patients of type 2 diabetes expected? Findings from both randomized trial and open label studies have also shown that SGLT2 inhibitors are able to reduce fatty liver content as assessed by different imaging technique and improve biological markers of NAFLD. Emerging data suggests a mechanism beyond reduction of hypoglycemia and body weight. So we know hypoglycemia, reduction in blood sugar, improving insulin sensitivity, and decrease in body weight are known mechanism for improving NAFLD, but there is a potential role of SGLT2 inhibitor in terms of decreasing inflammation and oxidative stress, and that is being hypothesized. Then let us talk about GLP-1 receptor agonist. So this is a meta-analysis of randomized control trial of GLP-1 receptor agonist in type 2 diabetes patients, and its effect has been seen on non-alcoholic fatty liver disease and ST2 hepatitis. Compared to placebo or reference therapy, treatment with GLP-1 receptor agonist for a median of 26 weeks was associated with significant reduction in absolute percentage of liver fat content on magnetic resonance-based spectroscopy, and the serum liver enzymes as well as greater histological resolution of NAS was seen with GLP-1 receptor agonist and most importantly liraglutide and semaglutide. This is another result from meta-analysis that once again says the analysis found significant improvement in hepatic fat content, liver biochemistry, body composition, glucose parameter, lipid parameter, insulin sensitivity, and inflammatory markers following GLP-1 receptor treatment. GLP-1 receptor agonist significantly decreases hepatic content compared to metformin or insulin-based therapy. So compared to placebo, compared to standard therapy, metformin and insulin, GLP-1 receptor agonist cause better reduction in fat content of the liver. GLP-1 receptor agonist also improved fibrosis marker, but it didn't reach the statistical significance. Now, at the end, I would like to find out a review on all anti-diabetic medications, pharmacotherapy in treatment of non-alcoholic liver disease. Let me tell you, lifestyle modification remains the mainstay of treatment of NAFLD and type 2 diabetes, because we all know the importance of reduction in body weight, reduction of body weight in terms of improving insulin sensitivity, and how lifestyle modification and exercise leads to improvement in insulin sensitivity, and that's why it translates into improvement in NAFLD and type 2 diabetes. But patients often have difficulty in achieving and sustaining adequate weight loss due to various shared pathogenic mechanisms leading to development of NAFLD and type 2 diabetes. It is thought that anti-diabetic agents are potential treatment options for management of type 2 diabetes, but we have to conclude that although weight loss is most effective, it is not sustained. TZDs, glitazars, SGLT2 inhibitors, and GLP-1 receptor agonists are anti-hyperglycemic drugs which can be used in patients of type NAFLD associated with type 2 diabetes mellitus, and they have shown to have histological improvement in non-alcoholic steatohepatitis. Thank you very much for your patient hearing. I would be happy to answer questions.
Hello. Thank you very much, Dr. Chandra, for a wonderful talk, quite comprehensively covered. I have a question if Raka, there is some time, a minute or two.
Go ahead.
So I want to know, because these are metabolic disorders and we can sustain the lifestyle modifications lifelong, but how long to continue the medications, especially in non-diabetics?
Let me tell you, this is a metabolic disorder and is going to stay throughout the life. So any treatment, lifestyle modification, weight loss, dietary modification, measures to improve insulin sensitivity has to go lifelong.
Yeah, that is
because
true,
this
that
has
I told,
to
but
this has
what
to
about
stay
the
with you.
medications? Like
Pardon,
we
sir?
have Pevens trial for vitamin E and pioglitazone. We have now saroglitazole coming up. What is the duration that we should treat with these drugs? Because all drugs will have certain side effect profiles.
I want to repeat again, the duration of treatment to see the effect has been 12 weeks to 24 weeks in different trial. But as this is a metabolic disease, this will continue throughout the life. As we treat patients of type 2 diabetes throughout, NAFLD is also a metabolic disease. It has to be treated throughout the life. That we have to understand. Unless we don't understand, we won't be able to convince our patient. This is a metabolic disease compared to type 2 diabetes. It is equal to type 2 diabetes. You have to get the treatment throughout your life.
Because these drugs are new and we don't have long-term safety data, the recommendations currently say that we need to use saroglitazole for about a year, and vitamin E and pioglitazone studies have restricted their patients, as you said, to 6 months. So I think that we need more long-term data to conclude that we can give these treatment for a longer period of time. And we usually give FibroScan significant importance in managing these patients, because that is the easily available non-invasive technique. And if you have a score of more than 8 kPa on FibroScan, these patients have a higher risk of developing severe fibrosis and cirrhosis and HCC later in life. So I would like to suggest here that all patients who are diagnosed with fatty liver on ultrasound should be subjected to FibroScan. What is your take? I would like to know the other chairperson's take on this also.
I agree. I mean, that is what I had been talking about. Our sensitivity to NAFLD is very low in our clinics. We tend to ignore it. Please be cautious. Get FibroScan done. Do the risk stratification and treat them early and adequately. Here you are treating not only NAFLD, but you are treating the whole metabolic disease. And I mean, NAFLD is within the spectrum of metabolic disease that we have been talking about. So don't underestimate it. Get FibroScan done early. Categorize patients who are in high risk, and upgrade your treatment so that NAFLD is treated adequately. I agree. Yeah, please.
A simple clinical score is available, that is NAFLD fibrosis score, and that is we need to implement in our day-to-day practice. And if you find your patient falls into F1 or F2, then you must be aggressive with periodic follow-up. So that you were asking how long to continue. That is what periodic follow-up requires, and based on that you need to take the decisions.
You know,
yeah, FIB score is there for the sake of time. I didn't include that.
Okay. Do we need to close for the?
Yeah, we need to go to the other session, please.
Okay. Thank you so much. And I would like to thank GDF and Dr. Raka for this wonderful opportunity. Thank you so much.
Yeah, Dr. Aniket Inamdar, he is a consultant at Samparan Clinic, Omega, India. He has done his MD DNB and AC NCD from Oxford, UK, a postgraduate course in endocrinology and metabolism. He has been actively into research by presenting several original research papers in international and national conferences and has been awarded several distinguishing awards. Over to Dr. Aniket for his wonderful deliberation, which we are looking forward, because this is a concept, this is a topic which we usually face in our day-to-day problems. Over to Dr. Aniket for tuberculosis in diabetic patients, how to manage.
Yeah. At the outset, let me thank Dr. Ashish and Dr. Raka for inviting me for such a great scientific extravaganza on diabetes. And thanks for inviting me for this important topic of tuberculosis in diabetes. Let me share my screen. Is my screen visible?
Yeah.
Yeah. Yeah, tuberculosis in diabetes is a very hot topic because we are living in such a part of world where tuberculosis is very common and also the diabetes. So tuberculosis is the largest infectious disease killer in the world, and the Southeast Asian region which consists of 8 low and middle income countries, including India, shares almost 44% of the world TB cases and the highest burden of TB mortality, almost 38% of the worldwide burden. So we share a burden of tuberculosis and diabetes both. The risk factor for developing tuberculosis as a diabetes has attracted its attention by projected increase and its prevalence worldwide. In 2018, it was estimated that diabetes affected 1 in 10 individuals globally, and it is projected that the number of cases of diabetes may increase by 40% in 2045. And this is the IDF data. And hence, an increase in global burden of diabetes poses a higher risk of TB spread worldwide in upcoming years. So we are in the overlap zone. China, India, Brazil, Bangladesh, and Indonesia and Russia, we have very high burden of TB. We have very high burden of diabetes also. So we are in this typical overlap zone, and we need to be more cautious because TB in diabetes is more infectious than tuberculosis in non-diabetics. As we all know that diabetes is a chronic metabolic disorder that essentially affect the function of pancreatic beta cells, resulting into the insulin resistance and chronic inflammation. Several meta-analyses show that diabetes mellitus is associated with 2 to 4-fold increased risk of active tuberculosis, even multi-drug resistant and extensively resistant tuberculosis. So how the TB and diabetes are associated with each other? Apart from the traditional risk factors such as poverty, malnutrition, overcrowding, and immunosuppression, including HIV/AIDS, diabetes mellitus itself is increasingly being recognized as an independent risk factor for tuberculosis. And TB and diabetes often both coexist. Studies have shown that 5 to 30% of the TB patients have concomitant diabetes. Diabetes and TB are separate disease, but they impact negatively each other. How? Diabetes will lead to more severe form of tuberculosis, and the tuberculosis will lead to the impaired glucose tolerance and hamper the glycemic control. Despite the fact that TB is associated with other immunosuppressive states, diabetes remains the most significant factor for TB infections at the population level. A study by Stevenson et al. Reported that diabetes increases the TB risk by 1.5 to 7.8%. And this is very, very high, especially in the Southeast Asian region. Another study, among the TB patients, the diabetes prevalence ranged from 1.9% to as high as 35% after screening. So one of the important things to remember here that every tuberculosis patient, we should screen him for diabetes too, because the prevalence we can see is as high as 35%. Again, in an American study reported that the odds ratio of multi-drug resistant tuberculosis in diabetes patients is 2.1. How the presentation of tuberculosis in diabetes is different from tuberculosis in non-diabetics. One of the other common things that we need to remember that though the type 2 diabetes is more prevalent worldwide, the risk of tuberculosis in type 1 diabetes is 3 to 5 times higher. Why? Because of poorer control, lower body weight of the patients, and younger age of the affected persons. While it is not clear whether diabetes affects the presentation of TB, some studies show that they have more lower lobe involvement than the non-diabetic patients due to the reactivation of old foci. Whereas some other studies show they do not report the lower lobe involvement. They report the lower rates of cavitations, but there are conflicting reports. TB associated with diabetes also show higher rates of hemoptysis, fever, and atypical presentations compared to the non-diabetics with tuberculosis. TB and diabetes more likely to present with pulmonary versus the extrapulmonary. Pulmonary tuberculosis is more common compared to the extrapulmonary. The cavitary tuberculosis is more common compared to the non-cavitary, and sputum smear positive TB is more common in diabetics compared to the non-diabetics. During the course of treatment, TB and diabetic patients take longer time to convert from sputum smear positive to sputum smear negative. So this is the point we need to keep in mind while managing these patients with tuberculosis and diabetes. And TB with diabetic patients more likely to present with drug-resistant and multi-drug resistant TB, which is a very high problem in countries like India. Together, the higher frequency of pulmonary tuberculosis versus the extrapulmonary tuberculosis, because as the TB with diabetes comes with more pulmonary tuberculosis, more cavitary tuberculosis, more higher chances of smear positive tuberculosis at the diagnosis and extending during the treatment, we must remember that the tuberculosis patients with diabetics are more infectious than the tuberculosis with non-diabetics. How the pathophysiological mechanisms interact the TB and diabetes together. In diabetes, as the cellular immunity is low, there are T cell helper T cells, cytokine number, and its response is low. TNF alpha, TNF beta, less increase will be there. Less interleukin 1, interleukin 6. There is macrophage dysfunction, which is commonly seen in diabetes, and reduced ciliary function, which is a very common feature in diabetes, which again predisposes to higher chances of getting tuberculosis infection. And in tuberculosis, what happens? There is increased interleukin 1, interleukin 6, TNF alpha. TB is again associated with tuberculous pancreatitis also. So there is a decreased cellular immunity. And diabetics show reduced T cell helper T1 cells. There is reduced cytokine response compared to the non-diabetics. Hyperglycemia is thought to also impair the force of expiratory expiratory burst in expelling pathogens. So more infective TB is more commonly seen in tuberculosis with diabetes compared to the non-diabetics. Again, the TB itself can cause TB pancreatitis, leading to pancreatic endocrine hyperfunction, which ultimately leads to impaired glucose tolerance or new onset of diabetes, and again will finally worsen its control. So how the TB tuberculosis infection may have latent tuberculosis or active pulmonary tuberculosis. In case of higher BMI and hyperglycemia, there is increased chance of primary infection with Mycobacterium tuberculosis, increased rate of progression to active tuberculosis, increased risk of disease severity will be there, increased spread of tuberculosis will be there, increased risk of treatment failure and death we can see in case of hyperglycemia. Triglyceride again increases chance of treatment failure. So this is the difference we can see in the tuberculosis with diabetics compared to non-diabetics. How diabetic impacts the natural history of tuberculosis. This is a very important chart and we can go through this. So this is a natural history. A Mycobacterium tuberculosis naive patient, when exposed to a pulmonary tuberculosis patient, either he may have no infection at all, he may develop latent tuberculosis infection, or he may develop directly primary tuberculosis. In case of diabetes mellitus, latent tuberculosis and primary TB is more common. Again, if has latent tuberculosis, there is a chance of reactivation in case of diabetes mellitus, whereas in non-diabetics, no TB will occur at all in patients with latent tuberculosis. Again, in case of if the patient has primary tuberculosis or reactivation of tuberculosis, he will straight away go to the treatment. And again, in the case of treatment, the patients with diabetes and tuberculosis will have higher chances of death and failure compared to the non-diabetics. If the patients are cured with tuberculosis after the 6 months or 9 months of therapy, again, in case of diabetics, they tend to have higher rates of relapse and higher rates of reinfection. So we need to keep these points of mind. So in every stage of infection, diabetes complicates the tuberculosis. In the treatment also, in the natural history also, in the reactivation of tuberculosis also. So how the clinical presentation is different, because we have seen the immunity as there is a decreased cellular immunity response. In TB tuberculosis patients with diabetes, they have higher cavities, they have a higher chance of pulmonary tuberculosis, higher rates of smear positive tuberculosis. They are more contagious than tuberculosis in non-diabetics, and we have got the higher rates of multi-drug resistance tuberculosis in diabetics also. So latent tuberculosis going into the active tuberculosis, again relapse, and there will be higher chance of treatment failure leading to death in case of tuberculosis. Whenever some diabetic person exposed to Mycobacterium tuberculosis, if he has diabetics, latent tuberculosis infection will be there. Again, in case of diabetics, reactivation will be there, leading to active tuberculosis. Stress hyperglycemia again increased due to the active tuberculosis. There are higher chance of relapse, death, and delayed culture conversion, and these all ultimately complicates the extensively drug resistance tuberculosis, MDR-TB, higher rates of treatment failure. So what is the impact of diabetes? Increased risk of disease itself, greater time to sputum culture conversion, treatment failure, higher risk will be there. Death is again very common in treatment with MDR-TB and XDR-TB. Change in the clinical picture. We have seen extrapulmonary tuberculosis is very less compared to the pulmonary tuberculosis. Lower lobe involvement is again more common in diabetics, and cavitary tuberculosis again we can see more commonly. So this is the picture where we can see the more cavitary tuberculosis in case of diabetes mellitus. Pre-diabetes itself, because of cytokine dysregulation, again predisposes to higher chance of getting infected with TB and its complication. So dyslipidemia, as we have seen in earlier charts, hyperglycemia, changes in the hormonal activity, and vitamin D deficiency also leads to more severe complications in patients with tuberculosis and type 2 diabetes mellitus. Again, healthy individuals, MTB infections, latent TB, risk of reactivation is more in case of diabetes patients. Over TB will be there. Then there is higher probability of patient delay because the patient is having both diabetes and tuberculosis. Atypical radiographic findings are more common in patients with tuberculosis and diabetes. They present with more severe signs and more severe symptoms at the time of presentation, and there are higher rates of failure and relapse and death, ultimately leading to increased risk of TB transmission in the society. Especially this is very important in countries like India, where the population is huge. We have a very high burden of tuberculosis in our country, and diabetes too. So how the management is different in tuberculosis patients with diabetes? As we all know, in the guidelines of WHO, CDC, even our Ministry of Health and Family Welfare, there is no separate guideline for tuberculosis and diabetes. But we have to keep in mind the drug interactions, because for the 6 to 9 months, the patients with tuberculosis will be on rifampicin, isoniazid, he will be on streptomycin, he will be on a lot of newer anti-tuberculosis drug in the second line. But we need to keep in mind that how these drugs interact with the anti-diabetics. Rifampicin being the key of a cocktail of anti-TB drugs, through its enzyme induction, it accelerates the metabolism of sulfonylureas and bigonides, reduces its plasma levels, and thereby leading to hyperglycemia. Isoniazid antagonizes the action of sulfonylureas and worsens its glycemic control. Theoretically saying, the dipeptidase inhibitor may cause immune paresis and possibly worsen the treatment outcomes in TB management. Thiazolidinones may be the substrate for cytochrome P450 enzymes, and which again are induced by rifampicin. So in many situations, some of the guidelines, some of the studies have shown that the insulin is a preferred agent in type 2 diabetes where there is an active tuberculosis infection. Why? The rationale being the severe TB infection, more body tissue loss, need for increased anabolism, pancreatic hypofunction, interaction between the oral antidiabetic agents and some anti-tuberculous medications, as we have just seen just now, and the possibility of associated liver disease, which would again preclude the use of oral agents. So lots of drug interactions are there with the anti-diabetics and anti-TB drugs. So we need to keep in mind, if the patient is presenting with a pre-existing diabetes on oral agents, then it is prudent to switch him to the insulin therapy because of so many factors. If he has got the severe infection, because of pancreatic hypofunction, which is commonly seen in tuberculosis patients because of tuberculosis pancreatitis, the interaction between these two types of drugs. So insulin becomes an ideal choice. If the patient has pre-existing diabetes on oral agents, we can switch him to the insulin therapy once he has been diagnosed with tuberculosis and diabetes. Diabetes again can affect the pharmacokinetics of anti-TB drugs also. Likewise, especially the rifampicin, by reducing its plasma concentrations. So like the anti-TB drugs affect the concentrations of anti-diabetic drugs too affect the plasma pharmacokinetics and pharmacodynamics of the anti-tuberculous drugs well. So there are conflicting reports about the efficacy of TB, because how the anti-diabetics can overall lower the efficacy of TB treatment. Conflicting reports are there, but there is no consensus. But consequently, the regimen of treatment of TB among diabetics and non-diabetics remains the same at this point of moment. There are no separate guidelines for tuberculosis patients with diabetics and without in non-diabetics. So first, depending on the resources and epidemiology of the community, screening for diabetes should be performed in all new TB patients with over age of 45 years, body mass index more than 25, first degree relative of diabetes, race and ethnicity, especially Southeast Asians. We must screen every new TB patients for diabetes. Second, the pyridoxine, vitamin B12 should be given to all INH patients with diabetes mellitus because of higher risk of neuropathy. And thirdly, given the diabetic patients are more likely to present with cavitations, smear positivity at diagnosis, and remain culture positive at 2 months treatment, continuation of phase of 7 months duration is again recommended for a total of 9 months therapy. But this is not still there in the guidelines. Some of the studies have shown that the diabetic patients should have more longer duration of continuation phase compared to the non-diabetics. In a retrospective study involving the TB patients in South Texas, they have found the diabetics were more likely to remain positive at the first month or a second month of a treatment. And some other studies have also shown that there is increased time for a sputum conversion. Diabetes increases the risk of failure and death, combined with death and relapse among the patients with tuberculosis. Diabetes have the odds ratio of combined outcome of failure and death at the rate of 1.69%. And again, diabetics tend to have a higher rates of relapse in tuberculosis. There is an association of vitamin D deficiency in tuberculosis. So some of the studies have shown that there is, if the patient has vitamin D deficiency, it is related to an increased risk of tuberculosis only in patients with persistent hyperglycemia. And another study in China also showed that over the study of more than 10 years, that type 2 diabetes mellitus patients have lower levels of vitamin D, which again predisposes to higher risk of getting TB. So two recent retrospective studies, especially in 2018 in Taiwan, have shown that the treatment of hyperglycemia with tuberculosis, especially with metformin, is a factor that prevents the tuberculosis in diabetes mellitus. So metformin in some studies have shown some beneficial effect, but still the guidelines, it is not there in the guidelines. A recent report suggests that the metformin acts by reducing the concentration of circulating metalloproteinases, and it is correlated with the reduced bacterial burden in tuberculosis diabetic patients treated with metformin and antibiotics. So metformin does have some positive role in the treatment of tuberculosis and diabetes also. So summing it up, I can say that being in an area of the world where the diabetes and the tuberculosis prevalence is very high, we need to screen every tuberculosis patient for diabetes. We need to identify the drug-to-drug interactions of anti-tuberculous drugs and anti-diabetic drugs. We need to screen them regularly. We need to see for the complications, as the diabetic patients with tuberculosis are more infectious than the non-diabetic patients. We should be more responsibly taking care of these patients, because being in such a crowded country, TB with diabetes again predisposes to very high risk of resistant tuberculosis and extensively drug resistance tuberculosis in the community. And at the end, I would like to emphasize the please use, because in the government setup, they are using most of the CB-NAT and TrueNAT techniques for the diagnosis of diabetes. Unfortunately, in the rural setup, still in India, in corporate culture also, we are having very less use of CB-NAT technique, which should be, and which is a very handy tool to diagnose the tuberculosis, to diagnose the resistant tuberculosis in time and treat the tuberculosis with diabetes very well. I would like to thank at the end Dr. Raka and Dr. Saxena sir for inviting me for such an important topic. Thank you for patient listening.
Thanks, Animate. You are always lively, doing so much research, our dynamic partner. Thank you. Thank you. Go ahead.
Thank you.
Ashish. Next is our Dr. Parimal Swami. Ashish, please introduce. Okay. Chairs. I'll say chairs, please introduce Dr. Parimal Swami. Dr. Parimal Swami is a good friend of me. He's my senior MD from, he's practicing at Jabalpur. He has designed so many things in patient care. He has designed and invented some manual nebulizer and asthma control cardiac center, intravenous insulin management app, and co-creator of some very indigenous apps, which are very, very fruitful. Faculty in national and international conferences, regularly contributing chapters in national updates, author of research work. And with this short brief, as we are getting late, I'll invite Dr. Parimal Swami for retinopathy lecture. Please.
Thank you. May I share my screen? Yes.
Yeah, please.
Is it visible? Is it visible, my screen?
Yes, it's visible, sir.
Okay, okay. Thank you very much. So thank you, Dr. Raka, and thank you, Dr. Ashish, for inviting me to participate in this great scientific event. Dr. Raka, special thanks to you, personal thanks to you, because it has rekindled some old memories with diabetic retinopathy, which I'll be elucidating at the end of my lecture. So friends, it is an underrated problem. It is a very, very less discussed problem amongst the physician community. Though the diabetic retinopathy is one of the most common diabetes-specific complications with an estimated global prevalence of 382 millions. And in India, 10 to 20% of diabetic patients, they suffer from diabetic retinopathy, and a significant majority of them are having vision they have got a threatened vision. So it's a big public health problem and a big stress on the medical care system of our country. And also it is a big economical, psychological, social stress on the society or at the individual level. Now, as a physician, we have to relook about the pathophysiology of diabetic retinopathy. Now, the evidence are saying that it's an inflammatory neurovascular complication with neuronal damage or dysfunction preceding the microvascular problem. So it is not a microvascular problem. It is basically a neurovascular complication having inflammation at its core. The same mechanism which are associated with the damage to the pancreatic beta cells, they also lead to the causation of diabetic retinopathy. Our current treatment success is limited, and it is often initiated far too late and after significant neurodegeneration has already occurred. And defining diabetic retinopathy simply as a microvascular complication is a misnomer because it restricts our understanding of the pathophysiological condition and as well as the potential therapeutic approaches which are already there for the prevention basically, or sometimes to ameliorate the effect of the diabetic retinopathy. Now, this is a flow diagram which shows the interaction of the genes, environment, with the presence of lifestyle factor like insulin resistance, the inflammation, which has got the roots both in the lifestyle and the genetics, and the common pathway of extracellular and intracellular fluid access, fuel access, which leads to the not only the beta cell dysfunction, target organ damage, including diabetic retinopathy. Now, when to screen as a physician, these are the simple guidelines which we all know since our PG days, that in type 1 diabetes, we should screen within the 5 years of the diagnosis. Type 2 diabetes is screened just at the time of the diagnosis, and usually every year if the patient is having the normal fundus. In pregnant diabetic women, before conception, once every trimester, and then 2 months after delivery, because all these conditions or all these phases of pregnancy are associated with the deterioration in the status of diabetic retinopathy. The screening should include basically a dilated fundus examination. That is a recommendation from the Indian Society of Ophthalmology. Our perspective, when we are sort of looking after a patient who is relatively asymptomatic or does not have the vision problem, and when he comes to us, when we should refer that patient to the ophthalmologist, again at the time of diagnosis for type 2 diabetic patient, before starting insulin, and most of the time, including myself, we forget that the patient may have the deterioration in diabetic retinopathy status, and we should refer the patient as soon as we are starting the insulin. Before pregnancy, I have already told you, Before starting pioglitazone, there is a sort of a compelling data which shows that pioglitazone may be associated with the deterioration, especially in diabetic macular edema. Before intensifying the glucose control therapy, and if not done already, patient has come to you sort of refusing the ophthalmic examination because he or she is relatively asymptomatic, then calculate the risk, which I will be telling you later, and convince the patient for the examination. Now, what are the modality through which we could detect or predict the presence of diabetic retinopathy? Number one, the gold standard is dilated eye examination or dilated fundus examination. Many of us are now having the portable fundus camera, and we could detect the presence of diabetic retinopathy in non-dilated eye without the presence of an ophthalmologist, but it needs to be confirmed by an ophthalmologist. There are various apps which can calculate the risk. Now there are artificial intelligence powered network or the fundus examination which could detect the presence of diabetic retinopathy, grade the severity of diabetic retinopathy without the help of ophthalmologist, at least initially. Then there are various mobile phone based apps which are being now developed, which basically check the fundus or can check the surrogate markers like some color vision defect which are there in the early diabetic retinopathy. And finally, for us, the clinical risk scoring tool which are there, and surprisingly very few of us use those risk scoring tool for the detection of or for the prediction of diabetic retinopathy. We are using the tool for heart, for kidney, for other problem or complication of diabetes, but not for the diabetic retinopathy. Now, as many of us are using fundus camera in our clinic with the help of an optometrist or eye technician, we should know the definition of the good quality image. The best quality image basically shows the clearly visible optic disc, clearly visible macula, and vessels which are all visible across more than 90% of the image. The image which does not show the optic disc, which does not show the macula, which shows the vessels less than the 60% of the image should be discarded. So again, we should know about the definition of the good quality image and the image which we should discard. And before we sort of give the report to the patient, we should check the quality of the fundus photograph, and only then we should give the image to the patient. If our optometrist is unable to take the image, the good quality image, then we should refer the patient to the ophthalmologist for the dilated eye examination. This is one app which is sort of becoming common throughout the world, which is called the Retina Risk. Again, it's a risk calculator based on the patient's gender, the presence of type 1 or type 2 diabetes, the duration of diabetes, and the HbA1c and blood pressure level. It will calculate the chances of sight-threatening retinopathy risk. And also it suggests the frequency of the screening or the checkup with an ophthalmologist at the individual level. It is basically an AI-powered tool, but it is available. It's not a free app, and you have to sort of pay a yearly subscription to use this app. Now, there are various automated detection of diabetic retinopathy software with the help of AI. 2 FDA-approved diabetic retinopathy detection systems are there for the non-ophthalmologist use, and some of them, as I believe, are also there in India, basically being used by the leading ophthalmological institute. So this is one approach where the early detection or the quantification of diabetic retinopathy can be done. Now, this is the severity scale of diabetic retinopathy. I'm not going into the detail, right from the normal to the mild NPDR to the moderate NPDR, where the few micro or aneurysm are seen, then severe NPDR, where the microaneurysm, hemorrhages, exudate are seen, and the PDR, where the neovascularization is also seen. So this is the whole spectrum of the diabetic retinopathy. Now, this is again the schedule for the screening by the ophthalmologist. If there is no diabetic retinopathy, type 2 diabetic patient should need or will need a checkup after 1 year or every 1 to 2 years. In NPDR, if it is mild, every year. With moderate NPDR, within 3 to 6 months, and then follow every 6 months. Severe NPDR, immediate referral to the ophthalmologist, and every 3 months follow up with the ophthalmologist. Proliferative or PDR, proliferative diabetic retinopathy, immediate and every 3 months. And if the center involving diabetes macular edema is seen, then every 1 to 2 months follow up with the ophthalmologist are required. There are few options of the treatment for diabetic retinopathy. I'm not going into the detail. If there is edema, then again, this one word is basically important, anti-VEGF, that is vascular endothelial growth factor. Anti-VEGF treatment is basically mainstay of the treatment of diabetic retinopathy. It is used both in diabetic macular edema as well as proliferative diabetic retinopathy, and sometimes even the intraocular steroids are required, and when the edema is there on the fovea or if it is threatening the vision. For the proliferative diabetic retinopathy, basically it is the anti-VEGF treatment with the help of laser treatment if there is leakage or the vascular integrity is disrupted. For the traction on the vitreous, then vitrectomy is required. Again, these details are not important for us because it is the ophthalmological domain, but we should focus on this control of the glucose, lipid, and the blood pressure. Now, there are certain myths and facts which we should address in our clinic as the primary care physician for the ophthalmological condition of the patient. Even with normal blood sugar, the patient might be having retinopathy. If there is no vision problem, even then the patient might be having retinopathy. The diabetes duration is not much. Again, the patient might be having subclinical diabetic retinopathy, and detecting subclinical diabetic retinopathy may be important in near future because we might get some therapies which will prevent the progression of diabetic retinopathy. So these are the myths which we should sort of address as a primary care physician for the ophthalmological problem of our diabetic patient. And again, the timely referral is always important. Now I'll come to the retinopathy risk score. This is a simple score, a recent score published in 2020 trial. And with the help of this, these are the variables: family history of diabetes, treatment method, HbA1c, and duration of diabetes. With increasing sort of intensity of the treatment, the dysglycemia and duration of the diabetes, the scores are given. And if the risk score is 4 or more than 4, then we should refer the patient early for the ophthalmological checkup. So it's a simple score, can be calculated with the only one investigation, that is HbA1c, which is usually now available with most of our patients, and this will sort of screen the patient. With this score of 4 or more, we could sort of apply this normogram where the disease duration, BMI, systolic blood pressure, post-meal blood glucose, HbA1c, triglyceride, renal function can be sort of graded on a point scale, and the total point can sort of predict the possibility of having diabetic retinopathy if the score is going up. Again, with no vision disturbance, patient being asymptomatic, even the diabetes duration which is not more, we should refer the patient for the ophthalmological assessment because it is important not only for the eyes but for other organs also. Now I come to the few of the drugs which can affect or which or influence the outcome of the diabetic retinopathy. We know about pioglitazone because of its propensity to sort of potentiate the fluid accumulation in the body. It is associated with macular edema. It's a big retrospective cohort study, and which shows with as compared to the no glitazone treatment, pioglitazone, and in this study even rosiglitazone was included, but the effect was similar, is associated with increasing diabetes macular edema. And when you sort of combine glitazone with insulin, then the incidence of diabetes macular edema increases significantly. So in patients who have got sort of a family history of diabetic retinopathy, any evidence of macular edema, then we should sort of avoid using pioglitazone. Again, as I have told you that it is basically the neurovascular immunological problem, not only the microvascular problem. So the neurovascular complex or the neurovascular degeneration are likely to exist before there is development of the microaneurysm. And we should sort of find out the specific approaches and therapies addressing this pathophysiology, and through this we can expect the reversal or stabilization of the diabetic retinopathy. So these are the few options: SGLT2 inhibitors, GLP-1 analog, benfotiamine, alpha-lipoic acid, fenofibrate, which was associated with the reduction, it could reduce the risk of progression of NPDR to the PDR by almost 40%, and omega-3 fatty acid, which has got the strong evidence or a strong sort of study data behind its role in the prevention in the progression of the diabetic retinopathy. Now, SGLT2 inhibitors, basically they address the pathophysiology of diabetic retinopathy. It is thought that SGLT2 activation may lead to the cellular damage, cellular swelling, and then diabetic retinopathy and all other complications. And through this effect, through the blockade of the SGLT2 could protect heart, kidney, as well as retina. And now there are some evidence about it that SGLT2 inhibitors may contribute to the prevention in the development of the preclinical diabetic retinopathy to the full-fledged diabetic retinopathy. SGLT2 might be associated with lower risk of diabetic retinopathy as compared to some other treatment, and SGLT2 treatment are associated with reduction in diabetes macular edema. Again, it was shown in human being, though in a small study, but it could sort of lead to the reduction in macular edema, which is shown here in this picture. This is the presence of fluid in the area of the macula, and after the 12 months treatment, you can see the reduction in the presence of edema in the retina of the eye of a diabetic patient. Now, the role of glycemic control in management of diabetic retinopathy. Each HbA1c reduction of 1% is associated with 35% reduction in the risk of DR, 15 to 25% reduction in the DR progression, 25% reduction in the vision-threatening diabetic retinopathy, and 15% reduction in the blindness. With this, I have made the diagram of a balance over here because the ground realities might be slightly different. Number one, that with significant medical and technological advancement, significant improvement in the treatment of type 2 diabetes, the real world progression rates are similar to the historical old clinical trials from a different time period in the progression of diabetic retinopathy. If left untreated, nearly half of all eye with severe NPDR will progress to PDR within 4 years, and many of these patients would be having loss of vision. Anti-VEGF treatment prevents deterioration in the status of diabetic retinopathy. HbA1c reduction, sudden HbA1c reduction with insulin and non-insulin treatment is associated with deterioration in status of diabetic retinopathy. The local ophthalmic treatment, basically, which is consisting of anti-VEGF therapy, may be important or may lead to the prevention of the pre-proliferative disease. Basically, the anti-VEGF treatment is reserved for the neovascularization, but even before that, it could sort of act to prevent the deterioration in the diabetic retinopathy. Again, short-term deterioration may potentiate, but long-term glycemic control, as I have shown you in the previous slide, may be associated with better outcome. And as physician, we should strive for legacy effect in our diabetic patient also, legacy effect for heart, legacy effect for kidneys, and legacy effect for the retina of the patient. Now, this is the last slide, and I have told you earlier that Dr. Raka has rekindled some old memory. Way back in 1988, my PG thesis was treadmill stress testing in type 2 diabetes, and we could find out that the treadmill stress test was positive, and it was very strongly correlated with the presence of diabetic retinopathy. And we presented that paper in the annual API. We got the best paper award, and that paper was again presented in the IDF conference in, I think, 1990. So the diabetic retinopathy is an opportunity to prevent the mortality in diabetes. Diabetic retinopathy is a powerful and independent risk factor for subclinical cardiovascular disease. The presence of diabetic retinopathy confers the higher risk than the conventional factors like LDL cholesterol, blood pressure, or HbA1c for the presence of subclinical coronary artery disease. There is a clear relationship between the presence and degree of diabetic retinopathy and coronary stenosis. The presence and degree of diabetic retinopathy should be considered a better tool for identifying type 2 diabetic patient at the risk of cardiovascular disease than the other traditional risk factor. And the presence of moderate to severe degree of diabetic retinopathy represents a good target population for the cost-effective cardiovascular screening. So friends, to take home for physician is that we should insist on fundus examination if it is already not done. We should use clinical scoring to convince the patient. We should educate and inform the patient and every opportunity about the early treatment of diabetic retinopathy. And if the diabetic retinopathy is moderately severe, then we should proactively screen and treat the kidneys and heart so that we can prevent the mortality. So thank you very much for a patient hearing. And if there are any questions, I'll try to answer them. Thank you again, Raka and Dr. Ashish.
Well, thank you, Dr. Piramal. You have highlighted certain very important points, especially the role of SGLT2 also, which has come into treatment of diabetic retinopathy and other things. It is actually an eye-opening for most of us because the retina is almost ignored in a diabetic patient. So inducting a retina scan will always be helpful. Thank you, sir. I close this session and I hand the next session over to Dr. Hina Goswami. And Hira, can you play the slide of Dr. Hina, please?
Thank you for the opportunity, Dr. Raka sir, Dr. Ashish sir. I'm Dr. Hina Goswami from Jamnagar. I'm going to present the chairperson of this session of Extra Miles of Happiness, today. So first I'll introduce Dr. Gurinder Mohan, MBBS MD. He's a professor and head of department of GMC Amritsar. Next doctor on our list is Dr. Shefali Karkhanis, a diabetologist from Mumbai, Thane. She has an experience of more than 12 years in the field. Next in the list is Dr. Kalyan Sen Gupta from Raipur. He's a consultant physician at Sai Kalyan Hospital, Raipur. So over to you, chairpersons. Over to you, chairpersons. Dr.
Gurinder, please introduce Dr. Amit, please.
Yeah.
Or Dr. Shefali, anybody, please.
Yeah. Thank you, Dr. Ashish. Thank you, Dr. Raka. This is indeed a wonderful event. I've been hearing as a delegate as well, and it is really wonderful. It's a pleasure to invite Dr. Amit Gupta for the next session. He is a director for Center for Diabetes Care in Greater Noida, has membership of the advisory group. He has numerous awards to his credit. He is won the Times of India Health Icon Award of 2021 and Excellence Award in Diabetes in 2021 as well. He is an investigator. He is a young scientist. He is a great reviewer, and I welcome sir.
Thank you, Dr. Shefali, for the kind introduction, and I'd like to congratulate Dr. Raka and Dr. Ashish for giving me this opportunity. And I think this session is very well defined as extra mile for happiness, and I take pleasure to initiate this session by sharing my screen. Just give me a moment. Just a second. I hope my screen is visible to all of you. So today I have given the task by Dr. Raka and Dr. Ashish to discuss something about meditation and its role in diabetes. So this is going to be a very brief presentation, and I would like to give you an insight that what is meditation and how it may help people living with diabetes or also the caregivers of the people living with diabetes. So let's begin with asking the question, why do people meditate? There may be many reasons for meditation, and one of the few common reasons that have been described are that somebody may like to get over an emotional crisis or a personal loss. Sometimes we would like to meditate to get a clarity, calmness, and focus to deal with some overwhelming stress at the work, in relationship, or in the family. Now, there is enough literature to support that the meditation can also be a tool to manage illnesses like diabetes, hypertension, and cardiovascular diseases. And there may be an ultimate goal, and it may be to connect yourself with the higher self. So there may be many reasons to meditate. And one of the reasons is definitely nowadays is to manage certain chronic diseases. So what the question is, what exactly is a meditation? What actually is meditation? And can meditation really help manage people living with diabetes? So what is meditation? So Gautam Buddha, we know that one of the first things which we see, we always see the Gautam Buddhas sitting in a meditative pose, even sleeping in a meditative pose, and all of us have his pictures around us. And whenever we think of him, the meditation is first thing that comes to our mind. So Gautam Buddha described meditation as we are what we think, all that we are arises with our thoughts, and be the witness of your thoughts. This is what Gautam Buddha said, and I think it is very, very right if you experience the meditation itself. Gurudev Sri Ravi Shankar, who is leading the task of meditation all across the world, he himself defines the meditation as the delicate art of doing nothing and letting go of all the efforts to relax into your true nature, which is love, joy, and peace. At the same time, it is important to consider the definition which has been proposed by the Walsh and Sapiro. And this is a well-accepted definition in clinical psychology. And the meditation refers to a family of self-regulation practices that focus on training attention and awareness in order to bring mental processes under greater voluntary control and thereby foster general mental well-being and development and those specific capacities such as calm, clarity, and the concentration. So this is what the meditation is. I am thankful for this slide to Dr. Sanjay Kalavasar and Dr. Gagan Priya because this has been taken from a publication, and this publication talks about the benefit of meditation in people with diabetes. And you can see that at the center, there is a holistic diabetes care, and it has three components. One is the social component, biological component, the psychological component. The social component has healthier interpersonal relationships, stronger physician-patient relationship, greater productivity, reduced loss of work days, less perception of disease stigma, while biological component has weight reduction, improved glycemic control, BP reduction, reduced heart rate variability, greater adherence to the treatment, and psychological component has reduction in psychological stress, anxiety, depression, better acceptance of the disease, reduction in the diabetes distress, more positive coping skills, greater adherence to therapy and the lifestyle, greater self-esteem and self-reliance, and less substance abuse. So this is a holistic model of the diabetes care, and there is a lot of scope for practices like meditation and pranayama and yoga in management of the diabetes. So what are the points? How does the meditation help to manage type 2 diabetes? It improves self-awareness. It allows you to press pause on the activity in the mind and life situations. You develop a sense of well-being. The awareness from the practice becomes a tool for behavior modification. The practitioners tend to make better life choices. They eat healthier diet. They engage less and less in habits that are self-harming in managing health conditions like diabetes. They continue making life choices that support the feeling of lightness and well-being. And for example, they may choose a bowl of salad over a high carbohydrate burger, or start walking up the stairs instead of taking the elevator. Just a second, I would like to, there is a lot of noise coming from my side. Let me just take care of that. So this is how the meditation can help to manage people with type 2 diabetes. And we will see what is the evidence and how does it happen. We know that there is a stress response, and the chronic stress has been linked to higher risk of diseases like heart disease, diabetes, stroke, as well as angina. Hormones and other mediators of stress like cortisol, corticotropin, blood lactate, ACTH, and other elements like plasma MDA, there have been linked to blood pressure, blood sugar, and they can lead to increase in the heart rate. There are many studies. When I searched the internet, I could find more than 52,000 studies which talks about the role of meditation in chronic diseases, and thousands of them have been in diabetes. And the studies suggest a regular practice of medicine can moderate physiological response to stress, lower the diabetes markers like oxidative stress, improve glycemic control or reduce blood glucose levels. And this in turn can reduce the risk of microvascular complication, reducing the risk factors for cardiovascular disease in patients with type 2 diabetes. And there are studies which show that meditation is linked to reduction in biochemical markers of stress like cortisol, corticotropin, blood lactate, ACTH, and the plasma MDA. At a physical level, the meditation improves cellular metabolism. There have been studies which shows that the regular practitioners of meditation and the SKY practice, that is the Sudarshan Kriya Yoga, improves multiple physiological indicators of insulin resistance like higher glucose tolerance and insulin sensitivity. This is a slide where you can see that what happens when in a parasympathetic state, in a neutral state, and in a sympathetic state. The sympathetic state is a state of the stress. And you see in the brain, there is a reduction in the alpha waves, there are more beta waves, reduction in mental focus and cognition, increased activity of the limbic system, impaired memory, and you will find that there is a decreased cardiorespiratory synchronization, increase in heart rate, increase in respiratory rate, and the blood pressure. On the contrary, the blue side, you can see the parasympathetic state, which you achieve in a state of meditation. You will find that there is an increase in alpha waves, there is a decrease in beta waves, increased mental focus, cognition, reduced activity of the limbic system, enhanced memory. There is a homeostatic state which is achieved, and there is a cardiorespiratory synchronization which is 1:4, and there is a decreased heart rate, there is a decreased respiratory rate, and there is a decrease in the blood pressure. So you can clearly see the impact of meditation on the state of the cardiovascular system as well as the nervous system. We all talk about the oxidative stress, and there are researches that show that yoga and meditation practices can significantly reduce oxidative stress in patients with type 2 diabetes. And not only in type 2 diabetes, it is also true for the type 1 diabetes also. And oxidative stress is something, and there is an imbalance between free radical and antioxidants in the body. And it is linked to insulin resistance, diabetes, neuropathy, as well as the other microvascular complications. The practitioners of the meditation and SKY has also shown increased level of antioxidant enzymes like glutathione, catalase, and the superoxide dismutase. We know that the sleep may be disturbed in patients with diabetes because of the multiple reasons. They may have frequent urge to urinate at night. They may also be having a concomitant issue of sleep apnea. And in some cases, they may also be having a restless leg syndrome, which may not allow the patient to sleep. And we also know that the lack of sleep can again trigger the stress response mechanisms. And it has been shown that the quality of rest that your body receives from a daily 20 minutes of meditation practice is much deeper. And according to research, regular meditation reduces the need for even long hours of sleep to get sufficient rest. And this is a very beautiful picture you can see, and almost everyone of us has seen that sleeping Buddha. But you can see the calmness on the face. You can see the meditative posture that still exists in the sleep of meditating Buddha. This is a very, very important position statement by the American Heart Association. And this statement is about the meditation in the cardiovascular risk reduction. And this is a position paper. And I am just giving you the summary of the findings and suggestions on the meditation and the cardiovascular risk reduction. So AHA says that studies of meditation suggest a possible benefit on cardiovascular risk. Although the overall quality and in some cases quantity of study data is modest. So more data is required, but there is no dearth of data that it is beneficial. The mainstay for primary and secondary prevention of the CVD is ACC-AHA guideline directive interventions, but AHA also state that the meditation may be considered as an adjunct to guideline-directed CV risk reduction by those interested in this lifestyle modification, with the understanding that the such benefits of intervention remain to be better established, but it says better established. So we can always do more research and prove that this is something which is in line with physiology and pathology. Again, this is the paper I was talking about. This paper is by our own Dr. Sanjay Kalra, and he received an award yesterday at this forum also, and her co-author Dr. Gagan Priya also. So they talk about the mind-body interactions and the mindfulness meditation in diabetes. So what they found out in a research paper, they analyzed the data, and they looked into multiple studies. And what they found is that the mindful meditation-based strategies are
I get the opportunity to
practice. They do not encourage. Moreover, many individuals may not be able to engage in moderate to vigorous physical activity. This may be due to physical limitations such as osteoarthritis, morbid obesity, CV or respiratory disease. They found that meditation-based therapies may offer immediate positive benefits in such individuals. And they also conclude that it may also help improve self-care behavior, self-reliance, and self-control. We know that diabetes is a 24/7 disease, and it requires a 24/7 attention to manage it. So anybody who is equipped with a self-care behavior, self-reliance, self-control is likely to achieve a better HbA1c control and better management of the better reduction of the complications. So this would ultimately result in better quality of life, and therefore the role of mindful meditation needs to be evaluated further in well-conducted studies. And I think GDF itself can take up these products, and we can work together to generate more data. There are now guidelines how to do such studies. This is also from the Dr. Mohan's center, and he gives 30 pointers on why mindful meditation can be an answer to diabetes distress. So I would just like to summarize that. We know that depression is a very common finding in people with diabetes, and mental health needs a lot of attention. Diabetes distress, we all know, comes with the diagnosis of the diabetes. It is something which is not depression, but it is a mental state that causes emotional reactions to the diagnosis, threat of complications, relentless demand of the self-management, and unsupportive social structure like stigma-associated discrimination or dealing with other people's negative reactions or lack of understanding, as well as it comes with a lot of financial implications like insurance, the cost of the treatment. And we know that 1 in 4 people with type 1 diabetes and every 1 in 5 people with type 2 diabetes is going to have some evidence of diabetes distress. And we, as already pointed out, managing diabetes is not easy. It is a 24/7 activity. So recent studies, as we have shown that there is activation of the parasympathetic nervous system with the meditation, and it actually has positive impact on the psychosocial well-being of the patient. Also, the psychologists and social scientists have given some thought to the question, what is meditation? We have already defined that. And apart from the above, the practice of meditation is associated with greater voluntary control of the mind, emotions, cultivation of the calmness, serenity, concentration, joy, love, reduction of anxiety, depression, anger, fear, or hatred. So all these things have been given. And we know that our neurological structures are such that they have a phenomenon called neuroplasticity. And several studies report both functional and structural changes in the brain in people who practice meditation, have been practicing meditation for long. And there is a scientific evidence for meditation which is related to neuroplasticity. It is already there, and all of us can go and see these papers. And mindful meditation has been incorporated into psychology as well as psychiatry practices for several chronic disorders. Benefits have also been demonstrated in depression, anxiety, sleep disorders, fibromyalgia, chronic pain syndromes. These are certain studies which have been by Koff and Hartman, another pilot study, another study which has been based on Buddhist-based walking meditation. And even the WHO also focuses on mind-body medicine as a complementary and alternative medicine. And meditation, prayer, mental healing, yoga, tai chi, art therapy, music therapy, dance therapy, all these have come together to find some role in management of the stress, which is ultimately going to increase the diabetes burden. So to sum up, what are the benefits of the meditation are that mental detox, negative thoughts and feeling, a calm mind, better concentration and clarity of thought, improvement in communication, blossoming of skills and talents, inner strength and healing, ability to connect the higher self and the ability to connect to the same source in everybody around. And there is a relaxation and rejuvenation also. If you want to meditate, then choose a convenient time, find a quiet place, get your posture right. Do it an empty stomach if possible. Do some warm up before that. Observe your breath. Have a gentle smile on your face and open your eyes slowly after that. Tomorrow onwards, there is a meditation, 7 days meditation challenge, which is starting from January 10, will be up to January 16th. All of you are welcome to join this meditation challenge and experience yourself what is meditation in itself. I would like to conclude by saying that if you meditate earnestly, pure in mind, and kind in deeds, leading a disciplined life in harmony with the dharma, you will grow in glory. If you meditate earnestly through spiritual disciplines, you can make an island for yourself that no flood can overwhelm. And a statement by Gautam Buddha. Thank you. Thank you very much.
Thank you very much, Dr. Amit Gupta. We now move on to our next speaker. Mohan, if you could introduce, please.
Hello. Yes, ma'am. Let me introduce our next speaker. She is Dr. Ami Sanghvi. She will be discussing about the very commonly ignored complication of diabetes, that is oral health in diabetic patients, that is responsible for many occult as well as infectious as well as non-infectious conditions in diabetic patient. So Dr. Ami Sanghvi, she is a consultant diabetologist and co-director of Sanghvi Eye and Diabetes Care Center, Mumbai. And she is consultant diabetologist at Namha Hospital, Mumbai. She had been lecturer for CPS Diabetology and member of organizing committee of Challenges in Diabetes since 2014 and Women and Diabetes since 2018. She had been a speaker and faculty at various national conferences and events like RSSDI and CAD. And then she has many chapters to her credit for RSSDI textbook of diabetes and articles in various journals. May I hand it over to Dr. Ami Sanghvi for her talk. Thank you.
Thank you, Dr. Mohan, for the kind words. A very good noon to everyone. And thank you, Dr. Raka, Dr. Ashish Saxena, for having me today for this presentation, which kind of made me also, read a different topic given. And congratulations to you both for putting up such a wonderful scientific feast. So the topic today given to me is oral hygiene and diabetes, and we opened our mouth about it. Now, even if we who are on this forum right now, how many of us have, proactively asked our patients to get their dental checkup done over a period timely, as we ask for other tests like the kidney or the retina? I think it's still one of those things which we do not talk to our patients much. Hopefully in the next 10 to 12 minutes, I'll be able to convince all of you to ask your patients to get their oral hygiene or a dental checkup done at least once in a year, so that, we can prevent complications which can occur due to this disease. when we all were in our MBBS days, we never used to get an exposure to this side of the medical studies. We never were exposed to any dentistry side. In fact, the dentists are more privileged. They get some exposure to anatomy, physiology, but we do not get. And I think it's again time that we also start getting exposure to this oral health right from the beginning when we start studying MBBS. So it's ideally the time to open our mouth about it. Now, periodontitis and diabetes, both are chronic, highly prevalent, coexistent comorbid diseases. Periodontitis is a chronic inflammatory disease triggered by the bacteria, leading to the destruction of the tooth supporting apparatus and finally tooth loss. Diabetes, we all know, a lot has been spoken about it. We have been discussing how important it is to maintain glycemic control. And now it becomes important to understand this bidirectional link between periodontitis and diabetes. A lot has been said about the global burden of diabetes. The latest numbers which are there with us is 537 million adults suffering with diabetes. And this number is predicted to go much higher in the next decade or more. So we all know the relevance, the importance of the same. It is not only a burden to the self, but also it affects the economy of any country. Diabetes definitely affects it's a huge financial burden on the patient himself, his family, and at large the economy of the country. Now coming to the prevalence of periodontal disease. Overall, the prevalence of periodontitis is 11.2%. That is approximately 743 million people are affected. It is more than the prevalence of diabetes is seen. It is periodontitis is the 6th most prevalent disease worldwide. And the numbers have exponentially increased from 1990 to 2010. There has been an increase in the global burden of periodontal diseases by 57.3%. And that there may be a contribution by increase in patients with diabetes too. Now, when it comes to relationship between periodontal disease and income, it has been seen that there is an inverse relationship between the economic strata and the development of the disease. So patients in low income group or lower economic strata have more risk, are 1.8 times have increased odds of developing this disease as compared to the high income group, maybe because of their poor oral hygiene care or any other habits they would be having. Even when it comes to the prevalence of the disease in the age groups, it's seen that periodontitis increases with patients in the older age group as compared to the younger age group. Now, coming to the most important part, let's understand the bidirectional link between the periodontal disease and diabetes. So it's like, it both affecting each other. Poorly controlled diabetes is a strong determinant for developing periodontal disease, wherein periodontal disease, it affects the severity of the diabetic pathogenesis, the glycemic control, and the worsening of complications. Now, there was a small study done, which was, the numbers weren't very huge in the study, but it was a wonderful study done with a 5-year follow-up period to understand the progression of the periodontal disease and its relation to the glycemic control. So it was a prospective cohort study with participants undergoing periodontal maintenance therapy. Around 92 patients were enrolled, in which where the diabetes control was assessed by the A1C. 23 had good glycemic control, 23 patients had poor glycemic control, and 46 patients were non-diabetic. Clinically, these patients were assessed for full mouth periodontal examination, was performed at all PMT visits in that 5-year-old interval period, and for bleeding on probing, the probing depth, and the clinical attachment level. And what did they see was, in all these parameters, over a 5-year-old period, be it the change in plaque index or bleeding on probing or the clinical attachment loss, what they had seen was patients who had poor glycemic control fared badly throughout. They didn't, patients with bad glycemic control did not have good, they worsened in terms of the periodontal disease. But what they saw was that patients who had good glycemic control and normal glycemic control did very well. So in fact, patients who had good glycemic control did almost similar to patients who had normal glycemic control in terms of these parameters of periodontitis over a period of 5 years, re-emphasizing the fact of having important glycemic control even in these scenarios. So poor glycemic control definitely leads to the risk of periodontal disease. Poorly glycemic control worsens the periodontal disease significantly, so much that there is a chance of tooth loss. And a good glycemic control, on the other hand, helps in maintaining the periodontal health and thereby reducing the complications. Now, one more important thing is that even prediabetes has been linked in the periodontal diseases. So in prediabetes patients, there is a strong association with bleeding on probing and higher periodontal parameters. So when there is a bacterial dysbiosis, which in the periodontal disease, it's been said that this bacterial dysbiosis can lead to an inflammatory milieu. This inflammatory milieu can cause increase in the pro-inflammatory cytokines and even the spillage of some bacterial and bacterial products, which would become the reason for pathogenesis for prediabetes and diabetes. So now we are kind of, desensitizing the dentist also, that if they have patients who are having periodontitis, consciously ask them about the history of diabetes, maybe get them checked, get their sugars checked. And some are now keeping even glucometers in their clinic for screening of any pre-diabetes. And that's where our association with as physicians and dentists can improve, and we can diagnose patients with diabetes. So we can start talking to our dentist friend that if they feel that their patients with periodontitis are presenting, ask them to get their blood sugars checked. And in fact, if the periodontitis is not even improving, all the more reason that they ask their patients to get their blood sugars checked. Because periodontitis definitely, as I mentioned, because of the inflammatory milieu, leads to worsening of the conditions with diabetes. It adversely affects the development of diabetes, its glycemic control, and thereby the complications. Periodontitis itself may risk the incidence of type 2 diabetes, and there is a greater risk of development of poor glycemic control. In fact, it is said that periodontitis, which sets up the inflammatory milieu and release of the pro-inflammatory cytokines, along with microangiopathy and increase in advanced glycation in products, can lead to development of diabetes complications, higher risk of developing diabetes complications. Even the story other way around is also there, that if as I mentioned that there is the periodontitis leads to the increased risk of hyperglycemia, A1C, both micro and macrovascular complication risk goes higher. Now, we weren't talking about all this some time back until a joint statement by ISP, that is International Society of Periodontitis and Periodontal Diseases, and RSSDI was released. In fact, it was released last year in 2020, and that's where we started realizing the importance of dental hygiene or oral hygiene in our patients with diabetes. Because even it's said that if some patient who has high sugars and you are trying everything to get their sugars down, you are pushing up the doses of your OSJ or pushing up the doses of insulin, still the sugars are not coming under check, ask the patient to go and see a dentist. Maybe there is a periodontal lesion there, even a beginning of gingivitis, which is the first lesion in of the periodontal disease, can, if it is taken care of, the blood sugar starts settling. So there is a link, a bidirectional link between the both of them. Periodontitis causing impaired glycemic control, increased incidence of diabetes, and because of the diabetes or highly uncontrolled diabetes, there is a subgingival microbiota or biofilms in the periodontitis, which can lead to the bacteremia, which invokes an inflammatory response and causes an immune response. And this is a cycle which is seen both in diabetes and periodontitis. Now, as there is a known factor of a common soil hypothesis between diabetes and hypertension, again, it's been said that there is a common soil hypothesis between the periodontal diseases and diabetes. In fact, it's kind of, there is one group of thought that, one school of thought that it all begins there. It all begins near the gums, near the gingiva, the bacterial flora, and which would, and the inflammatory response, which would then become the common soil for developing diabetes, atherosclerosis, rheumatoid arthritis, and many other inflammatory disorders. Now, when there is an inflammatory disorder, there is a release of host-derived inflammatory mediators. So multiple host defense mechanisms act together to eliminate this periodontal infection. There can be neutrophil migration, there can be complement activation, antibody production of cytokines, host-derived chemokines, prostaglandins, and TNF-alpha. So these inflammatory mediators are the connecting link between diabetes and periodontitis. And how are they connecting link? Let us see here. So these inflammatory markers which are present in the gingiva, the saliva, the GCF, as well as systemically, along with the impact on the periodontal microbiota, leads to the release of acute phase proteins. And this would activate the oxidative stress pathway, leading to impairing the insulin signaling and leading to resistance. And this complicates into hyperglycemia and other disease and diabetes complications, including the progression to periodontitis. If the glycemic levels are not taken care of, this leads to further progression. There is in the periodontal disease, and there can be destruction of the bone with the inflammatory mediators in the gingival tissue, activate the pathways that lead to the bone resorption. And this destruction can lead to, affecting the masticatory function of the patient and would lead to, again, nutritional deficiencies too. Also, if the glycemic levels are high, there can be destruction of the extracellular matrix. So summarizing the link, inflammation, immune response, and dysbiosis triggers a link between diabetes and periodontal disease. Inflammatory mediators lead to the periodontal destruction, and inflammation also progresses insulin resistance, which worsens the glycemic control. So we understood the link between diabetes affecting periodontitis. Patients with diabetes are at a higher risk of periodontitis compared to any normal individual, that there is 3 times higher risk. Poor glycemic control leads to increased periodontal risk, and longer the duration of diabetes, it leads to severe periodontitis. Vice versa, periodontitis also affects diabetes by causing a poor glycemic control. Periodontitis can be an early predictor of prediabetes and diabetes, and periodontitis leads to 2 times higher risk of diabetes development. So this bidirectional link between periodontitis and diabetes is extremely important to understand. And there comes in the most important part of the interprofessional responsibilities on the part of the physicians and the dentists too. In fact, dentists do call us up asking that your patient has come, your sugars are under control, and please look into the sugars. But how many times do we call up a dentist and say that, look into these patients? So now, if anyone wants to know more about this is a wonderful joint statement by ISP and RSSDI, which has been released, and they have re-emphasize the role of us as physicians. In fact, they have asked us that as we ask for the checkup for microalbuminuria, the renal profile, the retina once in a year, we need to refer our diabetic patients to dentists for oral health at least once in a year. We should look for periodontal signs and symptoms, and as treating physicians, support the dentist friends in terms of A1C levels to get the A1C levels down, to assess the risk of the progressive periodontal disease and assess the risk of hypoglycemia. On the dentist part, the responsibility is to evaluate the patient for diabetes symptoms, and if he has been diagnosed with pre-diabetes or diabetes, refer to the physicians, ask the patient the history for diabetes, and educate physicians on infection and other problems which affect the glycemic control. I end my talk here. Thank you all for your patient hearing.
Thank you, Dr. Ami, for a wonderful lecture. It's indeed something that we really ignore, and I think we should pay more attention to it. I invite the next speaker now. He's going to talk about a wonderful and a very important topic. Dr. Abudaya Verma, he is the director of SEWA, Super Specialty Endocrine and Women Care Center from Indore. He's a professor of medicine at the Index Medical College, and he has more than 30 international and national publications in Index journals. He's a reviewer at many journals, and he's an ADA certified speaker. He's a recipient of SK Khajio IMA Oration Award, and he has a lot of work done during the COVID-19, and he has been recognized for the same. He's also the recipient of prestigious Charak Award of MP in 2021. I welcome you, sir.
Dr. Shefali,
Thank you.
This is Dr. Abhishek Srivastava.
Yeah.
Actually, we just.
I was wondering the same, but
It's okay. We can have it. Dr. Abhishek is also with us after this.
Yeah, the CV put up was Dr. Verma. Okay.
Thank you, Dr. Shefali. And at the outset, I'd like to thank the organizers, Dr. Ashish and Dr. Raka, for organizing this Global Diabetes Forum, which had really a lot of interesting out of the diabetes topics also, like recently we have heard, and then the meditation earlier and yesterday also. So without wasting much time, I'll start again a bit different thing now about DPP-4 inhibitors, which we are using since a long time, almost more than 10-15 years. We have been using the DPP-4 inhibitors, and we know that they are quite efficacious in controlling the hyperglycemia, and they are quite safe also. So they have been proven for their anti-hyperglycemic effects and without causing hypoglycemia or weight gain. So now what in 2022 we have new about DPP-4 inhibitors. So I would be talking about those things briefly. So just to begin with, we know that DPP-4 inhibitors are a group of anti-hyperglycemic medications used to manage type 2 diabetes mellitus and to control the hyperglycemia and reduce the risk factors for various problems of micro and macrovascular. Various DPP-4 inhibitors have been approved by FDA, like sitagliptin, saxagliptin, linagliptin, and alogliptin. And vildagliptin is approved by European Medicine Agency, and it's not approved by FDA. We also know that these DPP-4 inhibitors, they act through the incretin hormones, which are basically the gut hormones, especially in the small intestine, and these are responsible for glucose homeostasis after oral food intake. So this is very important. The oral food intake response is important for the action of these DPP-4 inhibitors. Since almost last 5-7 years, it is seen that apart from these anti-hyperglycemic effects of DPP-4 inhibitors, they have some really important pleiotropic benefits also, like they possess anti-hypertensive effect, they have anti-inflammatory effects, they have anti-apoptotic effects, and are immunomodulatory effects in heart, kidneys, blood vessels, which are independent of the incretin pathway. So independent of these incretin pathways. So sorry, this is my, so sorry, okay, is my slide visible? Excuse me. Yes, okay. Sorry. There was some technical problem. Yeah. So these are recently been approved to, and it can be used in patients who had undergone kidney and liver transplant, where there is a new onset diabetes after transplantation. And we have seen now that recent guidelines in the last couple of years, they have shown that these drugs can be used as monotherapy also in drug-naive patient who can't tolerate metformin, or can immediately be started after the metformin therapy because of the various reasons we know. And these DPP-4 enzyme is basically a ubiquitous enzyme which acts on incretin hormones, mainly the GLP-1 and GIP, which maintains glucose homeostasis by increasing the insulin secretion and decreasing glucagon secretion. So till now, this was the scenario which was commonly known to everybody regarding the. Now what we have new in the 2022 about DPP-4 inhibitors. So we can see here, this was a comparative study recently published in 2020. DPP-4 inhibitors and cardiovascular events in patients with type 2 diabetes mellitus without cardiovascular or renal disease. And the conclusion of these study was that this cohort of low-risk patients newly treated for type 2 diabetes, DPP-4 inhibitors exhibited 13% lower risk of MACE compared to sulfonylureas, and similar risk for MACE compared to metformin. So this is again a kind of confidence-giving conclusion to us that yes, there are studies now where we have comparison with sulfonylureas where DPP-4 inhibitors have shown to reduce slightly the risk of MACE compared to the sulfonylureas. Then this is another very important study. The latest study you can see here, published in December 2021, the role of DPP-4 inhibitor and DPP-4 in different lung disease. We know, as we are now again in the third wave of this Omicron or COVID-19, we are seeing lung diseases now like a really important disease to be considered, like as compared to earlier. And studies have shown that DPP-4 has a role in pathogenesis of lung disease because it is highly expressed in lung parenchyma and the surface of epithelium, vascular endothelium, and fibroblasts of human bronchi. And a lot of studies are also done in respiratory diseases like Middle East respiratory syndrome or MERS, and non-infectious lung disease like pulmonary fibrosis, lung cancer, chronic obstructive pulmonary disease, and asthma, to see the role of DPP-4 and in the DPP-4 inhibitors in these lung diseases. And here you can see, this is a summary of those studies that they say DPP-4 plays a complicated role in lung cancer. So there are few studies which say that it may increase the risk, and there are studies which say that it may reduce the risk of some type of lung cancers. But they say that DPP-4 may provide now a new targeted therapy strategy for lung cancer, and studies are going on, and we may in future see DPP-4 inhibitors might be used for treatment of lung cancer. Then we have anti-DPP-4 antibodies, which basically target the binding site of this DPP-4, like YS110. And when this is there, the anti-DPP-4 antibodies, they block the entry of MERS COVID. So this can really help us in controlling the COVID infections. Then we have studies showing targeting the DPP-4 protein. And they say that this protein plays a very important role in development of vaccines for, again, this MERS or Middle East Respiratory infection and other viral infections also. So you can see here how the DPP-4 and DPP-4 inhibitor, its antibodies and proteins, they play a very important role in various respiratory tract infections. Now coming to non-infectious pathologies of lung, in mice studies, it has shown that there is a decreased mortality in these mice who had COPD. Saxagliptin has shown to elevate the asthma via NF-kappa B and TLR4 pathways. Sitagliptin has shown to reduce the pulmonary artery hypertension through its anti-inflammatory and vasodilatory effect. And studies are in pipeline regarding pulmonary fibrosis and the use of DPP-4 inhibitor. The results are not yet clear. So you can see that DPP-4 and DPP-4 inhibitors, other than their anti-hyperglycemic effects, they have role in various infectious and non-infectious pulmonary diseases. Now we'll see the early and chronic DPP-4 inhibition and cardiovascular events in patients with type 2 diabetes mellitus after an acute coronary syndrome. So we say that maybe that these drugs are quite neutral. They may, or earlier slide, it has shown that there is a slightly reduced risk of MACE with DPP-4. And this was a 2018 study, which was a landmark analysis of the EXAMINE trial, which used alogliptin as a DPP-4 inhibitor, and it showed that early after an ACS, patients with type 2 diabetes mellitus experience a significant burden of heart failure events and recurrent ACS, and use of alogliptin appears to be safe in these high-risk patients following the ACS. Then we have comparative effect of various DPP-4 on the laboratory parameters. Recently published, again, shows that DPP-4 inhibitors are well-tolerated hypoglycemic agents, and they have favorable effects on lipid parameters, especially with sitagliptin, vildagliptin, and alogliptin, and they have favorable effects on NASH or NAFLD, especially with sitagliptin, alogliptin, and linagliptin. Then DPP-4 inhibitors and risk of heart failure. We know there was a little bit risk seen of heart failure with saxagliptin, but then again this observational study shows that DPP-4 inhibitor did not increase the risk of heart failure compared to sulfonyl ureas. Then this is again a very important study, the role of DPP-4 inhibitors in bone physiology, and clinical studies have shown that there is a increased bone formation markers with DPP-4 inhibitors and reduction or neutral effect on bone resorption markers, but they have not shown any significant effect on the BMD and reduction of fracture risk. So overall, these studies, they suggest that DPP-4 inhibitors are beneficial for bone health. Next is the diabetes and cancer. I've already told about lung cancer. We have some studies which favor and which are not in favor of DPP-4 and cancer, but few studies again, they have said that DPP-4 inhibitors can accelerate the tumor metastasis, but still I would say this is still in the controversial phase. Then DPP-4 inhibitors and autoimmune diabetes. We know we have autoimmune diabetes. A lot of our patients are being now diagnosed at a quite young age of adulthood also, other than just being small kids. But use of DPP-4 inhibitors in these autoimmune diabetes have shown good safety profile only in preclinical studies and some randomized controlled trials for treatment of autoimmune diabetes, and no such guideline still give us the permission to use DPP-4 inhibitor in these autoimmune diabetes. Then comes the role of DPP-4 and DPP-4 inhibitors in the neurological diseases like Parkinson's disease. We know that DPP-4 inhibitors, they don't cross the blood-brain barrier. They affect, or their effect is mediated by an increase in circulating GLP-1 hormone. But studies have shown that sitagliptin, saxagliptin, and vildagliptin in rotenone animals who have Parkinson's disease had improvement in motor and cognitive performance alongside the preservation of dopaminergic cells, with evidence that this was mediated through their anti-inflammatory and anti-apoptotic mechanisms. And vildagliptin also has shown to restore the impaired neuronal insulin receptor function in rats who had high fat diet. So here you can see that DPP-4 and DPP-4 inhibitors, they had benefit in neurological conditions also. Now coming to the anti-inflammatory effects of DPP-4 inhibitors. Again, there are animal studies which have shown that ischemic reperfusion injury of heart, lung, and kidneys in mice, rats, and pigs have shown that DPP-4 inhibitors provide protection against this IRI. Sitagliptin has shown in patients with asthma to reduce inflammation and remodeling. I've already told you about this. Anagliptin has been used in mice models for inflammatory bowel disease, and it has shown that these mice, they have improved body weight loss and reduced disease activity. And murine experimental autoimmune myocarditis, linagliptin, has shown to reduce the inflammation and the cardiac fibrosis. And in the end, I would just talk about the benefits of early combination therapy in drug-naive patients or in patients who are not well controlled with metformin. The early combination therapy of linagliptin and metformin, we know what are the benefits of fixed dose combination because of their complementary mechanism of action. Low dose combinations therapy can give less side effects and can have better adherence, improve patient satisfaction, and lower the direct medical cost. Why metformin and DPP-4 inhibitors are ideal agent for the FDCs? Because They have benefits on pancreatic beta cells, pancreatic alpha cells. They reduce the hepatic glucose production, improves insulin resistance, and along with that, they have low risk of hypoglycemia and no additional weight gain. And see, here we can see the synergistic benefit of using the metformin and linagliptin, where they target different pathophysiologies and take care of blood sugar levels. Thank you. So any questions or any comments? Somebody can...
do we need to have question answer session right now or later on?
We can have it after all the sessions, right?
Thank you. Thank you, everybody. Thank you, organizers, Dr. Raka, Dr. Ashish. Thank you.
Thank you, sir, for this wonderful presentation. This is indeed an enlightening talk. So moving on to our next talk, another very important topic on hypoglycemia. So may I invite
Please unmute, sir.
Please unmute, sir. Gurinder, sir, please unmute.
Right, sir. So may I invite Dr. Abhishek Srivastava. So he's a chief endocrinologist, R&R Hormone and Clinic, Jabalpur, Madhya Pradesh. Hello.
So we can hear you, sir.
Right, sir. He's a committee member, Disease State Network, American Association and Clinical Endocrinology. And he's an editorial board member of Journal of Endocrinology and Metabolism Research. And he's on an editorial board member of MSD Research also, and being nominated for Best International Clinician Award from American Association of Clinical Endocrinology, and received Indian Icon Award in 2020. Another received Diabetes India Award in 2019 also, and received Research Excellence Award in 2020 for his study on hypogonadism. And he has been a faculty member in various national as well as in international conferences. So moving on to Dr. Abhishek Srivastava for his talk on for hypoglycemia.
Thank you, Dr. Gurinder, sir. Thanks a lot. And I would like to thank Dr. Raka and Dr. Ashish for inviting me in such a well-organized conferences, Global Diabetes Forum. And so let us begin. Are my slides visible now?
Yes, sir. Just make it in full screen mode.
Yeah. So basically, let us start with the topics. My topic would be hypoglycemia, awareness in diabetes, mainly because the diabetes is one of the most important parameters where we should look upon when a patient is suffering from recurrent hypoglycemic episodes. So to define hypoglycemia, we all know basically glucose levels less than 55 milligram per deciliter with symptoms that are relieved promptly after the glucose level is known as raised documented hypoglycemia. And one more thing, hypoglycemia is also can be documented on the basis of Whipple's triad. Basically, we know all that symptoms consistent with hypoglycemia, low plasma glucose concentrations, and relief of symptoms when plasma glucose concentration has increased. We can define hypoglycemia onto the basis of levels also. Level 1 can be stated as glucose less than 70 milligram per deciliter. Level 2 glucose values less than 54 milligrams. And level 3, a severe event characterized by altered mental and or physical status requiring assistance from the patient's point of view. Now, if we look at the homeostasis, the physiology of glucose regulation and how hypoglycemia is taken care by the body, mainly because see, when there is a hypoglycemic event, then we know that how that hypoglycemia is counteracted. They are mainly counteracted by the counter-regulatory hormones, mainly glucagon, epinephrine, cortisols. But what happens in diabetes is these counter-regulatory hormones response are being attenuated mainly. That is the reason why we as a diabetologist, endocrinologist faces more or less these problems when we are treating type 2 diabetic patients. And more or less, we know that a patient who is a pre-diabetic, where we see hyperinsulinemia mainly because of insulin resistance, then treating that patient or aggressively could also result into severe hypoglycemic episodes mainly. So one part could be increase in release of insulin, hyperinsulinemia, and second could be attenuated response from the counter-regulatory hormones, that is glucagon, epinephrine, cortisol, and growth hormones, mainly because insulin is mainly a first line of defense when a patient is suffering from hypoglycemia. Because what happens, the insulin secretion is decreased, glucagon secretion is increased, mainly because it is the second line of defense. Epinephrine, cortisol, growth hormones are seen at a very later stage when patient is suffering from an altered sensorium or a very, very pronounced hypoglycemic time. Now, if you look at the mechanisms of hypoglycemia, mainly hypoglycemia implies that the rate of glucose efflux from circulation is more than the rate of glucose influx, mainly, to simplify it. Now, what happens when there is an increase in efflux, increase in utilizations, like person is exercising more or less more, pregnancy or sepsis, septicemia is there in the patient, when there is an increased loss, like renal glycosuria pregnancy, and another aspect could be when there is decrease in influx from the glucose, like decreased endogenous glucose production in the absence of exogenous glucose delivery. Most commonly, that could be due to the hepatic pathology or renal pathology. One more mechanism could also be implied in the mechanisms of hypoglycemia, could be regulatory, enzymatic, and substrate. But from my point of view, regulatory is the most important part, because there is an increased secretion of insulin or decreased secretion of glucose counter-regulatory hormones, which I've already discussed with you in the previous slides. One aspect could be enzymatic and another could be substrate. Enzymatic could be primary or may result from hepatic disease when there is a lack of enzymes which could regulate glucose homeostasis, and another could be failure to mobilize or utilize gluconeogenic substrates. But these are of less importance. Most important could be regulatory, where we can see more or less these are the pathophysiological mechanisms. Now, if you talk about the predisposing factors of hypoglycemia, advancing age, most important, poor health knowledge, hypoglycemia unawareness, most important, which I would be discussing in the later slides. And the most common cause of hypoglycemia is medications used to treat diabetes mellitus, such as insulin and sulfonylureas. And risk is greater in diabetic patients who have eaten less than usual, more or less exercised more than usual, or have drunk alcohol. This is most important, because what happens when a patient comes to you with a newly diagnosed diabetes, what the physician says to a patient, भैया सब चीज छोड़ दो यार, तुमको diabetes हो गई है, तुमको ये नहीं लेना है, तुमको वो नहीं लेना है. But we fail to explain the patient that the total calorie count should be equal to 1700 to 1800 per day. उसको वो चीज तो लेना ही है. अब चाहे वो मीठा खा के 1800 कैलोरीज ले ले, या थोड़ा थोड़ा करके रोटी दाल चावल खा के 1800 किलो कैलोरीज ले ले. बट क्या होता है, what happens, patient suddenly stops everything. He stops eating sugar, he stops eating rice, he stops eating rotis also. He says, यार मुझे diabetes हो गई है, and doctor ने बोला सब चीज छोड़ देना. This is the problem where a patient faces, and that is because हम क्या करते हैं, basically हमने देखा है the UKPDS trial or the DCC trial, where they have given the legacy effect, the protocols of legacy effect, where the interventional trial, जिसमें हम देखते हैं कि हम अगर aggressively, if we treat a patient when he is in an HbA1c level of 7 to 8, then a patient sees more or less legacy effect in development of chronic diabetic complication. But what happens, जब patient सब चीज छोड़ देता है और हम उसको aggressively treat करते हैं, then the problem starts, because recurrent hypoglycemic episodes is being seen, and the patient, what happens, जब recurrent hypoglycemic episodes होता है, the patient more or less becomes much more vulnerable to delay his diabetic medications, to delay his diabetic meals also. That is the problem we as a physician also faces, and a patient also faces from his personal point of view. Anxiety provokes, depression provokes. So lot of psychosocial problems arises from the patient's part and from the physician's parts also. If we talk about the signs and symptoms of hypoglycemia, adrenergic and neuroglycopenic, we can divide those things. Adrenergic are weakness, tremors, sweating, tachycardia, nervousness, irritability, hunger, nausea. These are all the symptoms where a patient feels, and a patient tells to a physician that I'm feeling all these symptoms. And one we could also define as a neuroglycopenic symptoms like mental dullness, confusion, amnesia, incoordination, seizure disorders, coma, and focal neurologic deficits. But these are all signs which we see as a physicians, but more or less it is the adrenergic symptoms what a patient tells to you, and we should define hypoglycemia onto these adrenergic symptoms also. Now, if we talk about the clinical classifications, one could be stated as post-absorptive, that is fasting hypoglycemia, and second could be postprandial, that is a reactive hypoglycemia. Acha, significance is why I'm defining as post-absorptive or postprandial, because post-absorptive or fasting hypoglycemia is seen only when a patient is suffering from a pre-existing diseases. That is the part where a physician should take care of it, and he should screen a patient with different complications or with different comorbid associations linked with type 2 diabetes. Because when a person is seen with a recurrent fasting hypoglycemia, then certainly there is a problem and we should be aware of it. Postprandial hypoglycemia does not usually imply a serious underlying disorders. One could be a less meal taken by the patient or the drugs like insulin or sulfonylureas which a patient taking. But postprandial hypoglycemia does not usually imply a serious underlying disorders. It is the fasting hypoglycemia we should take care of mainly. If we talk about the reasons for fasting hypoglycemia or post-absorptive, drugs like insulin, alcohol, sulfonylurea, pentamidine, quinine, we usually don't prescribe, sulfonamides, others, but it is insulin or sulfonylurea which is most commonly being seen by even at the remotest places. If we talk about some critical illnesses, certainly hepatic failure, cardiac failure, one of them is congestive heart disease or heart failure, one of the most important causes where a patient is suffering from recurrent fasting hypoglycemia. Renal failure, certainly, sepsis, some underlying diabetic foot ulcers or suffering from long prolonged septicemia, and inanition. Now, some classifications could also be defined as hormonal deficiencies, like a person is suffering from cortisol growth hormone deficiencies, glucagon or epinephrine deficiencies, some non-beta cell tumors, some endogenous hyperinsulinemia patients like pancreatic beta cell disorders, beta cell secretagogues, autoimmune hypoglycemia, or ectopic insulin secretions. But these are all very rare disorders where these hypoglycemia, fasting hypoglycemia is seen. But what should be mainly concerned is the hypoglycemia associated with mainly insulin, alcohol, sulfonylureas, cardiac failure, renal failure, hepatic failure, and glucagon or epinephrine attenuation response. If we talk about the postprandial hypoglycemia, certainly some congenital deficiencies of enzymes of carbohydrate metabolism can also be seen, right? Hereditary fructose intolerance or galactosemia. HFI is more or less common than galactosemia, where a patient suffers from recurrent postprandial or reactive hypoglycemia. If we talk about the elementary glycosuria, then post-gastrectomy, certainly a patient faces the problems of postprandial hypoglycemia recurrent. And one could also define as idiopathic postprandial hypoglycemia, that is functional. So we have defined hypoglycemia, we have defined the reasons for hypoglycemia, but most importantly, hypoglycemia is seen in type 2 diabetic patients. Forget about hypoglycemia beyond diabetes, because it is diabetes what we see in day-to-day life. So basically, we would be discussing about hypoglycemia problems in type 2 diabetes. And hypoglycemia is most commonly seen in type 2 diabetic patients as a result of the treatment of diabetes. I've already discussed with you before, and it is the limiting factor in the glycemic management of type 2 diabetes. It causes recurrent morbidity in most people with type 1 diabetes patients and in many with advanced type 2 diabetes. And it is sometimes fatal also. And it causes a vicious cycle of recurrent hypoglycemic episodes, which can also be termed as hypoglycemia associated autonomic failure, which is in common terms is known as hypoglycemia unawareness. We will be discussing shortly what is hypoglycemia unawareness. Now, if we talk about the burden, what hypoglycemia puts onto a patient and puts onto a physician also. If a patient is a type 1 diabetic patient, mainly average 2 episodes of symptomatic hypoglycemia per week, and at least 1 episode of severe hypoglycemia is seen at least in type 1 diabetic patients, putting them in temporarily disabling conditions. every year. An estimated 2 to 4% of people with type 1 diabetes die due to hypoglycemia. Now, who can be the culprit? Mainly, it could be unawareness, hypoglycemic unawareness. It could be from the physician part also. It could be from the patient part also. But we can't say mainly who can be the culprit. But more importantly, it is a patient who suffers most of the severeness of hypoglycemia. Now, if you talk about the patients in type 2 diabetes, it is less frequent as compared to type 1 diabetic patients. Mainly, metformin, pioglitazones, AGIs, GLP-1 analogs, DPP-4 inhibitors, mainly these drugs do not cause hypoglycemia. But however, if we combine these medications with insulin or sulfonylurea, then certainly we see more or less recurrent episodes of hypoglycemia mainly. But who can be held responsible for this? Certainly insulin and sulfonylurea. And right now we have more options, more protocol treatment guidelines where we can say that insulin and sulfonylureas can be kept onto the backlogs rather than keeping them into the front line, keeping them as a frontline warrior. We have other options also where we can use those options and defy the problems of hypoglycemia, recurrent hypoglycemia. If we talk about the conventional risk factors, certainly insulin, influx of exogenous glucose is reduced, insulin-dependent glucose utilization is increased. These are all the pathophysiological conditions and or mechanisms where we can say why a patient suffers from recurrent hypoglycemic episodes. Most importantly, what we should know is the influx of exogenous glucose is reduced by overnight fast by the patients or following missed meals or snacks. Most importantly, by the patient. Then insulin independent glucose utilization is increased when a patient exercises more or less, because जब उसको पता चलता है डायबिटीज हो गई तो वो वॉकिंग ज्यादा करने लगता है, जिम जाने लगता है, दौड़ने लगता है. So this can also be one of the most important factor. So a physician should look into all these aspects when he starts treating type 2 diabetes patients. Then sensitivity to insulin is increased. Certainly, what happens? जब पेशेंट एक्सरसाइज करता है या हम इंसुलिन सेंसिटाइजर दे देते हैं इनिशियली, जैसे pioglitazone. I have experienced myself when I have prescribed pioglitazone onto the initial phases, then certainly the sensitivity is increased and we see the phases of recurrent hypoglycemia. Then we should imply these situations where we should seriously look into these matters, because sensitivity to insulin's increase initial phase certainly means that there is some improvement in the beta cell secretion. There is an improvement in the glucose utilization by the muscles. One could also be endogenous glucose production is reduced, that is alcohol ingestions is reduced, then insulin clearance is reduced, that means renal failure. So mainly there could be a lot of options where we can say that why the recurrent hypoglycemic episodes occurs. The insulin deficiency, one of the most important factors, hypoglycemia unawareness, lower HbA1c levels or lower hypoglycemic goals that are, this is the most important line which I would like to emphasize is I would take only 5 minutes to 7 minutes, not less than that, not more than that, Dr. Raga, please. Lower HbA1c levels targets is being set by the physicians. Kya hota hai when a patient comes to you with an HbA1c of say 10 or 11 and we set a target of I want this patient's HbA1c level to 7. Then the problem occurs, because then we imply to more combination therapy, we imply to insulin therapy, we imply to the sulfonylureas also, because without combination therapy, we won't be able to achieve the lower HbA1c targets which we have set. So basically, when a patient comes to you with an HbA1c of 10 or 11, do not set a target of around 7%. Gradually reduce your HbA1c level targets. Like if a patient comes to you with HbA1c of 10%, bring him to around 9%, 8% gradually, then we can say that, okay, gradually decreasing HbA1c level does reduces the problems of severe hypoglycemic episodes. I was talking about the hypoglycemia unawareness. Why this happens? Because it is caused by the attenuated sympathetic adrenal response, or largely the decreased sympathetic neural response to hypoglycemia. Why this happens? Recurrent hypoglycemia episode does attenuates the response of the sympathetic response which a patient has physiologically when he is a non-diabetic. It is characterized by the loss of warning
Sorry
signs.
to interrupt, Dr. Abhishek, sir.
Please, 5 minutes.
Yes.
I'll take 5 minutes.
as faster as possible.
Yeah, please, sir. I'll be fine. So these are characterized by the loss of warning, mainly adrenergic signs, what I have told you before, like tremors or hunger, nausea, vomiting, घबराहट, all these signs. ये loss हो जाता है patient में. This is the problem where happens because patient को पता नहीं चलता है that he is onto hypoglycemia. That is the reason why the morbidity and mortality is increased onto the patient. It is 6 times increased risk of severe iatrogenic hypoglycemia during aggressive treatment. So mainly we should avoid being too much aggressive when a patient comes to you with lower HbA1c levels. Now, if you talk about the prevention or treatment of hypoglycemia, certainly one of the most important thing is hypo-aware program, which has been done in Sweden and Denmark jointly. This was a 2.5-hour group session. We can also implement. Why I'm saying this, we can also imply this hypo-aware program. It is been there. We can search it in Google also. अगर हम अपनी प्रैक्टिस में हाइपो अवेयर प्रोग्राम रखते हैं, it is mainly इन्वॉल्वमेंट फिजिशियन का होना चाहिए डॉक्टर के साथ. Very effective hypo aware program because it has been studied in type 1 diabetes and type 2 diabetes, where level 3 of hypoglycemia has been reduced by 33% and hypoglycemic unawareness is been reduced by almost 62%. That is why I am emphasizing to search this hypo aware program and try to inculminate onto your clinical practice when a patient, if you want to treat a type 2 diabetic patient, educate them. There are certain medicines, glucagon or IV glucose is required. If available, glucagon should be given. Intranasal glucagon is there, intermucosal glucagon is there. Which one is superior? Both are equally effective, be it IV, be it intranasal or intermucosal glucagon. Rescue pens are also there if you want to treat those patients. Various pens are there if you want to treat a patient with hypoglycemia mainly. But हम क्या करते हैं? Basically हम dextrose डाल देते हैं. This is the most simplest way if you want to say it. So what the guidelines say, occurrence and risk of hypoglycemia should be reviewed at every end of encounter. Investigator has indicated glucose is the preferred treatment for hypoglycemia mainly when blood glucose levels falls down less than 70 milligram per deciliter. Glucagon should be prescribed for all individuals of level 2 or level 3 hypoglycemia. So that is, it should be available at the nearest counters. Glucagon administration is not limited to healthcare professionals. They can be given by anyone else. And hypoglycemia awareness program should be run at every part of the country. So hypoglycemia is common in people with type 2 diabetes treated with sulfonylurea, glinides, or insulin. And mild hypoglycemia is much more common than severe. Severe hypoglycemia is associated with an increased risk of mortality. Half increase the risk of severe hypoglycemia, that is hypoglycemic associated autonomic failure, and approaches to prevent and treat hypoglycemia need to be employed aggressively. Thank you. I'm sorry I've been late so much. I'm sorry.
Thank you so much, Abhishek sir. So the today's session for Extra Miles for Happiness has been concluded. So any questions regarding the session, we are open. Does anybody has questions? So we can go back to the next session then.
Yeah, thank you, Dr. Hina, for conducting this very nicely. Thank you, the chairperson, Dr. Shefali, Dr. Gurinder, Dr. Kalyan, and all the speakers. We proceed to Smiling with Technology, and we have Dr. Surajit K. Patra, who will lead us through the session. Is Dr. Surajit Patra there?
Yes, yes.
Yeah, he's here.
Yeah, Surajit, please introduce the chairpersons and let us go ahead.
Yeah, sure. So thank you, Dr. Ashish and Dr. Raka for providing this opportunity to be a part of this Global Diabetes Forum. So welcome you all to this session on Smiling with Technology. And for this session, we have two important chairpersons, Dr. Parikshit Goswami from Himmatnagar and Dr. Rohit Warrior from Thiruvananthapuram. So I welcome both our chairpersons, Dr. Parikshit and Dr. Rohit, to conduct the further session on Smiling with Technology. So over to you, Dr. Rohit and Dr. Parikshit.
Thank you, Dr. Surjit, for an kind introduction, and I congratulate Team Global Diabetes Forum, and particularly Dr. Raka and Dr. Ashish for conducting a wonderful virtual conference. So first and foremost, important point to remember by all speakers that we are running short of time. I think so we are 45 minutes late, running very short. So I request all the speaker to remain in time, and I request them to cut short their talk at least 2 minutes. First, I'm going to introduce my dear friend, Dr. Vipul Chavda from Ahmedabad, who is an MD Medicine and founder director of Drugs Institute of Medical Sciences, a district coordinator for RSSDI Ahmedabad, and he has been awarded with the Diabetes India Best Work in Diabetes Awareness, Times Group Excellence in Diabetes Care, American College of Physicians, Early Care Physicians Award, and he's a principal investigator for numerous trials, and he's a national and regional faculty for educations of HCPs. And he's going to talk on a social media app and digital therapeutics in rural diabetes care. Over to you, Dr. Vipul.
Thank you so much, sir, for kind introduction. And because it is a technological forum, I have given my talk in a virtual format. So I would request RX to play it, and we can save the time and we have time for discussion if allowed. Over to RX team.
Good morning, all. A warm welcome to all of you to this wonderful scientific feast of Global Diabetic Forum. At the offset, I would love to thank my big brother, Dr. Raka Sivhare and Dr. Ashish Saxena, sir, for giving me opportunity to talk on this prestigious forum. I'm given a topic that is very, very important in our day-to-day nowadays. And when the non-communicable diseases are increased by so many margin in our country, then it is very, very important. That is social media and digital therapeutics in rural diabetic care. In this 15-minute talk, we will discuss understanding the need of virtual healthcare, what is digital therapeutics, how digital therapeutics and social media in diabetic care are very useful, and what are the barriers to use this tool for the management, especially when we are talking about rural India. So let's understand something about virtual healthcare. So healthcare system in India is very traditional since I must say century, and we need to update it. When we are talking about semi-urban or urban area, there is easily availability of secondary and tertiary medical care, but still they are not uniform, and there is incentive to entice specialist practice in suburban area that have not been very successful. But situation is very poor in a rural area. People struggle to access timely and good quality of medical care, and there is substandard access to specialty care. So this leads to emergence of virtual healthcare in our country. How and when they are useful? They provide urgent care to a rising issue like increasing burden of chronic non-communicable disease. They help to develop a smaller and cheaper option for the patient where they can connect to the specialist from their mobile and other small devices. There is a shifting healthcare model to an increasingly patient-centric design, and to provide easy healthcare access to remote area, there is an emergence of virtual healthcare system. So let's understand the digital therapeutics. The word digital therapeutics do not mean any gadget that we use to measure our body's anything like a pulse or blood pressure or anything like temperature or ECG. Digital therapeutic is a software-driven, evidence-based therapeutic intervention to person for prevention, management, and treatment for the non-communicable disease. It is used independently or in combination with medications, device, and therapies. They are reviewed and approved by the regulatory authorities at regular intervals, and they are also supported by advanced latest technology. So I must say that digital therapeutics is a new horizon in public healthcare. There are so many dimensions for this digital therapeutics. They involve mobile health, they involve health information technology, they involve devices, sensors, wearables, and they are personalized for all the individuals, and they connect healthcare provider by the mean of telehealth. So what are the categories we can include in digital therapeutics? Based on the target product profile covered by digital therapeutics, each treatment belongs to one of the following categories. It can be for address a medical condition like diabetes or cardiovascular disease or obesity. It can be used for manage or prevention of medical disorder or disease like some psychological illness or again diabetes and obesity. They can be used for optimized medication. For a condition like diabetes and obesity, patient requires constant motivation and constant supervision. With the help of digital therapeutics, it is possible. And they are also useful to treat a medical disorder or disease like diabetes and other psychological disorder. What are the characteristics of digital therapeutics? First of all, there is a target population, any adult population with chronic disease, either they are physical or mental, can be targeted by the use of digital therapeutics. The mechanism of action is an increased self-efficacy with the use of advanced technology. What are the active ingredients of digital therapeutics? The user's experience with the digital therapeutics is used to take inputs from the user, and there are no absolute contraindication. There is only patients should use a mobile with internet and with some applications. What are the role of other treatment? The treatment must be continued. This digital therapeutics is an adjunctive to the clinical care and case disease management. A patient's requirement is intact cognitive ability, digital access, and ability to use an email or application in their mobile. And what are outcome expected? Improve clinical output, prevent complication, and save money for the patient and their families. So normally we understand digital therapeutics with wellness tracking applications or device, but we must understand that digital therapeutics is different from wellness tracking applications. First of all, digital therapeutics focus on only one condition, while healthcare or wellness tracking device are focused in general health of the patient. Digital therapeutics regulatory requirement like multicentric RCT among target population, they are undergo many trials. They are also phase 1, phase 2, phase 3, and post-marketing surveillance as well. By wellness tracking device are minimal technology requirement for downloading the application from the app store. The therapeutic claim, digital therapeutics is just safe. They are proven therapeutic value by collection and analysis of a real world evidence, while wellness tracking devices are unsustained claims about the clinical benefits. Digital therapeutics is a business to client model, while tracking devices are business to client model. The compliance, the prevention of readmission or repeat intervention in a given amount of time is a key performance indicator for the digital therapeutics. While wellness tracking device, there can be a n number of uses, they can repeatedly use it, and there is a direct turnover of the patient. And digital therapeutics can be reimbursed by the insurance company, while wellness tracking devices are backed by the consumers themselves. There can be a various stakeholder in the digital therapeutics. There can be a IT industry, be a partner of it, healthcare provider, government sector, pharmaceutical industry. There are regulatory bodies, NGOs, of course, patient and philanthropic agencies are a part of dimension of digital therapeutics. So let's talk about digital diabetic care, how they are useful. So we must understand the need of digital therapeutics because the number of diabetic patients is rising every second, every day. And out of 88 million people with diabetes in the Southeast Asian region, 77 million people belong to India, and half of them belongs to rural India, where there is actual need of good quality care. So digital therapeutics provide solution for all the stage of diabetes. When patient is a pre-diabetic, they help them to self-tailor digital intervention program for reducing their weight, reducing their blood pressure, reducing their cholesterol as well as blood pressure. There are mobile apps, wearables for monitoring of progress and motivation. When patient is already diagnosed for the diabetes, this digital therapeutics with the use of social media app helps the patient for a motivation, adherence to the therapy, and improves the compliance. Decision support algorithm for glycemic target and tailored therapy can also be used for diabetic patients. They are also useful to tailor the clinical dosage of insulin and other medications. When patient is having some complication or they are long-standing diabetic patient, these therapeutics used for improved quality of data by including non-text field in the retinal and foot examination and define referral pattern and monitoring compliance. And when patient is already having some comorbidities with diabetes, this engagement of patient and healthcare professional in the same loop and target should be identified, written out and monitored. The digital therapeutics is boon for such patient because they need not to go repeatedly to the hospital and exposed to the unhealthy environment and waste their time and money both. So digital therapeutics and diabetic care, we must say person with diabetes need to make numerous daily decisions including diet, exercise, insulin dosage, and timing, while the therapeutics help them for electrical medical records, insulin pumps, sensor, glucometers, and other variables help in generating useful data, and multiple digital tool and app enhance patient compliance using motivational tool and incentives from social media and gaming technologies. Again, a COVID brings so many difficulties in our life, but there are some things that we should cherish. Because of COVID, the telemedicine and telediabetology is now officially allowed in India, and there are advantages of telediabetology in terms of they provide individualized health information, enhance decision making in clinical management, increase awareness on diabetes through education, facilitates remote monitoring and information delivery, available of diabetic care facilities at the doorstep of the patient, easily accessible, and employment opportunities is also there for the local population. Now, what are the evidence behind that? So this was the largest telemedicine study ever conducted for informatics of diabetic education and telemedicine project. And the result was at the 1 year of the follow-up, an improvement in glycemic control, blood pressure level, and total and low density lipoprotein cholesterol were noted. So yes, at the end of the 1 year, the telemedicine is effective in diabetes management. Again, smartphone apps are very frequently used nowadays. And the study was also conducted on 163 persons for type 2 diabetes who have uncontrolled diabetes. And the study showed that greater reduction in HbA1c with smartphone applications and clinical decision support by the use of the application was noted. This was also one other study where the smartphone app promote diabetes self-management education was evolved, and they found that it is very useful for the patient, not only for the blood glucose control, for also prevention of the complication. Video consultations are also effective in diabetic management, and the study on the 165 patients, they showed that video consultation proceed by uploading relevant measurements can lead to clinically and statistically significant improvement in glycemic control among persons who have not responded to standard regimen. So digital therapeutics, they help 360-degree from patients' data collection to data analysis to review the report and improve the outcome. Whether the patient are pre-diabetic, diabetic, already long-standing diabetes, already having some complications, these all are very useful. Now, when we merge the artificial intelligence in digital therapeutics, we can find that all three works together and help in devising a customized and more tailored therapy regimen for the patient with type 2 diabetes. And I must say that the average person with diabetes spends no more than 0.1% of their time in the course of an entire year discussing health matters with the medical professional. But when we see that how many times they spend on social media, there is so many times they spend there. So if we use the digital therapeutics with social media apps for encouragement of compliance of therapy, monitoring of blood sugar level, there must be so huge response in terms of good quality of life and good management of blood glucose level. Social media and peer-to-peer healthcare are very useful with the use of Facebook or YouTube or Instagram. And social interaction is very useful for motivation for not only type 2 but type 1 diabetic patients as well. But is this digital therapeutics and social media are available to everybody? Is it so easy? No, there are some barriers to use of digital tools for diabetic management and future perspective in the rural area. What can be the barriers? First and most important is technological constraint and quality aspect. Second, the patient must be literate to read and write and use the language where the applications are built on. Lack of basic amenities like mobile and internet, finance and unavailability, person's fear and unfamiliarity to the digital platform, and perspective for medical practitioners, because some doctors and some patients prefer only face-to-face interaction. At that time, this virtual healthcare may not helpful. And last but not least is support from the government bodies is required to more promotion of this virtual healthcare. Our team of RIMS, develop a digital connect program during the first and second lockdown, and we found a deconnect initiative where a team of RIMS and expert doctors and dietitians and physiotherapists connected to healthcare providers in the peripheral and rural area of our city, and they doctor treat their patient at their clinic. So one doctor to more than 100 patients a day were delivered a good therapeutic option and proper education conducted. So it was a deconnect program versus telemedicine. In telemedicine, there is a one doctor to one patient, but in deconnect program, we did a one doctor to patient. And by that, we can address a mass population with the use of digital therapeutics. And the benefits to the patient, that is the right care at right time, at right place. For the provider, they acquire a new knowledge, treat more patients and build community of practice. For the community, there is a reduced disparities among the medical fraternities and treatment protocols, retain providers and keep patients to a local system themselves. And for the system, there is increased access, improve quality and reduce the cost of the treatment. And because of this program, our RIMS Institute won a Best Diabetic Awareness Initiative 2021 award during Diabetes India 2021. So I must say that future of digital therapeutics is very, very bright. Newer therapy, including implantable drug delivery system, automated closed loop system for insulin delivery, and miniaturized non-invasive glucose monitoring system will be the future of digital healthcare for India. And new digital healthcare technology will create a digital diabetic ecosystem to enhance rather than devolve care from the humans. So take home message from today's talk is virtual healthcare and digital therapeutics help in improving communication between the physician and the people with diabetes who are separated by distance. Virtual healthcare and digital therapeutics address major challenges to improve access to healthcare, and digital data management help in improving glycemic control and reduce complications associated with diabetes. And this therapy is an effective, efficient, and unique method to help monitor symptoms, progression of diabetes, and treatment adherence, and by that prevent complication of diabetes. So with that, I will thank you all for your listening. And again, congratulations team of Global Diabetic Forum for a wonderful program. And our team RIMS is trying to cater more patients with the use of this digital therapeutic. Thank you so much.
Thank you, Dr. Vipul, for an excellent and wonderful talk. And it is really important for all of us to understand how the digital therapeutics will really play a part in the future care for our type 2 diabetes and type 1 diabetes patients. I, along with Dr. Rohit, chairing this session, and I request Dr. Rohit to introduce our second speaker.
Yes, thank you, Dr. Parikshit. So thank you, first of all, thank you, Dr. Raka and Dr. Ashish for allowing me to chair in this prestigious global forum. So next speaker, we have Dr. Amit Kumar. As you can see here, he's had a huge list of accolades. He's done his MD diploma in geriatric medicine and diploma MSc diabetes from UK. He's an internal medicine and diabetologist consultant. He's a consultant at Apollo Sugar Clinics, and he's a winner of Diabetes Awareness Initiative Award at Diabetes India Forum 2020. And he's been very active with a lot of active patient awareness camps and healthcare training activities in the field of diabetology for the last 6 years or so. And he's had various papers, presentations in national and international conferences. And his areas of core interest include obesity and metabolic syndrome, diabetes in the geriatric population, use of CGM in gestational diabetes, and of course, today's topic, that is use of artificial intelligence in diabetes care and precision diabetes care. So he's been associated on the research front with various AI technology partners. As all of us know now, this is the era of AI, where we have a lot of AI-based devices and technology interventions coming in, especially in the field of diabetology, for helping patients manage their diabetes better and better. Over to you, Dr. Amit, for the next session.
Thank you very much, Dr. Rohit, for the kind introduction. At the outset, I would like to congratulate Dr. Raka, Dr. Ashish for putting up this wonderful show, and thank you for giving me this opportunity, to talk on a topic which is very close to my heart. And please allow me to share my screen. And I understand we are running very late, so I would try to keep my talk very brief. Right. And I hope my slides are visible. So at the outset, I'm going to take you through over the next 10 to 12 minutes on the role of artificial intelligence in diabetes management. And we often use the word artificial intelligence. So I'll just try and dig a little deeper into what exactly artificial intelligence is and how we can actually make use of artificial intelligence into our daily practice. At the outset, let me make a disclosure that throughout my presentation, I will be talking about a few brands and few apps, but we do not have any financial disclosure with any of them. And my presentation is purely for educational and knowledge sharing purpose. So I'll be dividing my talk into 3 halves. And the first part, I will be talking about what is artificial intelligence. And this is very important for all of us to actually understand what the crux of AI is. Then we're going to quickly look on to the applications of artificial intelligence in diabetes. And then we can ask ourselves $1 million question. Will artificial intelligence replace physicians? Well, let's see what we have. So to introduce, we know that artificial intelligence is basically the ability of a computer to do things that would require intelligence if done by human. So AI emulates these aspects of human intelligence by the means of a number of tools. Artificial intelligence is nothing new. It just means more computing power, more data, more structured data. That's very important. And a better algorithm, the more we refine it, the better the algorithm gets. And of course, it opens up a new era of investment into healthcare. This is a very important slide, and I will just take you through it because, as clinicians, we often try to associate ourselves with this magic word called artificial intelligence, but very less number of times do we dig deeper into it and we look into it. How exactly is artificial intelligence helping us? So these are how the different methodologies that are there of artificial intelligence, which can be used in diabetes care. The one terminology is expert system in medicine. So that is a system with the ability to, capture the expert knowledge, facts, and reasoning techniques to help care providers in routine work. And there are 3 types which are often used. One is the rule-based reasoning, which is the very basic form of AI. Then you have the case-based reasoning, which finds a solution to new problems by adapting previously good solutions to a similar problem. So that's how it keeps learning. And the most important one is the fuzzy logic. And the fuzzy expert systems are used for representing in a computer understandable way expert knowledge that uses ambiguous terms. So it's not always 0 and 1. In fuzzy logic, there is somewhere in between the 0 and 1 binary inputs that they take for reasoning by the computer. And then, of course, this is a term that we have all heard about, that is machine learning. So machine learning algorithms are characterized by the ability to learn over time without being explicitly programmed. Machine learning draws on the results from AI probability and statistics, computational complexity theory, control theory, information theory, philosophy, psychology, neurology, and so on. So it keeps learning and it keeps adapting. That's where machine learning includes. And the algorithms which are used in machine learning are decision tree, artificial neural networks, genetic algorithms, and support vector machines. I know these terms are quite new to us, but as I take you through it, I hope we can be more familiar with these patterns of AI algorithms that are being used. So then there is another type called deep learning. Deep learning is nothing but it's just a new branch of machine learning, and it is based on the neuron behavior inside of the human brains. So it is basically an evolution of the artificial neural network, and it utilizes a hierarchical level of ANN to carry out the process of classification. The deep learning algorithms are particularly very powerful in the learning process and provides a high degree of intelligence to system based on them. So with this brief introduction, I mean, AI is a huge topic, but with this brief understanding and introduction to the different types of AI algorithms which are used and which would probably be used in future, in diabetes care, let us look at what are the current applications of artificial intelligence in diabetes care. And this is a summary as to where are the places where artificial intelligence can be used. One is diabetes prediction. The other is a lifestyle guidance for diabetes patients, which is the self-management applications. And our previous speaker just beautifully depicted that in digital therapeutics. Then, of course, is the most important part, the most important application of insulin injection guidance, that is the insulin pumps. And then you have the connected pens. Then you have the glucose monitoring devices, which is the CGM and the connected glucometers. Screening and monitoring of diabetes complication is a very important aspect where you use AI. And last is the precision medicine in diabetes care, which is the future. This is a brief overview has how these different algorithms you can see are being used into the different applications of diabetes care. And as you can see here, the support vector mechanisms are used in prediction of pre-diabetes and diabetes. So we can have a good predictive algorithm based on the geographical area, based on the epidemiological condition of that area. And then you have got the fuzzy logic, which can be used for going in to understand the blood glucose pattern detecting in pump sensors, which can used for closing the loop, and so on. These are the different methodologies which can be used in diabetes care. And deep learning and artificial neural network is more commonly used in the dietary guidances, in the patient management apps, and also in retinopathy assessment. The genetic algorithms are often used, and this is being under development in foot ulcer predictions. And we also see a role of decision tree algorithms in diabetes management, that is precision medicine. Now let's look at each of them one by one overview. First is diabetes prediction. So we are expecting that machine learning algorithms like support vector machine or logistic regression back trees, which can be used in the diabetes prediction model. And by using data mining from the EMR, various projects are already underway on these predictive models. And this is the way in the future that we can reach to precision medicine. So different assessment models for different races and ethnicity should be developed for accurate predictability. So imagine in a different geographical area with different ethnic background, we can have a different predictability model and different algorithms of precision diabetes care. And next is the lifestyle guidance for the diabetes patient. And this is something which Dr. Vipul kind of highlighted upon. And let me quickly take you through it. These are some of the lifestyle apps. And some of us are already using this for our patients, or our patients are already on it. So you see the diabetes lifestyle coaching apps using AI are bringing a paradigm change with an individualized approach. And there has been the Look Ahead trial, which uses machine learning to reanalyze data and confirm that type 2 diabetes patients can benefit from intensive lifestyle interventions. And there are various such apps like the Blue Star, MyFitnessPal, Glucose Buddy, Fudukate, etc., which are widely used diabetes lifestyle app across the globe. Let's look into the insulin pump, because when we talk about artificial intelligence and technology in diabetes care, you cannot get away, giving a little overview about insulin pumps. So these are the various types of insulin pumps which have been there. You have the basic insulin pump, and then you have the ones with the connected CGM, and of course you have the hybrid closed loop insulin pump. And this is the way how the Medtronic's insulin pump has, progressed, and they have developed over the years. And you can see the sensor augmented pump, the smart guard, which gets suspended on low, then there is the smart guard, which got suspended below low. And of course, now you have the smart guard auto mode, which adjusts for both the highs and the lows. That is the 670G system. And these are the components of this hybrid closed loop insulin pump, and you can see this is the model of the Minimed 670G, and it of course has got the Guardian CGM, which is with the transmitter. Then it has a one press Certer, and it gets connected to the CareLink system on the computer, and it has also got the connector called the Contour NextLink 2.4. So this is the component of the hybrid closed loop. And this is how the evolution has been. So from the manual mode standard pump therapy, you are having the Minimed 670G with the SmartGuard technology. Now the standalone or the sensor augmented pumps, it suspends on low or suspends before low, and that can be set in the pump based on the on the pattern of glucose pattern or the glucose variability pattern in the patient. And of course, you have the auto mode, which is the hybrid closed loop model, which is the sensor augmented only pump, and that regulates the basal delivery through the algorithm dose every 5 minutes, and even the patient boluses for meals and correction, and that is very important. That is almost close to closing the loop. And this is the newest model of the Minimed 780G, which is probably yet to be available in India, but this is something that we are all waiting for. This is almost closing the loop. So the 780G automatically adjusts the basal insulin rate every 5 minutes and supports the selection of a lower target than the 670G. The system will have fewer alarms and be easier to use, and it targets a TIR of about 80%. And the pump is also Bluetooth enabled, hence it's easy to connect with the smartphone. And this has been the evolution of almost closing the loop for the Medtronic's insulin pump. Now let's look into beyond the insulin pump. Let's look into something called smart insulin pens, because we are all used to using smartphones. So can we have a smart insulin pen? And they already exist. So you have the connected pens, which will integrate the data via app recommended and titrate the dose advice. So there are two models which are available. One is the refillable insulin cartridges with built-in wireless communication abilities and sensor to track the insulin delivery. And then you also have the disposable pen with sensors in the form of smart caps or attachments. These are the two types of smart insulin pen which are available. One is the InPen, and the other is the NovoPen 6 and the NovoPen Eco Plus. Now you see the InPen is an FDA approved smart pen. It is acquired by the Medtronics. The app helps track insulin doses and glucose levels. And the app also has a bolus calculator, which prevents the insulin stacking. So this is very helpful. These smart insulin pens are very helpful for our type 1 diabetes patients, especially the young ones, the adolescent age group ones, where you can actually guide them. Then again, you can see the NovoPen 6 and the NovoPen Eco Plus comes with an electronic display which shows the amount of active insulin, the size of the last dose, and the time of the last injection, which is very, very helpful to the patient. And it's compatible with long and short-acting insulin. And the most important, especially helpful for the type 1 diabetics, is that it has the dosing ranges from half a unit to up to 60 units. And that would really be helpful to our patients. Beyond smart insulin pens, we also have got continuous glucose monitoring. And this is a part of the technology that we are all using. These are the three types of continuous glucose monitoring which are available. You have the Medtronic Guardian Connect that is connected often with the insulin pumps. And you also have the Freestyle Libre Pro. That is something that we're all familiar with. We all use. And we have for our patients the Freestyle Libre. And you can see here the Guardian Connect is actually the first AI-enabled real-time continuous glucose monitoring. It uses a predictive algorithm that alerts the patients significant swing in the blood glucose levels up to 60 minutes prior to the event. And that is fantastic for a patient. It uses the Sugar IQ Insight technology, and it continuously analyzes how a patient blood glucose level responds to factors like food, insulin, dosage, and daily routine. And that's where we come to the individualized care for our patient. And then, of course, we have the Libre Pro, which is the blinded professional CGM that we all use. And it is a 14-day record. And I'm not going deep details into it because this is something that we are all familiar with. The Freestyle Libre is very important. This is now there available in India. It's an intermittently scanned CGM device. It measures the glucose level continuously, but only displays the value when swiped by a reader. The next version is the Libre 2, which is also an integrated continuous glucose monitoring. It can be used as a part of the integrated system with other compatible medical devices software or electronic interface. Libre 2 has a customizable audio alarm, which alerts the patient within a minute if you're too high or too low without even having to scan. That's the advantage that will come with Libre 2, but this is again yet to be available in India. The next is the connected glucometers, and this is something which has brought a lot of change in the lifestyle apps. And this is one of the connected glucometer app. This is the My Sugar app, which is connected to the AccuCheck. And you can see here how the dashboard of the My Sugar app looks like. So these are the things that the patient gets to see. They get the bolus calculator, their blood glucose graphs, they can get their estimated A1C, and they get their point in range also. Once they put on their, they are connected to the My Sugar app, their AccuCheck values will come in their app as the points in range. And then you have the One Touch, which gets connected. So the One Touch VarioFlex has got connected to the One Touch Reveal. So this is also another way it gets connected. And you can see these small dots, in the reports wherein the patient gets their point in range. So beyond, actually, we can use the connected glucometers to look at the glycemic variability, the inter-day and the intraday glycemic variability in our patient. And all these can be used with the help of artificial intelligence and technology. The next important part, and again, something that we are already using into our clinical practice, is diabetic retinopathy. And why it is so important to have the use of AI in diabetic retinopathy is because of this. Because 2019, there was a data that was published that goes on to show that the prevalence of diabetic retinopathy in India is 16.9%, and that is quite large. So where is the problem? The problem is the diabetic retinopathy is known to cause moderate to severe visual loss. And trust me, these AI-enabled diabetic retinopathy algorithms are very good in detecting the sight-threatening retinopathy. That's where they come, that's where they stand out. The health burden is accentuated by the huge capita cost. And we know that this has further increased since the introduction of the anti-VEGF injections. And most important is that disease does not show overt symptoms until it reaches an advanced stage. However, if it's detected early on, vision impairment can be averted by early intervention, which is also the most cost-effective option. So where is the problem actually? The problem is, the barriers is the primary issue is the grading of the retinal images by ophthalmologists or the trained persons whose numbers are very scarce compared to the load of patients which require screening. And the second problem is some of these patients are based in the rural areas and they can't get the eye care provider. Third, such follow-ups which are required for years, the attitude, the behavioral aspect, the accessibility to healthcare, all these make a negative impact into getting access to our ophthalmologist or retina specialist on time. So that's where artificial intelligence solution comes into play, where such limited created an interest in assessment of the images using fully automated AI-based grading system. And in real time, the system would decide whether a patient would require referral and could potentially be much cheaper. It comes in much cheaper. And what it definitely does is that it definitely distinguishes from the sight-threatening retinopathy to the other types. And that's where it can help you in screening, and it aids you in early referral of these cases to a retina specialist on time. So finally, in April 2018, the US FDA approved the AI algorithm, which was developed by IDX to be used with the Topcon fundus camera for DR identification. How does these AI algorithm use? They use that artificial neural network. So that is deep learning. So deep learning has shown to identify diabetic retinopathy or even diabetic macular edema in the retinal fundus images with very high sensitivity and very high specificity. And most of these studies have reported sensitivity of automatic DR screening ranging from 75% to 94%, and the specificity accuracy is also comparable. Now, these are some of the AI reported images which I use in my clinical practice, and I'm sure most of us are using this. And this is an image which is captured by a non-mydriatic handheld camera, which is a single 40-degree retinal image, and the report was generated by machine learning. Again, this is the commonest one that is used by most of us is the image captured using Remedio, which is a smartphone-based camera with autofocus. And you can see here the shaded portions are the areas which could be an area where there could be a microaneurysm, or there could be some NPDR images there. So the report shows AI showing 97% accuracy according to their study. And this is from my personal experience. I have found them to be very effective, because they not just pick up the the cortical spots and the microaneurysms quickly, but they also grade the retinopathy. And these are the images captured using a non-madriatic autofocus camera. And this has been reported using the AI developed by a company called Artelius. And this is how their report looks like. So you can see, based on AI, they are grading the images into various categories as mild NPDR, moderate NPDR, severe NPDR, and PDR. But what it definitely does is they have 100% sensitivity and specificity in differentiating from NPDR from PDR, and that's very important. A sight-threatening retinopathy does not get unnoticed by these AI-based screening. So early referral is always helpful to us. Quickly, I'll move on how AI can be used in diabetic foot care. And you can see here, this is an AI-based smartphone camera system which enables individuals to take active role in daily wound care, and especially during this COVID pandemic. This is something that would aid our patient, which would potentially accelerate wound healing, reduce travel cost, and overall health expenditure. And the researchers are also working on a low-cost thermal imaging system that can quickly assess the diabetes patient's risk of developing foot ulcer. The neuropathy foot scan, which we often carry out in our clinics, this is how the thermal imaging looks like when the patient comes to us in our clinic, and you take a foot scan using this kind of a Podia scan machine. And this is also something that is graded using technology and artificial intelligence. And this is the most hyped point in diabetes care, that is precision medicine. And, we've talked about the use of CGM and technology in gestational diabetes. And you can see here, there's already the use of artificial intelligence in gestational diabetes. And as early as 2018, NHS had adopted AI app for gestational diabetes. And as it goes on to read here, the NHS had adopted a software system from Sensign Health with an aim to helping manage gestational diabetes in their patients. This is an example of how we are using technology. This is an example of one of my patients who has been visiting to us. And you can see this patient, this is an example how we titrated the insulin and how we took away the inertia of the patient. You can read the text here. The patient was kind of a little apprehensive about whether they are going to get hypoglycemia or not, and they texted us back on the app, and we assured them just keep snacking so that you can control your levels. This is again an example of a
sorry to interrupt.
Yeah, I'll just conclude. I'll just conclude. I've just got 2 more minutes. Yeah, so this is an example of a 27-year-old primary gravida who was detected with GDM in April 2021. And the patient started with an A1C of 9.6. And with the help of our app-based technology, we brought the blood sugar down with the point-in range, which the patient kept sending to us. And the patient got their A1C down in the period of pregnancy. So beyond CGM, there is a role of technology using point-in range, using SMBG. We can help our patients in GDM. A quick note on precision medicine, that is the use of AI in EMR. And I think this is the way forward, where data would be collated and that would be transformed into a usable action with valuable outcomes. And to come to the last part, that will AI replace physicians? Well, machine learning represents a shifting clinical paradigm from the rigidity-defined management strategies to data-driven precision medicine, and that is where we are heading to in future. Healthcare professionals will require adequate training to operate AI-based model, but we must accept AI with its limitations. Otherwise, it would be de-skilling the profession. So will AI intelligence improve our diabetic population? Yes, AI will definitely help our clinicians to make more informed decisions using precision technology with the help of results derived from various analysis. And what we are looking at in future is deep medicine. And that is, I guess, what we're looking at the addition of AI into our daily practice to help us take better clinical decisions. And I think with this, I'll end my talk, and we can take up the questions later. Thank you.
Thank you, Dr. Amit, for a very informative, wonderful session on AI. A lot of interesting topics. I'm sure attendees would have questions we could discuss later on. We can move on to the next session. Over to Dr. Parikshit to introduce our next speaker.
Thank you. It was indeed a wonderful talk, Dr. Devya. Yes, I am really enlightened with your talk and how this artificial intelligence will really change the paradigm in the management of diabetes. And now we are moving for a third talk for this session, and very eminent, very emerging, and very enthusiastic diabetologist, Dr. Bharat Sabu, whom I had met just a few days ago at Ahmedabad and at Mumbai. Is a chief diabetologist and director at the Prayas Diabetes Center Indore, and he has a list. I think so it will not end, and I think so everybody knows him. And he's a master in putting a paper at most conferences, and one of the best oral poster in IDF 2021, and one of the top 20 papers in ESE 2021, and won the third prize in the oral paper presentation at Diabetes India 2021, best oral paper as a co-author at RSSDI 2020, winner of RSSDI USV Award for Innovation in Diabetes Care, author of a book titled Diet Therapy, working on to develop AI-based model for precision healthcare delivery in diabetes. Over to you, Dr. Bharat, for dealing with smart ways to extracting useful data from EMR for healthcare. Over to you, Dr. Bharat.
Thank you, Dr. Parikshit. Thank you for the kind introduction. And I would like to thank Dr. Raka sir and my dear friend Ashish for giving me a topic which is very close to me. So data is something which I always look up at, and I'm really thankful to my chairs also for introducing me well. Thanks a lot. And I hope my slides are visible to you and I am audible to you.
Yeah, perfectly fine, Dr. Bharat. Please go ahead.
Yeah. So the topic which has been given to me is smart ways. What are the smart ways where we can extract useful data from EMR for the healthcare? So the topic is really vast because technology is immense and infinite, but I will be sticking to the time because we are already running late, and let me guarantee you I will finish in less than 15 minutes. So the learning objectives which we have today, my talk are to describe why data extraction is important, to identify challenges in data extraction, what are there, to describe the general layout of a data extraction form, and to suggest the method for collecting data accurately and efficiently, because data is the fuel which runs AI, digital therapeutics and everything. And then to discuss the pros and cons like any other thing for querying the original authors, and in the end, the key messages, if there are any. So what I would be dealing with first is the importance of data analysis. And at the core of healthcare transformation, we all know there is a data-driven quality improvement, because data is actually changing the way we are treating our patient, and a lot of quality changes are coming with the help of data in our day-to-day practice, and we are making our practice more cost efficient, I would say, and efficient as well to the patients. As my previous speaker, Dr. Amit Dey, has told us about the thing related to precision medicine. So that will be not my talk, and I will be talking about why data extraction is important. So why data is important? Because to summarize studies in a common format and to facilitate synthesis and coherent presentation of data, we need data. And again, we need data to identify numeral data for meta-analysis of anything. But then we again need data to assess the risk of bias if it is there. And then again, we need data to identify systematically missing or incorrectly assessed data, because a lot of data is incorrect. So we again need data to assess what is wrong in it. And outcomes that are never studies, because we are dealing with diabetes, and every day we deal with something new in diabetes. And we can help underrepresented population also with the help of data. That is why data extraction is very much important. People also call it data mining. So data mining is again the term where data extraction is involved. Now the extracted data or the mined data should have three characteristics. It should accurately reflect the information to be reported. It should remain in a form which is close to the original reporting, so that the dispute, if there are any, can be resolved. And it should importantly provide information which should be sufficient to understand the study, because a data which is not giving the sufficient information is not of any use. Now the extracted data is needed. Why? Because and it is to extract data, it is a very labor intensive process. So we need to extract only the data which is required, because it can be costly also. And if we are extracting too much data, we are prone for errors. And different research questions, because we always work by the research questions, so they may have different data needs. Suppose we require data for fasting, then we should extract data only for fasting. We should not go on collecting each and every data out of our data sheet. Now on data extraction, what we should do, it involves more than copying words and numbers from a publication to a form, because we need to employ logic to it, which we need to do. Otherwise, we will be having too much of jargon data, which we will not be able to use. It should be in clinical domain. Methodological and statistical knowledge is needed. It is very much required to ensure the right information is captured. The interpretation of published data is sometimes needed, and the reported data is sometimes it is not what was carried out. So something we are having different what we intended to. And it also has a risk of bias and applicability typically occur, which occur at the same time. So these are the things which we need to deal when we are doing a data extraction. So it makes data extraction a very boring task. People find it very boring because as it has been quoted by Gurvich and Hedges, it is an eye-opening experience to attempt to extract information from a paper that you have read carefully and thoroughly understood, only to be confronted with ambiguities, obscurities, and gaps in the data that only an attempt to quantify the result reveals. So many a times we find those papers where we have very ambiguous data, obscure data, and there are various missing links in data. So all these things make the data extraction part very, very, very boring. Now, what data to collect? We should stick to the question, the research question. Key question and eligibility criteria should be the guide for extracting the data. We should anticipate what data summary table should include. We should anticipate in our mind to describe the study, to assess outcome, to have a risk of bias and applicability, to conduct meta-analysis. That is what we should have in our summary table. Best is to use the PICOT framework. PICOT stands for population, intervention or exposure, comparator whenever it is there, outcome, what is there, timing of the study, and the study design. If we are going by this PICOT framework, we will extract a wonderful data out of it. So data elements, population, intervention, and comparator, when we see, it can include patient characteristics such as age, gender distribution, and disease state. More specific items may be needed depending upon the topic. Intervention or exposure and comparator items depending on the extracted study. And study type may include the type of the study, which can be randomized trial, observational study, diagnostic test study, prognostic factor study, or it can be a population-based genetic study. So the type of study depends on the study which we are doing. Now the outcome should be determined with the help of a technical expert panel. We should be clear about what outcomes we are looking at. The criteria are often unclear about which outcome to include, because if we don't have a proper outcome and we don't know what to discard, we can have a lot of data with us. Example, we want to see the mean change in HbA1c, or we want to see the change in PPG, or suppose if you want to see the change in both. These three scenarios demand different data sets. Recording of different definition of outcome again creates a decision bias, I would say, in the front of experts, because then two people can collect different data. Now regarding outcome, apart from definition setting, quantitative data are also needed for analysis. There are death, patient with at least one hypo, or the count data, which can be number of hypos, counting multiple ones. Then there can be continuous variables like blood pressure, pain score, survival data can be there, and correlation data and slopes are there. So the study design and timing is also important in collecting the data. The data elements to be extracted because they vary by the type of study. And consider collecting this information when recording study characteristic for randomized trial. Whenever we are doing, we should always mention number of centers if it is centric study, method of randomization, what we have done, blinding techniques, what were used, funding sources, and whether to not an intention to treat analysis was used. This is usually lacking in many of the data which we usually see. Now, we should always provide instruction. We should provide instruction to all the centers which we are collecting data from, to have an operational definition of, first of all, outcomes and what should be extracted. All the data which are extracted should understand the operational definition in the same way. They should not interpret the operational definition in their own ways. So we should make clear that everyone is understanding what we intend to get the data for. Then pilot test forms or of several published papers should be made available to the people so that they can see how to extract the data effectively. Then we should encourage communication in between groups through various means of communication to clarify even those questions which we find mundane but may be important for the study. Again, there is a technique of a double extraction. Double extraction means there are two people which are extracting the data out of the data sheet, and independent extraction is done by both of them. So this is a trade-off between cost and quality of data extraction, because the cost definitely increases, but the quality improves. Or reduction in the scope of work may be necessary if independent data extraction is desired. And a single extraction, if done carefully by experienced reviewer, is equally beneficial. But to remove the bias, if it is better, if we are able to do, we should go for a double extraction. Me and you can share our Excel sheet of data and we can extract data for each other, and that will simplify the process and remove the biases. Now, developing data extraction form. So data extraction form should be developed to address the need. A generic data extraction form should be done. There are common generic elements, but we should include the form elements which are adapted to each topic or study design. There should be a separate, I would say, form for every study. Then organization of information, as I have told in the PICOTS format: population, intervention, comparator, outcome, timing, and setting. So it is highly desirable. Then we should balance the structure of the form with the flexibility of its use. Anticipate the need to capture the unanticipated data. We should also look for the unanticipated data, because many discoveries are made when people were not looking at it. So we should not ignore the mundane data also. We should use an iterative process and have several individual tests in the form of multiple studies, so that our data quality remains ensured. Now, what are the problems which we can have? Forms should be constructed because it is again a tedious job. An original field may turn out to be inefficient. Then we need to again rectify our form. And the extractor who is extracting the data should be thorough as possible in the initial setup. Then he should be able to reconfigure the table if they are required to. And a dual review process to fill in the gap should be encountered with the data extraction forms. Now, this is the example of evidence table. First draft was created. Study description, study design, inclusion, exclusion criteria, baseline characteristic and outcome. And then in the second draft, the study description, inclusion, exclusion criteria, population and baseline characteristic was again restructured. So first draft may look good, but second draft can be better. So we should always have a scope for improvement in our data sheet if we want to have a better data mining. Now the final draft will look something like this, and we can have that incidental findings also, which we were not looking previously. So this is again a bonus if we can find something which is not intended for. Now, what are the common problems? Lack of uniformity amongst the outside investigator. This is a very common problem because everyone behaves in a different manner, and no matter how clear instructions we give, data will not be entered identically. And many a times we are relying on our staff, which is not trained properly, so they don't put the data in the proper format. Solutions are to develop an evidence table guidance document which can show that what to enter where, and then limit the number of core members so that what we are dealing with should be in hands of a few people who are very experienced to avoid the discrepancies. Now, sample fields from a table guidance document. In the country setting field, data extractor should list possible settings which can be encountered in literature, academic medical centers, community database, tertiary care hospital. This is just an example. So you can have.
Bharat, sorry to interrupt. Can we finish within 2 or 3 minutes? I'm extremely sorry to interrupt you.
I will. Don't worry. Thank you. So in the study design field, data extractor should list one of the following, and randomized control trial or the trial or the study pattern should be evaluated and mentioned. Now, the two investigators extract different data. That is the bias which is there, which I was talking about. So what are the tools available? Pencil was previously available. We have Microsoft Word, which can help us. Microsoft Excel, Microsoft Access, EPI Info are the software which are there. Dedicated off-the-shelf commercial software are there. Then homegrown software can be used. Now extracting, who should extract? Domain expert can do versus the methodologist. What method should be used? Single or double independent extraction depends on the quality of extraction. And should data extraction be blinded? It depends on the author or the journals. Now challenges. There are problems in reporting, inconsistencies, and data must be reported in graphs, which creates a problem. So why does this problem exist? Because few research reports given effect size and normal deviation, p-values. People don't know these things, and little calculation is automatic, and most of the calculation we need to do by feeding the data in. So this creates ambiguity in data. Now, other common issues are missing information and partially overlapping patient subgroup and fraudulent data, which is a very common problem. People put what is not intended to put, or they don't do it and they put the data in. So the pitfalls are data extraction is laborious and tedious. To error is human. Data extractor will identify error and will err themselves. Interpretation are subjective and unavoidable. Data is not reported in a uniform manner. So the data extraction or the key question will be a guide in extracting the proper data. There is no single or correct way to record the extracted data. We need to formulate our ways. It requires familiarity with the content, so an expert is required, and we should be persistent. We may fail one time, but we should be persistent so that we can extract a meaningful data. We should be comprehensive in collecting the data. We should also cover the question what is intended in the study, and inconsistencies which are there, they indicate the suboptimal reporting quality. So we should deal with it. Thank you.
Thank you, Dr. Bharat. It was really an eye-opening session from you. Everybody really want to jump into the research actually, but unfortunately, how to extract data it's a big question in front of us. Already we are running short of time, but one question that lots of doctors now using EMR. What is your practical tip to all of them to extract the data from their EMR actually? Okay, whether to do by own or whether one should hire the agency, and how to do. Okay.
Dr. Parikshit, it's a wonderful question. First of all, thank you for this, because what I have found in my experience, the biggest problem with data extraction is we are not putting the data in. If we don't have something in, how we can extract it out? So the form fields which are there, they should be, they are actually very extensive, but due to lack of time, we should be practical. We are not able to fill all the form fields. We should make a habit of our staff filling all the form fields, because I have told you in my talk also, even a mundane data can give out something which is very new in the field of research, and new research is picked up like anything. So we should not let the form fields be empty, first of all. Secondly, regarding data mining is again should be in the hand of experts. If you are not well versed with the SPSS and other softwares or the Excel, you should go with agencies. There's no harm in going with agency, because if you are not extracting your data, it is like you are having a jewelry box in your home which is buried deep in the sand and you are not getting it out. So it is of no use actually.
Okay, fine. Thank you very much. Over to Dr. Rohit for introduction of our next speaker. Thank you.
Thank you, Dr. Parikshit. Thank you, Dr. Bharat. It was a wonderful session. It's quite useful for budding researchers like us too. Thank you. Over to the next speaker, Dr. Ashish. As you can see, the list of accolades Dr. Ashish has. He's MD Medicine. He's got a diploma diabetes from UK, from Cardiff University, UK. He's also having a CPS diabetology from All India Institute of Diabetes, SLRage, a hospital, and he's got a postgraduate certificate course in diabetology from Boston University, Cleveland Clinic from Italy, and he's also got a certification course in diabetology, ADA. He's got a certificate course in evidence-based diabetes management, BHFI. He's also got the certificate course in management in thyroid disorders, diabetic foot management. He's organizing secretary for Jabalpur Diabetes Update, Jabalpur Thyroid Update, and MMRF Insulin Workshop. He's the president of API, president of Jabalpur Endocrine Society. He is the organizing secretary for RSSDI MP Chapter 2020. He's the vice president for RSSDI MP Chapter. He's honorary secretary and founder of Mahi Medical and Research Foundation. He's a member of American Association of College of Endocrinology, Endocrine Society of India, API, IMA, RSSDI, ITS, Diabetes India. He has a number of awards and recognition. As you can see here, he's received the RSSDI Fellowship Award for 2020. He's received the Best Diabetes Awareness Initiative Award at RSSDI 2014, Diabetes India, Best State of Art Diabetes Food Clinic Award too. Over to you, Dr. Ashish, for your topic.
Thank you, Rohit, for your kind introduction. As I am having my bad throat, I will try to finish the talk in 5 minutes. And thanks a lot to Raka and
Ashish. Don't stress, yeah. This is pandemic time. I wish that your health should be. We will move on. You are a renowned speaker in our forum, and you're our great friend. Don't stress too much. Your throat is very
Thank
bad.
you, Raka, for inviting me here. And point of care testing, I will finish in 1 second. That it is the test which we can perform in our clinic at the patient side. What advantage we have is the time which we save, because many patients are coming from far away. So it is a test. Point of care test is very important in our diabetes clinic. It will save your time. It will be advantageous to patients, and it will give you a quick result for preventing of future complications. Thank you. Thanks a lot.
Yeah, Dhingra sir. Ashish, thank you. Really thank you for coming up, even though your throat is bad. And real thanks, Bharat, for such an interesting talk which you have given, and Dr. Amit. The eye-openers of everything. Over to you, Chairperson. I just wanted to thank Ashish personally.
Thank you.
Thank you. It was indeed a great session, and really, Dr. Ashish has made this conference, and how committed he is actually, and he will be the next leader in the field of diabetes that everyone know. Dr. Bharat Sabu is one of them. So I think so. We do not have too much questions. Dr. Rohit, have you had any questions?
Just before we close, I just have one quick question to Dr. Amit. That was a very interesting session on AI, but a quick question, Dr. Amit. So you are speaking about the 780G and the 670G, and the 780G is the next evolution in the insulin pump and the artificial pancreas. So what is the specific difference in terms of the automation? How far is it closed loop? I mean, how far is it a next step in evolution as compared to 670G? Is it that the bolus is also automated, or what is the exact difference?
Yes, so the 780G actually comes with the automated bolus actually, and that's where actually it uses the AI in kind of deciding the dose when it's high as well as when it is low. So that's when it is to suspend when it is high, and when it is low, as well as when it needs to be given when it's high. So that's where it works in closing the loop. But the advantage with the 780G is that it is also linked with this Bluetooth enabled, so everything can be kind of mapped into the smartphone of the patient. I think we will get to know about more features of this. I mean, this is what it says in the in the display of this in their website. But once we get the pump coming in, what I feel, it was supposed to be launched in January, I think. But so far, I don't have any news whether it is launched in India or not. But I think once we get that pump coming on, I think we'll get to know more about it.
Got it. So probably based on the ISF and the calories that the patient puts in, it's able to calculate the bolus.
Yes, so that would be almost like closing the loop. Yes, almost like an artificial pancreas, that as close as you can get.
Okay. Thank you, doctor.
Thank you very much. We are running short of time, so thank you very much once again giving us an opportunity to participate in this wonderful virtual conference. Next session, over to organizers.
Thank you, Dr. Parikshit and Dr. Rohit, for nicely conducting the session, and thank you all the speakers for your nice presentations. So that concludes our session on smiling with technology. And for the next session on mental happiness, I would like to invite our chairpersons, Dr. Jimit Badgama from Surat and Dr. Susil Patel from Vadodara, to conduct our session on mental happiness. So over to you, Dr. Jimit and Dr. Susil.
Thank you. First, Dr. Anubha, because Dr. Vitul will be joining after Dr. Anubha.
Yeah, thank you. Yeah. Okay.
So we
have
Dr.
Anubha Srivastav. She is holding the 4 gold medals and 22 certificates of honor in MBBS, ECP Wellness Award in the 2021, Dr. S.S. Rastogi Memorial Award, ICN Award in the 2021, and there are so many awards to net, so we are wasting the time handing over the session to her. She's a professor in the Department of Medicine, MLM Medical College, Prayagraj. So over to you, madam, for your talk. Yeah, thank you for the nice words and kind introduction. Without wasting my time, I'd like to start my slides. I would like to thank the organizing committee for including me in such a session, and specifically to Dr. Ashish, who actually we really talked about what needs to be talking on a forum, and specifically including me on the mental wellness, or I should say mental happiness. In next 15 minutes, I'll be trying to stick to time. Yeah. So we'll be talking today on 3 Ds, what we diabetologists needs to remember. As we are all aware, 50% of our psychiatric illnesses are unrecognized or untreated by all the patients who are suffering from diabetes. So if we talk about depression, it's one of the common illnesses affecting around 340 million people globally. 1 out of 20 adults is suffering from depression, and specifically the elderly, it's 1 to 5% who are depressed. If we see the Indian data, it's a common disorder, around 9.1% data, which is available of 2001 World Health Report. Over 3 decades, if we see, depression is just next to heart disease, being a global burden of diseases. So everything has a definition. Definitely for a disease like major depressive disorder, we need at least either of 2 criteria, that is depressed mood or anhedonia, that is loss of interest or pleasure during 2-week period, along with 4 criteria, which we all are aware, the DSM-5 criteria, which I'm not enumerating. As you can see, the cognitive symptoms as one of the 9 diagnostic criteria, that the concentration difficulty, diminished ability to think or concentrate, or indecisiveness. If you just recall in our day-to-day practice, we being physicians, seeing patient, most of the patient, they do complain that they have started feeling forgetfulness, or they just feel like they are having decreased memory. So these are not dementia per se, but they can be part of the psychiatric illnesses co-liaising with the medical problems. They are not very uncommon. Though we, at times, we may miss the subtle signs. A word about dementia. We are very well aware that around 6 to 10% of our population of more than 65 is suffering from dementia. And in future, if the predictions see, Asia can be a biggest hub for the dementia over the world. It's a group of symptoms that affects memory, reasoning, and mental tasks. It's a chronic disease with a progressive cause. Only 2% of people suffer from dementia under the age of 65, and the likelihood doubles every 5 years. It's basically a clinical diagnosis. No diagnostic or biological parameters are required to diagnose. It's basically affecting the 3 areas of the brain: the decision-making, language, and memory. The types of dementia can be classified. It is usually the brain atrophy, which can be seen on the radiological investigations. We are talking on a diabetic foundation. We ourselves are very well aware that it is the next epidemic. We still are not out of the present pandemic, and the non-communicable disease, diabetes, is another pandemic which is just around the corner. Diabetes, as we all are aware, 1 in 11 have diabetes, or 1 in 10 nowadays. Worldwide, the incidence of diabetes has doubled in the last 2 or 3 decades. Dealing with mood or cognitive status may sometimes feel less important in this major challenge of long-term health planning. Is it? Let me take you to the lane. The association between depression and diabetes. The 3 conditions, dementia, depression, and diabetes, they are highly prevalent in older people, and they most likely they are interrelated, saying it to be a triple D. Depression in its various forms is the most common affective disorder in the elderly. They usually have a synergistic cause and may be one of the risk factors resulting in dementia. Maybe the patient may not be classified as a major depressive disorder, but diabetic patient, they may have a diabetic distress. What is it? It is not only common, but can significantly affect a patient's self-care in addition to proper blood glucose measurement, medication, and nutrition, including physical activity. The set of symptoms include fear, anxiety, sadness, which are triggered by patients' negative experiences of diabetes. It is actually a bidirectional relationship. If you see the presence of psychological, social factors, as per se a patient is depressed, or because of hyperglycemia, the feeling hopelessness, worthlessness, along with negative feeling may definitely decrease the diabetes self-care and strategic insulin restriction. This is one way to look at it. Is it only a psychosocial problem, or there are any neuro or a brain metabolic connect? Depression increases the risk of diabetes between 1.6 to 2.5 times, and nevertheless, diabetes increases the risk of depression by 1.2 times. Any newly diabetic individual, you come and see, first is the neglect, he cannot have it. And then it is actually the features like maybe हो सकता है. So it requires a lot. I said a distress can be created. Let's see what the biochemical or biological mechanism could be. If you see this common soil hypothesis, the genetic background, the inherited factors on the acquired lifestyle risk, with these various psychological and social factors, they all affect both the disorders. I'm talking about the hypothalamic axis dysregulation. There are counter-regulatory hormones. There are neuronal like serotonin, noradrenergic pathways which are being affected. This causes dysregulation. There has been studies which have shown there has been reduction in the size of the brain matter of the temporofrontal areas, the inflammatory region. So it's just not a psychosocial abnormality, but definitely a neuro degenerative decline may be one of the risk factor. This comorbidities of depression and diabetes may be a risk factor for development of dementia earlier in the population. Depression is very common in Indian subcontinent too. The prevalence rates ranging from 2 to 84%. Type 1 diabetes, it is around 2.7%, and type 2, a major chunk of 8% to 84%. So this, we are talking about the bidirectional relationship. 15 to 20% of people with diabetes will develop clinical depression, while depression is 2 to 3 times more common in people as compared without. So this is a continuum process. Depression and diabetes independently has been associated and has caused complications and comorbidities as per se. So if we compare the physical and mental health between diabetic individual with or without depression, it has been shown the ones with diabetes and depressive symptoms have a worse prognosis as compared to the without. Diabetes is associated with all stages of diabetes. If you see, there are lots of data which suggest that the depression is associated in pre-diabetes state, and is that the hazard ratio increases and may lead to mortality even. The synergistic interaction between diabetes and depression results in decreased metabolic control, higher incidence of micro and macroangiopathic diabetic late complication, and decreased quality of life. This comorbid depression and diabetes can increase the mortality risk, as shown by the Hunt study, which is around 2 to 3 times increase in mortality, not only increase, but also linking to rise in self-harm. Insulin, which is one of considered to be a high-risk medication, has been used as a suicide attempt even. So the management can be the cognitive behavioral therapy, the medication of both the diabetes and antidepressant medication, the lifestyle modification. The choice of antidepressant should be safe on cardiac and metabolic profile, should be with a drug-drug interaction. The patient is already on medication with minimal sedation and sexual dysfunction. SSRI seems to be safer than the TCAs when we consider the co-liaisining and their association with effect on cognition and mood. Should be considered. Our own college, where we were talking about the association of diabetes and depression, which was seen by the Department of Medicine and Psychiatry. Not only the co-liaisining is seen in the patients, but also to the healthcare providers. Talking about the diabetes and dementia. In type 2 diabetes, there's increased type 3 disease, diabetes, which is associated with Alzheimer's disease, is also known. Depression is more common, not only in Alzheimer's, but much more in dementia with Lewy bodies. So talking about the pathophysiology, there is a continuum of metabolic disruption, the vascular damage, the neurohumoral effect. Also, hypoglycemia can cause cognitive decline, and vice versa. Dementia may too make patient uninteractive and promoting to cognitive dementia. Talking a bit about neuroimaging, as I was previously talking about, they may affect the regional or global cerebral volume depletion. Decreases in gray matter has been seen in the hippocampal area, the temporal and the frontal regions. The studies have their association between earlier onset of diabetes and subsequent risk of dementia. Talking about the trio, diabetes, depression, and dementia stem at least to a significant degree from a common, treatable, usually preventable, and often reversible physiological source, that is the insulin resistance. Quite a lot of literature suggests that depression and as a risk factor for dementia in patient for type 2 diabetes, the effect of depression and diabetes and their progression to dementia, not only in type 2, but depression in type 1 diabetes and risk of dementia. We've been discussed the pathophysiology. They're talking about the brain and the metabolic neuraxis. A relationship J-shaped curve has been known. The diabetes and depression together accelerate cognitive decline, increasing the risk of dementia. The relationship between the glycemia and cognition is controversial. There is a linear relationship in non-diabetic subjects. That is, higher the blood glucose, the greater is the loss of cognitive impairment. But in case of patients with diabetes, I will be referring it to be equivalent to be a honeymoon period which a patient of diabetic face. The period of blood glucose control may show greater deterioration in the cognitive impairment. This could be explained by the role of hypoglycemia. So it's very essential that we not only need to address hyperglycemia, but also prevent episodes of hypoglycemia. Diabetes is associated both with depression and dementia, and seems logical that triple association is frequently found in elderly patients. The existence of this triple D will carry prognosis in the patient and will force a global approach to them. The clinical implication on diabetic patient, what does it mean? Because we are having dementia in a patient earlier than 65 years of age. There seems to appear reduced physical activity once the patient is demented and depressed, impairment in diet, non-adherence in the treatment strategies, undiagnosed hypoglycemic episodes, and falling being more frequent. So this may be causing worse prognosis in diabetic patients. So what is to be suggested? Evaluation of dementia, depression in patient with diabetes. a risk-specific dementia risk score was developed to predict the risk of dementia in patients over 60 years of age over 10 years. So based on this scales, the points of higher risk of dementia can be assessed. There are various tests which can help with neurocognitive impairment to raise suspicions of disturbance, and even simply asking certain questions regarding like during any past you had felt depressed, hopelessness, helplessness during this month, or the last month you were disinterested or unhappy. If we just give some time to our patients, listening to our patient, that may definitely help to our diabetic patient, just rather than seeing the blood glucose, the numbers, and chalking down the medication. Diabetes mellitus, what should be the treatment goal? Both in the scenario where 3 Ds are associated, both the antidepressant medication and various psychotherapeutic methods are affecting in reducing the symptoms of depression and distress, though lifestyle modification seems to be effective in lots of studies. But one of the study, Accord-All study, has shown that not much beneficial changes have been seen when this was strict control was done to assess the brain volume and cognitive performance after 80 months. So we need to start earlier. We need to interact with our patient more effectively. So the treatment options are not specific once we talk about the cognitive decline in patients of diabetes, but as the pathogenesis lies to be in insulin resistance, so some agents, specifically intranasal insulins, which are still in the pipeline, the incretin-based anti-diabetic metformin, pioglitazone, have shown to be beneficial, though more studies required to fulfill making it to be advocated as a guidelines. Prevention of hyperglycemia is one of the important aspects when we talk about diabetes, mood, and cognition. What does the guideline say? The American Psychiatric Association recommends the monitoring of diabetes control whenever initiating or adjusting the dosage of an antidepressant therapy, as we are all aware that medications like clozapine and olanzapine, though they are the antipsychotic group of drugs, may have a deleterious effect on the blood glucose. The Canadian guidelines also recommend screening of diabetes as a risk factors in patients with psychiatric disorders. The ADA and its position statement has emphasized the psychosocial care to all individuals with diabetes and monitoring and screening for diabetes distress, depression, anxiety, eating issues, social and family support to be required. Hence, for all adults more than 65, annual screening for cognitive impairment or dementia is indicated. To summarize the options dealing with cognitive performance, mood, sleep, other psychological components, we need to recognize possible disorders in diabetics, periodically inquire with simple question, short and practice test, and high-risk individuals should be done. So as we have all been a part of the RSSDI campaign, I would like to advocate a 6th vital sign in diabetes. The 3 Ds, diabetes, depression, and dementia, can very well be assessed using some of the tools for assessing diabetes distress, for depression, for cognition, for mood. Above the age of 65, an annual screening for cognitive decline and depression in people should be warranted in diabetic patients, as the depression is readily treatable. Remission should lead to improved cognitive function and quality of life, and hence the prognostication of diabetes per se. So we should always be there to support people. Even with diabetes, people can make a change. So with the motto, let's talk for diabetes, this I would like to hand over for the questions. I think I was on time. Hello.
Yeah, that was perfectly in time, Dr. Anupa.
Yeah.
Dr. Vitul is back. So, Nirav, can we have the slides of Dr. Vitul? And our chairpersons, please introduce Dr. Vitul.
Am I audible?
Yes, yes. You're audible, sir.
Yeah. So our next speaker is Dr. Vitul Gupta. He is the Health and Human Rights Activist, member of Executive Committee, Cardiological Society of India, Fellowship of ICP,
CSI in ACP and IACP. Role of honor in the table tennis, lawn tennis, badminton, and the swimming. And chairperson of the organizing subcommittee, API Con 2014, Ljubljana. So not going in the much detail, I'm handing over to Dr. Vitul Gupta for his session. Over
Thank
to
you, sir, for kind words. So I'll share my screen.
So your mustache hardness is due to human rights?
Yeah. I am not able to share my screen, in fact.
Share, sir. Take 1 minute. Yes.
Yes.
Go ahead, sir.
But it is, hiding half of my slides.
Go to slideshow.
I have done that. Okay. Thank you, Dr. Ashish and Dr. Aka, for giving me an opportunity to speak on rather important subject, challenges in diabetes education. Because I feel what we are deliberating all day round and yesterday also, only diabetes education will be effective in arresting the progress.
Not really care about the guidelines. So CDS should
I start a lecture with my father.
Policy decision and regulatory trainings for all the members of the who are doing the clinical trial and pre-submission meetings.
Dr. Aka, आप अपना off करो
because
please.
we are doing pre-submission
Mute करो.
of the clinical trial application.
So I'm starting my lecture paying tributes to my father for what I am today and Dr. Gurpreet
Sir,
Singh.
sorry to
for
interrupt
all
you.
my academic
Can you just make it in full screen mode, sir?
Can I continue?
सर आप फुल स्क्रीन मोड में कर सकते हैं एक बार बिकॉज़ फुल स्क्रीन मोड में नहीं है आपका जो भी प्रेजेंटेशन
इसका मेरा?
हाँ सर हाँ
नहीं फुल
वहाँ पे एक
स्क्रीन
नीचे बटन है सर फुल स्क्रीन का वो पावर पॉइंट में रख दीजिए पावर पॉइंट स्लाइड्स में
So it is full screen only.
परसेंटेज 43%।
पर कभी कभी वहां से नहीं होता है, आप ऊपर ना स्लाइड शो में जाके करोगे तो हो जाता है। ऊपर देखिए स्लाइड शो है, उसको आप क्लिक करिए, वहां पे आप प्रेजेंटेशन पे मोड पे जाइए तो हो जाएगा।
So I have gone into this and now it is full screen. Okay.
सर और यू प्रेस शिफ्ट F5 आप शिफ्ट F5 प्रेस करेंगे तो भी हो जाएगा वो।
नहीं, इसको एक बार स्टॉप शेयर करके फिर इनको दोबारा करना पड़ेगा मुझे लगता है। You should stop screen sharing and then open the slides again in full screen and then share the screen, so it will work.
It is new share.
एक बार सर आपका जो पावर पॉइंट चला उसको एग्जिट करना पड़ेगा आपको। You will have to stop that once and then.
ठीक है। Now it is okay.
No sir.
Only your second slide is visible. Slide पे double click करिए sir.
Now it is moving.
No, not at all. Shall we move to next session? Then we'll give Dr. Vitul sir.
Okay.
नीरव आप डॉक्टर वितुल की स्लाइड्स ले लो, फिर आप प्रेजेंट कर दो, आप शो कर।
Okay sir.
You go ahead with next session. Next speaker. Then we'll give Vitul sir if there is any problem.
So sir वितुल सर आप एक बार ट्राई करना चाहते हो और भी
नहीं मैं भेज देता हूँ।
ओके सर अब मुझे मेल कर दीजिए, मैं मेरे एंड से शेयर कर दूंगा सर।
आप व्हाट्सएप कर दो सर मुझे, मैं कर देता हूँ।
ओके।
Let we have another session.
Yeah.
Yes. So we have Dr. Alok Modi. He is MD FISH FSCP PGDL from the UK. He is a consultant physician.
Dr. Alok?
Yeah, I'm around. Should I start?
Yeah.
Yeah, please start, sir.
Okay. Many thanks and gratefulness to Dr. Raka and the organizers for conducting thoda hatke but a very wonderful seminar on diabetes. Very different, very palatable, and a wonderful weekend academic feast. So my topic is a tough topic. I'll try to do justice to it because it's more of an obscure topic. There's not much data to support from medical literature. I'll try to share some of my own experience, and I'm sure I'll learn better from the seniors and the esteemed faculty over here. Is my slideshow visible?
Hello.
Yes, sir.
Manisha?
Topic that's been given to me is psychosocial
Yes, sir.
support.
Yeah, please introduce.
Now, moving on to another lecture on teleprescription apps in diet and nutrition. Presenting
Dr.
the
Raka, you have
real-world
to mute
data.
yourself.
Welcome Dr. Arvinder Singhal.
So the topic heading is very nice, psychosocial support. And I like the second part, which the organizers have given me much needed care in diabetes. And I'm sure everybody will agree to that. It is a very much needed care in diabetes. I think the previous speakers have covered it already in a very beautiful manner. The issue here is diabetes and psychosocial distress. Various aspects of diabetes, including diabetes per se and non-compliance, cause psychiatric disorders. And there are psychiatric disorders which are overlaying in diabetes, and they worsen the diabetes part. And they also present as diabetes and vice versa, including lack of medications. Now, what is the frequency? Are we really so serious about it? Do we really need to pay so much of attention about this so-called double D, which is diabetes distress? Is it something worthwhile, or is it just a topic that we need to talk because we need to talk about it? So as you can see, the data says that there is an incidence ranging right from 18% to 45% over 18 months, which means at least 50% of our diabetes patients in our clinic are suffering from diabetes distress. But are we taking care of it? Do they really impact medication taking behaviors? Do they impact in the performance and the outcome of the disease? We talk about glycemic control being poor, leading to cardiovascular morbidities and mortalities. Do these things actually result in a decreased lifespan in a patient with diabetes, especially the type 1 patients? Do these people grow up properly? Do they have a good future and a good adolescence and a good youth? And do these parents, are they comfortable with this kind of distress in diabetes? So you see the spectrum runs like this. Right from the time a person is broken the news that he's got diabetes, from the time of diagnosis, they start getting worried and they're scared about their health. Then they start developing complications. Then they realize they don't have much support in managing the diabetes. The biggest thing that we are all, I'm sure you all know that there are at least 47 guidelines telling us how to manage diabetes, right from ACE, ADA, RSSDI, JAPI, Australian, NICE, etc. But the common thing that is there in all the guidelines right at the top is lifestyle management. And lifestyle management and stress is something which goes hand in hand. And the truth is that there is a sheer loss of happiness. The moment you tell them and you start discussing diabetes with them, I'm sure they consume a lot of our time discussing the happiness part, not exactly the treatment part, and it is vice versa, which leads to loss of health and vice versa. There is a lot of sheer drop in performance because of frequent hypoglycemia attacks, especially if these are unaware hypoglycemia attacks. A lot of subclinical neuropathies are there, which cause decrease in performance. We have discussed in and out over multiple conferences about what is insulin inertia. And that is something that we know it's very difficult to overcome. We know the truth that we do so many programs and we do such wonderful activities, but the truth is that most patients do not stick to their diet. And erectile dysfunction, which is supposed to be the first thing which comes up in the course of diabetes, is something that hardly anybody discusses, neither the healthcare provider nor the patient. A lot of people are very happy to hide diabetes in their insurance form, especially pre-diabetes, and then the hospital owner and the consultant faces the music when the cashless is rejected because he turns out to be a diabetic, but it was not declared as a pre-existing illness. I try to do a lot of CGMs, but for various reasons, people are scared of getting their sugars revealed to the doctor through a CGM. There is a lot of taboo. There has been some wonderful sessions today about type 1 diabetes. A lot of doctors would agree with me that marriage becomes a very big taboo for people with type 1 diabetes and young patients, Modi, etc., with developing type 2 diabetes at a younger age. The truth is that in India, about probably every third patient is a diabetic. And let me ask you this very candid question. In our own faculty in the last 2 days, all the esteemed diabetologists that they are today, how many of us are diabetics? Please ask yourselves, and have you been honest with your disease? Have you been honest with the therapy? Have you been taking therapy from your esteemed colleague, or have you been treating yourself so that you don't get discovered to be a diabetic? That is the amount of socialism that is associated with diabetic. I think that answers a lot of questions. So you see, this is a vicious cycle of depression, which was very beautifully covered by the previous speakers. I won't waste time on that. Bottom line is it's a vicious circle. Food habits, social interactions, family interactions, social media interactions, poor guidance, lack of education, not getting good support from society in general leads to depression, leads to further complication of diabetes, and vice versa, etc. Now, I tried to scan the literature in a big way. I could not get a lot of data which would give me credence to my talk today, but there is not much data available, but I could find a few data and some wonderful Indian data which I like to share with you. This was a Dawn study, Diabetes Attitudes, Wishes, and Needs, and it showed very clearly the impact of diabetes on quality of life and well-being. And if you go abroad, and today most of the diabetes centers in India talk a lot about QOL. We're interested in quality of life. We are not very keen on HbA1c. We're not interested in glycemic control. We are not interested in end-organ damage. Of course, these play a very important role. I would be wrong to say these things are not taken into consideration. But so what if you have an HbA1c of 6.5 and you have no organopathies, but there is no quality of life? Person is crazily not eating anything which has little amount of fructose or glucose or maltose or lactose or whatever, is living like a starved individual because of firm belief that there should be zero carbs in the diet. So there are so many issues like hypos and other things which cause reduced well-being. There is a perpetual knock on the door like cancer, that you've got diabetes, so there is a reduced emotional well-being. There is a sheer drainage of finances because insurance does not cover most of the OPD expenses of your diabetes, especially if these people are on second-generation basal insulins and the newer analog insulins. And you look at the relationship with families and peer members, do you think that they really have such wonderful relations? Well, data doesn't show that. Data shows something different over here. Look at this study from the Dawn 2 study. It shows that 50% of the people have emotional distress. Now, that is something very disturbing. If you look at the developed countries versus, I think, most developed country in the world, which is our country, look at the figures are so high. More than 50% of our own patients are living perpetually in an emotional crisis situation. It's like a marital disharmony, which many couples pass through with daily jhagdas and fights. A lot of diabetics are not happy, even if they're well treated, and that is something we really don't focus upon. The study also shows that women with diabetes report much more worse psychosocial outcome than men. And the figures are quite alarming over here. They're like 66% plus 20, 55 plus 24. So it's more than 75% people who have got a very bad interactive capabilities with their peers, friends, and subgroups. The leisure activities are down, emotional well-being is down, physical health is automatically down, and there is a lot of mental jugglery which is going on in the mind of a diabetic. The worst part is we talk of sexual discrimination, we talk of ethnic discrimination, we talk of regional discrimination, but we don't talk about diabetes discrimination. We talk of so many Ds like dementia, depression, but do we talk about diabetes and discrimination? Around 20% of people experience a lot of discrimination from their communities. There are studies which show that spouses discriminate a spouse which has got diabetes, discovered probably 3 years after marriage. Children sort of look down on their parents and vice versa. Because you've got a diabetes, people feel you belong to a different planet, you should not be with them. And that is extremely disturbing to a person with diabetes. And this discrimination goes across different countries and different performances. But if you look at the Turkey, India, and China, and I'm interested in India, which I've highlighted over here, the incidence is pretty high. And I'm sure we're not aware of it, that most of our diabetics are highly mistreated by various subgroups in society. Now, the truth is that this is what I call as the boon, which is the silver lining on the cloud, and which many doctors are not aware of. Most family members actually want. There is always a pilot person in the family, either a spouse or a brother or a sister or a daughter, or somebody who wants to be involved in the betterment of the patient, of their family member. But how many of us target that member rather than target only the patient? So around 46% people would be involved with the care of the diabetes patient. 40% of people want to get involved, and around 37% actually don't know how to get involved. So these are quite alarming figures which should be tapped by diabetes educators and diabetologists. And if you look at all the spectrum of different diseases, subgroups of diabetes which is causing poor quality of life. It is hypoglycemia, which is some of the most pertinent factor, which very few people are ready to discuss. And because they do not have the right tools, because they do a fasting and post-lunch once in a month, or they do a non-structured SMBG and they find out a few occasional hypoglycemia episodes, or they find unaware hypoglycemia episodes and they don't discuss, but family members are worried because the patient is not aware, but the family member is highly aware. So these people did some wonderful data, and I think this is a phenomenally wonderful data because they scanned around 15,000 patients, and I didn't see any data which is scanned more than this. This was a very well done observational horizontal study which involved diabetes specialists, nurses, dietitians, healthcare professionals, as well as family members. And if you can see, a good number of healthcare professionals were involved in the study to find out how we can make life better for the diabetic. And they realized that the majority of family members were never called for diabetes education by the healthcare provider with the patient. So that is something very sad, that we talk to our patients, but we do not involve the family member when we are discussing with the patient about pros and cons and insulin therapy and insulin demonstrations, insulin pump demonstrations. And Dr. Saurabh Mishra said very appropriately, when you do a group session, the results were better. So you see, in type 1 diabetes, around 70% family members were not even aware that there's an educational facility going on. And around type 2 diabetes, around 80% people were not even aware or they didn't participate. So that is something which we are missing the bus totally and completely. We keep focusing on insulin therapy and the new modes of therapies and paradigms of diabetes care shifting, but we don't even take 1 minute to educate a single family member. And we have seen a lot of spouses and family members who don't even know that their patient is on insulin. There's another thing which dawned from this Dawn study, very eye-opening study came out over here, that the perceptions of communication differ quite a lot between the end organ, the end recipient, which is the patient, and the HCP or the healthcare professional. So if you see over here, 30% people with diabetes were asked by the healthcare professional as to what would be your idea, how do I formulate your diabetes plan? So only 30% patients felt that the doctor asked them, whereas 60% doctor or 56% doctors felt, of course, I have asked them, how come they don't realize it? Now, if you look at the second aspect of it, people with diabetes were listened as how they would like to go on with their life, whether they would like to take insulin in a particular manner, whether they would like to take all the tablets together, whether they are aware of how to manage hypoglycemia. Only 37% people said that after meeting with the doctor, we are aware of it. But 77% of the doctors said, of course, we've explained it to the patients. Now, what about the confidence in the doctor? Around 38% patients felt that the doctor has generated enough confidence in managing changes to their life because they've got diabetes, whereas doctors felt, 72% doctors felt, yes, we have done a wonderful job. 30% doctors felt they have not done a wonderful job. So you see, there's a big disparity. So if you translate this into your own clinic, if you've got 100 patients OPD per day, it's around probably 30% patients are going with a real benefit of meeting you as a diabetologist, whereas you might feel you have done a wonderful job. But the truth is that if you take a questionnaire, most of them are not aware of the kind of benefits you're offering with artificial intelligence, with CGMs, with empowerments and diabetes gadgets and gimmicks and all that. What this data has also shown that if you actually spend time in diabetes education, you get better quality of life, better diabetes empowerment, and that is what we are talking about in precision medicine, the branch of ADA from 2021. Less psychological problems and overall a better well-being. And all this data, if you can see, the p-values are less than 0.05, which means these are all statistically significant. I'll move you towards another big study which was done in Canada, which is Diabetes Canada, and they labeled it very beautifully, opening the Pandora's box. They realize that it's a very vague topic where they are going into. It's very uncharted waters, but very difficult to handle and very difficult to give success and results because it involves a lot of counseling, which may not be done properly. And they found out one very simple thing. The moment you're diagnosed with diabetes, which becomes a diabetes burden, it eventually burns the patient out, causes a lot of diabetes distress, eventually pushing the patient into depression because of diabetes and not because of Alzheimer's or cerebrovascular disease or any other reason. And they concluded this entire data. It's a huge study. I would not take a lot of time to do that. They realized that most of the doctors feel it is not your job to change the patient. Providers do not feel it is your job to change the patient's behavior, but providers were told that to identify, educate, recommend, and support is also part of your job. The Canadian doctors did not feel so. And if you can understand the behavior of your patient, you can negotiate choices. We don't give choices to our patient. We say you have to take insulin. We don't discuss if insulin is not taken for the next 6 months, what options do you have? We feel that you must take SGLT2 because though you have not developed nephropathy, you might develop it tomorrow. But doctor, I cannot afford SGLT2. So what options do I have? We do not focus on the self-image of the patient. We focus on the efficacy of the patient. We do not offer social support and stress management. And what they said is keep the conversation running. You may not be successful in the first visit or the second visit or the third visit, but what is preventing you from keep running the conversation in every visit? So the truth is that first time when we see the patient, we spend time talking with the patient. Second time we speak to the relatives. We do it over 3 to 4 sessions. Then it is CTO. We don't spend time. But they say, no, keep the conversation running. Keep picking up those things and keep discussing it. So having discussed the London data and the Canadian data, let's come back to India because that is relevant to us. What about India data? And I'm very happy to share that our leading diabetologists have done a phenomenal work, as you can see, Dr. Kalra, Dr. Unikrishnan, and a lot of other doctors, Dr. Avasthi and all our favorite diabetologists have done phenomenal work here. And they have done such wonderful work that they have found something very different from the Western world. They find that in India, the peak reasons why we get psychosocial disturbances are economic factors, cultural factors, religious factors, and सबसे बड़ी बात है, we believe a lot in alternative medicines and we strictly do not follow allopathic medicine. Most of the diabetics, you will all agree, have a lot of respect and credence to non-allopathic forms of medicines, and though you may prescribe the cheapest and the most wonderful sulfonylureas, they may not be taking it, or they may be taking it as a mixed pathy with other drugs. So that is something we don't realize and we don't focus into, and that can prevent a lot of complications if we are aware of it. And they've given us not 1, 2, 3, 4, 5, 6, they've given us 94 recommendations for management. So I'm going to pick up the peaks of those 94 recommendations, and I would encourage all of you to read this wonderful paper by these authors. It's a paper worth reading with a cup of tea in your hand. Makes a lot of difference in how you would approach your patient. So let me pick up the highlights here. Effective patient teaching and problem solving, the SWOT analysis and the care analysis would work wonders when you're interacting with your patient. And an HCP should behave like a water and not like a HCP totally in interacting with the patient. What is all this? What is the water approach? Welcome your patient. Let him feel welcome to your clinic. Let him not feel burdened to enter your clinic. Let him, please ask him what is bugging you. Don't come out with your lecture, what is diabetes, what is insulin. Ask him and then assess it based on his emotional understanding of diabetes. And don't hide from the patient that you've got nephropathy and cardiomyopathy, etc. Tell the truth, but tell it in a palatable manner. And a very important thing, neither you should be forced, nor you should be too casual about it, but you should be empathetic about it. And sabse badi baat hai, make sure that he's reassured that no matter where you are in the diabetes spectrum, we are always there to help you, and we will help you. Your life is not bad today, so that you can return back to me with further care and further benefits. That's the water approach. What is the care approach? We need to improve the awareness among our patients. Do we improve the awareness? No. Do we improve awareness in the community? I know there are a few doctors who are spending their mornings, Sunday mornings and other working holidays to work for the community and through Rotaries and Lions and other things like I do. But how much time do we actually work to improve the awareness in the community? And how much precision medicine do we do? How many times are we focused about the benefit of the patient and the patient approach rather than the doctor approach? So that is a care approach. Do we generate enough competence, just confidence for the patient? Are we authentic in our accessibility to our patient's queries and doubts? Do we reciprocate the respect that the patient has for us? Means, do we respect the ideas and views of our patients with the kind of respect he comes to us? We are empathetic. We are all doctors. We have taken the Hippocratic oath. But do we express our empathy to our patient? And are we simple and straightforward? Or do we discuss complex algorithms about insulin management to our patients and make him run away from insulin? Are we not supposed to be simple and straightforward when we prescribe medicine and discuss simple things about retinopathy and nephropathy and all? So they went ahead, having taken this loop, they said the next step should be like in dementia, as Madam covered, one should have a cognitive behavioral therapy approach. One should be highly motivated in therapying your patient. It should be a problem-solving approach. So fine, if you've got a nephropathy, you've got a retinopathy, you've got a cardiomyopathy, so you just don't write drugs and send him off. You tell him how cardiomyopathy can be taken care of besides drugs. You tell him how the microalbuminuria may not hurt you for the next 20 years if you keep taking ACE inhibitors and if you keep monitoring your glycemias. So take the problem, solve the problem, discuss with the family. The family may not like the person to be on insulin because he's an elderly person, he's a senior citizen, he forgets to take insulin, he takes wrong dosages at wrong times. So listen to the family, understand the needs of the family. A gastroparesis patient may not be having a good diet in spite of you writing a wonderful diet chart. So listen to the family and educate the family with the therapy that you're planning for the patient so that they get the benefit. This is something which they've discussed. I would not discuss it. It would be something that will take a long time. Folk dance therapy, I would leave you guys to read it. So this could be a little homework, but please go through it. It's really wonderful. Do we discuss the eating habits of the patient? Do we tell the patient that eating a ras malai once in a while is not bad? So if he likes gulab jamun, how can you tell him don't take gulab jamun for the rest of your life? It's not possible. So do we discuss his eating habits and then do we tailor our diet therapy according to that? Or do we make the patient change his eating habits to suit our prescription? That is something which is very important. A lot of people present with end organ damage, and the first thing to occur is erectile dysfunction, as we all know. That is in males. Do we know that there is loss of libido in females and she cannot satisfy her husband? That is something. Are we scared to discuss? Are we embarrassed to discuss? Is the patient embarrassed to discuss to a male diabetologist? Do we take pains to do counseling in the sexual dysfunction in the bedroom? That is important. Social assessment and management. What is his relation with the neighbors, with the peer group, with his bosses, with his co-workers? Do we discuss that? We don't discuss that. Family structure. Do we know that there is a joint family there and he may not be able to take insulin in front of his juniors? Do we know that the grandparents may not approve of insulin in the family? So there are so many other aspects in the family structure that we should be aware of rather than just discussing the therapy for Mr. XYZ. Do we know that female diabetics are treated different in the family diabetics? Do we know that people with Ramadan are fasting for the entire month and then you need to do something about insulin? And Dr. Uri Krishnan has published a wonderful data on liraglutide with Ramadan. I won't go into that. Do we know that most of our Indians are fasting on Mondays and Tuesdays and Thursdays, but they're not fasting on the other days and we're not even aware, and we are very comfortably giving them glimepiride 4 milligram every day? Do we know that insulin is not a drug because they don't want to take it because it's different, but because they think it's a taboo? They think taking insulin means end of life concept. Do we know that our patients feel that certain foods are good for diabetics and no matter how much you break their head, it won't be able to shake them? Do we know that most of them hate fruits, they hate jaggery, they hate a lot of good things? And there is data in the literature to support that they are right and they'll land up in trouble because of that. Do we take care of our type 1 diabetic patients and see what is the response of their teachers, their principals, their classmates and the trustees of the school to insulin pumps? Are we aware that certain class 1 type 1 diabetic patients have a lot of problem with their physiotherapists, teachers over there? Do we consider that patients who are having falling grades and decreased output at work are failing to reach their targets because of hypos and not because they're not concentrating? Are we aware that a clerk who's sitting for 8 hours in a call center has to take insulin pen, does not feel like going to the toilet to take the pen, is highly embarrassed to inject herself with insulin? So these are a lot of social aspects they have written that we should be aware of. Do we really take pains to calculate the cost of the prescription on a daily basis? And then cost of the prescription on a monthly basis and yearly basis? Maybe we can offer them cheaper alternatives. It's not that only the exotic new drugs are going to give you all the benefits. Now, these topics were covered very well. Psychological comorbidities like anxiety, disordered eating, mental illnesses, depressions, and all that. And I won't cover it right now. But what they have recommended is start screening patients. Learn to screen. I feel split up 50% of your time prescribing and at least 20% of the time trying to screen. At the time of diagnosis, every time the patient comes to a follow-up, if there is a change in glycemia, if he's going to hypoglycemia or hyperglycemia, if he's developing a new onset microalbuminuria, if there's a subclinical retinopathy, nephropathy, every time he's hospitalized. Like to share from a very leading diabetologist how one person who was doing very well for 10 years suddenly started bumping up her sugars and they were wondering if she developed CKD or if she's developed some kind of insulin resistance. And they scanned the thing totally and completely and they realized there's nothing wrong. And they were wondering why the sugars are 140 have jumped up to 240 and 300. And they realized that the patient had got chest pain as considered a cardiologist in a leading corporate hospital in Mumbai. And she was told if you don't do an angioplasty, you would land up in trouble very soon. And because she didn't do an angiography and nothing was found because an angiography was not done, she had sleepless nights and her stress boosted her sugars like anything. And when she was told that there is no need for an angiography because your stress test is normal, her sugars came back to normal without bumping up her medications. So these are some real life things. People get hospitalized with pre-diabetics and turn out to be diabetics and start blaming the lab and the hospital for abnormal sugars because they were non-diabetic in their knowledge so far, and they are disturbed in their sight and they need to be taken care of. So when new onset complications occur, when glucose control goes bad, self-management goes bad, these are the times you need to intervene. And when there are violent episodes or changing of medications or lack of self-care provider, lack of resources, bad communication in the society, in the peer group, or differences in the medications or mixotherapy going on, these are the times probably a counselor or a mental health care provider is required. If there are youth with behavioral difficulties, mental illnesses which were highlighted now because of hypoglycemias, undergoing bariatric surgeries and metabolic surgeries, or self-care behaviors at work are identified. Time to take
we need to
I'll just finish in 2 minutes because I couldn't see the timer. I'm sorry. So learn to be smart as a diabetologist, be specific, measurable, achievable, realistic, and be limited in your time. I'll just run away with my experiences in my own diabetes care, as Dr. Raka discussed with me. A lot of hypos don't come out with hypos. A lot of hypos do not come out with hypos, but they come out with chest pain, behavioral changes, and performance issues. And please remember that a sugar below 40 is not necessarily an hypo for a chronic hypo, and a sugar above 200 could be an acute hypoglycemic attack for a person above 300. Erectile dysfunction is very common, very unsought about. We hesitate to discuss with the wife. Sometimes they are more upfront than the husband, especially in the allied area where I'm practicing. Sometimes patients start having affairs and disharmony at the house. Sometimes people are heavy passive smokers, and that causes, active smokers, which brings out the erectile dysfunction, which was not present earlier. CGM is something which I use very often. It's the standard of care today. And we do not tell a patient that diabetes is supposed to be beyond sugar control. It is not just a control of blood sugar, which is important. Diabetes is an umbrella of all retinonephron, all other pathies, and why CGM becomes important and why they should not depend only on a glucometer and should check once in a while with the lab. Myths about insulin, I can give a talk for 2 hours. I'm sure you all can cover it for 3 days together. So a lot of myths about insulin needs to be covered beautifully and completely. I've written a blog. I write a lot of blogs. I would encourage doctors to write a lot of social media things. There is a lot of Google Baba concept, WhatsApp concepts, community concept. Do you know that a lot of non-diabeto, non-approved, non-medical diabetes support groups are running, which are charging 1 lakh to 2 lakhs per year from patients, and they're happy to support that group and learn all kind of nonsense, and they come and teach you about diabetes from that. So I believe in lohe se lohe ko kaatta hai. Why are we not active on social media? Why can't we talk on WhatsApp? Why can't we talk on YouTube? Why can't we tell the people what is wrong and what is right? And Dr. Shweti, thanks. I found this slide to be very beautiful. Thoughts create feelings, feelings create behaviors, and behaviors reinforce thoughts. That explains a lot of things. The summary of the whole thing is a thought to ponder for all of us. Do we give quality time to our patients? That is why. Think about it. Why our patients are running away to alternative medicine people, quacks, and social groups? Because we don't give time to our patients. We don't talk to our patients. The moral of the story is talk, talk, and talk. Don't stop talking. Thank you very much. Sorry for exceeding my time. And thank you once again, dear organizers and the Allied faculty group, for making me a part of today's seminar. Thank you very much.
Thank you, sir, for your wonderful insights on the psychosocial support system in the diabetes management. The key is that listen to the patient, assess the patient, and educate the patient. And we all have to introspect ourselves why or where we are lacking in the system. So moving ahead, if we have Dr. Vitul Gupta sir ready, then we can have his presentation.
Wonderful talk, Dr. Modi. And sir, Dr. Vitul sir के पास आ रहे हैं, diabetic education ही चाहिए.
नहीं मैम,
डॉक्टर अनूप आपने बहुत अच्छा कवर किया था. It was so nice to listen to you.
Dr. Lok has taken 2 lectures time to explain each and everything, and that makes my task easy.
We need diabetes education only.
Everybody will be relieved if I am finishing in 15 minutes. So thank you, Dr. Ashish and Dr. Raka, for giving me an opportunity to talk on rather important topic, challenges in diabetes education. Because as Dr. Anuba and Dr. Alok has discuss the things of mental issues as well as psychosocial support. So half of the things what I am going to talk pertains to those previous talks. So I start with paying tributes. Next slide, please. To my father. For what I am today is because of him and Dr. Gurpreet Singh Wander. Because of my all academic activities are promoted, guided and mentored by Dr. Gurpreet Wander, and thanks to my family. Next slide, please. So India faces a huge burden of complications and of diabetes. What we are talking about in last day also and this day also, over half of the Indian population is at risk of developing diabetes at some point of time in their lives. Urban India is more likely to develop diabetes rather than ever before, and rural India is also catching up fast. Next. In India, more than 77 million adults are living with diabetes, and researchers predict that this will increase to 134 million by 2045. An estimated about 57% of cases remain undiagnosed, increasingly with risk of serious complications, as was beautifully depicted by Dr. Bansi Sabu. Next. And what are the challenges in diabetes care in India? Rising prevalence in rural as well as in urban areas, high prevalence of pre-diabetes, genetic and environmental risk factors, how we are different from Caucasians, rising prevalence among young people, delayed diagnosis. Next. Low disease awareness among general public as well as low disease awareness among the healthcare professionals, as Dr. Alok has beautifully enumerated the reasons of both the factors. Limited healthcare facilities, high cost of disease management, which is really important in Indian setup, suboptimal diabetes control, rising rate of diabetes complications we are all worried about. Next. Next slide, please. So India is gaining the status of diabetes capital of the world. And most serious challenges, as I have already told you, lack of general awareness about diabetes, rapid lifestyle transitions. We are moving from infectious diseases to non-communicable diseases, narrowing urban-rural divide, and most effective solution, creating awareness for prevention and control of diabetes. Whatever infrastructure we build, ultimately it will depend upon control of diabetes, that is prevention. So lack of diabetes education and awareness is leading to increased prevalence of diabetes because of unfavorable lifestyle. That is why it is called as lifestyle disease. Delayed diagnosis because of lack of awareness about symptoms. Fewer people have controlled diabetes. Increasing complications such as amputation, stroke, CKDs, and blindness. Next. So this picture is very dangerous, and it reiterates the fact that only diabetes education and awareness can arrest the march of diabetes epidemic. Whatever infrastructure we build, ultimately it will depend upon education and awareness to stop the diabetes epidemic. Next. So what are the challenges in diabetes education? Low awareness level, we have to increase the awareness level. That is the first and foremost challenge. Huge population, huge number of people with diabetes. We need to educate each and everyone. Deficient healthcare structure, deficient qualified manpower of healthcare professionals, socioeconomic considerations, and faith in alternative system of treatment, which is again was beautifully depicted by Dr. Alok. Next. Diabetes self-management education is globally recognized integral part of diabetes management, practiced by developed countries through trained diabetes educators. Unfortunately, in India, it is still not considered as an essential part of diabetes management. So basically, it is the most neglected part. We depend on only prescription, that is pharmacotherapy, and education is left ignored. Sadly, the cadre of diabetes educator is virtually non-existent in India and may be available only in a few five-star hospitals. Next. Evidence shows awareness and knowledge about diabetes is grossly inadequate in India. A massive diabetes education program are urgently needed at national level. The National Diabetes Educator Program, initiated in 2011, was first structured education program for diabetes educator in India. Still, the number of diabetes educators are grossly inadequate for a huge diabetic population in India. Next. So what is our motto today? Diabetes awareness and you. What we are doing to combat this silent killer. Next. Next. So that is where the role of Global Diabetes Forum and RSSDI and all the professional associations come in to increase the awareness level among common people as well as the healthcare professionals. Among common people, on an average, people with diabetes spend only 3 hours a year with healthcare professionals, and for remaining hours, they manage their diabetes themselves, and that is also with suboptimal knowledge, and you can very well imagine what will happen. A population-based study reported 41 were not aware of adverse health effect of diabetes, 30% knew about the complications, and 46% felt it is a temporary phenomenon that I take treatment for a few months and then it will not be needed. Next. Similarly, the Curious study also reported the suboptimal knowledge of diabetes among people as well as diabetic population. Next. And more studies report that 60% are unaware of risk factors, 50% are unaware of complications, 50% are unaware of good glycemic control could help avoid complications. And similarly, basically these studies, they show the suboptimal level of awareness among people. Next. So here also the suboptimal awareness levels are depicted by various studies. Next. So awareness about healthcare professionals, as Dr. Alok has told us, that lack of education about diabetes may also be common among medical professionals. That is, lack of understanding for the need of constant monitoring and consistent tight glycemic control in patients. In a study, about 33 healthcare professionals in some countries reported lack of formal diabetic training. Next. Next. So low level of awareness of diabetes among physicians result in poor glycemic control in Indian patients. Lack of awareness among physicians also impact use of insulin therapy. Practitioners prescribe alternate or traditional therapies or oral anti-diabetic drugs for diabetes care to retain patients or due to lack of proper information. Use of insulin therapy is used as a last resort of disease management and sometimes to scare the patients away that you take this drug regularly, or they create fear in their mind that insulin will be given. Next. So general physicians and family doctors are responsible for delay in insulin therapy due to their suboptimal knowledge and attitudinal issues. Poor referral to endocrinologists, lack of patients counseling, suboptimal care impedes the effectiveness and efficiency of patients' care in India. Primary care physicians getting certified as diabetologists at low-level universities and colleges provide substandard care, and you will find numerous pads, prescription pads, having the designation of diabetologist and cardiologist of all the MBBS doctors and physicians. Next. So what is the way forward? So my dear friends, diabetes awareness among people, diabetic population, as well as physicians is the way forward. Next. So there is urgent need of education and awareness about diabetes among general population, among diabetic population, as well as, most importantly, healthcare professionals. Next. So role of diabetes education is mainly for prevention and control. So we need to prevent diabetes, and if there is diabetes, we need to control diabetes. So that is the crux of this lecture, providing knowledge and skills, changing patients' behavior, motivation to comply with recommendations, improving quality of life, establishing a partnership with family and healthcare professionals, which again was very well explained by the lecture by Dr. Alok, preparing for self-care, increased awareness of risk factors as well as complications. Next. Food patterns appropriate for individual needs. Again, Dr. Alok has beautifully explained this factor. Regular physical activity, regular monitoring of blood glucose, pharmacological adherence, follow the doctor's instructions, knowledge about acute problems, psychosocial adaptations, motivation to achievement, and risk reduction of chronic complications. Next. Previous slide, one slide was missed. So component of effective diabetes awareness control has three important components. So there have to be different strategies for general population, strategies for diabetes patients, as well as strategies for healthcare professionals. Next. Next. So for general population and diabetes patients are to be the common strategies that is requiring a large outlay of resources and efforts to succeed. Multiple modes of communication are needed. So now we have conventional modes like drama, skits, newspaper, and TV. The modern non-conventional modes are internet, short message services, mobile phone apps, etc. Next. Community involvement is very, very important. Telemedicine-based multidisciplinary care has to be instituted. Popular figure and community leaders can convey that message very effectively. Public-private partnership program will be unique to Indian setup, where most of the health services are given by the private doctors. Pivotal role of media help in dissemination of accurate information. So this is very, very important because we have so many quacks like Baba Ramdev going in for media for disinformation, and media has to be very, very sensitive to provide only accurate information. Identification of the high risk groups and need to be educated. Here the role of professional organizations like Global Diabetic Forum, RSSDI, DIPSI, API becomes larger than life, and that is one where I congratulate Global Diabetic Forum for this unique effort. Next. So educational and awareness program should be simultaneously planned for various stakeholders in diabetes management. Uniformity of content to ensure consistency of information across various levels. This is real important. And multi-stakeholder participation, broad consensus of opinion recommendation endorsed by the national level organizations. So we have to have consensus statement by all the stakeholders involved in diabetic management, whether it is RSDI or it is DIPSI or it is Global Diabetic Forum. So we need to have a consensus based on evidence. Next. Multiple level of synergistic partnership between government and private sector, integrated diabetes education across all levels of healthcare professionals from primary healthcare to the super specialists, family-centric education program to involve the most important stakeholder who bears a significant burden of disease indirectly. So family, again, Dr. Alok has very beautifully, stressfully, discuss the role of family in this. Easy to comprehend information, communication for everyday strategies is very important. Next. Specialized doctor educators have to be there. socio-cultural factors and strength prevalent in that society must be incorporated in the curricula to enable those with diabetes to become advocates for primary prevention in their family and their communities. Here comes the role of the community leaders. The curricula should create effective balance between intellectual appeal and practical usefulness. Sometimes they are at loggerheads, intellectual as well as practical usefulness. So we must create a balance among these two things. Next. Education and awareness is only one of the key components for prevention and holistic management of diabetes and its complications. Currently, health education to prevent diabetes in rural India is almost non-existent. Major gap exists in education about health and nutrition. Awareness about lifestyle factors for NCDs is also unsatisfactory. Next. Next, please. However, the knowledge alone is sufficient to bring about behavioral change, and patients' health attitudes and personal barriers to diabetes care are influenced by social, cultural, socio-economic, and healthcare system factors. The identification of underlying reasons for variation in attitude behaviors is increasingly being recognized as an essential element for designing and evaluating diabetes education program. Next. So, my dear friends, what is the take-home message from all these 3 lectures? I must say that there is urgent need for a vibrant education and awareness program in India for diverse journal as well as diabetic population, including healthcare professionals. Identifying key strengths and weaknesses associated by socio-cultural factors should be incorporated in the program, engaging all healthcare professionals in imparting health education. National Program for Prevention and Disease Control offers communities for improving care for primary as well as secondary level prevention programs. Next. Socioeconomic, educational, cultural, and language barriers poses a significant challenge in implementation of an effective program. Diabetes education is a dynamic and ever-changing field, with diabetic educators need to respond to these changes in practice, and role of diabetes educator is therefore crucial in disease management progress. And till the diabetes educators are ample in India, every person, every healthcare professional can act as diabetes educator. Next. So challenges in diabetes education are numerous, but that should not discourage us, but strengthen our resolve to do whatever is possible under the given circumstances. So we should resolve today to start diabetes education for every person visiting our hospital, for high-risk group, for common people, especially for diabetic patients. Next. So that is our motto. That is where the Global Diabetes Forum is working very good, to great efforts by Diabetes Forum to spread awareness about diabetes among the healthcare professionals. Next. So I must mention here 3 people who are involved in diabetes program, especially diabetes prevention. Dr. Bansi Sabu, who last year has made RSSDI visible among common people. Dr. Sunil Gupta is doing a great job with Hello Diabetes program, and all know Dr. V. Mohan's contribution to diabetes prevention and control as well as in research regarding diabetes. Next. So my dear friends, only awareness and education can beat diabetes. And thank you very much for giving me an opportunity. So I invite all of you to MAPICON 2022 from 15th to 18th September 2022 at Bathinda. Thank you very much.
Thank you, sir, for your wonderful insights on the diabetes education challenges and what are the possible solutions. And we have the next session on the adult vaccination in the diabetes, that is by the Dr. Sanjeev Gulati, sir. So after the education topics, we are now moving to the another healthcare topic on the adult vaccination. Dr. Sanjay Gulati is a MD, DMRD in the DFID. Is a director of the Diabetes Center, Center for the Management of the Diabetes and the Obesity, director and the physician of the Sarvatam Hospital, Bhopal. So over not wasting much time on the introduction, let's hear him about the adult vaccination in the diabetic patients. Over to you, sir.
Thank you, Dr. Sushil, for the kind words. And I would like to thank Dr. Raka and Dr. Ashish for extending this invitation to me for participation in this very successfully being organized Global Diabetes Forum. So we have learned a lot about the diabetes education in past 2 lectures. Now we move on to an area which also needs a lot of education for not only our patients, but also the healthcare workers who are working in the area of diabetes, the adult vaccination in diabetes. I believe COVID has given us a lot of lessons, and one of them is the vaccination is not only for kids, it is also for the adults in certain diseases. This is one lesson COVID is giving us and general population. We can see the data from US from the second peak of the second wave of COVID-19, where they have done a study to see the hospitalization rates among the vaccinated and non-vaccinated people. And we can see here that 16% higher rates of hospitalization in those people who were vaccinated against COVID-19 as compared to who were not vaccinated, so had a higher rates of hospitalization. It's not only the vaccination, it is the booster dose now coming into the play. There's a study to prove the role of booster dose, an active booster versus a placebo booster on infection rates of COVID-19. And we can see here a marked difference in those people who received active booster versus a placebo booster as far as the cumulative incidence of the COVID-19 is concerned. Not only the difference is only after 1 week of the booster dose, the curves have started separating. So it's not only to vaccinate the people, it is also to properly give them booster dose of the certain vaccine which are required. And that's why IMA has urged all the diabetes people should be given a booster dose of COVID-19, and government has kindly and thankfully consented for the booster dose of COVID-19 for the vulnerable population. And all of us, now the window for the appointment has already been opened for the booster dose of vaccination in the vulnerable people and healthcare workers. And all of us can go tomorrow and get ourselves vaccinated for the booster dose. Now, key challenges in the adult immunization in India. The adult vaccination is by and large neglected not only by the people of the India, the healthcare workers, policymakers. None of them consider adults vaccination as seriously as it should be. In fact, a person who can stand in a queue for hours for his kids' vaccination may not even go to hospital for his own vaccination, or may even refuse to get vaccinated for, we have seen hesitancy for the vaccination in people against the COVID-19. But thankfully, our people, our Indian peoples are accepting COVID-19 vaccination at much more higher rates as compared to those developed population of USA and UK, where the anti-vaccine lobbies are very strong. So that is why our people probably are now not getting very serious infection with the COVID-19 in the current third wave of the COVID-19 pandemic. Also, among the published guideline from the WHO-like professional bodies, there is lack of consensus regarding the adult vaccination strategies, different kind of adult vaccination strategies. Also, failure of the healthcare provider to monitor vaccination status and lack of specialized centers for the adult people is there in our country as well as in many parts of the world. There are vaccination centers, setups, data, recording, everything is there for the kids. But for the adults, this area is by and large neglected, and lack of drive among the policymakers is also there as far as the adult vaccination is concerned. Vaccine, what are those vaccine preventable illnesses in diabetic population? It is a well-known fact that diabetes people are 6 times more likely to suffer from invasive pneumococcal diseases as compared to the non-diabetic population. In one retrospective analysis from Portugal, where they studied the 5-year data from the hospitals for those people who were admitted for the community-acquired pneumonia, what they found is the mortality risk and also the hospital stay for those people who were admitted for community acquired pneumonia and they were suffering from diabetes was significantly higher as compared to the non-diabetic population. When we think of influenza infection in diabetic population is 3 to 6 times, has a higher chances of hospitalization, and mortality risk is significant, is 5 to 15% among the diabetic population. Diabetic population, when we think of the hepatitis B virus infection, they are more likely to get infected with the hepatitis B because of the unhygienic practices during the sharing of glucose monitoring devices, like somebody may touch the blood stains on the glucometer and get infected with the hepatitis B virus. Mortality risk for the diabetic people who suffer from acute and chronic liver disease is significantly higher as compared to the non-diabetic population. When we think of the zoster infection, it is associated with the longer use of the antiviral therapy in people with diabetes, and those people who catch the zoster infection, they suffer from more severe post-herpetic neuralgia as compared to the non-diabetic population. So what are the RSSDI ESI recommendation for the vaccination in the Indian patient with diabetes? They clearly say that all diabetic subjects should be educated for administering at least, I will repeat, at least pneumococcal and influenza vaccine. The annual vaccination against influenza is recommended for all diabetic patients more than 6 months of age, especially those with all patients, especially those with diabetes. And we prefer quadrivalent recombinant vaccine for the influenza for the diabetic population. Live attenuated vaccine in diabetic population for influenza should be avoided. The vaccination is contraindicated or postponed in these patients who have hypersensitivity to active substance or any of the excipient of the vaccine. Somebody who has a history of chicken egg allergy should be, this is a kind of a relative contraindication for the flu shot. History of Guillain-Barré syndrome within 6 months of a previous influenza vaccine, these people should not be given another shot of influenza vaccine. We can postpone the vaccination in those people who are suffering from any febrile illness, as is generally recommended also. Now, this is the CDC from US guideline for the adult vaccination, and highlighted here is the people who are suffering from diabetes. Now they say that influenza vaccine, as the recommendation for influenza is same as our RSSDI ESI clinical practice guideline. 1 dose annually for all people with diabetes, Tetanus, diphtheria and pertussis, that has to be replaced by TD, that is tetanus and diphtheria. 1 dose every 1 booster dose every 10 years and 1 extra dose for pregnant females. Varicella, again varicella and 2 doses of varicella for all diabetic population. Those highlighted here in the yellow color are recommendation for all those people with diabetes or non-diabetic who do not have any history of previous vaccination or do not have previous documentation of same infection. So it should be given to all people with diabetes, almost all. HPV, all patients with diabetes below 26 years of age, 3 doses. All males with diabetes, 3 doses below 21 years of age. Zoster infection, 1 dose of zoster infection should be given to all diabetic, irrespective of previous history of zoster infection. So this is also important. Anybody who has previous history of zoster infection, we cannot avoid the zoster infection in that patient. This patient also requires a zoster infection. This is the CDC guideline from USA. Mumps, measles and rubella, again 1 or 2 doses depending on the indication for all diabetic. So here is the list of those vaccination which should be given to the all diabetic population according to the CDC guideline. When we come to hepatitis vaccination, hepatitis B, all patients of the diabetes should be provided with the hepatitis B vaccination. Those areas which are marked as violet here are the recommendation for a specific group of people, like meningococcal vaccine to those who are traveling to Kumbh or any other areas, hepatitis B to highly endemic areas. So these are not the necessary vaccine, but these 5 vaccine, influenza, tetanus, varicella, HPV, zoster and pneumococcal vaccine. These vaccine and hepatitis B, these should be given according to CD guidelines for all diabetic populations, except in those people where it is contraindicated. Now, again, the ADA guideline for vaccination is also same: hepatitis B, HPV, influenza. When we come to the pneumococcal vaccine, we have two vaccines. One is pneumococcal polysaccharide vaccine, another is pneumococcal conjugated vaccine. Indian guidelines say that all patients with diabetes more than 2 years of age, they should be given pneumococcal polysaccharide vaccine that is available with the name of Pneumovax. While the ADA guidelines are slightly different, they say that pneumococcal conjugated vaccine, which is available with the name of Prevnar, is given to those people who have additional immunocompromising factors, like if they are suffering from chronic renal disorders, or if they have undergone the cochlear implantation, or if they are having some kind of a cerebrospinal fluid leakage, they should be vaccinated with PCV, that is Prevnar. But Indian guidelines say that all diabetic patients should be vaccinated with Pneumovax 1 dose. And those people who cross the age of 65 years after 1 dose of Pneumovax or Pneumovax, they should be given another dose of Pneumovax after the 65 years of age. But the gap between two doses should be at least 5 years. So again, the guideline by ADA is same as the CDC guideline: tetanus, diphtheria, zoster. What is the difference between two pneumococcal vaccine, PPSV 23 and PCV 13, that is pneumococcal polysaccharide unconjugated vaccine and pneumococcal capsular conjugated vaccine? The main difference is efficacy among the elderly population. PPSV is highly efficacious against the invasive pneumococcal disease in elderly population, 50 to 70% effective in preventing the invasive pneumococcal disease in this group of population, while pneumococcal conjugated vaccine is not that effective against prevention of the invasive pneumococcal disease in elderly population. But this vaccine is highly effective in reducing the nasopharyngeal carrier stage of the pneumococcal diseases. So this can bring down the community burden of the pneumococcal diseases, but not the pneumococcal polysaccharide vaccine. That is why PCV is being given nowadays to children who are below 2 years of age, so that it can bring down the overall disease burden of the pneumococcal diseases among the kids. But as I have said earlier, there is a lot of neglect regarding the adult vaccination in the diabetic population as well as the non-diabetic population. What can we do to improve the vaccination of our people with diabetes? There is a study in the US. They have studied family practice settings through the implementation of one management program, which is known as 4-pillar transformation program. What they did is they intervened at various levels, like interventions were included in the standing orders for the paramedical persons to educate the patients of diabetes for vaccination, to administer them vaccination at the time when it is needed, vaccine needs screening of the patients of diabetes, patient education, electronic medical record alerts to the HCVs and the patients also, and appointment of an immunization champion in the family practice sessions and quality improvement meeting. And the results were tremendous. 10-week post-project implementation, the increased screening and education resulted in 64% of the eligible patient being vaccinated with pneumococcal polysaccharide vaccine 23, 86% pneumococcal conjugated vaccine, 89% were vaccinated with tetanus vaccine, and 54% were vaccinated with the herpes zoster vaccine. So the results indicate that the formal printed education and on diabetes and vaccine increased the vaccine uptake in eligible patient by 76%. So again, this whole session is on the diabetes education. This area also needs educating our patients of diabetes regarding the need for at least 2 vaccination in our country, influenza and pneumococcal vaccine, because we are a poor resource country. So our patient may not afford all the vaccines which are indicated by CDC or adult vaccine guideline by the US guideline, but at least we can educate them to accept the pneumococcal and influenza vaccination. What can the policy makers do for the increase in the vaccination of the adult population? And what are the areas where it is lacking? There's lack of surveillance. So pilot studies can be done to collect data on the adult vaccine preventable disease burden. Multidisciplinary consensus to develop the national guidelines. There are no national guidelines for the adult vaccination in our country.
lack of coordinated adult immunization programs can be developed. Lack of recording system is there, so it can be maintained. There is a lot of data recording, data submission regarding the children's vaccination, but there is no data recording or no data maintenance as far as the adult vaccination is concerned. There are missed opportunities for the vaccination. Incorporate vaccination into the regular health checkup programs. More affordable brands of the vaccine can be made available for the adults. Lack of proper provider recommendation is also there. We are spending most of the time with our diabetes in hyperglycemia management, in management of hypoglycemia, in preventing the cardiovascular diseases, in preventing the diabetic foot problem. But this is an area in our chamber also, probably we are lacking the focus on the preventable diseases. At least pneumococcal and influenza vaccination can be given proper attention. So home message is educate our people and healthcare workers working with you regarding the need for vaccination of diabetic patient. At least vaccinate all your diabetes patient for influenza, pneumococcal diseases, and hepatitis B virus diseases. Try to expand the vaccination scope beyond the above mentioned diseases. Thanks for the patient listening. Thanks.
Thank you, Dr. Sanjeev. Over to the chairpersons.
Thank you, sir. Thank you, sir, for the wonderful lecture over the adult vaccination, which is actually the need of the day. And when we are in the era of the COVID vaccination and the booster doses upcoming for the diabetic patients, specifically more than 60 years of age. So this lecture is meaningful in the same line also. And now we are having the discussion about the adult vaccination. So I don't see any question over here. If you have any question, then we can ask. Otherwise, we can move ahead. Looking at
I don't see any questions, so I'll quickly go through to Dr. R.L. Khare. Nirav, please, the slides of Dr. Khare.
Thank you.
I'm extremely sorry that we are running behind schedule, but the topics are so interesting that I don't have the heart to stop my speakers. So
yeah, I agree.
Knowledge, I don't think so anybody will mind. That was the reason I was not interfering, because these are all very important topics, and the main purpose of the conference is to spread happiness and awareness and education. Dr. Khare is an MBBS and MD, and he lead through this wonderful session. Dr. Khare, all to you now.
Just one second, Dr. Ashish. Just wanted to thank Dr. Vitul for all those kind words. He repeatedly spoke very kindly. Very grateful to you, sir. Honored and humbled. Thank you very much, sir.
Dr. Khare, please proceed. Dr. Khare?
Dr. Khare, sir, you have also got notification on your screen to unmute yourself. Please unmute.
Okay, sorry. I'm audible, sir?
Yeah.
So I want to thank Rakesh sir and Ashish sir for this opportunity. And as we are running short of time, I'll just start our next interesting session where everyone is centered the sexual happiness in the diabetic patient. And to chair the I invite Dr. Appam Chaudhary and Dr. Tarun Chatija sir and Dr. Palak Gowri ma'am. And over to chairperson to please introduce our next speaker. Thank you.
Yeah, if may I, good evening all. Myself, Dr. Rupam. It's a privilege to be a part of Global Diabetes Forum. And we have this evening a very interesting and less talked topic, that is the sexual dysfunctions and the sexual problems that comes along with diabetes. So to enlighten us, we have three eminent speakers this evening. We'll start with Dr. Rakesh Parikh, who is well known to all of us. He's a consultant diabetologist in Jaipur. He's fellow of American College of Endocrinology, Royal College of Physicians, life member of RSSDI, DFSI, and lot many other institutions. So over to Dr. Rakesh Parikh to enlighten us of male sexual dysfunction.
Thank you, Dr. Rupam. And thank you, Dr. Raka and Dr. Ashish, for inviting me for this prestigious conference. Let me share my screen. Is it visible?
Yes.
Please go ahead.
Visible and
So,
Beautiful slide. Yeah.
in this, like male sexual dysfunction in diabetics is a huge topic, and we know that there are several conditions that patient might present to you with, but the most common ones are the erectile dysfunction and premature ejaculation. So let us focus our discussion on these two only. And, at the onset, let me have a disclaimer that I am not a sexologist. So I don't claim to have cure for all the sexual dysfunction problems that patients come to you with, but maybe we can discuss. My slides are automatically moving. 1 minute.
You have given Viagra to your slides.
Okay, so let's start with ED first. Oh, sorry, something is wrong. I don't know why. Just give me a second, please. I will restart it.
I think, sir, it's an auto mode. You have to go back, and in the slide, you have to off that auto mode.
I never put auto on. I don't know how it got. Like Dr. Raka said, probably. There is some.
Your slides are excited now.
Okay, let's try it again. Okay, so erectile dysfunction, to define ED, it's the consistent or recurrent inability of a man to attain.
Not visible.
Sorry, is it visible?
Not visible.
Oh, sorry. Apologies for the delay.
Can we have Dr. Purvi madam first?
No, I think because I just have another talk which is ongoing. I think.
Okay, go ahead.
Is it working fine now?
Yes, yes.
Okay. So to define ED, it's the consistent or recurrent inability of a man to attain or maintain an erection sufficient for sexual performance. The overall prevalence is very high, something around 16 to 25% in the general population, and the prevalence basically varies depending on the definition of ED that is used in the study and the cohort that is studied. But in general, we can say that the prevalence goes up with the advancing age. People who are elderly people, something like those who are above 70 years, they are having 6 to 7 times higher prevalence compared to the younger population, and the rising prevalence is basically age-related hormonal changes, some metabolic or inflammatory factors, and comorbidities that are common with the elderly population. So the physiology of erection, I'm sure we all are aware of that. It's the sexual stimulation basically leads to sexual or tactile stimulation.
Now let us come to the SGLT2 inhibitors. I will not go.
So we all know that it's a neurovascular phenomena, and the sexual or tactile stimulation basically leads to parasympathetic activity, which leads to relaxation of the smooth muscles mediated by cyclic GMP. And there is influx of blood in the corpus cavernosus, which leads to erection. And then at the same time, the veins are compressed, and that is how the blood stays there, and that is how the erection is achieved. Now, there can be several causes of erection. The erectile dysfunction, causes like diabetes, hypertension, excessive alcohol use, smoking, certain medications, hypogonadism, cardiovascular disease, advancing age, or certain neurological problems. And the other component which is very important is the emotional causes, the psychological stress. Now, some of the slides are still moving, but I'll try to match with the speed of the slides. So if we go in details about the causes, the psychological factors can be something like the performance anxiety, psychological trauma, depression, psychosis, or misconceptions related to sexual activity. There can be vascular disorders like PVD or hypertension or venous leak, neurological disorders like stroke or peripheral neuropathies, multiple sclerosis, spinal and pelvic trauma, endocrine and metabolic disorders like diabetes, hypogonadism, hyperthyroidism, hypopituitarism, hyperprolactinemia, hyperlipidemia, liver disorders or renal disorders. Then miscellaneous causes like smoking, drugs and alcohol abuse, structural abnormalities of the penis, surgery or trauma. These all can be the factors. Now, among the medicines, there is a long list of drugs which can be involved or which can be responsible for ED. So we must be careful about these drugs. The commonly used drugs like the thiazide diuretics, beta blockers, or CCBs can also be a cause for ED. The other group of drugs like TCS or SSRIs, which are often used. Some studies have even said that there is evidence supporting that statins might be responsible for ED in some patients. Now, while evaluating these patients, the most important aspect of evaluation is the sexual history. We must look at the onset of symptoms. If the symptoms have been gradual over a period of years, then it goes more in favor of organic cause. But if the symptoms have been sudden, then the cause is more likely to be some psychological factor. The duration of symptoms, the circumstances when the ED occurs. Some patients might have the ED only with their own partner, but otherwise they are not having erectile dysfunction. The most useful question that you can ask your patients is that, do you have the nocturnal or early morning erections, which is a physiological phenomena. Normally, every man gets erections during the night when he's in REM sleep, and that is noticed also. So the patients, if you just ask them that, do you get early morning or overnight erections, and if his answer is yes, then you can rule out the organic causes. It's more likely to be a psychological cause. And is the problem of having erection or maintaining that erection? So some patients, they get a normal erection, but that erection is normal till the time the patient is in supine position. Once the patient starts moving his gluteal muscles, then the erection is lost. And that is very clearly indicative of the pelvic skill phenomena, where by changing the positions, the blood from the penis is diverted to the gluteal muscles, and that gives a very clear indication that the problem is probably with the vascular structure. Loss of libido, if it is associated with the ED, then it goes more in favor of associated hypogonadism, or some psychological cause can also be there. Concurrent premature ejaculation, basically some patients who have premature ejaculation, they consider that they have ED, but basically just because they had ejaculation, they lose their erection. It may not be ED at all, it might just be PME. We should also look at the medical history of the patients, any comorbidities like cardiovascular disease, diabetes, depression, or alcoholism, whether the patient is smoker or not. That is again a very important question. History of pelvic surgeries, radiation, or trauma, that must be asked. Then any history of neurological conditions, we should look for that also, and any other endocrine problems, or the use of recreational drugs or prescribed medicines. One of those might be the culprit for ED. So these are the things that we must look at while taking the history of such patients. Then on examination, in addition to the routine blood pressure measurements, sometimes you might need to go for testicular examination, specifically when you are suspecting hypogonadism as the cause. Examination of penis might be required if there is a possibility of some structural abnormalities. If you are suspecting some vascular or neurological cause for the ED, then you might need to go for the vascular or neurological examination. In lab test, in addition to the routine tests like HbA1c, lipids, TFT, LFT, and RFT, if the patient is giving the history of decreased libido, then we must go for testosterone levels. Some patients you might need to go for prolactin levels or PSA. There are certain specialized investigations which can be done in patients in whom you see that the patient is very young and he has had the difficulty of getting erection since a long time, or patient who has got a history of trauma, or the patient who has got some abnormalities with penis or testes on examination. The patients who are not responding to medical therapies, these are the patients where you might need to go for some specialized investigations, and these are the specialized investigations that are available. Intracavernous injection test, the color Doppler ultrasound to assess the vascular integrity of the penis, the phalloarteriography to clarify about any vascular abnormalities, the cavernosometry to assess the venous occlusive mechanism, and the most important one is the nocturnal penile tumescence, where you monitor the patient's erections at night. Now, just by doing this nocturnal penile tumescence, you can differentiate the patient between those who are having organic condition or psychological condition. So, in the nocturnal penile tumescence testing, the equipment is put on the patient's penis. There is a band which is surrounding the penis, and that band measures the circumference of the penis, the rigidity of the penis, the time for which the penis has been rigid. So, those things are monitored there overnight. And after getting the results, if you see that there is no erectile response on the test, that means that the patient has got some organic etiology. If the patient has got erectile response, then it rules out the organic causes, and you must be facing a patient who is having some psychological reason for his erectile dysfunction. And in those patients, the re-evaluation of psychological factors and counseling might help. If the response is equivocal, then you might go for the same test for a consecutive three nights, and then you might get the erectile response, or you may not get the erectile response. So in patients where there is no response or no erection, And when you are suspecting an organic cause, then another test that is useful is the PBI, or penile brachial index, which is just like our ABI that we routinely do for diabetic foot patients. So in PBI, if the PBI is less than 0.7, then that is highly suggestive of arterial insufficiency, and you might need to go for a vascular evaluation. But in patients whose PBI is more than 0.7, it rules out arterial insufficiency, and you might have to look for the other causes. So if the patient also has got neurological deficit and PBI is more than 0.7, then you must assess his neurology. Neurological evaluation should be done. If PBI is more than 0.7, but it falls after exercise, so the one that I referred to earlier, that is pelvic still syndrome, where the blood is getting diverted from penile artery to the pelvic muscles, and in these patients, then you need to go for arteriography or surgical repair. The patients who have a PBI of more than 0.7 and it doesn't change after exercise and there is no neurological deficit, then it might be probably a venous disorder, and then you need to go for vascular evaluation. So in terms of treatment, we must first identify and treat the organic comorbidities that are there in the patient. We must counsel the patient and educate the patient along with the partner, then identify and treat the psychosexual dysfunctions which are there. And then there are certain medications and devices that we can use, and surgery can be offered to selected patients. Now, non-pharmacological interventions, lifestyle modification is very important. Advice for regular exercise and weight loss and smoking cessation helps in a lot of patients. In the patients who are having psychological causes, the psychological counseling and reassurance helps them a lot. Among the drugs, as we know that the erection is mainly managed by cyclic GMP levels, so you can prevent the degradation of cyclic GMP by using the PDE5 inhibitors, and by doing so, you can increase the levels of cyclic GMP. The other alternative is to use the prostaglandin 1s, which basically activate the PGE1 receptors, and that is how the adenylyl cyclase activities improved, and the patient's cyclic AMP levels are improved, and that is how the patient gets erection. So these are the two options among the pharmacological therapy that we have. So PDE5 inhibitors are the first line therapy, and these drugs basically, as we discussed earlier, they just inhibit the breakdown of cyclic GMP, and that is how the smooth muscles gets relaxed, there is vasodilatation, and the patient gets proper erection. Now among these we have different drugs like sildenafil, tadalafil, vardenafil, and avanafil, which are available. Most of these drugs, they all have the same mechanism of action, so there is no difference in the mechanism of action, but their PK profile, PD profile, their isoenzyme sensitivity, and side effect profile might differ. The PDE5 inhibitors are not the initiators of erection, so the patient must have sexual stimulation in order to get any response from these drugs. In terms of efficacy, there is no head-to-head trial to compare these drugs, but if you look at overall studies, these drugs are highly effective, and you will see the response in around 80% patients with these drugs. In terms of PK profile, tadalafil, as we all know, is the long-acting one, which has got a duration of action lasting for around 36 hours. The others are short-acting. So when you are using tadalafil, we must advise the patient that he should not use it on consecutive days. He must skip it after using for 1 day. Now, when to what all things we should tell the patient who is being prescribed these drugs. We must clarify that there is a need for sexual stimulation to have erection. This drug will not work if you do not have a stimulation. The absorption of sildenafil specifically is reduced with food and fatty food specifically, so they must give a time gap in between. The maximal efficacy you can expect after 1 hour of taking this drug, and 2 hours with tadalafil, and the patient may not get response in first few attempts, so you should advise the patient to try it at least 6 to 8 times before giving up. Some side effects like headache, indigestion, flushing, and nasal congestion can be seen in these patients. And there are contraindications that we must keep in mind. Any patient who is having a severe cardiovascular disease, patients who are on nitrates, the patients who are having prolonged QT, you should not use vardenafil. The patients who are using alpha blocking drugs, they might develop hypotension, so we must be careful there. And in patients who are elderly or having renal or hepatic dysfunction, you might need to go for dose adjustment. Then what are the causes for treatment failure? As we discussed earlier, food or drug interactions, the wrong timing, the submaximal dose use, or the lack of sexual stimulation, or heavy alcohol use, or associated hypogonadism, or there is problem with their relationship. So these are the common reasons for failure. Once you are sure that the PDE5 inhibitors are not working, then you can go for any of the other alternatives like intracavernosal injections, or vacuum constriction devices, or intraurethral alpostadil suppositories, or inflammable prostheses, and vascular surgery if there is any vascular reason. Now, the workup for these patients, when a patient comes to you for ED, the first and foremost advice that you give is of lifestyle modification. As we discussed earlier, psychosexual counseling of the couple must be done. And if the patient has got associated hypogonadism, then that must be treated by giving him testosterone supplementation. And after that, if the patient has ED, you can add PDE5 inhibitors. If that fails, then you can go for the alternative options. And the surgery is, penile prosthesis is the last choice that you have. Certain patients you might need to refer to a specialist, specifically the patients who have got deep-rooted psychiatric problems or CNS disorders or complex endocrine disorders or severe cardiovascular diseases. Some patients who have a lifelong erectile dysfunction or some structural abnormalities with the penis, you need to refer them to a specialist. Now we'll move to the second aspect, that is PE. So again, there is no consensus on the definition of PE, but ejaculation that occurs sooner than desired and there is loss of control over ejaculation, which causes distress to either or both the parents, is PE. Now, there is no consensus, as we said, as I discussed earlier, but in general, a patient who has got the intravaginal ejaculatory latency time of less than 60 seconds definitely is having PE. But most of the definitions agree that 120 seconds can also be used as the cutoff. And it might depend on the cultural habits of the particular society. As we see that there is a difference in the IELT in different countries and different races. So in terms of epidemiologically, it's a very common dysfunction, which is again seen in 4 to 39% patients in general population. But as I said earlier, the definition is not, there is no consensus on the definition, and that is why there is a variation in the reported incidence. The rates are generally not affected by age or marital status or race or country of residency. Now, there is a disconnect between the diagnosis and reported prevalence of PE, because male patients do not often spontaneously offer that they are having this problem, and clinicians usually do not inquire about this condition very often. The patients don't report it because they feel embarrassed. They think that it's not a medical condition, and they are not sure whether the doctor will be able to address their issue. So that is why they are not very open to you. Now, the exact etiology of PE is not fully known. The combination of physiological and psychological factors are involved. The PE can be primary, or it can be acquired or secondary to some other conditions like prostatitis or UTI or opioid withdrawal. Then some important aspects in the history. We must look at the age of onset of the disorder, the frequency of PE, whether it is consistent or is it happening only with some particular conditions. The circumstances when the PE happens. The IELT patients are usually able to tell with what is the IELT that the patient has. We should look for any other existing sexual problems like ED. And we must also look at the patient's, if it has affected his relationship or it has affected the sense of well-being. Now, in a physical examination, there is not much that you can do, but if you are suspecting some reason for PE, then it might be helpful to look at the prostate. Psychological evaluation is very important, and anxiety, performance anxiety is a very common cause for PE. Now, in terms of treatment, we must treat the underlying cause. There might be some infection if it is there. Pharmacological interventions are there to be offered to patients, and behavioral interventions. Now, this is a very interesting book and a very useful book that I would request that you should offer to all the patients who come to you with PE. Masters and Johnson's. It is for general people, and it explains very well. And there are certain techniques that they have talked about. The common one being stop and squeeze technique, where they say that the patient, when he feels that he's going to ejaculate, at that time he should stop, and then he should squeeze the base of his glans, and then he can again, start with the intercourse. So that is how they can prevent the PE. Now, in pharmacological interventions, we have topical anesthetic drugs, then TCAs, SSRIs, and PDE5 inhibitors. Now, among the topical agents, you can use anything like lidocaine or prilocaine. You can apply it on the penis 20 to 30 minutes prior to intercourse. But you must wash off before going for intercourse. And the potential problems are that it might you might lose the pleasure, specifically in the male partner, and there might be some skin reactions or allergy. There are certain condoms also which come pre-filled with these agents, and those are also available in the market. Now, TCAs, they are presumed to work via the neurotransmitters that are involved in the ejaculation, and the chlorpheniramine is one of the drugs. It can be used in certain patients. You can use it on SOS basis or on daily basis. The side effects, we are all aware of the side effects of TCAs. you can go for approach where you're using it on SOS basis or on daily basis. The patients who are having ILTS more than 60 seconds, the patients who have higher self-reported sexual satisfaction, and the men who ejaculated 2 or more times a week are expected to have better response while using it on SOS basis. The SSRIs are again very commonly used. The common one is paroxetine. It can be again used as SOS or can be given on daily basis. The side effects are there, which is a potential problem. Now, these are the different SSRIs that we have, SSRIs and TCAs that we have. The most commonly used one is paroxetine, which is often used by doctors. Now, PDE5 inhibitors, the mode of action is not very clear, but probably by improving the cyclic GMP levels, they prolong the nitrous oxide effect, and that is how the patient has got better erection, and that gives him the performance anxiety is relieved, and that is how it helps in maintaining the erection. You can use sildenafil, and again, we discuss about the potential problems with it. Now, among the oral medications that we have, the multiple studies have shown that SSRIs and TCAs are good in delaying the IELT. Among the SSRIs, paroxetine seems to be the best, with sertraline and fluoxetine close behind. Although more efficacious in some studies, almost twice as many adverse effects are reported with clomipramine compared to SSRIs, and the evidence of sildenafil is weakest in terms of use for premature ejaculation. I thank you all, and my apologies. The slides were running fast, so I had to adjust with the speed of the slides. Thank you again, chairpersons, as well as the organizers, for inviting me here.
Thank you, sir, for your nice and elaborative talk. I think we can move to our next session, that is female sexual dysfunction. I request our chairperson, I am not able to visualize chairperson, to please introduce our next speaker, Dr. Purvi Chawla, ma'am.
Dr. Tarun, can you introduce the
yeah, I can. Good afternoon. Thank you, Dr. Raka and Dr. Ashish, for inviting me here as chairperson. It's been a wonderful session. Dr. Purvi Chawla has a long list of which we shall mention. She's done MBBS from Mumbai, MS Pharma from USA, PG Diabetology from UK, and she's a consultant diabetologist and director of clinical research in Mumbai. She has a whole lot of achievements. I think let's hold on. We'd like to hear her talk, because if we list every of her achievements, we'll probably take a lot of time. So I invite you, Dr. Purvi. Thank you, ma'am.
So much. Good afternoon, everyone. I should say that Dr. Rakesh has really set the mood rather than pace. And big thank you and congratulations to Dr. Raka and Dr. Ashish Saxena. You guys have been relentless, and there's a lot of cheer out there for you both and for the wonderful sessions that you have planned. So congratulations. I'd like to share my slides. Yeah. So once again, thank you for, having this session, which is, we always cover male sexual dysfunction, but the female sexual dysfunction is almost a taboo, never talked about, at least by the patients. And now we are just beginning to speak about it at all major conferences and prestigious platforms like this one, for example. So I'm extremely thankful for this session. And let's deep dive into it. So to understand dysfunction, let's understand what sexual health really means. Normal sexual health is a harmonious state of fulfillment with a physical, emotional, interpersonal, social, and spiritual sense of well-being. And sexuality covers not only just the activity per se, but thoughts about sex or the physical attributes and desire for sexual activity. And while sexual well-being is important for a good quality of life, it's negatively impacted by diabetes. And despite, the fact I just told you that there is a lot of emphasis and there's a lot of talk about male sexual dysfunction and a lot of drugs being, researched and talked about and looked into for male sexual dysfunction, there's very little attention that comes to female sexual dysfunction. In fact, so much so that patients don't even think that it's important to talk about it or share with the doctors, and doctors don't bother asking about it. So, well, the establishment of the International Society for the Study of Women's Sexual Health in 2001, almost 20 years ago, which is a multinational or multidisciplinary international community which is dedicated to the advancement of the study of female sexuality, has rekindled this interest again, and people are talking about it, and the subject is getting center stage attention, which it duly deserves. With that, the WHO defines female sexual dysfunction as the various ways in which a woman is unable to participate fully in a sexual relationship as she would wish. Well, the principal stages of sexual response cycle are desire, arousal, and orgasm, and any disturbance in any of these causes female sexual dysfunction, or FSD, as I will be referring to it in the remainder of the talk. The Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5 definition of FSD, includes disturbances in sexual desire and psychophysiological changes in the sexual response cycle, causing marked distress and interpersonal difficulty. DSM-5, it combines sexual desire and arousal disorders into the female sexual interest and arousal disorder. Then you have the orgasmic disorder, and vaginismus and dyspareunia are combined again into the genitopelvic plane and penetration disorder. May I request everyone to mute?
उसको रीस्टार्ट करें.
Importantly, it
अच्छा,
says
पूरा स्टॉप करके रीस्टार्ट.
Importantly, these components of sexual dysfunction as per DSM-5 should be present for at least 6 months to be called FSD, and not just, so it helps to differentiate a transient problem for a long-standing or a persistent dysfunction as such. The components, as I just described them, definitely includes hypoactive sexual desire disorder, or HSDD, which is the most common one, as you will see in the subsequent slides, which is nothing but reduced frequency and aversion to sexual intercourse. And then there are arousal disorders, orgasmic disorders, and sexual pain disorder as well. The Basson's, or the Rosemary-Basson's nonlinear model, was a very interesting one, because that describes that the function of female sexual response is actually, it's a function of emotional intimacy, sexual stimuli, and satisfaction from the relationships, besides all the biologic and psychological stimuli that, or the factors that interplay. So it's a very complex, it's a complex aspect or physiological function that drives this female sexual response, and let's be mindful of that. And why are we talking about it today? Is it really that common? In women with diabetes, you will be surprised to know that the prevalence of FSD, or female sexual dysfunction, is ranging from 20 to 80% as per various surveys. And systematic reviews have shown that it's almost 41% in premenopausal women and up to 64% in postmenopausal women. And systematic review and meta-analysis have also shown that the frequency of FSD is much higher in type 2 diabetes than type 1. In fact, one study that compared insulin pump therapy and multiple daily injection therapy in type 1 diabetes patients found that there was almost normalization of sexual function at the end of the study, which suggested the role of tight glycemic control as well as avoidance of hypoglycemia in type 1 diabetes. And this was in the insulin pump arm rather than the MDI pump, in the MDI arm. Depression and mental health status were independent predictors for FSD in diabetic women in this study. So again, an important point to note here. So desire and arousal disorder, as I told you, is the commonest, almost ranging to 71%. Diminished clitoral sensation, which leads to orgasms, is 63%. orgasmic dysfunction up to 50%, and then you have vaginal discomfort, dyspareunia, and vaginal dryness as well. The etiology is multifactorial and involves not only anatomical factors, vascular ones, nervous and endocrine. And we know that diabetes, its comorbid conditions, and the complications of diabetes, each of these impact each of these factors as well that are closely or intricately involved in FSD. This study in 600 women with type 2 diabetes that completed a questionnaire of self-report measures of sexual dysfunction found that longer the duration of diabetes, older the age of the women, higher the BMI, presence of cardiovascular disease, and other diabetes complications were definitely associated with worse sexual function. Metabolic syndrome and atherogenic dyslipidemia were also independent predictors of FSD. And only depression and marital status were the strongest independent factors associated with FSD. Other factors include, in diabetes in particular, include the treatment modalities used, phase of the life that the patient is in, psychosomatic factors like body image issues or insulin pump use or anxiety, quality of life, interpersonal relationships, etc. Women with diabetes and cardiovascular disease or renal dysfunction or peripheral neuropathy definitely less likely to engage in regular sexual activity. Women with a history of stroke were found to have low level of sexual satisfaction even when they engaged. And women with peripheral neuropathy were found to have impacted not only the desire, but overall sexual activity due to the physical health as compared to those without neuropathy. So the pathophysiological mechanisms that cause sexual dysfunction in women with diabetes are so many, they're listed here. And I just want to highlight a few important ones. For example, hyperglycemia will reduce the hydration of the mucous membrane, causing dryness, dyspareunia, and several genitourinary infections, again causing sexual discomfort. Vascular complications associated with diabetes, we know, may reduce the blood supply locally in the sex organs and again cause dryness and arousal problems. Neuropathy and neurological factors may also impact the structural and functional changes in female genitalia and reduce the sensation and impaired sexual response itself. Hormonal dysfunction as well as deficiencies may also impact the lubrication of the vagina and overall cause loss of interest, fatigue, depression, etc. The most important ones in women seem to be psychological. For example, anxiety, the stress, low self-esteem issues, body image issues, fear of rejection, fear of performance, traumatic sexual experience in the past, and history of abuse. Depression, again, we know that diabetes and depression, Dr. Anubha gave a wonderful talk today on the same. And I'm not going to elaborate, but we know that diabetes and depression are so closely interlinked, and the incidence or prevalence of depression in diabetes women is much more, maybe 2 or 3 times more. And that also impacts the sexual dysfunction, sexual function and health. And socio-cultural factors, which is not new for anybody in this audience. Other important factors include, again, infections that I elaborated on, other metabolic conditions like PCOS, obesity, thyroid dysfunction, premature ovarian insufficiency. But we know that depression, coping skills with the disease, quality of relationship with the partner all play a very, very major role. Nutritional deficiencies also may impact the sexual health, including calcium, vitamin D, vitamin B1, etc. Deficiency may also impact sexual health. Drugs like antihypertensives, beta blockers, diuretics, lipid-lowering drugs like statins, even SGLT2 inhibitors, and the possible infections associated with that, all those impact sexual health. Neurotropic drugs, antidepressants, psychotics, anti-epileptics, antihistaminics, and the entire list of drugs is given here are all important considerations when we are evaluating female sexual dysfunction. Moving on, the symptoms and signs of FSD are very much what I already described you based on the components of female sexual dysfunction. Although we know that hypoactive sexual desire, which is nothing but this decrease or loss of desire or interest in sex, is the commonest one. Then there may be inadequate lubrication locally before or even after intercourse, spasms, pain, etc. But I want you to just understand what the different terms are. So vaginismus is recurrent or persistent involuntary spasm of the lower vaginal muscles. Dyspareunia is persistent or recurrent genital pain associated with sexual intercourse. And these may coexist maybe because of very tight or hypertonic pelvic floor muscles, giving rise to that fear of intercourse or pain, anxiety, and complete avoidance of intercourse completely. Vulvodynia is another important term, which is an outcome of painful diabetic neuropathy. It may be provoked or even generalized, and a subcomponent is clitoridemia, which is underreported and under-recognized as well. So we need to do a complete local examination and treat with local gels and creams and oral medications. Now, screening and diagnostic methods for FSD are well examined so far, but they are extremely tough. Like I told you, nobody wants to talk about it. So we need to gently ask for permission if we need to speak about this with the patient. Nothing can replace a good history and examination done in a very comfortable environment with the use of a very flexible conversation style and also some structured interviews. We can even ask the patient to maintain a satisfying sexual encounter e-diary, where the number of sexual events experienced and their satisfaction may be reported. There are several validated questionnaires. For example, the commonest one, which is used, is the Female Sexual Function Index, FSFI, and there are many others, but this is the commonest one used. And the whole aspect of diagnosing is based on the principles of allow, plicit, or MEBES, which means plicit is the most common one, which means you ask for permission before you start interviewing the patient, even based on limited information, give specific suggestions, and intensively treat the problem. You also must know the menopausal status of the patient and the onset, whether it was lifelong or just acquired recently, and the situation, whether it was situational or generalized. So again, the history must not only include the one with the presenting symptoms and stuff, but also include thorough gynec history, psychiatric history, birth control history, hormone therapy history, etc. So very, very detailed history should be taken. Local and general examination should be very thorough as well. Abdominal and gynecological exam and pap smears and other tests that need to be done to rule out even presence of infection. And other maybe focused workup may be required, like working up for the HPO axis status and the hormonal status, including hyperandrogenism, TSH, prolactin levels, SHBG, estradiol, total testosterone, calculated free testosterone, etc. must be included as indicated. Several possible determinants also include the complications associated with diabetes, and those should be screened and ruled out as well. So that is screening and diagnosis. Well, therapy includes, and the goal of successful therapy is restoration of sexual drive. And because hypoactive sexual desire disorder is the main component of FSD or the principal FSD, and all other components seem to arise from this, we need to resolve this before and above everything else. So management may definitely includes optimal glucose control, genital hygiene, psychosocial optimization, and then specific interventions like therapeutic patient education, psychotherapy, couple counseling, non-pharmacological and pharmacological interventions. Well, optimal glucose control, I don't need to elaborate on this, but we know that a healthy diet, routine exercise, adequate sleep, avoiding to smoke or moderation in alcohol intake, and use of appropriate therapy for diabetes is extremely important. An ancillary analysis of the Look Ahead trial even told us that intensive lifestyle modifications was as compared to the control group was associated with restoration of or improvement in the total FSFI, or the female sexual function index scores. And this can definitely, positive lifestyle changes will impact endothelial dysfunction, insulin resistance, oxidative stress, all in impacting positively. And then that's an important component for those with diabetes. Genital hygiene, again, is also a very important aspect, which I'm not going to elaborate, but we know that needs to be talked about to the patient. Specific treatment for FSD may include psychosocial optimization, which may include couples therapy, family counseling, buddy system, where you assign a more comfortable person that the patient will be more comfortable talking to provide that support, education, and counseling for the patient. It also involves therapeutic patient education, where you educate the patient on not only the anatomy, physiology, role of good glycemic control, nutrition, nerve health, and of course, cognitive restructuring. And psychosexual therapy, which is one of the most important components of female sexual dysfunction, where you teach them relaxation techniques, desensitization, non-demand touching, psychodynamic exploration, and even with different exercises, even mindfulness and cognitive behavior therapy. These have been found to improve FSD to a great aspect. Vaginal lubricants and moisturizers are very helpful for vaginal dryness in women with diabetes who are post-menopausal particularly, or those with hyperglycemia and complain of vaginal dryness or dyspareunia. Many cases can be treated with simple interventions like treatment of underlying genital infections. Drug therapy, well, drugs that increase desire include, replacing thiamine levels in the blood in the brain with salbutamine, yohimbine, sildenafil, arginine sachets with ginseng, bupropion, Botox, oxytocin nasal spray, omega-3 fatty acids, which also improve the perimenopausal symptoms, and DHEA. Again, there's limited evidence for the same, but has shown to improve the libido in female subjects with diabetes and female sexual dysfunction. Newer agents include flibanserin, which is approved by the US FDA. It increases dopamine and norepinephrine secretion through serotonin, and it's approved for hypoactive sexual desire disorder in premenopausal women, although specific counseling must be included, and there's limited data with this drug in those women with diabetes. Bremelanotide is another drug that has also been approved in the intranasal and subcutaneous routes of injection. This is MCR4 agonist. Again, they help in hypoactive sexual desire disorder. And then there is a combination of testosterone and sildenafil also, which is approved for the same. So again, guidelines from the Canadian Urological Association, they give it from, they outline the treatment based on the diagnosis. For example, if it's orgasmic dysfunction, then they say mindfulness, sex therapy, hormonal therapy, bupropion, PDE5 inhibitors, and even yohimbine hydrochloride. So they have beautifully outlined this, and I refer you to, I refer that guideline to you if you for further management. And this is just a hypothetical mechanism of action for the current treatments for HSDD or hypoactive sexual desire or dysfunction. And all the treatments are hypothesized to modify the functional neuronal pathways through experiential stimuli, corticosteroid hormone action, and modulation of the neurotransmitter levels. And you can see they're impacting not only the prefrontal cortex, but the other areas of the brain involved, supposedly involved in FSD as well. So overall, are we doing enough for this in women with diabetes and FSD? Well, we definitely need further studies to understand occurrence of sexual dysfunction and its impact on quality of life among women with diabetes, especially from conservative society like ours, and also to understand the role of newer treatments like DHEA supplementation, estrogen androgen replacement therapy, and also flibanserin. Ask, and of course, listen. Encourage the patients to share with you their problems and listen to them patiently. Structured and friendly questionnaires to be developed, and of course, work up and treat the disorder when found. So thank you very much, Team GDF 2022, for this wonderful opportunity. Remember that intercourse is driven by what's between the ears rather than what's between the legs. And because every woman deserves the joy of her sexuality, we need to talk more about this and resolve issues associated with female sexual dysfunction in women with diabetes. Thank you so much.
Thank you, ma'am, for a wonderful session. If there are any questions, we can take them, or depending on at the end of the session.
Dr. Palak, please introduce our next speaker.
Yeah. Dr. Puri, that was a wonderful lecture on female sexual dysfunction. And what I saw, what was very encouraging, is that all the participants stayed throughout the talk. And now that Dr. Rakesh has set the pace, you have set the mood. And this couple has now had a perfectly performing sexual activity and yet not having baby. Let's learn from Dr. Dakshata what is the problem in diabetes, the infertility issues in diabetes. Dr. Dakshata is a preventive diabetologist and director at Conquer Diabetes Center, Mumbai, founder of Home Diabetes Club, and founder committee member of United Diabetes Forum. Dr. Dakshata, the stage is yours.
Thank you, Palak ma'am. Can I just start my sharing screen?
Sure.
Neelam, can I share screen?
Yes, ma'am, you can share. Hello.
Okay, so at the outset, let me thank Dr. Raka sir and Dr. Ashish sir for making me part of this super successful Congress. And what I loved about it is first Congress probably, but health, happiness, harmony, and peace, which are the pillar of our pharmacotherapy and our treatment. So I think the theme itself is so motivating for us, and it is so important throughout our medical career when we are learning and when we are treating patients. So heartiest congratulations from my side, and every topic is being given such compassionate touch. And this topic also, which is a hidden topic, not much discussed in many conferences, is being included. I had a tough job, sir. I want to share that there is not a single chapter on infertility and diabetes. We treat infertility and diabetes so routinely in our practice. But I searched in Pickup, I searched in Jasmine, I searched in many books in women and diabetes. A lot of other factors are covered, but infertility and diabetes as such is not covered. But then I could find some, I can say, clinical material and articles from the internet, and we definitely do have our clinical experience. So just whenever we are starting any topic, it is always definition. And definition is infertility. What is infertility? It is inability of a couple to achieve pregnancy over an average period of 1 year if women is less than 35 years. And if woman is more than 35 years, it has to be a period of 6 months. Despite adequate regular, that is 3 to 4 times regular unprotected sexual intercourse. And to be on a lighter note, probably nowadays stress, lack of time, these are the main factors for infertility in diabetic women and non-diabetic women. And we had huge surge of gestational diabetic women in 2021. 2020 was a year of pandemic. People had a lot of time. They were having home food. They were doing yoga. They were doing some home exercises. And so many women of, diabetic women or PCOD women who were not able to conceive, they were at home, stress-free, they got time, and they got time for this 3 to 4 times session in a week. And so many women conceived, and we had peak of gestational diabetic women. I would come to that point later in the course of my talk. Infertility may also be referred that inability to carry this pregnancy to term. That is also very important. If there is something called as, it can be because of woman, man, and it does make a difference in India when it comes to socio-economic situation, whether it is the couple is infertile from both the side, it is only from woman or man, it's very important. It can be primary and secondary. Primary means couple has never conceived, and secondary means the couple has conceived once, and there is a problem in second pregnancy. First pregnancy was probably full-term normal baby or miscarriage, and there may be some issues to be addressed. Now, this disorder is not just metabolic or medical problem. It has a lot of psychosocial and economic problems as well. 10 to 15% of the couples worldwide, they face infertility problem. These are some statistics from Africa and Nigeria, because I was going through the literature, and a lot of, literature from African countries and Nigerian countries. The 20 to 60% people in Sahara, Sub-Sahara are, infertile couple. Now, I'm going to touch this topic first about male infertility. Whenever the couple is not able to, have baby, always woman is blamed first. But let's look at it from male infertility point of view first. Now, this is one literature where there is statistics are given between diabetes and male infertility, especially in type 2 diabetics. It is said that almost 10 to 25% couples are infertile, and out of which most of the time 10 to 30% causes are from male infertility point of view. So it's a request for every one of us that whenever we are labeling our type 2 diabetic women as an infertile woman, we have to see to it that the partner is also investigated properly. Partner may be undiagnosed diabetic, or he may be having some metabolic problem. That the moment you know that this girl had diabetes, this girl had type 1 diabetes, nobody bothers to check a male partner for infertility. So we have to keep these things in mind. Now, male infertility is described as male's insufficiency to cause fertilization in a fertile female over the period of 15 or almost 12 to 15 months. 50 to 60% of infertile couples in childbearing age, because of some social barriers, they don't seek medical help at all. And among these couples, 10 to 30% of the infertility problem is because of some problem in male partner. Now, AG, that is the main villain of any diabetic complication, advanced glycated end products, hyperglycemia, metabolic problem. Patient may not be diabetic, but AG start forming 10 years before diagnosis. So this is something which we have to take into account, that we are treating neuropathy, we are treating nephropathy, or we are preventing ECG, we are doing everything as per ADA protocol to evaluate complications.
The older one.
And then along with hyperglycemia, there is a decreased libido, there is impotence, infertility, depression because of hyperglycemia. There may be some other physical disorder. Patient may be on many antihypertensives which cause ED. Then one thing I want to share that I didn't know this, that spermatozoa also are known to secrete insulin. So that, and they are very much sensitive to hormonal fluctuations. So deficiency of insulin or insensitivity to insulin in diabetic, it alters endocrine pathway, resulting in impaired male reproductive function. So it's not just hyperglycemia, but the insulin secreted by spermatozoa also gets fluctuated, and that also causes a lot of male reproductive function. And this is from an authentic journal. Now, on investigation, on microscopy, on biochemical examination, we see that there is decreased sperm production, the quality is not good, decreased Sertoli cell vacuolization, decreased fertility, and then if you see epididymitis, morphology, density, everything is deranged. LH, FSH, testosterone levels are very much decreased because it is a central axis. All the hormones are going to get affected. Number is decreased. So these are few things which we see on paper when we investigate patients. Now, whether it is type 1 diabetic patient, type 2 diabetic patient, whether it is beta cell deficiency or insulin resistance, endocrine disorders, they are going to have a central axis of decreased testosterone, FSH, LH levels, decreased motility, decreased morphology. The viability of the sperms is not going to be very long, and that is going to contribute to male infertility. AG is oxidative stress. They are going to have more oxidative damage, DNA fragmentation. there is disrupted seminiferous tubules and altered sperm parameters. Then neuropathy. Neuropathy is going to give you basically a decreased sexual response, loss of libido, erectile dysfunction. There is going to be retrograde ejaculation because of bladder neck relaxation, because of autonomic neuropathy. So we need to treat everything simultaneously. Now, in diabetes, I just mentioned that oxidative stress and advanced glycated end products are the main damaging factors, and they are going to cause neuropathy. So we need to, have a multifactorial approach. Now, these are few elegant studies. They have demonstrated there is a high correlation between type 2 diabetes, type 1 diabetes, and reproductive function, giving rise to less sperm count, testosterone levels are low, Sertoli cells are low. So these are the studies which support that, in type 2 diabetic patient, there can be problem. Now, type 1 diabetes on male infertility, most of the time, diagnosis of type 1 diabetes is before puberty. So if type 1 diabetes is diagnosed before puberty, lot of things can happen if patient's sugar is not controlled right from the beginning. Before 1923, before advent of insulin, there was, a huge problem for type 1 male infertility. But after, 1950, 1990, as the better insulin was, produced and intensification of insulin was done, now there are insulin pumps available. So with better control, patients are doing much better, and our male type 1 diabetic patients are having almost same paternity rate as non-diabetic patients. Now, these are few studies with type 1 diabetic and gonadal hormones. So now these are other factors, pelvic neurological factors. This can happen to any non-diabetic patients as well. Because of hyperglycemia, there is some more urogenital infections or some, gland infections, pelvic infections. So everything is contributing, towards the same cause, male infertility. So we have to have a multifactorial approach. Now, these are some points we have to remember that ED needs to be taken into account. Retrograde ejaculation, asking that after sexual intercourse, if your urine is cloudy, this is the best clinical diagnosis. Don't have to do any, micturition urogram or anything. Just ask color of urine after the act. Then depression needs to be corrected. These are few things we need to look into. There is definitely no different treatment of male infertility in diabetes. Everything is going to be almost same. Lifestyle modification, de-addiction, antioxidant therapy plays a huge role. Definitely it is helpful. Pharmacotherapy for diabetes has to be intensified for type 1 diabetes and type 2 diabetes. If there is no response, then IVF or ICSI for patient whose sperm quality is not good can be tried. And then there are surgical treatment like implantation of penile prosthesis, reconstruction of bladder vesicular sphincter for any retrograde ejaculation, or if there is any procedure for vascular regeneration. So these are the things. Now going into my favorite topic, that is metabolic and reproductive disorders, or probably correction of these disorders in women. I'm going to talk about type 1 diabetics initially, that before 1923, the pregnancy rate in type 1 diabetes or amenorrhea was very, very common. By 1950, it improved, but still, after introduction of insulin to type 1 diabetic patients, a lot of things improved. Similarly, their menstrual cycles improved, infertility improved. 1993, there was intensification of insulin MDI, insulin pump was introduced, and after that, the menarche delay was mild, then menstrual dysfunction was mild, weight gain was little more in type 1 patient because probably due to over-insulinization, and emergence of polycystic ovarian disease in type 1 diabetes was seen. I'm going to explain this in the next few slides. That in type 1 diabetes, because of hyperglycemia, I'm going to the second column first, there is a lot of glucotoxicity. This glucotoxicity is causing abnormal ovarian folliculogenesis, there is follicular apoptosis, and there is early menopause. That is the basic simple thing. But when patient has hyperglycemia, exogenous insulin requirement goes up. Then ovaries are exposed to high levels of exogenous insulin. That gives same kind of picture like hyperinsulin resistance causing hyperinsulinemia in type 2 diabetics. Similar kind of picture is produced. Ovaries of that type 1 is exposed to high insulin levels, and it gives rise to PCOD. Now there is insulin deficiency, there is catabolic state, less leptin calcitonin level, less GnRH, less LH-FSH level, steroid production is less, there is hypogonadism, there is delayed puberty, menstrual irregularity. So this is how the reproductive life of a type 1 diabetic start if sugars are not controlled or patient is over-insulinized. In type 2 diabetes, I'm not going to go into the detail because it's basically PCOD, nothing more. Insulin resistance giving rise to high LH-FSH levels. There is abnormal folliculogenesis. There is hyperglycemia causing glucotoxicity, causing abnormal folliculogenesis, increase pre-androgen follicles, ovulatory dysfunction. There is hyperandrogenism also, and these are few things which we know and we have been seeing every day in our PCOS patient and type 2 diabetic patient. Few things I want to pinpoint that in type 1 diabetics, it is seen that they always have this fear of dying without having sexual intercourse or motherhood. So there is early sexual behavior seen in nowadays type 1 diabetic patients because of so much of overexposure. One thing has to be kept in mind. Second thing, if there is A1C increased by 1%, duration of menstrual cycle is every time prolonged by 5 days. So that 1% glycated hemoglobin reduction will actually give a good menstrual regularity. Now, these menstrual disturbances are every time not reflective of bad ovulation. Sometimes patient may be having menstrual irregularity but having good quality ovulation. So don't assume anything in any patient. Now, talking about recommendations, ADA suggests that starting at puberty, preconception counseling has to start at that point. It is not very early. That is the time when sex education is given. That is the time you have to give preconception counseling at the time of puberty. Same, International Society of Pediatric Diabetes also resonates with the same idea. So these things, and don't put negative things in patients' mind about fetal malformation, but they have to be warned about that thing so that the A1C control starts 5 years, at least 5 years before they conceive. It's not just 2 months or 3 months before they start planning pregnancy. So it has to be a staged approach, awareness, overview, and in depth. Everything has to go slow, and education has to be always step by step. Now, this is a study where in type 2 diabetic patient, if the diabetes is before their reproductive journey, just a second. Hello, Nirudan. Yeah, I'm coming. I'm actually in the middle of the lecture. Yeah, immediately. Dr. Raka? Hello? Hello?
Yes.
Dr. Raka, can I just take a second? Just a second? Sure. Yeah,
sure.
Please allow me that. It will be highly appreciated because I want to continue the session. Just give me a second because
no problem. Please
I'll explain you.
No problem. That's okay. Please carry.
I'm very sorry for this, but just give me a minute.
Please, it's okay. Just relax. Take your time.
Sorry, sir. Okay, so when type 2 diabetes is diagnosed before starting their reproductive journey, the chances of miscarriage or chances of infertility is very, very high. That is what is projected in this study. One second. Okay, now weight changes and infertility, risk factors and infertility. These are few things. Sir, one second. Sorry. So now treatment and investigations are almost same for infertility problem. Medical conditions include pelvic inflammatory disease, endometriosis. So whenever we are treating any type 2 diabetic patient for infertility, diabetes is not the only cause for infertility. We have to see to it that, PID, endometriosis, PCOD is always taken care of, but other problems like tubal blockages, most of the time, undiagnosed tuberculosis of pelvic problem is very, very common. So these are few problems which we really need to look into. Now, we know that fertility is at peak between 18 to 24, and it begins to decline after the age of 27, and it drops at a somewhat greater rate after 35. And typical woman has 12% of her ovarian reserve till the age of 30, and it is only 3% between the age of 35 to 40. So we have to be very, very traditional in our approach. We shouldn't be thinking about this ovum bank and everything. You have to be very traditional, that if you know that you have history of PCOD, if your mom is diabetic and you have metabolic syndrome, you have to get married early and you have to have your first child by 25 or 27. That is very, very clear. 81% of the variation in ovarian reserve is due to age alone, making age very, very important factor for female infertility. So there are some things where we have to be very traditional while treating this patient to prevent infertility. Now, lifestyle, definitely tobacco, smoking, alcohol are going to have some negative impact. So smokers who are, 60% more likely to be infertile. Women don't smoke, but you know that, with this kind of lifestyle, nowadays there are women who are smoking, or they are consuming, rural area, they're consuming tobacco. So these things should be discouraged. Now, hormonal imbalance and infertility, you have to take into account, you have to do LH, FSH, their prolactin levels that needs to be taken into account, testosterone, everything. Hyperprolactinemia has to be treated. Now we're talking about thyroid. Thyroid and diabetes always coexist. So thyroid disease had been shown to be associated with increased risk of premature and stillbirth. So even if thyroid is subclinical, you see to it that, every time if patient is hypothyroidism, the TSH level remains less than 1.5 or 1 for, normal fetal development, and simultaneously.
It is having the same criteria and there is something wrong with the response.
Now, diagnosing imaging, the workup for infertility remains same for any diabetic patients. Now, before few things which we need to take into account, that existing diseases, treatment, if there is any STD or any urinary tract infection. Remember, repeated urinary tract infection also changes pH of vagina in type 2 diabetic patients. So that also needs to be eradicated completely. That may be many times the simplest reason of infertility. Then weight reducing drug, if required hormonal treatment, surgical intervention, and last but not the least, IVF. But remember, IVF is not a magical solution for any women with metabolic problem, type 2 diabetic patients. They need to tackle both the things simultaneously. Now, before talking about preventive strategies and solutions, I have few cases to discuss. I haven't made the slides, purposely. So the first case which I'm going to discuss is 37-year-old female type 2 diabetic patient since last 2 years on insulin and metformin, and she's married since last 7 years. She's trying to conceive since last 2 years. Her BMI is around 25, her A1C is around 9.6, and she's absolutely non-adherent to lifestyle measures due to, some working timings or working pressure. Now, the solution for this patient, because I purposely didn't put any slides for, treatment of infertility and diabetes women, because it is absolutely not a, standard treatment protocol. It has to be a customized, tailor-made protocol as per her diabetes, as per her lifestyle. So this patient is already 37-year-old patient. She has to take break from her career. And this is the patient when she conceives, because she's already on insulin and metformin, still her A1C is on the higher side. So nothing is working for her. She has to have a pregnancy as her priority. Her infertility needs, some lifestyle modification, which her right now working schedule is not giving time, and her biological clock is ticking. So this patient has to take break from work. She has to plan her pregnancy, and this is the patient who has to continue metformin till term to have to avoid bad obstetric history. The second case which may come to us, which is a common patient to us, that a type 1 patient, fortunately she got married, she had a good life partner, she's 27-year-old patient. Diabetes was diagnosed 21 years back. That was before her menarche. So that suggests that her reproductive years were exposed to hyperglycemia. She's married since last 3 years. She's planning pregnancy since last 2 years. A1C is around 9.0 on multiple doses of insulin, but A1C is not coming down. So simple thing, this patient needs to, first of all, we need to look into her sonography to see whether she is over-insulinized and she has some simultaneously PCOD as well. And this patient needs intensification of insulinization with pump therapy. Believe me, these are the patients when they go on pump therapy, the requirement comes down because pump is the, you can say, most physiologically deliver of insulin. So the insulin requirement comes down, and patient A1C also comes down simultaneously. Now, third patient which I would like to discuss is, she's a 32-year-old woman, not a known case of diabetes, married since last 2 years, and now she's planning pregnancy since 1 year. Now, routine fertility workup shows that she has diabetes. Her A1C around 7.1, fasting around 170, PP low, PP is 98. Since her fasting and A1C on the higher side, her mom is diabetic, BMI is on the higher side, and USG shows PCOD. So we know that this is the patient who is heading towards diabetes. She is not gestational diabetic when she conceives. So now this patient needs very strict lifestyle modification, and this patient needs a very bold dose of metformin, more than definitely 1.5 to 2 grams to start with. Her PP is low, so we don't have to give her sulfonylurea or insulin. This patient will settle down with weight reduction, metformin, and she will definitely conceive. Now, one more patient I want to discuss is, she's an 18-year-old girl, menarche at the age of 15, delayed menarche, irregular menses. During pandemic period, this girl has put on about 8 to 10 kgs because of no physical activity and outside ordering of the food. USG is showing frank PCOS picture. Now, this is the patient who needs definitely immediate metformin, weight loss, and this patient has to be, counseled for early marriage, early pregnancy, and planning of, her conception, and idea about infertility, and some education about gestational diabetes. So this is the patient who should be empowered by preventive education at early age. And what can be our fifth patient? Fifth patient is an invisible patient. Now, this is the patient who will be a female child of all these 4 patients. Now, this child will be exposed to hyperglycemia when this infertile women will conceive. Most of the patients are already type 2 diabetic patients, or maybe they will be gestational diabetic patients. We have to see to it that the patient sugars are very tightly controlled from the beginning, so that female child in utero is not exposed to hyperglycemia, because a fetus pancreas starts responding to maternal insulin by 16 weeks of pregnancy. If that is the time your sugar is not controlled, this child's pancreas, the fetus pancreas, is primed for pubertal obesity, pubertal PCOS, and then eventually infertility. So we have to work on that kind of preventive level. Education is very, very important. Now, these are few international organizations, CDC, ADA, APHA. These are the organizations which are looking into women's health and especially infertility. Now, stigmatization, discrimination, these things need education, awareness through media, seminars, pamphlets. We need to have a lot of efforts. Policymakers are working for it. See, you can see in this picture, the problem is so huge and the efforts taken by us are not enough. We need support from government, we need support from policymakers, we need support from schools, from everybody. So we have to work as a team. Now, these are the small steps taken by my team from Conquer Diabetes, that we go to school, we start picking up girls at the age of 7th standard, 8th standard. It's not only sex education which gynecologists or general physicians which are giving to the patient. It's us, the physician, whoever is focused in diabetes practice, is diabetologist, whoever is doing preventive diabetology practice. We need to reach out to these girls to have them a good reproductive and metabolic life, maybe 10 years down the line. So definitely education is empowerment. We all believe that prevention is better than cure. But I believe that milligram of prevention, that half an hour spent with these 100 girls will really take them along. Milligram of prevention is worth kilogram of cure. Thank you so much.
That was a wonderful talk, Dr. Purvi. Dr. Dakshita, but I would like to throw in a line that you were talking of early education, especially in the fourth case of infertility that we discussed, that she should be educated to marry early. I tend to differ in that point because we have this egg freezing program in IVF centers, which is highly successful. And so more of the women can have the egg frozen at an early stage, and then they can use it at a later stage in their life when they wish to have a planned pregnancy. That is the only, that is a small opinion. A percentage of women can make use of this.
Yes, 100%, ma'am. Small percentage of women, people want to go for very professional careers, which will demand for, their time, and their sleep cycle and eating cycle will be disturbed. I totally understand. But nowadays, girls who are doing BA, BSc, commerce, and they're just going for 8 hours job and they want to delay their pregnancy till 35 and 37, absolutely unjustifiable doing ovum donation, ovum banking for such patients. I don't, encourage that.
The woman who is BA, BCom might not feel like marrying also at an early stage. There are so many other things that people find more important than marriage.
No, we are going against nature by doing this. I think all of our women doctors who are successful at the age of 60 right now, there are many or so many women who are in corporate field. They had got married at the age of 24, 25. They have their both the children before 30, 32 without any metabolic problem. Still they are successful. I feel nowadays, I'm not against anybody, but nowadays girls who don't want to take the responsibility early, they are just delaying marriage and they are running into infertility. I would say more than 50% cases are attributed to that. That is what is from my clinical experience.
Thank you, Dakshita.
Ovum banking is definitely a very noble option. I understand, but that is not for everyone.
Thank you, Dakshita.
Thank you.
Any more questions? Well, it was a very interesting talk, and I really thank Dr. Rakesh, Dr. Dakshita, and Dr. Purvi for such a wonderful session. When me and Raka were discussing about how to put in, actually, we are lucky that we got the best speakers for this session, and obviously, thanks to Dr. Tarun Satija, because I know once we were discussing, he's my boss, he's my teacher, and once we were discussing in one of the forums, and he said कि यार diabetic patient है कमजोरी करके आता है openly बता ही नहीं पाता है that he is suffering from these problems और हम Bicasul और B-complex देते रहते हैं. So that is where the thought came that we should have discussions on these things because these are regular patients. Thank you, Dr. Rakesh. Thank you, Dr. Purvi. Thank you, Dr. Dakshita, for making this session actually a wonderful, successful session. And now we proceed for the next session.
Thank you for this awesome opportunity.
Thank you, Purvi. Thank you. I'll introduce our rapporteur, Dr. Salesh. He will be taking us through this. He has got a lot of interest in podiatrics, and this happens to be a section which is a foot care symposium, happiness in giving a healthy foot, a healthy feet to patients. So all to you, Dr. Salesh.
Hello, am I audible, sir? Yes, first of all, thank you very much, Dr. Raka sir and Dr. Ashish sir, to give me this opportunity as a part of Global Diabetic Forum 2022. when we are talking about the diabetic food we can't neglect. I mean, everyone knows that diabetic food complications is also a major role in controlling the diabetes. So as a part of Global Diabetes Forum 2022, this food symposium, the chairperson I want to introduce, first of all, Dr. Manish Jangam sir. He is a preventive cardiologist. Second chairperson is Dr. Rajnish Saxena sir. And third person is third doctor is Dr. Arun Maya sir. Now I want to give this chair to Dr. Manish sir first.
Good evening, all. Yes, we are running too late, but the academics never stops. It has to be continued. And at the outset, I should thank Dr. Raka and Dr. Ashish sir. It's really a good academic feast, one of the best virtual conference again, and it's a great management as well. Now I will hand over podium to Dr. G. Arun Maya sir to introduce Indian Podiatry Association, Dr. APS Suri sir. Over to you, Dr. Arun Maya sir.
Good evening, Dr. Thank you, Dr. Manish. On behalf of the Food Care Symposia team, I congratulate and compliment Dr. Raka and the entire team for a very interesting Global Diabetes Forum 2022. A new year, greetings to each and every one of you. And it's a great privilege for me to introduce our esteemed speaker, Dr. APS Suri sir, the National President of the Indian Podiatry Association. He, with this entire team, focusing on the prevention of amputations in the country with the slogan called I Prevent Amputation. Dr. APS Suri is a very renowned diabetic foot surgeon in the country, having a global reputation. He's a director and the head Diabetic Foot Care Center, New Delhi, and at Fortis Hospital. National President of the Indian Podiatry Association. Did podiatry residency from the Harvard Medical School, Boston. Did diabetic foot fellowship programs of the Temple Hospital, USA. American board certified hyperbaric specialist, and also the member of the both national and the international associations. And sir is also focusing on a strong educations to the medical team at the country by conducting various foot educations programs or the fellowship programs in collaborations with the US universities. It's a very great privilege for me to invite you to deliver a session, sir. Once again, a very warm welcome to you.
Thank you, Dr. Maya sir, and thanks for the invite, and thanks to Dr. Raka and Dr. Ashish and congratulations for the nice conference. I'm sorry, there's some problem in my camera. I just focused just when Dr. Dakshita and other Dr. Parul madam was doing.
Amarpal sir, you can talk from space also. And only thing which we will hear will be foot.
Okay. Thank you so much. I'm sharing my slides. So, are my slides visible?
Yes, sir.
Yeah. So at the onset, we all know that diabetes is a global epidemic. We have been listening since afternoon. So many people suffering with diabetes all across the world. And at present, we have no cure for this disease. India, we are touching at something at 77 million people with diabetes. 60 to 70% of all diabetes, they had foot neuropathies. 1/4 of these patients, they land up with foot ulceration. And 1/4 of these patients with foot ulceration, they land up into amputation. So I think what we have been doing in our Indian Podiatry Association has been that how we can reduce the vast number of amputation, which is, we all know is vastly high in all over the country. Diabetes, as this conference of GDB tells, that it is a leading cause of non-traumatic lower extremity amputation. And a simple foot ulcer is a precursor to about 85% of all lower extremity amputation in diabetics. We all know that something around 2 lakh people annually, they lose their leg in India. And that's how it could be that. And we have to look at the topic which is given to me is a cost-effective diabetic foot care. And that is what I'm going to share in next 30 to 40 slides. This is how that, what is the cost effectiveness like how we can prevent these vast amputations in our patients. Shockingly, less than 50% of these amputees, either a unilateral or a bilateral below knee amputation or an above knee amputation occurs. These patients are not able to achieve mobility, either because of the cost factor. Again, they are not able to bear the cost of the calipers or the prosthesis, or they don't have the assessment to the ONP departments or to the podiatry departments. And we all know in US, something around 20 to 30 billion is a yearly cost to diabetic foot care, and so is it's high in our country also. If you look at 5-year mortality rate, if you look at this slide, that neuropathic ulcers, they have 45% mortality rate, as well neuroischemic ulcers, they had 56% mortality rate. That means these people, they die in next 5 years. There's such a high 5-year mortality rate for neuropathic or neuroischemic ulcer are there, which is only second to lung and pancreatic cancer, other than vastly high to all the prostate, melanomas, breast carcinoma, urinary bladder, and all other carcinomas in the body. If you look at rule of 5-15, 15% of these patients, they develop an ulcer, 15% of these ulcers, they develop osteomyelitis, 15% of these ulcers again land up with amputation, 85% I've already mentioned. Half of these amputed patients have contralateral amputation within 3 years. This is very important to learn, that whenever a patient is coming to you, he has got a unilateral amputation, our staff or our educators or our paramedics should be able to examine the other normal foot. This is very important to see, because these patients, they will have same peripheral vascular disease, they will be having same level of neuropathy in the foot, they can have high pressure areas, callus formation, any cracks in the other foot. That simple care has to be given to the other foot, because we have to save that contralateral amputation. Half of these patients, they die within 5 years. Also, every 20 seconds, a limb is lost to a diabetes all over the world. And in India, I said that 2 lakh legs are amputated every year. We all know that diabetic foot care is a costly figure. If you go on the last slide and see that inclusion of care provided by podiatrists for those with diabetes alone can save the healthcare system by $3.5 billion. This is a US dollar data, that $3.5 billion per year could be saved by if a simple preventive podiatry care is given to the patient in a diabetes care. So that is very important, that podiatry should be part and parcel of all diabetology clinic, and we should be able to give a simple education to the patient how to take care of the foot, and that is what we are trying to do under Indian Podiatry Association. If we look at wounds when we deal into diabetic wound care, just to mention here that first 4 weeks tell us the story for a diabetic foot healing. Whether whatever way we are doing, we are taking care of sugars, we are taking care of infections, we are taking care of offloading, dressings, and all these advanced technologies, or we are looking at cost-effective technologies. But first 4 weeks of our wound care will tell me that if my wound reduction is more than 50%, then there are 58% chances that the wound will heal in next 12 weeks of time. If my wound healing is less than 50% in first 4 weeks, that means there are only 9% chances that this wound will heal in 12 weeks of time. So then you and me have to do something. We have to look at the factors that why this wound is not healing. Either my sugars are not well, either the patient is walking on that foot, offloading is not there, either the cultures are not proper, I'm not giving antibiotic according to the culture, or whatever dressings I'm doing, or patient has got a poor vasculature and I'm doing dressings and other things over there. So you have to refer or talk to the vascular surgeon, and periphery and like that, you have to look at other factors that why this wound is not healing. So this is very important, other than that we keep on increasing the cost of the patient, because if the dressings you keep on doing 2 to 3 weeks or more of dressing, patient keep on walking on that dressing, so that will keep on increasing the cost to the patient, but your wound will not heal in that period of time. Also, 49% of these ulcers may fail to heal despite all traditional good ulcer care. This is also very important. You and me, we are trying our best to do for the patient's wound, but 49% of these ulcers, they fail to heal. That is a time that we have to think of all advanced technologies, what are available in your clinic, and that you have to use it. And again, cost-effective advanced technology. There are a lot of costly technologies which I'll share in one or two other slides, but we have to think of the cost-effective technologies. If we look at new treatment modalities, offloading is very important. Debridement again is a very important part and parcel of the diabetic wound management. VAC therapy is important and very cost effective. There are some costly affairs also like KCI and other some international companies are available. But yes, we have to indigenously, we can plan our own VAC system, which can really save the cost to something around 2,000 to 3,000 rupees for a single VAC application. Superoxidized solution and growth factors are available. Lot of dressings are available like hydrogels, hydrochloride, collagens, and langenates. But if we mix these dressing with silver, then again the cost will increase. So we can try to use dressings which are indigenously made in our country. Some international companies are available, but yes, again, cost have to be seen for these patients. Magar therapy is at the back step. Hyperbaric oxygen, very few centers in the country are using that. Again, it is little costly affair, and whenever needed, we should be judicially use hyperbaric oxygen therapy. Again, a very cost-effective dressing is honey dressing. Honey is easily available in every part and parcel of the country. Any clinic, you can just take raw honey, mix it with the calcium alginate sheet, and you can apply that on the wound, and very cost-effective dressings are available with that. Vacuum assisted closure, you can see patients or wounds on the plantar surface or on the dorsum of the foot. After doing the debridement, we can apply these VAC therapies, and we can indigenously use the foam. You can see patients over here like bigger wounds. And if we keep on doing dressings for these type of wounds, again, the cost of the patient will increase. But if we apply VAC therapy, vacuum assisted closure, and send the patient back home early to their homes, we can discharge the patient early, because if the patient needs 2 to 3 weeks of admission in the hospital, early we can discharge them. That will again decrease the cost of the patient, and VAC can continue. Sometimes twice or thrice VAC is applied, and these type of good granulation tissue develops on the plantar surface or on the dorsum of the foot or any part of the foot, and then we can early graft these patients. Again, the duration of wound healing for these type of wound, the bigger wounds, can be decreased by using vacuum assisted closure in these patients. Again, then in this type of wounds, if you can see in the second photograph, offloading again is very important. With a rocker sole sandal, these patients are totally mobile and they can walk properly with this. NPWT draws the wound edges together. It is provides direct and complete wound bed contact, evenly distributes the pressure, removes the exudate, and also in the initial first or second application, we mainly use to remove the exudates, but then later on, it is mainly for the granulation tissue formation. Reduces edema, perfusion, and it's a very useful therapy if we have to use VAC therapy on the bigger wounds. And really, we can save cost of the patient and early discharge this patient back to the home or to the hospice care. Debridement, I think as a physician or diabetologist, we should not be scary of doing debridements on the patient. There are different type of debridement techniques. Sharp debridement, where you can just take the scalpel with a tooth forceps or artery forceps or any type of instruments what you have in the clinic, and you can remove the dead tissue. There's a myth that we should not be removing dead tissues, but no, you should be able to remove all necrotic and dead tissue. Then only the healing process starts for this patient. Mechanical debridement can be by ultrasonic, but yes, ultrasonics are costly units. Again, we have to see the cost of the patient. Enzymatic debridement, autolytic debridement by hydrogel are one of the most effective methods which we can use to give it to the patient. Hydrogel is again very cost-effective measure. Hardly 200 rupees or less than 200 rupees is the cost to the patient, and we should use on all necrotic wounds and even for the development of the granulation tissue. When the wound starts to granulate, that time we need to have a moist wound healing. Now the concept of moist wound healing is very important, and we should I think if you are dealing into diabetic wound management, hydrogel should be a part in your kitty, where you should keep it in your clinics or into your pharmacies, and that should be given to on the patient. A lot of time, I think all the delegates would be seeing patient like this, having calluses under the first toe, under the interphalangeal joints here, under the fifth or fourth metatarsal heads, on the instep area or on the heel area, wherever the high pressure is there. So early identification of these calluses is important. Just take the scalpel and debride these callus. And again, if there's a wound, underlying wound, give them a hydrogel dressing for say 5 to 6 days of time. Tell them to use soft soles inside the sandals or chappals or whatever slippers they are wearing. And you can give them these type of very cost effective. Hardly the cost of these soles is something around 250 to 300 rupees with a U-pad type thing. If you have a felt sheet or Evazode sheet, you can, with your scissors, you can make a U-pad and give them on the under surface of the sole. And these soles can go inside the shoe of the patient. Then there is the cost effectiveness that you can really reduce the cost. Sometimes giving a shoe or a sandal to the patient, a diabetic sandal, a diabetic offloading sandal will be costing something around 2,500 to say 4,000 rupees to the patient. Here you can do that in 200 to 300 rupees to the cost to the patient. But yes, offloading is must in the patient, because if you don't offload that, this callus is bound to develop it again. Because why this callus is formed, try to understand that. The area of that callus is that the fat pad tissue between this callus, the subcutaneous tissue, and the metatarsal head is decreased because of the high pressure area. In diabetic patient, there is an anterior deviation of the fat pad tissue. Because of that, high pressure develops under the metatarsal heads, and that is the reason by this. So if you don't offload this and you debride it after 2 or 3 weeks, or after 1 month, or after 6 weeks, patient will come back again to you and will say that callus is formed again. So offloading is very important. So you have to see what things are available in your clinic, and then you can debride that and offload that. This is again a callus on the heel area. When I debride it, you can see a callus again. In this, again, you can just give them hydrogel, or sometimes you can give them collagen powders, which is again a very cost-effective measure of doing a wound dressings. And then a simple sole can be given inside the shoe of the patient. Make a cutout under this area in the sole, and that is again will help that in the healing process. This is again thick calluses. A lot of delegates would have seen these slides before, but yes, point of mentioning here is that these calluses, we should be able to debride that, but with debridement, offloading is important. You have to give them a solution of offloading first rather than doing the debridement first. So debridement and offloading will go hand in hand, and this is again a very cost-effective measure. Give them PPT sole, Evazode sole sheets, Plastozode sole sheets are available. With these type of offloading pads can be given inside the footwear of the patient itself, and that will really cost effectiveness. And patient compliance of the patient is also very important, because patient will say that they will, I personally have seen that these patients, they wear these soles and they follow the offloading process more, rather than when we give them a particular, we give offloading sandals, front offloading, heel offloading, and other rocker sole sandals when they are indicated. And yes, as a topic given to me today is that what cost-effective measures we can do in this patient. Again, you can see after debridement, good foot care cream or these type of moisturizing cream is very important to moisturize, keep the skin moist, so that this fat pad tissue is deficient over that area, and then offloading can be given to this patient. And these type of offloading, I think everybody knows about these sandals. We can give that. And this is again a rocker sole sandal, which is indicated to reduce the pressure, shift the pressure from the heel to the front part. Very important for shortcuts foot or mid-foot ulcers. These rocker sole shoes should be given to these patients having a midfoot or the ulcer. The concept of offloading is that when patient is walking, he has pressure distribution at 1 or 2 places. With orthosis or with these soles or with this whatever I'm trying to use for offloading, I redistribute the pressure on different areas of the foot, from the medial side to the lateral side, or from lateral side to the medial side, or from the hind foot to the forefoot. So like that, biomechanically, I can reduce the pressure at the site where the wound is, and that is again a very good measure of wound healing processes. There are different type of orthotics and insoles, which can be customized also for the patient, or over-the-counter things are also available. And this is again a big field to discuss in podiatry, and that's what we are trying to spread in most of our chapters of Indian Podiatry Association, that these are the things we should be able to prescribe to the patient and dispense to the patient when they are coming for in wound care, in the wound clinic methods. So these are different type of rocker sole modifications. This is again a different chapter, but just to mention here that we should be able to think of rocker sole sandals or rocker sole modifications in our clinic when we have to give this for the patient to shift pressure from the middle of the foot to the forefoot area. Hyperbaric oxygen therapy, yes, it's a costly affair. The unit itself is costly, and cost to the patient varies from different centers from 2,500 to say 3,500 rupees per sitting. For 10 patient, 10 days therapy, we make a plan of something around 30,000 or 32,000 to the patient. For 20 sitting, it costs about 60,000 to the patient. But yes, we have to discuss with the patient and this. But rather than if patients can't afford hyperbaric oxygen therapy, then now topical oxygen is coming in a role. So where you can just in some of my patients where they can't afford it, when the patients are admitted, I just take the oxygen line from the patient's bed and put it in the wound and leave it at about 2 liters per minute per hour therapy, and it goes along with the dressing. And next day when we see slowly and slowly in 4 or 5 days granulation tissue starts to develop along with the dressings and whatever I am doing. So topical oxygen has a role in clinical enhancement on wound healing, and yes, these are cost-effective measures where we can enhance the wound healing process of the patients. This is again a burn injury on the dorsum of the foot. Hyperbaric was given to the patient along with VAC therapy. Granulation tissue was formed, and later on a grafting can be done to these patients. Necrotizing fasciitis is a big field here. In US, hyperbaric is the answer to these patients. Before taking them to the operation theater or ORs, they do hyperbaric oxygen therapy on these patients, and then later on we can graft them. But yes, now topical oxygen could be an answer where hyperbaric can't be afforded by patients, so we can use topical oxygen. Lot of instruments are available here in Delhi and Bangalore and Bombay, Chennai. Most of the centers, they have topical oxygen, which again helps in the granulation tissue formation. Adjuvant therapies is very important in diabetic foot care. Negative pressure acid, indigenously we can think of this. Growth factors are available. Amniotic membrane products are available, which are again cost-effective therapies, and shockwave therapy can be given to the patient. But very important, one of the things is PRP. Now, this is something that in wound care we have been doing for many, many years now. I do something around 8 to 10 patients per day. You can just take 20 ml of the patient's blood. We can spun it about 8,000 to 10,000 RPMs per minute. And this is in the first part, you can take 20 ml of the patient's blood is taken, centrifuge, and this is the Buffy coat we get it. We take this Buffy coat in the syringe and then put it all around the periphery of the wound. You can take Caltostat or calcium alginate sheet, or Supersoft AG sheets are available. You can just take a small piece, wet with this leftover Buffy coat, and put it on the wound bed and leave it for about 2 to 3 days of time. And subsequently, in the next 7, 8 days or 10 days, you see that wound start to granulate nicely. So granulation tissue, fibroblast migration, collagen deposition, and all different type of wound healing processes start when we are doing PRP. It is nothing. We take the growth factors from the patient's own blood and centrifuge them, separate out, and these are all RBCs which have been saturated back, and then we can inject them. Now, along with PRP, we can do PRFM, where we make a gel of the PRP, and that can also be put in these wounds. And this is very cost effective. Hardly the cost goes to something around, you can say 3,000 to 5,000 rupees is the cost to the patient for a single sitting. Most of the patient we do single sitting, but yes, these are very cost effective because really PRP helps in wound bed preparation. Stem cells again is a big field. I won't be discussing in this forum for that, and it is little coming out to be little costly. But yes, when we do stem cell therapy, we can take autologous stem cells from the, now we are doing liposuctions. That could be a cost-effective measure of doing stem cell rather than getting stem cell from the, we can do bone marrow aspiration and liposuction from the patient, which can really reduce down the cost under 10,000 rupees for the patient. And that can really help in the peripheral, in revascularization in a peripheral vascular disease. So this is here, we can do bone marrow aspirate and liposuction, peripheral blood, umbilical cord, and allograft. They are a little costly, but the first three could be a cost-effective measure or answer to this topic which has been given to me for stem cell therapy. But I think I will prefer PRP, better to the stem cell in wound bed preparation, and if we have to look at the cost for our patient. Dressings, hydrogel, I said, should be the #1 dressing. Everyone should keep it. Alginates, one should keep in the kitty. Collagen sheets, very cost-effective sheets are available, which is something around 250 rupees to a single sheet of 10 by 10. You can just use for epithelialization. Lot of wounds which are something around 3 inches or 4 inches, we have just epithelialized without doing any grafting by using this collagen. But time is very important. You have to eradicate your wound bed with biofilm when you are using these collagen sheets, and use it judiciously. And when you are using collagen sheet, you just wet it with normal saline or superoxidized solutions and put it on the wound and just close it for about 3 to 4 days of time. Do not open every day or every alternate day. Give it a time of 3 to 4 days of time. Then it heals. Hydrocolloids and hydrofibers should be used. Silver-based foam dressings are a little costlier, and we sometimes use when there's a lot of exudate or we see a lot of biofilm is there and a lot of exudate is coming. That time we use foam dressings with silver dressings. But honey dressing again is a very cost effective. So if you ask me, anybody ask me that what are the most cost effective dressings which I use for an Indian scenario for our patient, I will say hydrogels and honey dressings. These two should be my should be in my basket to use it on my patient. These are different type of dressings. I think every part of the country there are different type of dressings available. We should be able to use them. This is nanocrystalline silver with collagen based cream by Tom Smile, one of our friends, Dr. Anand Suri. Very nicely he makes them, and it is very effective. We have been using on our patient. Purilon again from Coloplast. Again, it could be a cost effective answer for hydrogels. So hydrogels like Silver X Heal gels, Mega Heal, Hydro Heal, lot of companies are available, and international and as well as national companies are available. Antiseptics we should avoid on diabetic foot ulcers. Only thing is glacial acetic acid can be used, but effective against Pseudomonas when we see green color dressing. Otherwise, powder iodine and all these antiseptic ointments have no role. Voxil again can be a new chemical entity for the management for diabetic foot ulcers. We can use them on wounds where difficult to heal wounds, mainly on the rear foot area or under the calcaneal area. Sometimes these burn injuries, we give Voxil with hydrogel again, should be given for early epithelialization with a sole or front offloading sandal can be given to these patients, because you have to see where you can enhance the wound healing process early so that these type of patients, they don't go into gangrenous state or developing gangrene over this area or necrosis in the wound. This is again, you can see a wound, debridement should be done, just taking the scalpel. You don't need this patient to take them in the operation theater. In the clinic itself, in the OR or into your treatment room, you can debride them, give them hydrogels, and that is good enough for this. But these are bigger wounds, you need grafting to be done, to discuss with the vascular surgeon, and then you need to graft these wounds. Charcot deformity is something, again, the topic why I put these slides is that this is something which we have to plan in a very cost-effective way, because if you don't identify these patients early in your clinic, it is really a dystrophy to the patient and catastrophe to the patient, because really it takes away the whole cost or whole financial burden. It's a big financial burden on the patient. Any unilateral hot swollen foot when you see in the clinic, and when I ask these patients, are you walking on this foot? He says, yes, my diabetologist has told me to walk on the foot. So it rises as a physician, as diabetologists, we tell them to do walking or do exercise. But when you see a hot swollen foot, please don't tell them to walk. You have to offload that patient, and for the most important thing is you put them into a POP cast or a TCC cast. Talk to your orthopedic surgeon, or even if orthopedics is not available, you yourself should be trained enough to put them into a plaster of Paris posterior slab. At least by the time he is walking to his bathroom, he's walking in his house or going roaming around in his house, he should not be able to put his foot or pressure on that foot, because that is where the tarsal metatarsal joint morphology is broken away. This is usually misdiagnosed as cellulitis, gout, or deep vein thrombosis. All these three conditions, if you tell these patients to walk 2 kilometers, 3 kilometers, 5 kilometers for your diabetic care, nothing will happen to the foot. You are not causing the damage to the foot. But if it's a Charcot's foot and you have not diagnosed or early diagnosed this patient and you tell them to walk, it is the catastrophe to the patient, because that is again going to lose so much of financial money of that patient that you won't imagine that. This is the way this patient, most of these x-rays when we get, you can see the tarsal metatarsal morphology is totally broken down. And when we ask these patients, they say that I'm walking, because it's a neuro-orthopedic foot. So early identification of these patients in our clinic by our staff or by yourself is very important, and put them into a posterior slab. High plantar pressure, again, we can do that. Find out the high pressure areas. I don't want to get into all these details, but this is the answer to this total contact cast. So moment you see this patient, put them in the TCC if they don't have an ulcer. If they have an ulcer, put them into a posterior slab, a Scotch guard or a plaster of Paris slab, and then give them a surgical sandal like this. And then whatever dressings you have to do, send them for MRI, X-ray, whatever investigation you do. But on the day one, you offload them. That would be the most cost-effective answer. And I think this should be the take-home message of this topic, which Dr. Raka and Ashish said. I'm really thankful to them to keep this topic of cost-effective diabetic foot care. And this should be the answer, where we can really save these patients from major amputation, because these patients will totally go into below knee amputation if they are mismanaged. And this is a later answer, that give them a rocker sole shoe later on when the active Charcot converts into an inactive Charcot. That time we can shift these patients to rocker sole shoe. And these, I have got a history of more than 500 patients where not a single amputation we have done in Charcot's foot. Because this is the thing we usually have to see in these patients, and most of these patients get into a below knee amputation. So this is all, I think the answer to this. 22nd, 23rd January, we are planning for a midterm meeting, but I think looking at the Omicron scene, we are all postpone that. We will be planning something in March or April. We'll let you know into this. So this is all I have to you. So cost-effective dressings should be the hydrogels, calcium alginates, superoxidized solutions, TCC cast or the posterior slabs. This should be the answer to this. And a simple foot ulcers, and with different type of planning we can plan in our clinics, that what type of dressings we have to use, what type of offloading we have to plan, and that should be the answer we can give to our patient, and really we can save. There's no wound in our practice which we are not able to heal. But yes, sometimes team management is very important, looking at a diabetologist, podiatrist, vascular surgeon, and then looking at the orthopedic surgeon if required, and other modalities can be used. But yes, diabetes educator or a paramedic is a very important part to offload for dressings, and these type of things we should be practicing in our clinical practice. Thank you so much to the whole team for inviting me in this forum, and best of luck.
Thank you very much. Thank you very much, Dr. APS Suri. You nicely covered from simple wound to Charcot therapy. Everything you covered in your lecture. And again, I am very much thankful to Dr. Raka and Dr. Ashish for giving me this opportunity to be a part of this wonderful program. And now our second speaker is my friend Dr. Ashu Rastogi. I welcome Dr. Ashu Rastogi. Please, if you have the slide of introduction, please show the slide. He has more than 90 research papers in his credit. He has best research paper in International Working Group on Diabetic Foot in Netherlands in the year 2019. In his credit, Professor B.R. Srivastava Orison Award, A.R. Seth Award, Best Research Paper by US Endocrine Society in the year 2015, and so many awards he has in his credit. At present, he is professor at PGI Chandigarh, and he is also working as a vice president. He is devoting his services as a vice president for Diabetic Foot Society of India, treasurer RSDI, Punjab chapter. So many awards and so many credits in his name. I welcome Dr. Ashu, and now I hand it over to Dr. Ashu Rastogi for highlighting the main role of biologics in the management of diabetic foot and future perspective of diabetic foot. Welcome, Dr. Ashu.
Yeah, thank you, Dr. Rajneesh, for your kind introduction. And I'll also like to thank and congratulate GDF, Global Diabetes Forum. I think this is the first conference in 2022 on such a large scale. So without wasting time, because we are already around 2.5 hours ahead of the schedule, I'll just focus on role of biologics, diabetic foot, because almost everything is covered by my prior speaker. And I'll be very brief and I'll try to cover the topic in just 15 minutes. So this is our OPD at PGI Chandigarh, and this is my room, you can see here. And this is all of the patients who are suffering from either diabetes or diabetic foot. So this picture is just to show that this problem is not so meager, and this is a huge problem, and you will see number of patients, because we already now are sitting at 75 million people with diabetes in our country, and it's going to increase further. This is one of the pioneer papers by our friend at Texas, Dr. David G. Armstrong. And he told that the lifetime incidence of all foot ulcers is around 15-25%. But interestingly, only 1/3 of these ulcers heal within 3 to 6 months. So what happens is around 70% of the ulcers are not healing at 6 months. That means these are chronic non-healing ulcers. And here comes the role of biologics. Moreover, in mainly the Western countries, 77% of diabetic foot ulcer are able to heal by 1 year, but it is only at the best of the centers, and we cannot compare this with India. And roughly 40% of the patients, unfortunately, even after healing, have recurrence within a year. And later on, it leads to mortality or amputation at 70%. So that's why we are discussing, and I will definitely thank Dr. Ashish and Dr. Raka to have foot ulcer or diabetic foot as one of the topic in this forum. So this I wanted to highlight. This is one of the pioneer studies in India where we were the main investigators in this study, which was published in Diet DRCP. And this is one of the largest study in the world with more than 4,300 patients with neuropathic foot ulcers from 5 centers across India and also UK and US. So we followed these patients for a median of 9 years, and our main aim was to know what happens to a patient who comes with foot ulcer to your clinic and what happens to the leg as well as the life. Interestingly, we found out that if a patient is having foot ulcer, he has around 5 times higher risk of dying as compared to a routine diabetic patient who does not have a foot ulcer. You can see from this Kaplan-Meier curve, which is a blue bar with blue curve, which shows the mortality rate or the survival rate in patients with foot ulcer, and green one is when routine common garden diabetic patients, and in this study where controls were also taken. Most common reason was again the coronary artery disease, suggesting that if a patient comes with foot ulcer, it's not a simple foot, it's patient as a whole that is more important. Similarly, as Dr. Suri was mentioning about Charcot's, so this is again one of the largest study in the world regarding Charcot's neuroarthropathy, of more than 260 patients with around 560 diabetic controls who were followed for more than 5 years, and we wanted to understand the mortality in this patient with Charcot's. And interestingly, again, we found out that odds of dying in a patient who is Charcot's is around 3 times higher as compared to a routine diabetic patient who does not have Charcot's. So we should never miss Charcot's. And because we are all living in the COVID-19 era or COVID-19 pandemic, so this was one of the study where we studied the foot outcomes during the COVID-19 pandemic times. And this is a retrospective observational cohort study, which is published in a very reputed journal, that is PLOS One, and more than 1,100 patients of diabetic foot ulcers were taken, and they were provided virtual triage during the COVID-19 and teleconsultations during COVID-19. And was main aim was, does COVID-19 affects the foot care? And interestingly, if we are rigorously following the virtual triage and teleconsultations, probably we can have similar ulcer and limb outcomes compared to face-to-face foot care delivery, especially in patients with Wagner's 1 or UTS1, UTS, University of Texas 2 ulcers. So this is a very important outcome that we showed in this study. Now, coming on to the basic topic of biologics. So biologics are basically substances or some kinds of dressings which just hasten the process of wound healing through acting on some natural processes that usually occur in a normal process of wound healing. Now, these are the 4 stages of wound healing that is called hemostasis, inflammation, proliferation, and remodeling. And as you can see that in all of these processes, It's the role of the growth factors, the cytokines, and the multiple things that are there. And all of these processes are hastened by these artificial things or biological things which can be harvested, and therefore they are known as biological materials, as the topic was given to me. But we should understand that unfortunately we have so much research into biologics, but only 4 FDA approved therapies are approved for chronic cutaneous wounds. They are dermal substitutes. I'll show you some of the data with dermal substitutes, which are just a dermis which is placed over the skin, over the ulcer area. Then there are bioengineered human skin equivalents, which come in the name of Apligraf and Dermograph. And then we can have recombinant human growth factors. And one of the most studied growth factors is platelet-derived growth factors, which is FDA approved. Now we also have other growth factors like EGF, but they are not FDA approved for use in diabetic foot ulcers. So this is about the FDA approval. Now coming on to the dermal substitutes. So dermal substitutes come in the name of Integra. This is an Integra dermal template. Now, what does it mean? So this is a dermal replacement layer, which consists of a matrix of collagen and the glycosaminoglycans. We know that is chondroitin sulfate is a part of a normal cell wall. So therefore, this dermal substitute is quite effective. Moreover, it also has a temporary epidermal layer over that, which is made up of silicone. So it prevents against bacterial contamination. So they have been studied where they have studied Integra, and they found out that the wound closure with Integra is quite significant. Just with a single application, the wound closure was significantly better at 4 months. And also, you can achieve a closure of the wound much faster as compared to standard of care. So these dermal substitutes are effective. And this is one of the recent papers that I got, and this is regarding a dermal substitute, which is in the name of Epifix, which found out that the maximum efficacy of these dermal substitutes is there, and they can achieve wound closure just within 12 weeks, and almost 80% of these patients. So out of all these substitutes like dermal cellular, dermal acellular, or epidermal cellular, the dermal cellular substitutes are the best, and they achieve the best healing rate, which is with Epifix. Now, coming on to some cell-based products, because earlier was an acellular product, because it mainly consists of collagen and chondroitin. Here it is a cell-based product, which comes in the name of Apligraf. It is available in India also, and they are bilayered human skin equivalent. So this is made up of both the collagen matrix with neonatal fibroblast, and they are overlaid by a stratified epithelium. So you should understand the difference between a human skin and Apligraf. In a human skin, the epidermis is made up of the 5 layers, followed by the subdermis and the dermis, and then the hair follicles, and it also has the vascular layers and the dermal matrix and fibroblast. This graph is mainly consists of the dermal matrix and the fibroblast, and it usually does not have the up layers, but they have produced a bilayer kind of graft over that, which provides a very good covering of the ulcers. So first you have to clean the ulcer by normal saline or any washing agent. Possible if there is some necrotic tissue, it needs to be debrided. Then Apligraf is placed directly on the wound. You can directly place this Apligraf on the wound and then cover it with non-adhesive dressings, and then area is wrapped. It has been found that usually the ulcer heals by 5 weekly applications. So Apligraf has to be given weekly. Just within 5 weeks, a very good healing rate is obtained. And moreover, the time to complete closure of the wound is significantly less with Apligraf as compared to standard of care. Another graft is a derma graft, which is a human fibroblast cells. And with human fibroblasts, we know that they secrete some kind of proteins, which forms a bioabsorbable scaffold. And this scaffold is very important to epithelialize a wound. It can be used in almost any kind of full thickness diabetic foot ulcers, but it is preferably used in patients with chronic non-healing wound in any plantar location, whether it may be heel, whether it may be toe or forefoot. In any kind of ulcers, you can see the heel ulcer, the great toe ulcers, and this is again a great toe ulcer, a forefoot ulcer. Every kind of wound can be grafted with this derma graft, which is very easy to apply. But remember, The wound should be properly debrided. It should not show any signs of infection. So it should be clean wound. It should have a good blood supply, and preferably if it is ischemic wound, then you should do some kind of endovascular interventions. There should not be the bone underlying the base of the ulcer, and sinus tract should not be there. In these area, just apply the this dermagraft and place the dermagraft and cover it with non-adherent dressing layer, and then leave it for at least 72 hours. It can be kept even up till 5 days, and then it needs to be changed. So this is how these dermal substitutes, or whether acellular or cellular, works. Now coming on to another kind of the products that are again biological products which are used for diabetic foot ulcers are placental derived or amniotic or chorionic derived products. Now they are available in India. That's why I'm showing in these slides. They are basically made from human amniotic membrane, and they consist of an extracellular matrix and the cytokines, which are preserved in these amniotic membrane, but living cells are destroyed. So they can be available in the form of sheets, which can be freeze dried. And one of them is Grafix, which is a human viable wound matrix. So there have been some clinical studies with the human viable wound matrix, and they have shown that the proportion of patients who achieve wound closure with this Grafix is significantly better. You can see 62% wound closure as compared to just 21% with the standard of care. And interestingly, the wound healed earlier, just within 6 weeks, as compared to more than 11 weeks in patients who were just provided standard of care. So these placental products are quite effective. And one of the product that is available in India and that I am also using in our clinics is an Amcoplast, which is a minimally processed dehydrated human amnion and chorion membrane allograft, which has all the structural properties of the extracellular matrix. Because we know that once in a natural wound, this is the extracellular matrix, which is formed by the fibroblasts, macrophages, and the epithelial cells that tend to form the granulation tissue and the epithelialization of the wound. You can artificially create this environment by using this Amcoplast. This resulting dehydrated allograft serves as a very good biological wound covering. So what you need to do, just place this membrane over the entire wound area and press it down. Use strips. You can also apply a secondary dressings, leave in place for a period of around 5 to 7 days, and then reapply after some time. And it has been seen that in my experience, most of our patients who have an ulcer more than 2 to 5 centimeters square require around 3 to 4 or around sometimes 5 Amcoplast dressings. They predominantly stimulates the proliferation of the keratinocytes and migration, stimulates granulation tissue, collagen production, and there also inhibits the ECM degradation. So this has been a recent paper again from Tettelbach, one of colleagues, which I know, who has published this paper from amnion grafts, and they have found out that 70% of patients who were given this amnion graft had good healing as compared to just 50% of the ulcers. And as expected, the number of grafts that were required per healed wound was 5. So this graph shows that the greater rate of complete wound healing was observed with this in this blue line with this amnion graft as compared to standard of care. Now it is readily available in India, and we can definitely use in patients with chronic non-healing wound. Coming on to the platelet concentrates, and Dr. Suri was showing the PRP. So we are also using this PRP in platelet concentrates, but just going on to the data, what we have regarding this is one of the Chinese papers published in 2018. This is regarding the platelet-rich plasma that we call PRP. But now this PRF, that is platelet-rich fibrin, is also available. And as expected, and as he was also mentioning, we just take 20 ml of patient's blood, we centrifuge it, it divides that into 3 main layers, and it is the middle layer that mainly contains the platelet concentrates and the growth factors. So this PRF has all the mitogenic and chemotactic compounds which is required for the wound closure because it helps in the migration and the proliferation of the fibroblast and the epithelial cells. Moreover, it also has fibrinogen, fibronectin, and many growth factors which are required for wound healing. And you can see this is one of the meta-analysis that has showed that overall, if a patient is using platelet concentrate, especially the PRF, they have around 3.7 times increased chances of wound healing as compared to a patient who is not using platelet-rich concentrates. But problem with PRP is that it promotes early healing in a very short time. But what about the long-term effect? Because we want that the wound should not break and moreover, it should not have a recurrence. Therefore, people have come up with further advancement in this PRP, and it is called the leukocyte platelet-rich fibrin, or APRF, which is further advanced PRF. So this is how the PRP or PRF, or leukocyte-rich platelet-rich fibrin, is collected, and then this is kind of the wound over which once it is cleaned, and then this PRF is applied, and you can see that just within 3 weeks, the patients who were offered the PRF, they had a better wound area reduction as compared to a patient who was given a standard of care. And there have been recent studies just published in October, and one of the studies published in November 2021 in International Journal of Lower Extremity Wounds, which have shown a remarkable efficacy of this APRF. Coming on to the last part of my presentation is about growth factors, because we have been using this and we have our own experience as PGI, and this is one of the papers that we published way back around 10 years back in DRCP, where we use PDGF, and we showed that if we are using PDGF, there is significant reduction in the wound area with PDGF as compared to standard of care. And in another study, they have been found that 1/3 more ulcers heal in patients who were using recombinant human PDGF as compared to standard wound care. And this is one of, again, a meta-analysis in Cochrane, which showed that if the patient is using PDGF or any kind of growth factors, now EGF is also available in India, and I'm also using EGF. So they have significantly 1.5 times increased chances of wound healing as compared to standard of care. So this is one of the paper that I just came across, which was published around 2 weeks back in Molecules. This is a very different kind of concept. This is about a film forming spray of Chitosan, which has a human epidermal growth factor for wound healing. And this paper is really interesting, and they found out that if using epidermal growth factors, it can be used in the form of liposomes, which forms coatings, and it also has Chitosan, which inhibits the enzymes which degrade the epidermal growth factor. And this is a mice study, actually. This is not a human study, and they found out that this kind of preparation is very useful for wound healing. So last thing, this is about nanotechnology and wound healing, because these are also biologics. So you can have many kind of nanoparticles which have been studied for wound healing, both in animals as well as humans, and they act on almost all stages of wound healing. But one of the most common thing that we are using is silver nanoparticles, readily available in the market. And the silver nanogels and silver nanoparticle dressings are available, and they are again one of the biologics for wound healing. So I would say that we were also the part of IWGDF guidelines at Hague, at Netherlands in 2019, and they say that you can consider any of these adjuvant treatments for non-infected ulcer that failed to heal after 4 to 6 weeks. And they have specifically mentioned about sucrose octasulfate dressings, which and the investigators are mainly from Manchester in UK. And you can also use the leucovorin or leukocyte platelet fibrin patch, and placental membrane allograft can also be used, like Dermagraft and Apligraft. But they are very categorical about saying that the following treatments are not supported for routine ulcer management, like collagen, growth factors, bioengineered tissue neuropathic ulcers. Still, we need a lot of data regarding that. They also say to avoid silver and other antimicrobial agent dressings for application onto the foot. So I'll conclude by saying that the biological therapies are very promising. A lot of research is going on, and we also have a lot of experience in many things that are available in India also. But remember, we have to judicially use only in those patients once we have left with no options, especially non-healing wounds which have failed on conventional treatment, useful in chronic wounds which have stalled the wound healing processes. But patient proper selection is very important. Those who have a good vascularity, non-infected wound are very important. So thank you, and back to the organizers.
Thank you, Dr. Ashu sir. It was really an apt presentation. Very nice journey through biologics. So if anybody is having questions, I think there is no any question in chat box. So over to our next presentation. Yes, our next talk is on diabetic peripheral neuropathy, but beyond pregabalin. So I will welcome Dr. Mukulesh Gupta sir. He is a senior physician and diabetologist at Lucknow, one of the renowned personality. Present affiliations: Director at Udyan Healthcare Multi-Specialty Hospital, Secretary Lucknow Diabetes Study Society,
Secretary Indian Pediatric Society UP chapter. He has been having a lot more fellowships on his records, and he had a lot more research publication in ESD, EDA, diabetes therapeutics, and everywhere, clinical epidemiology and global health as well. And he has a lot more. He has participated as a clinical in multiple clinical trials also. So over to Mukul sir.
Thank you so much. And first of all, I'd like to really congratulate Dr. Ashish and Raka for really thinking out of box as far as preparation of this scientific agenda was concerned. It's really enthralling, and I've really thoroughly enjoyed it throughout the day and the last day also. So let me share my screen. And once we have discussed diabetes and various organs like brain, heart, liver, kidney, and now we have descended onto foot. And once we are talking of diabetic foot, then certainly we have to look up to Dr. APS Suri, and he has given his wisdom onto diabetic foot management, the cost-effective way. And Dr. Ashu has given us insight into the diabetic foot as well. My job is to talk about the contributor to these conditions, diabetic foot, that is diabetic peripheral neuropathy. I'll be rushing through my initial slides just to set the context, and then I'll slow my speed to really talk onto the subject. So we know that this is the most common complication of diabetes, what we face day in and day out, which involves nearly 50 to 90% of the patients with diabetes. Patients, they lose their sensations, nearly 70% of our diabetics, leading to diabetic foot ulcer. And then this foot ulcer can lead to amputation. Emphasis has already been made by Dr. Suri that we have amputation every 20 seconds somewhere in the world. And then once one foot is amputated, the other foot is already at risk. And once both foot, they are amputated, then the 5 years mortality is very high. So very simple looking condition like diabetic peripheral neuropathy or diabetic painful neuropathy can really culminate into a very catastrophic end. The pathogenesis roots to hyperglycemia and various mechanisms, which you all know, polyol pathway, the oxidative stress, the glycated end products, the DAG and the PKC activation, and 6 fatty acid metabolism, all ultimately depleting ATP, affecting the nerve conduction, leading to cell necrosis and activation of genes involved in neuronal damage, and finally affecting the axonal structure. It basically happens through occlusion of vasa nervorum that leads to damage to the myelinated and the unmyelinated nerve fibers, and finally resulting into diabetic neuropathy. If we talk of the incidence after 20 years of the diagnosis, 50% of the
Sir, sorry to interrupt you, but your slides are not moving, sir.
Okay. So what I'll do is I'll continue in this mode. They're moving now?
Yes, sir.
So I'll continue in this mode. So after 20 years of diagnosis of diabetes, 50% of the patients, they will have symptomatic neuropathy, 40% they will have asymptomatic neuropathy, and only 10% they will have no neuropathy. So just imagine 90% will certainly have neuropathy at some point in time. Classification, we all know, sensory motor, autonomic, mononeuropathies, and proximal motor neuropathy. Long fibers getting affected first, and therefore we see signs and symptoms in the lower limb first, but upper limbs can also be affected. The presentations, what we see in our clinical practice, depending upon the fibers which are affected, the larger fibers, the smaller fibers, the proximal motor neuropathies, and at times the mononeuropathies, which can be cranial or truncal, and can be entrapment involving ulnar, median, or lateral popliteal nerve. The symptoms can be positive or negative in form of spontaneous pain, allodynia, hyperalgesia, hyperesthesia, paresthesias, negative in form of hypoesthesia, anesthesia, hypoalgesia, and analgesia, depending upon the fibers which are involved. Initially, when the small fibers they are involved, they lead to burning, lancerating, tingling, and shooting electric shock-like pain in the lower limbs. typically worse at night when tired or when stressed. But once they are there, they are accompanied by hyperalgesia, allodynia, hyperesthesia, dysesthesias, or paresthesias. If the large fibers are involved, then it can lead to loss of protective sensations. Feet may feel as if they are wrapped in wool or the person is walking on cotton. And all this will finally interfere with the activities of daily life, leading to disability, psychological impairment, and reduced health-related quality of life. Signs we are all aware about: dystrophic nails, callus, Charcot's foot, dry and cracked skin, all can point towards the presence of sensory neuropathy. The imbalance between the intrinsic muscles because of the neuropathy, leading to various deformities like claw toe or the Charcot foot. Complications because of sensory motor neuropathy, leading to ulcerations, which may be painless, neuropathic edema, Charcot's arthropathy, and callosities. Autonomic neuropathy, varieties of it: postural hypotension, gastroparesis, diabetic diarrhea, neuropathic bladder, erectile dysfunction, neuropathic edema, Charcot's arthropathy, and gustatory sweating, all can be present, and we have to be thinking about it every time whenever we are seeing patient, because as I have already told, this is the most common presentation as complication in diabetes. But the diagnosis remains a diagnosis of exclusion. And we have to think about other conditions first and then think about diabetes. But certain symptomatologies and symmetricity will point towards the diabetic neuropathy, typical signs if they are present, or if suppose we are able to pick by certain examinations. We are all aware about by these common tests, which can be detecting the functions of the smaller fibers in the larger fibers in form of the Tangy monofilament test or the tuning fork test, which can all be combined by using these biothesiometers or the neurotouch machines, makes the job simple and analyzes the foot in much better way. So all these can be used in our day-to-day practice, not to forget about foot whenever we are talking of diabetes. Then there can be certain validated scores. Dr. Chawla has already presented this long time back, that NSS score or the National Neuropathy Disability Score, they can be used because they have got a sensitivity of nearly 71.1% and a specificity to the tune of 90%. They are validated as well, reproducible, and therefore they can be made use of in our day-to-day practice. Now coming to the management part. If we talk of ADA 2022, once again, everything is focusing towards patient-centric approach. And therefore, we have to be thinking about the age of the patient, the quality of life goals, functional status, and comorbidities before we jump onto the pharmacotherapies. So the first goal is to give at least 50% pain relief, but the secondary goals have to be there: restoration of improvement in the mood, sleep, function, and quality of life. But the first drug we know is the pregabalin as per the guidelines. But what happens if suppose it doesn't work? It doesn't work, or if the patient is not able to tolerate. So adverse effects with pregabalin: somnolence, blurred vision, difficulty with concentration, dry mouth, edema, weight gain, serious side effects like allergic reactions, suicidal thoughts, dizziness, fall, and troubled breathing, all can basically lead to a situation where you are not able to use pregabalin. In that situation, we have to be ready that what next if suppose the pregabalin is not working. That is my topic in particular. Before we think of the options, we need to briefly see onto this pathway, the ascending one and the descending one, going through the brain and descending through the dorsal horn in the spinal cord and coming once again back to the peripheral nerve. At various points, we can address the situation or the problem of neuropathy. It can be the medications which are affecting the central sensitization through the alpha and the delta ligands, working through the calcium channels, or the tricyclic antidepressants, tramadol or opioids. If we are wanting to address to the descending modulation, which can occur through SNRIs, tricyclic antidepressants, tramadol, opioids. If suppose we want to locally address to the nerve endings, then capsaicin, local anesthetics, tricyclic antidepressants, or if suppose we want to neuromodulate, the nerves, that is another option. I'll talk about this very briefly, but these are the things which are available and they can be used in various sorts of dosages, like gabapentin up to 300 milligrams, duloxetine maybe up to 120 milligrams, but one is basically try to remain somewhere around 60 milligrams, topical capsaicin, tapentadol, amitriptyline, venlafaxine, and I'll touch upon all these options in very brief. So antidepressants, including the serotonin and the norepinephrine reuptake inhibitors, duloxetine and venlafaxine, they are the options. Duloxetine became the first agent approved by FDA for treating painful diabetic neuropathy in 2004, and it is recommended by AAN and ADA as well. Dosages, 60 milligrams preferably. Adverse effects, including nausea, somnolence, hyperhidrosis, constipation, dry mouth, and anorexia. If we talk of venlafaxine, preferred dose somewhere around 150 milligrams. It is recommended by ADA, but not approved by FDA. Adverse effects, nausea, somnolence, insomnia, and dyspepsia. Serious side effects may be there, dizziness, fall, hallucinations, and increased heart rate. Tricyclic antidepressant, the most common amitriptyline, which is used by all of us. But once again, this is something which has got some more adverse effects, and therefore the usage has to be restricted. The dosage range from 10 to 90, but one has to be somewhere in between. Adverse effects, we are all aware about anticholinergic side effects. So that limits the usage of amitriptyline. Coming to opioids, once again, this is an option, but which is not universally accepted because of the dependence which can happen with this. And therefore, one has to avoid the long-term use of these agents. But if we talk of something different, very close to opioid, that is tapentadol, which has got dual mode of action. One action through the opioid effect, and the second through the effect of norepinephrine reuptake inhibitor. And therefore, this particular agent is something which is approved for use in painful diabetic neuropathy since 2012, and we can use it to the dose of nearly 200 milligrams to 500 milligrams a day. Common side effects, nausea, vomiting, and dizziness, but this becomes handy if we are talking of alternatives. Coming to topical capsaicin, once again in 2020, the FDA approved use of capsaicin 8% topical patch for treating painful diabetic neuropathy. It is acting via agonism of the transient receptor potential vanilloid 1 receptor, that is TRPV1. But the problem is that there can be occasional severe burning sensation and the site pain which can occur with local application. There are other agents which once in a while we do try, that is carbamazepine or L-carnitine. There are 2 RCTs which show improved pain and nerve regeneration. If we talk of ALA, there are conflicting results. So these are other options. Gabapentin, of course, is another option which can be used, which acts very similar to pregabalin and has got similar side effects as pregabalin. But because of the limitations of these pharmacological agents, we have to resort to some other options as well. There are a lot of clinical trials on these pharmacological agents, numerous double-blind randomized controlled trials, which speak of nearly 50% reduction in the pain management, and therefore all these are recommended by various guidelines. As an alternative to pharmacotherapy, once we are not able to use them, then there comes the role of neuromodulation, which is basically a medical technology that reversibly enhance or suppress nervous system activity with the goal of treating disease, and includes both implantable and non-implantable devices that deliver electrical, chemical, or other agents. These can be intrathecal therapy, transcutaneous electrical nerve stimulation, TENS, spinal cord stimulation, SCS, and recently a 10 kilohertz spinal cord stimulation, which has been shown to provide clinically meaningful pain relief for patients refractory to conventional medical management. So there are a lot of trials and a lot of ways in which neuromodulation can be done. I'll touch upon them very briefly. The transcutaneous nerve stimulation, TENS, it is non-invasive, inexpensive, and easy to use form of neuromodulation using 50 hertz or low frequency less than 10 hertz in burst or in continuation. The mechanism, of course, is not very clearly known, but the hypothesis is that it improves microcirculation and higher levels of beta endorphins and meta-enkephalin, increased expression of proteins, including the calcitonin gene regulating protein and nerve growth factor, leading to reduction in the inflammation. This is something which can be very easily and commonly used in our patients. If we talk of other modalities, that is low frequency pulsed electromagnetic fields, that is PEMF or the FREMS, which is the frequency modulated electromagnetic neural stimulation. These have been tried and a lot of studies, but the effects, they are transient. If we talk of intrathecal pain therapy, that is another option wherein we give the drug bypassing the systemic action, and therefore the drug delivery is there in the intrathecal part. Here, specifically to mention is this giconotide or morphine. Out of these two, giconotide is recommended more strongly by the Polyanalytic Consensus Conference, PACC. No tolerance or withdrawal and significantly less respiratory depression. It is a non-opioid analgesic that binds selectively and reversibly to anti-voltage sensitive calcium channels, thereby blocking the release of pro-nociceptive neurotransmitters in the spinal dorsal horn. So this is another thing which can be used in refractory patients. Conventional spinal cord stimulation, first used in 1967, and it is recommended since 1980s, and it is based on the gate control theory by Melzack and Wall. And functional MRIs in patients, those who have been given this, has shown that this modulation, after some period of time, is capable of giving long-term benefits. Burst spinal cord stimulation, unlike conventional and high-frequency spinal cord stimulation, which delivers stimulation at a constant or tonic frequency bursts, is characterized by clusters of high-frequency pulses, and it is trying to emulate naturally occurring neuronal firing pattern. There is some evidence, but once again, they are not very strong. Here comes another thing which has come up in a very nice way: high frequency or 10 kilohertz spinal cord stimulation, and a recent Senza PPN study which was presented in North American Neuromodulation Society 2021. And in this study was found that 86% of the subject met the primary endpoint of 50% pain relief. And therefore, this is once again a thing which is important or which can be used in patients, those who are refractory to other therapies. Now, this brings me to another area which is very important and exciting, and that is the analgesics of future. That is the hepatocyte growth factor for the management of diabetic painful neuropathy. And here the thing in consideration is VM202, which is basically acting through the hepatocyte growth factors. So hepatocyte growth factor, it is a multifunctional cytokine known to induce neurotrophic activities, including the enhancement of neuronal survival. Hepatocyte growth factor acts as a survival factor for motor and sensory neurons and enhances axonal outgrowth. The HGF receptor or the MEK tyrosine kinase is located on the peripheral sensory and the motor neurons, as well as the Schwann cells in the epithelial tissue. It is to be given in an injection form, and presently the status is the phase 3 trials are on, and the phase 2 findings, they are really, we can say good, because once the patients, they have been given this therapy and followed up for a period of 8 months, it has seen that these patients, they rather showed improvement over a period of time. With the passage of time, there is improvement in the pain of that individual. That means that there is something happening in form of neuronal regeneration. So that potential is there with this agent, and there are newer studies which are on, and probably this will become another area of managing the diabetic peripheral neuropathy. I cannot leave the discussion without the basic foot care education, because these have to be incorporated at every stage. We all know about it, but just mention that these are things, and a slide on the basic workup for patients wherever we think of diabetic peripheral neuropathy, because we certainly will have to eliminate other causes of neuropathy before making the diagnosis of diabetic neuropathy. Thank you so much. Pain, we know that it is inevitable. Suffering is optional. Thank you so much for this opportunity given to me.
Thank you, sir. It was a really nice presentation. Touched a lot more virtues beyond pregabalin. Absolutely nice and apt presentation. So our next presenter is Dr. Arun Kedia, and his topic is rheumatological manifestation in diabetes. Intro slides, please. Yes. Dr. Arun Kedia is from Chhattisgarh. He has been a consultant physician and head of ICU at Raipur. He has a clinical experience of more than 10 years. He is a life member of API, RSSDI, ISCCM, IRA, and he has been a chairman of API Raipur Chapter 2021, district coordinator for RSSDI, and part of a lot more clinical trials. Over to you, sir.
You're on mute.
So you are on mute.
Sir, please. Okay.
Are the slides visible, sir?
Yes, sir.
Okay. So at the outset, first of all, I would like to congratulate Dr. Raka sir and Dr. Ashish sir for giving me this opportunity and for holding this wonderful conference. And it has been going very well even on a Sunday evening. Despite going late, I can see that the interest of all the faculty and all the chairpersons is still on. So after a very wonderful talk by Dr. Suri sir, my task is very easy. That is rheumatological manifestations in diabetes. And as diabetologists, we all see these manifestations almost every day. So diabetes and rheumatology go hand in hand, probably because the underlying pathophysiology in both the cases is chronic inflammation. And that is where the rheumatological manifestations set in. So why do we discuss and why are we worried? Most of these rheumatological manifestations are associated with a very high morbidity, mainly in the form of pain. And a few of them may cause a significant disability to the patient to the extent that they can cause and they can lead to amputations. Many of these may go unrecognized or overlooked in our day-to-day clinical practice, and it has been seen almost 30% to 40% cases are diagnosed very, very late. Many of them are treatable if they are recognized in a very early stage, and so it is very important to be aware of all these conditions. At the same time, the presence of these conditions also indicate that the patients might have microvascular complications, and it has been seen that patients who present with rheumatological manifestations, almost 50% would have either a retinopathy or a nephropathy. So these are the significances to look for rheumatological manifestations in type 2 or type 1 diabetes patients from a diabetologist point of view. So if we have to enlist all these manifestations, we'll divide it into upper arm and lower arm, the lower extremity. So in the upper extremity in the hands, we have limited joint mobility, the trigger finger, the Dupuytren's contracture, and the carpal tunnel syndrome. At the level of shoulders, we have adhesive capsulitis, calcific periarthritis, and reflex sympathetic dystrophy. At the level of feet, Charcot's arthropathy, which has been very nicely explained by Dr. Suri sir in the previous lecture. Very important manifestations in the form of amyotrophy and muscle infarction would be discussed over here. And then at the skeletal level, we have diffuse idiopathic skeletal hyperostosis that we need to discuss here. But what are the underlying pathophysiological mechanisms which lead to these soft tissue disorders? So the most important is that there is a non-enzymatic ligation of collagen fibers. And this is what is the pathophysiology in most of the rheumatological manifestations. There is an increased collagen cross-link, and this cross-link is not in a systematic manner. There is a haywire distribution of the collagen. At the same time, there is increased hydration mediated by the aldol reductase pathway, which leads to thickening of the soft tissues. There is increased accumulation of abnormal collagen, or what we call as the cross-linked collagen. At the same time, because of advanced glycation end products, there are microvascular abnormalities which involve at the level of the skeletal tissues and soft tissues. And these collagens and this soft tissue hyaluronidase are resistant to enzymatic digestion, and that leads to accumulation of abnormal byproducts. There is associated neuropathy, which also leads to decreased sensation and decreased perception by the patients. And of course, because of chronic inflammation, there is a role of multiple cytokines which work. And these cytokines are actually a complex group of chemicals which work and which lead to chronic inflammation. So all these mechanisms per se would lead to all the skeletal manifestations, and not a single mechanism can be pointed out as to the underlying pathophysiology. Now, moving on to the most common that we see in our daily practice is the adhesive capsulitis, or what we call as the frozen shoulder. So what the patient presents with a progressive painful restriction of shoulder movement, and these movements are painful, both are at active and passive movements, and especially at the external rotation and the abduction movements. And more commonly, left-sided hands are involved more than the right-sided for reasons unknown. The prevalence may be up to 1/3 of cases in diabetes patients, and it may also be seen in up to 10% of cases of non-diabetes patients. The underlying pathophysiology is the thickening of the capsule, which results in the reduced volume of the glenohumeral joint, which leads to restricted movements. And this restricted movements then become painful. And if the patient comes in the early stage, then the treatment would be a graded physiotherapy. The patient may improve with analgesics or intra-articular steroids. But once the patient presents very late, then most of the time these patients would need manipulation under general anesthesia. But what is more important is that these patients need to be taught about the progressive nature of this disease. And so patient education becomes the most paramount part of adhesive capsulitis. Most of the patients need to be ascertained that they will get well, provided they go for regular exercises and regular physiotherapy. Now, moving on to limited joint mobility, which is seen in the hands, it is also called as diabetic neuroarthropathy. It is a painless condition which is characterized by thick, tight, waxy skin on the dorsum of the hand with flexion deformities of the metacarpal and interphalangeal joints. This is seen mostly in type 1 diabetes, but also in type 2 patients. And it is usually associated with long duration diabetes, poor metabolic control, and microvascular complications. The prevalence may be between 8 to 30%. And how you can demonstrate clinically is by the prayer sign or the tabletop sign. I'll just show you the pictures. Again, early recognition would be the essential part of preventing contractures in these patients and to prevent permanent deformities. At the same time, optimal glycemic control, cessation of smoking, physiotherapy, and occupational therapy would be helpful to prevent any deformities. So this is what is a typical prayer sign. If the patient is asked to clasp both the hands together, then he is unable to approximate both the palmar surface of the hand, and this is called as a prayer sign. Similarly, the tabletop sign, if you ask the patient to put his palm on the top of the table, then the palmar surface of the hand may not be touching the top of the table. So these are the two signs which we see clinically. Then we come to the Dupuytren's contracture. Again, the prevalence in diabetes patient is to the tune of 20 to 63%, depending upon the various studies. It involves thickening, shortening, and fibrosis of the palmar fascia, leading to deformity. And again, the prevalence increases with age and duration of diabetes. The most common fingers that are involved are the middle finger and the right ring finger. Sometimes patients may have bilateral presentation. In diabetes, usually the presentation is mild, but early detection is important because physiotherapy is usually sufficient in early stages. In late stages, local steroid injections may help to prevent fibrosis. So this is how the Dupuytren contracture looks like, and we have seen such cases even in hypothyroidism. Then the next thing is the trigger finger or the stenosing tenosynovitis. Again, the prevalence is almost 20% associated with long duration diabetes. The patient usually presents with a catching sensation or a popping and locking phenomena associated with mild pain in that affected finger. Clinically, what you see is a palpable nodule over the metacarpophalangeal joint, and there is thickening along the flexor tendon sheath. and you have to literally pull the finger in order to release the lock that the patient suffers from. Sometimes you can have multiple finger involvement, and again the treatment would be physiotherapy, local injections of steroids, and in very debilitating cases you can go for some plastic surgery. So this is what is the typical trigger finger, and patient needs to be taught about massage and the splinting of the finger in order to prevent permanent deformity. Then another important finding is the carpal tunnel syndrome, which is also an entrapment neuropathy. The prevalence may be up to the 15%, more common in women, again associated with advanced age and duration of disease. Patient typically presents with paresthesia over the median nerve cutaneous distribution. It is often worse at night, and in extreme cases, you can get thinner muscle atrophy. You can demonstrate carpal tunnel syndrome with the help of Kinnell sign and Phelan's test. This is the typical distribution of the median nerve, and you can see that it is distributed over the lateral 3.5 fingers, and the patient typically presents with paresthesia over this distribution. And this is the Phelan's test, where you do a reverse prayer sign and you approximate the dorsal surface of the palm and wait for 1 minute, and the patient will have a severe pain. At the same time, if you tap on the this carpal tunnel area, then the patient will have electrical pain type of stimulation in the 3.5 fingers. So these are the two tests that can be done to demonstrate the carpal tunnel syndrome. Then at the level of the skeleton, you get the diffuse idiopathic skeletal hyperostosis, or what you call as the DISH. It is seen usually in type 2 diabetes patients who are obese. It is generally characterized by new bone formation in the thoracolumbar spine with metaplastic ossification of tendons and ligaments elsewhere. The disease clinically very closely mimics ankylosing spondylitis, but what is important is here the intervertebral spaces are not involved. The patients are usually asymptomatic. They complain usually with some stiffness and some pain, and the diagnosis is usually radiological. So an X-ray will show this ossification of the anterior ligaments, and what you can see is there is a sort of bamboo spine appearance, typical what is seen in ankylosing spondylitis. Then the Charcot arthropathy, which Dr. Suri has already explained very well, which is a consequence of peripheral neuropathy with repeated trauma. The involvement is from the ankle to metatarsophalangeal joint and then tarsometatarsal joints, and this is basically a very, very destructive type of neuropathy. The prevalence is high to the tune of 10%, and the diagnosis is usually clinical and radiological. Usually MRI is diagnostic in a very early stage, and the treatment, as sir has already spoken, that in the early stage it is the offloading, and subsequently you need to do surgery if the patient has developed advanced stage. So this is an advanced stage patient where the patient has already having misaligned joints, and there are bone destructions, and you can see that these patients would need really corrective surgeries, or sometimes even they can develop ulcers leading to infections and amputations. Now, another important diabetic amyotrophy where the patient presents with diffuse proximal lower limb weakness, muscle wasting, and diffuse pain with asymmetrical loss of the tendon jerks. These are usually type 1 diabetes patients and elderly type 2 diabetes patients who present with significant weight loss. However, the cause is not really known, but it has been found to be either inflammatory immune-mediated vascular reticuloplexopathy or the microvasculitis leading to neural injury. The diagnosis is usually an exclusion diagnosis. However, the electrodiagnostic test in the form of NCV can help to give a clue. The disease is usually self-limiting. The treatment is usually supportive. There have been studies on use of immunosuppressants and steroids. However, they are not very strong recommendations of using immunosuppressants and steroids in such patients. Most of these conditions are self-limiting. Now, this condition is very unique to diabetes. It is rare. Almost 2 years mortality is 10%, usually seen in long-standing type 1 diabetes. And patients usually present with acute onset muscle pain and swelling, usually of the thigh and the calf. The differential diagnoses are usually myositis, deep venous thrombosis, ruptured Baker cyst, and amyotrophy. MRI is diagnostic. High clinical suspicion is required, and treatment is usually symptomatic. People have used antiplatelets, NSAIDs, and immobilization in order to prevent the pain associated with muscle infarction. Osteoporosis, I think, has been very extensively covered in the form of bone health and diabetes by a previous speaker. But what is worth mentioning is that the relative risk for hip fracture in type 1 diabetes patient is to the tune of 6.9. Type 2 diabetes has been found to be preventive against osteoporosis because of probably high BMI, but the bone quality changes are much affected by microvascular changes. And there is definitely a higher incidence of fractures even in type 2 diabetes. Drugs like pioglitazone used in diabetes have also been implicated into the pathogenesis of osteoporosis. So osteoporosis again has to be taken care of in all diabetes patients, and it is a must to prevent falls in patients, especially with long-standing diabetes. So to summarize about all the rheumatological manifestations in diabetes, if you have to think of conditions limited only to diabetes, it is muscle infarction. Conditions which are more frequent in diabetes are the limited joint mobility, trigger finger, carpal tunnel syndrome, Dupuytren's contracture, frozen shoulder, and Charcot's arthropathy. And conditions which share the risk factors with diabetes mellitus are osteoporosis, osteoarthritis, gout, and diffuse idiopathic skeletal hyperostosis. So what is the way to move forward? So we must understand that these conditions are associated with high morbidity and disability. These are unrecognized and overlooked. Many are treatable, and these indicate microvascular complications. So all we need is a multidisciplinary approach. We need to involve good podiatrists. We need to have a very high clinical suspicion for rheumatological manifestations, and we need to recognize them at an early stage. We need to involve physiotherapists, occupational therapists in order to achieve wonderful results. And of course, patient education would be the most important step in order to prevent the morbidity and disability associated with all these rheumatological manifestations. So with that, I thank you all, and I thank the organizing committee to give me this opportunity to speak on a very important topic of rheumatological manifestations in diabetes. Thank you, sir.
Thank you, Arun sir. It was one of the fantastic talk. And there are two questions for Dr. Mukulesh sir specifically. Dr. Mukulesh sir, are you there? I think he's not there.
He was there some time ago. I don't know, maybe some disconnection or something.
Yes. So I thank all the speakers in this session. And I especially thank Dr. Raka and Dr. Ashish sir for a very wonderful academic feast. So over to you, Dr. Ashish sir.
Yeah, thank you all for the beautiful deliberations, right from Dr. Suri to Dr. Ashu Rastogi to Dr. Mukulesh to Dr. Arun Kedia. And thank you, Dr. Rajneesh and Dr. Manish for taking forward this session. And it is really wonderful to see the enthusiasm. I went through the through the audience, and I could see that people are still glued through the audience part. So it is wonderful that people are taking knowledge beyond capacity, even though we are late, but still thank you. And now I'll go to the final session for some interesting topics, and I will request Dr. Surendra Mittal. He is an MD Medicine to take forward the session and introduce our chairpersons.
Thank you, Dr. Ashish sir and Dr. Raka sir for giving me the opportunity in this wonderful conference. Now I would like to introduce the chairperson for this session. This is the last session, but not least. It contains some interesting topics in the diabetes which is untouched by most of us. And with this, I introduce the chairpersons: Dr. Raghuveer Sharma sir, Dr. Sachin Gate, Dr. Vijay, and Dr. Deepak Chudasma sir. And the dice is all yours, sir, to the chairpersons.
Can we have the speaker slide, please? Yeah, they are just logging. Raghuveer is just logging. Thank you. This is a wonderful topic by none other with one of our experts, Dr. Malay Parekh, who is a fellow in diabetes as well as a postgraduate diploma in diabetes, a consultant diabetologist at Rajkot, and a member of RSSDI, ADA, ISPAD, EASD, ACP, IMA, who has, to his credit, many abstracts, papers selected and presented in both national and international journal. A treasurer of RSSDI, investigator in many clinical trials. Welcome, Malay, for your deliberation. He'll be talking on a very interesting topic, skin manifestations in diabetes?
Special thanks to Dr. Ashish sir and Dr. Raka for giving me this wonderful opportunity in GDF 2022. My dear sir, Dr. S.S. Daria sir is also here. Hello, sir. And hello, Ashish sir, Raka sir. How are you? Yes. So without wasting much time, I am going to share my screen. Is it visible? Is it visible? Right? Is it visible, sir?
Yeah, it's visible. Go ahead, Male, go ahead.
Okay, sure. Thank you. So my today's topic is very informative and very interesting: skin manifestation in diabetes. We all know diabetes mellitus can be complicated by a variety of cutaneous manifestation. A good metabolic control may prevent some of this manifestation and may support the cure. Unfortunately, many OHA have some cutaneous side effects. It is important to be able to recognize these signs and symptoms and to either treat them appropriately or refer the patient to a dermatologist or diabetologist. Among all the diabetic patients, eventually develop skin complications from long-term effect of diabetes mellitus on the microcirculation and on the skin collagen, and skin infections are more common in type 2 diabetes, where autoimmune related lesions are more common in type 1. Patients who have had diabetes for many years develop the most developing skin problems. And furthermore, diabetic-related cutaneous lesion may have serve as a port of the entry for the secondary infection. This is a pathophysiology of the skin manifestation in diabetes. Diabetes mellitus lead to the PVD, sensory motor neuropathy, and limited articular movements. It lead to the neuropathic foot, lead to trauma, and associate with the neuroischemic ulcer. It also lead to the autonomic neuropathy. Then it lead to the perspiration, reduced dry skin, callus formation, and there is alteration in the blood flow and lead to the neuropathic ulcer. So various skin lesions seen in the type 1 diabetes like periungual telangiectasia, necrobiosis lipoidica, bullosis diabetictorum, vitiligo, and lichen planus. Some skin problems associated with the type 2 are yellow nails, thick skin tags, diabetic dermopathy, and acanthosis nigricans, acquired perforating dermatosis, calciphylacetes, eruptive xanthoma, and granuloma annulare. Various cutaneous infections also common in patients with diabetes are candidial, dermatophytes, bacterial, and mucormycosis. So what are the classification of the diabetes skin manifestation? Most common is vascular, metabolic, necrobiotic, bullous, infectious, neuropathic, treatment-related, and miscellaneous. So first is a vascular manifestation. In this diabetic dermopathy, there is some skin spots, a multiple round to oval macules over the shins, thighs, forearms, and it is a hyperpigmentation and atrophy. It's twice common in the older men and should have more than or equal to 4 lesions. It is a marker of microvascular disease and high correlation with the diabetic retinopathy. It represents the post-traumatic atrophy and post-inflammatory hyperpigmentation in the poorly vascular skin. In the histopathology, there is endothelial proliferation and pus deposit in the basement membrane of the blood vessels. It requires no treatment. Next one is the rubeosis feci, diabetictorum. It is a rosy redness of the face, evident in the newly diagnosed diabetics. Up to 60% hospitalized patient with the diabetes develop this. It associated with the vascular tone and increase in the viscosity. It is often a sign of the poor glycemic control and return to normal with the improved control. Next one is the erysipelas like erythema. It is a well demarcated red area in the feet and legs. It is a painless and lack of the systemic sign of the infection. It mostly seen in the elderly diabetics. It may be underlying bone destruction and compensatory increase in the peripheral microcirculation due to decrease in the perfusion due to large vessel disease. And there is a spontaneous resolution over the week, but it may reoccur. Next one is the pigmented purpura. It due to the RBC extravasation from the superficial plexus. Some sends paper spots from red macules to orange tan patches. It frequently associated with the diabetic dermopathy. There is an increase in the incidence in the elderly diabetic with cardiac failure, and it is a marker of the microvascular disease. Next one is the periungual telangiectasia. Is very common, seen up to the 49% diabetics. In these metacapillaries and irregularly elongated loops, it often associated with the Nelford erythema and accompanied by the Rh cuticles. There is a functional microangiopathy and tortuosity indicates the structural changes. Next one is a metabolic manifestation. It is a very, very common in the type 2 diabetes obese patient. You very often seen in the OPD, acanthosis nitricans. It is a symmetrical, velvety appearance with verrucous hyperpigmented plaques associated with the papillomatous skin tags. Its most common site is the axilla and the nape of the neck. Another site is hand, feet, and the mucous membranes. And it is a marker of the hyperinsulinemia. Treatment is weight management, keratolytics, and topical retinoid acid. Next one is eruptive xanthomas. It occurs in less than 0.1% of the diabetic patients. Crops of small 1 to 4 millimeter yellow papules with an erythematous halo. It may be pruritic and tender. Most common site is buttocks and extensor surfaces. It appears in association with the elevated triglyceride, and it resolves with the treatment of glucose and lipid. Another next is yellow skin and nails. Its prevalence 40% type 2 diabetes patient, more common in the elderly, is most evident in the distal end of the hallux and caused by the hypercarotinemia and protein glycosylation and products. Another next is diabetic thick skin. Diabetes mellitus generally associated with the thickening of the skin, and it occurs in three forms. First is general asymptomatic but measurable thickening. Second is clinically apparent thickening of the skin involving finger and the hands. And third is the diabetic scleroderma. It is an infrequent syndrome in which the dermis of the upper bed becomes markedly thickened. Lower slide, you just see the pebbly pattern of the skin on the dorsum of the second digit. Diabetic scleroderma, I already mentioned, it is a non-enzymatic glycosylation of the collagen. Site is fingers and dorsum of the hand with limited joint mobility and Huntley's papules. Site is chest, neck, shoulders. There is an increase in the dermal thickness and difficult to tan the skin. There is a body orange appearance. It may be subclinical and may be improved with tight glycemic control. Another next is necrobiotic manifestation. In this necrobiosis lipoidica, its incidence is 0.3 to 0.7% of the diabetics. Total mean age of the onset is around 34 years, more common in females, Caucasian type 1. It is well circumscribed papule, lead to the radial expansion associated with the sharply demarcated, slightly depressed yellow waxy plaques with the erythematous rest border, lead to central atrophy with telangiectasia, start with the necrotizing reticulopathy, lead to the collagen degeneration associated with the granulomatous changes, and followed with the sclerotic stages. Most common site is pre-tibial medial malleolus. Out of that, 15% outside the legs. Ulcerated in 1/3 patient, it persists despite glycemic control. It has the chronic course and 20% remit spontaneously. And the treatment of this intralesional steroids, aspirin, and pentoxifylline. Next is disseminated granuloma annulare. No clearly established association between localized form and diabetes. And in this, it runs a protracted course and symmetrically distributed on the arms, neck, and upper half of the trunk and less open on the legs. Treatment is intralesional, topical, or systemic steroid, isotretinoin, dapsone, and PUA therapy. Next is bullous manifestation. Bullous diabeticum, more common in type 1 and males, usually confined to the feet, occasionally on the hands. It is spontaneous, not related to trauma or the infection. Blister contains steroid clear fluid, rest on a non-erythematous base. It heals in 2 to 3 weeks without starring. There are main three types. First is common type. It clears steroid blister on the tips of the toes and the finger. It heals without the starring. There is an intraepidermal cleavage. Second is hemorrhagic bulla. It heals with stearing. There is a dermoepidermal junction cleavage. And third is the multiple tender non-stearing blister in sun export area. And there is a lamina lucida cleavage. Next is the skin infection in the diabetes. There is a bacterial infection, very, very common. Staph associated with the furuncle, carbuncle, and erythema. Streptococcus pyogenes associated with the cellulitis and erysipelas, and Pseudomonas species associated with the malignant otitis externa lead to cellulitis, osteomyelitis, meningitis, tendinopalsis, and lead to mortality up to 50%. Treatment is IV quinolone. Another is toenail infection and toe web infection. Another bacterial infection are the erythrasma. It is a chronic asymptomatic symmetrical red scaly macerated plaques in the axilla and the groin due to Corynebacterium minutissimum, and treatment is a topical and systemic erythromycin. Another is non-clostridial rash gangrene. It develops in the soft tissue and due to E. coli, Klebsiella, pseudo or bacteroids. Fungal infection in diabetic patients is very, very common. First is Candida. It leads to oral or purlish, means angular stomatitis. Another is vaginal or melanoprosthitis. Intertriginous skin include toe web, peronecia, and nail infection. Another is the dermatophytosis. It due to T. rubrum, T. mentarophytes, and epidermophyton flotosum. And this mucormycosis, we know it's very, very common last 2 years in COVID pandemic area. It is a black crust or pus in the terminate, nasal septum, palate, and orbit. Cerebral involvement in two-third case. Treatment is debridement, IV amphotericin, and treatment of the ketosis. And there is a very, very high risk of the mortality. Next is neuropathic manifestation. There is anhidrosis, hyperhidrosis, and neuropathic ulcer is very common. It is a circular punched out ulcer in the middle of the callosity or a metatarsal heads. Some diabetic treatment related skin manifestation is very common in day-to-day practice due to insulin reaction. Some is immediate, localized or generalized erythema urticaria. Some is delayed itchy nodule 4 to 24 hours after injection. Lipoatrophy is circumscribed depressed area, and lipohypertrophy, soft nodule resembling lipoma and prevented by the rotating injection sites. Some skin effects due to OHA. First generation sulfonylurea has a venous cutaneous side effect like chlorpropamide, tolbutamide, and it occurs in first 2 months of the treatment. Another maculopapular eruption are the most common reaction, and other disappear with discontinuation of the medication. Other cutaneous reaction are generalized erythema, urticaria, lichen node eruption, erythema exudative multiform, exfoliative dermatitis, erythema nodosum, and photosensitivity reaction. Second generation sulfonylurea such as glipizide and glimepiride also been associated with the cutaneous reaction like photosensitivity, rash, urticaria. Some report also suggest metformin also associated with the drug eruption, psoriatiform, erythema, exudative multiform, and leukocytoclastic vasculitis. And pioglitazone we all know associated with the edema. So another next is the acquired perforating dermatomes. Umbilicated hyperpigmented papule with a central keratotic blood. Most common site is extensor surface of the extremities. Pruritus is a major symptoms and strongly associated with the end-stage renal disease. And histology show a transepidermal elimination of the degenerative elastic and collagen fibers. And treatment is the topical tretinoin and phototherapy. It's very, very common in routine day-to-day practice vitiligo or skin depigmentation occur more often in the type 1 diabetic patients. From 1% to 7% of all diabetic patients have vitiligo versus 0.2 to 1% of the general population. And the mechanism behind this is not been elucidated, but some have suggested the past polyglandular autoimmune syndrome. It is a rare immune endocrinopathy characterized by the coexistence of at least 2 endocrine gland insufficiency that are based on the autoimmune mechanism. And patients should be advised to avoid the sun and to use the broad spectrum sunscreens. For localized vitiligo, topical steroid are the preferred, and whereas generalized vitiligo, ultraviolet B light treatment is more effective, and cosmetic treatment is an option for improved well-being. Next is latent planus. It is a polygonal erythematous flat lesions. Site is the wrist, dorsal of the feet, and the lower legs. Oral or genital lesion, white lacy pattern. Differential diagnosis, it contains lichenoid drug reaction, and treatment is topical steroids. So by that, I conclude my slides. Diabetic dermopathy or skin spots, it's considered to be the most common dermatologic manifestation of the diabetes. Skin manifestation of the diabetes may also serve as the port of the entry for secondary infection. A candidal infection can be an early sign of the undiagnosed diabetes. Diabetic scleroderma may present as limited joint mobility of hands, and good metabolic control may prevent the some of this manifestation and may support the cure. Thank you so much.
Thank you so much for enlightening us, Malay, with so many common things which we see in our day-to-day practice. And definitely people have become wiser. We have, at least I have become more wiser looking to your slides, because sometimes we get a lot of patients with this type of problems. And now it will be very easy for us to establish and treat. So next
thank you. And thank you, sir, Ashish sir, Raka sir, for giving me this opportunity. Thank you so much.
You're welcome. Next is my dear friend, Dr. Daria. He will be talking on one of his very nice topic, which me and no, Dr. Abhijit is not there, Dr. Daria. He'll be talking on a very interesting topic, which will keep us all rejuvenated. A consultant physician diabetologist, an effective, very nice worker for the Rajasthan chapter of RSSDI, as well as the upcoming EPICON. He has presented several papers. Very recently, he has received the Governor's Award for the American College of Physicians. So all to you, Dr. Daria, for your presentation.
Thank you so much, sir, for a kind introduction. At the outset, I would like to give thanks Dr. Ashish and Dr. Raka sir for giving me this opportunity to be a part of this Global Diabetes Forum. And in fact, since last 2 days, everybody have seen the extravaganza of this medical science in the diabetes field. And we are already running 1.5 hours late. So because of my 2 earlier speakers are not there, so I am in front of you. And I'm not the showstopper, but but after me, Dr. Ram Kumar will be the showstopper. So let's, Dr. Raka has given me that topic, which is a most debatable in day-to-day.
समय को देखते हुए सही टॉपिक है ना?
So I think each and everybody will face the questions through their patients that, sir, can I take the alcohol in a diabetes or not? So I tried my best to justice with the topic. If something left, please forgive me. So should I share my screen?
Yes, sir.
Okay.
सर आपकी स्क्रीन पे वो ग्रीन कलर का बटन दिख रहा है आपको फॉर द स्क्रीन शेयर?
I am sharing that, but something PowerPoint. Okay. Dr. Raka is laughing. It's not a effect of alcohol, sir. So it's okay. My slides are visible. So let's start.
Yes, visible.
Something wrong, something wrong. So diabetes is an emerging global pandemic, and India is the second largest capital of this diabetes, and it is having a dubious distinction of being the diabetes capital of the world. Along with the diabetes, the alcoholism rates are also increasing in India, and last global survey saying that 55% increase in alcoholism in India over the last 20 years. And this relation between the diabetes and alcoholism, importantly giving the rising trends. Alcohol is metabolized mainly by the oxidative pathways in the liver, and the enzymes involved are the alcohol dehydrogenase, cytochrome P450, and the catalase. The products of this oxidative metabolism of alcohol are mainly the acetaldehyde and the acetate, and which are the main contributor to the cell and tissue damage. A small amount is metabolized by the non-oxidative pathway in the extrahepatic tissue also. So this is a picture which we have learned in our MBBS first year in the biochemistry classes, that by ethanol, with the action of the alcohol dehydrogenase enzyme, it converts into the acetaldehyde, and that leads to acetate, which goes into the finally circulation. But during this pathway, there is a alcohol dehydrogenase enzyme and increase in the reactive oxygen species and increase NADH and NAD ratio, which is responsible for the tissue damage. So now the effect of alcohol on the carbohydrate metabolism. If somebody is taking the moderate alcohol intake, that inhibits your hepatic gluconeogenesis by the 45%. And this is in glycogenolysis decreased by 12% with the moderate drinking. And there is a reactive hypoglycemia, which is because there is if you are consuming a carbohydrate-rich meal and alcohol, which both leads to the exaggerated insulin response, which results in the hypoglycemia after the 2 to 3 hours of your meal. And this alcohol diminishes the increase in your growth hormone, and which is seen as a response to the hypoglycemia also. So the risk factor of this diabetes due to your alcohol, it is a U-shaped risk curve regards to the production of the diabetes. There are so many studies have shown that if there is a consumption of alcohol in moderate quantity, then it is associated with the decreased risk of your type 2 diabetes. And this decrease in risk is higher in women compared to the men of the same amount alcohol consumed. And there is a no protective effect is seen from the higher intake or abstinence. The moderate consumption has been defined as a 5 to 30 gram per day, or the 0.5 to 2.5 drinks per day. And there is a high consumption of your glucose, your alcohol, that is defined as a more than 60 gram per day, is associated with the increased risk of the diabetes. This is a classical U-shaped curve, mainly in women. There is a risk of alcohol taking. The exact cause for this reduced risk is not clear till now, but the hypotheses are saying that this is because of your increased insulin sensitivity and anti-inflammatory effects of alcohol, and some role of adiponectin effect is also there. And this protective effect is influenced by so many things, like which type of beverage you are taking, whether alcohol, whiskey, gin, rum, vodka, and the frequency of drinking, whether 1 pack, 2 pack, or the 4 pack. This obesity and the family history of diabetes also influences the effect of your protective alcohol moderate consumption. The most studies have been shown that there is a decrease in your blood glucose following the acute alcohol intake, because there is an enhanced insulin secretion, a reduced hepatic gluconeogenesis, which is seen mostly in the fasting individuals. And similarly, some conflicting results have appeared regarding the effect of this acute alcohol intake on risk of your diabetic retinopathy and nephropathy. This article was published in Diabetes Metabolism Journal in 2012 April. Come to the heavy intake of alcohol with an increased risk of type 2 diabetes, because there is excess calorie intake and obesity, induction of pancreatitis, disturbance of carbohydrate and glucose metabolism, and impairment of your liver function, which affects our blood glucose levels. And the high intake of alcohol is more than 60 grams in men and more than 50 grams per day in women. This risk is notably higher in women compared to the men. And it also, again, as I told, the types of drink consumed and the amount of alcohol and the calories. These are the common beverages people are taking. This is champagne, light beer, wine, dark beer, and the hard liquor. And everybody is, all the drinks have different calories by the consumption of their total amount of the alcohol taking daily. So as we can say that if somebody is taking 4 hours of champagne, that it will give you the 90 calories, while the only 1.5 hours of that hard liquor. So it is also defined in different proof that some is having 80%, 90 or 100%. And 100% proof of this only 1.5 hours will give you the 125 calories. So what is the effect of this alcohol on your pancreas? The effect on the beta cell function is still not clear, but few studies have shown that this alcohol inhibits the insulin secretion and had a deleterious effect on the beta cells. And the possible mechanism for that this dysfunction of beta cells is because of your heavy alcohol consumption, and that heavy alcohol of consumption is increasing your reactive oxygen species production, and they are the very sensitive beta cells for the oxidative stress. And this ROS, which is a reactive oxygen species production, is the one of earliest event in your glucose intolerance through the mitochondrial dysfunction. Alcohol is associated with insulin resistance and impaired glucose tolerance, condition that precede the onset of your type 2 diabetes. This is the effect of alcohol on pancreas. As we already discussed, that the alcohol mainly metabolized by in the liver with the oxidative pathway and some non-oxidative pathway in the extrahepatic tissues, and finally ultimately leads to your acetaldehyde and reactive oxygen species, which induces your morphological alteration in pancreas and harmful to the cell membrane, intracellular protein and DNA, and liposomal fragility. Some studies have shown alcohol addiction that alcohol elevates the level of beta cell apoptosis, and that is why there is an increased insulin resistance in the liver and skeletal muscles after the alcohol increases. These mechanisms probably play a role in progression of disease as seen in the diabetic alcoholics. Though this alcohol reduces the risk of diabetes in a normal population, but there is a major cause for disease progression is diabetics also. So indirectly, it affects the self-care in diabetics, direct effect on diabetes control, and increased mortality and morbidity of diabetes-related complications. And glycemic control is also affected through the short-term administration of associated with the hypoglycemic. And studies have shown that there is a poor glycemic control in the alcoholics. Heavy drinking also causes your diabetic neuropathy and retinopathy progression. There is a greater risk of hypoglycemia in presence of oral sulfonylureas. Chlorpromide basically reduces the rate of elimination of your alcohol from the blood, and alcohol increases the risk of metabolic acidosis on patient on the metformin. Diabetes commonly co-occurs with your alcohol dependence. There is a higher risk of medical consequences which are seen in diabetics with the alcohol dependence. And as we know that there is a hypertension, GI bleed, sleep disorder, major depression, hemorrhagic stroke, liver cirrhosis, cancers, and others. The relationship between the alcohol consumption and the onset of diabetes, different studies have shown there is a generally beneficial relation between your alcohol consumption and the onset, mind it, in the onset of your type 2 diabetes. But there are variation occurred on the depending amount or the pattern of consumption, type of drink, race, your body mass index, your age, and the gender. So these are the denominator for this consumption and the onset of type 2 diabetes. And recent studies present that there is a risk reduced in the development of diabetes in the moderate alcohol users compared with the non-drinkers. And this reduction up to 30% has already been found in the adults. And this was published in your Journal of Metabolic Endocrinology. So one of the researchers already shown you that there is a U-shaped relation between the alcohol consumption and diabetes risk. Compared to minimal or non-consumption, the risk diabetes is lower for moderate alcohol consumption, while the high alcohol consumption leads to an increased risk similar to that of the non-drinkers. And one meta-analysis found that significant evidence shows that there is a cohort studies from different countries that the consumption of less than 30 grams of alcohol per day is associated with the low risk of type 2 diabetes in the general population. So we can say the people who are taking 1 pack per day or 30 gram alcohol per day is having the lower risk of developing type 2 diabetes. Not at all showed the same maximal risk reduction was 18% with consumption between the 10 to 40 gram per day. The protective effect of alcohol consumption on the onset of diabetes occurred in both men and women, and the highest protective effect was associated with an approximate consumption of 22 gram per day for men and 24 gram per day for the women. So now it has been suggested in New Zealand adult worker, there was a study and they showed the inverse relationship between their alcohol consumption and the incidence of type 2 diabetes in individuals with the normal weight and the overweight. But this study found no protection with the obesity. Another systematic review from the Japanese, they concluded that in Japanese men who are having a lower BMI, less than 22, and taking alcohol intake, there is an increased risk of developing diabetes mellitus. In another multi-center study where the 11,140 diabetic patients evaluated about regarding their alcohol, the 30% shows that they were taking 5 servings of wine and 7 servings of beer or a distillate on the average per week. And out of these, 30% reported, the 4% reported extremely high intake of more than 20 doses for men and 14 for the women per week. And the similar prevalence of alcohol consumption was estimated at 30.9% among the elderly with at least one chronic illness such as diabetes in the US. As per the American Diabetes Association, they recommend that diabetic patients should limit their alcohol intake to 1 daily dose for women and 2 for the men. 1 serving should be correspond to only 340 gram of your beer, 140 gram of your wine, or the 42 gram of your distillate, which can be 80, 90 or 100% with the proof. The risk of hypoglycemia increases in diabetic patients who are insulin dependent or on secretagogues when they consume alcohol. IDF also recommends for a healthy lifestyle that the general population limit their alcohol consumption for up to 2 daily doses, or for diabetics, excessive alcohol consumption should be avoided for a better glycemic control. So finally, I'm concluding my talk that alcohol is having a U-shaped relationship with the diabetes. The moderate consumption of alcohol can reduce the risk of diabetes in a normal population. Abstinence does not afford a protective effect, and the heavy consumption of alcohol can increase the risk of diabetes. So in diabetics, the alcohol consumption can accelerate the progression of disease, adding to their morbidity and mortality. Thank you.
Thank you, Dr. Daria, for a lucid presentation, especially for the way you have presented it with the different slides. Dr. Aka has told me Daria will always present something very different, and you stood up to the expectation. So coming to the concluding session, we have none other than Dr. V.V. Ramkumar. And
thank you, sir. Thank you, Dr. Aka and Dr. Ashish, sir. Thank you so much.
Thank you. And we come to Dr. V.V. Ramkumar, who we kept at this moment because we started with a theme, and Dr. Ramkumar will be justifying the theme, humor, happiness, and peace in diabetes care. So the session now belongs to you, Dr. Ramkumar.
Yeah, good evening, and thank you very much for giving me this opportunity, Dr. Raka and Dr. Ashish. And it's nice to be with you all, and wonderful sessions, and so many people who are happy because you are given opportunity to talk, and wonderful. That's very good. Okay. Can I share my slides?
So you are so happy, Dr. Ramkumar.
And you are ending with the alcohol and laughter. It's a very good ending.
Because it is virtual, so then we need to have laughter and alcohol. Because we would have added together.
To more laugh, we can have SS Daria again.
They say that people call people who drink alcohol alcoholics. but they don't call people who drink Fanta fantastic. That's the
problem. That's why you are here.
That was a good thought. Really. Because I am a fantastic person.
Okay. So, do I have 20 or 15 minutes, Raka?
Time is yours.
Oh,
time is yours. We all just want to be happy.
Thank you very much. And we are going to discuss about humor, happiness, peace, and diabetes. We're going to conclude the conference with this topic, which is a very interesting ending. So, as you know, diabetes can take a tremendous toll on both physical and psychological health. Psychologically, people with diabetes experience rates of depression that are 1.5 to 3 times higher than the general population, and they have twice the rate of anxiety. You know all these things, and there was a lot of discussion. I saw that, and I don't want to go into detail, but I want to show this cartoon. This fellow, he got diagnosed as diabetic, and he is sitting on the cart with all the rounds. You know, it is anti-ant markings. So he's scared that the ants may bite him because he's diabetic. So if you have diabetes, you have so many misconceptions, you're scared, so many things will happen. So what we say is humor may serve as an important buffer to these physical and psychological hazards. If you develop humor, you can come above these problems. Humor has been found to boost the immune system, reduce the risk of heart disease, and lower blood pressure and blood sugar. And psychologically, humor has been shown to decrease stress and combat this depression. All these things, you know all these things. And what we should do is, every time you find some humor in a difficult situation, you win. So if you can take everything less seriously or easily, then you will win. And this cartoon, he is my favorite cartoonist, is Glasbergen. And he says, according to my research, laughter is the best medicine. Giggling is good for mild infections. Chuckling works for minor cuts and bruises. And snickering only makes things worse. So you have to laugh heartfully. And if you want to know happiness, the secret of happiness is find a job you really hate and get fired from it. So if you come out of something which is problematic, you will be happy. So these are all the scores. If you want to assess the patient score, it is called paid. Nobody pays for us. That's why we don't use these scales. And this is the score, what we have to see whether the patient is happy or not, and feeling scared or feeling depressed, worrying about the future, feeling that diabetes is taking too much of your mental and physical energy, and coping with complications of diabetes. These are all the things which we have to go through to improve the happiness or other things. And we have some questionnaire developed by Dr. Carla, and he says glycemic happiness scale for patient and doctors. So even doctors will have problems if you are treating a chronic disease like the diabetes. Do you feel happy and satisfied that you chose to be a diabetes care professional? So all these things are for doctors and patients to know how they happy are there. This is a survey done by Dr. Kalra, and in search of glycemic happiness, interim analysis of the observational survey of persons living with type 2 diabetes, what they conclude is that apart from good glycemic control, a flexible and convenient treatment regimen, level of diabetes education, and their current satisfaction with life are important determinants of glycemic happiness in persons living with type 2 diabetes. So we have to take more, not only glycemic control, but we have to go a bit more than that to assess the happiness. I mean, we have to inquire into their problems, and we have to talk with the family, and we have to give them assurance. And I feel that education is the best part in that. Jocelyn says that education is the best treatment for diabetes. So if you can spend some more time and educate them, they will be very happy. And I usually take 15 to 20 minutes education program in my language, and they will be very happy to hear you. So, and they need so many sessions. And if you spend 15 minutes, they will be very happy because you are spending 15 minutes with each person. It's like that. So try to take this education part. And if you can educate, then you will have better control. And this is the study done in India. And they said that important determinant is diabetes education and flexible and convenient treatment regimen. It should not give very complex regimens. And then apart from that, if you can do all these things, we will have a very good glycemic control. Okay, we wrote an article in one journal, Laughter Therapy in Diabetes. So what is laughter therapy in diabetes is if you can make patients laugh, or if you laugh with your patients, what are the physiological benefits of laughter? They upregulate the genes related to natural killer cell activity in diabetes and thus improve immunity. You know, everybody is talking about immunity nowadays because of COVID. So if you can laugh, they can increase the immunity and modulates the renin-angiotensin system and offers a way of influencing vascular tone. If you laugh, it will even prevent complications also. And well-conducted studies have demonstrated a beneficial effect of laughter on postprandial glucose levels. In Japan, they did a study. They showed a serious film and compared with a comedy show, and they found out that if you watch a comedy show, you will have less postprandial sugar. And if you see the endocrine basis, laughter diffuses the fright, flight, and fight effect of catecholamines. If you laugh, all the catecholamine effect will be going, which serve as a counter-regulated hormones against insulin. These are all against insulin. If you laugh, you will have better benefit. Attenuating the frightening effect of these hormones may help reduce insulin resistance in persons with dyslipidemia. So these are the benefits of laughter. So what is the conclusion of this? Based upon the current evidence, laughter therapy should be promoted as a part of diabetes self-management education and of coping skill training. Laughter should be utilized as a therapeutic tool by the diabetes care team to achieve goal of euthymic glycemia, euglycemia or glycemic happiness, not only in their patients, but themselves. So if you laugh with your patients, you will be happy also. So laughter is contagious. If you laugh with your patient, they will be happy and you will be also laughing. So begin by smiling and laughing yourself. The patient and her family will automatically follow the suit. Find humor and positivity in adversity. You will automatically find an opportunity to achieve health and happiness. So this we should implement in our clinic. So these are all the advantages of smiling. Smiling makes us attractive. If you tell women, they will be very happy. And smiling relieves stress. And smiling elevates our mood. Smiling is contagious. If you laugh, everybody. And people laugh in the same language. And smiling boosts your immune system. Smiling lowers your blood pressure. Smiling makes you feel good. And smiling makes you look younger. If you tell women, if you smile, you will like younger, they will like it. And smiling makes you seem successful. People who smile, they think they are very successful people. And smiling helps you to stay positive. So these are all the benefits of smiling. So how we use laughter therapy? So they classify laughter therapy into two types. One is the classification were operationalized as following. An intervention was classified using humor or spontaneous laughter if some humorous stimulus was mentioned as being part of the therapy, such as humorous jokes or humorous videos. So if you show the patient some humorous videos or jokes, they will laugh. That is called as using humor. That is spontaneous laughter. And another one is not using humor but simulated laughter. If it was specifically mentioned only laughter yoga, which is a non-humorous per definition, or non-humorous laughter was used, or when all elements of the interventions were clearly mentioned, none of them involved humor. So you can use laughter yoga and make them laugh. So what is the effect of laughter on hypertension? They found out that if you laugh, you can reduce the hypertension. Mirthful laughter, laughing heartfully. And effect of laughter and diabetes. I already told you that in Japan, they did a study and postprandial glucose was shown to be lowered by 46 milligrams due to laughter. So laughter is a very good postprandial glucose controller. And laughter and nephropathy. Laughter was found to reduce prorenin levels, and laughter could have been beneficial effect in slowing the progression of nephropathy by acting through prorenin receptor gene and thereby reducing blood prorenin levels. So it can prevent complications also. And you know, when you laugh, there will be release of endorphins, which are natural pain killers. So you can have laughter in neuropathy also. I think they have to do some studies. Okay, let us come to laughter yoga. Okay, laughter yoga is it was started by Dr. Madan Kataria. What are the principles of laughter yoga? Laughter yoga is a unique concept where anyone can laugh for no reason without relying on humor, jokes, or comedy. Laughter is initiated as an exercise in groups, but it will turn into real laughter with eye contact and childlike playfulness. What we will do is we stand in a group and start laughing. And it was named laughter yoga because it uses laughter exercises and yogic breathing. Laughter yoga was started in 1995 at Bombay by a medical doctor, Dr. Madan Kataria, and his wife in a Mumbai park. Now we have these laughter clubs throughout the world, around 120 countries. So laughter should be, to get the benefit, laughter should be sustained at least for 10 to 15 minutes to get the benefits. Natural laughter lasts only a few seconds. So as a laughter yoga is done in exercise, we can have prolonged laughter, which brings physiological, hormonal, and psychological changes in the body, which are beneficial. And the thing is, laughter should be deep, that is belly laughter, using diaphragm to bring all the physiological benefits, which possible laughter yoga clubs. Laughter should be unconditional. These are all the things. Okay, so now we will laugh for a while. So Dr. Raka, you finish your phone call, and Dr. Ashish, you both finish the calls, and we will laugh together. Okay, and I will stop screen sharing and we will laugh together. Okay, so let us start the laughter for a few seconds, 10 seconds. Let us start. As we think we had a drink by Dr. Daria, and we will laugh. Okay, for 10 seconds. Laugh with me.
Arey Daria bhai has de.
I think he didn't get his all call. Maybe that's why he's not laughing. Okay, so what we'll do in laughter yoga is we'll start laughter yoga with clapping. So clap with me. Ho ho ha ha. Ho ho ha ha. Ho ho ha ha. Then we will come into the mood with eye contact. We will be together because laughter is contagious. Then what the second part is we will do is laughter yoga, deep breathing. So what we will do normally, just breathe with me 3 times only. What we will do normally, we'll take a deep breath, hold it and leave. That's what we do normally. We'll try again. Hold it. Right. But in laughter yoga, what we will do is, while exhaling, we will laugh it off. So we will get all the benefits of laughter. So do with me. Take a deep breath. Hold it. Another time. Okay. Hold it. Okay. Another time. Hold it, laugh. So very good. Hey, so what we will do is in the third step, we will become like children. They say that children laugh for 400 times a day, but as we become adults, we will stop laughing. We will be seeing for condition whether why we should laugh, why we should smile. But if children will be happy because they laugh more. So what we will do is with every exercise, we will laugh. So we call it very good. Hey, so whenever you have a problems, go to other room and say this. Very good. Hey, very good. Hey, very good. Hey, this is how children laugh. Okay, this is a childlike playfulness. And fourth important is you should laugh with me. So we will have some laughter exercises. What we will do is we will do some laughter. So from laughter yoga started in India. So what we will do is we'll say namaste laughter. Hold the hands like that. Look into other person's eyes and say, So whenever your wife is angry, try this. But I'm not sure about the results, but you will laugh at least. And we need a coffee break. So what we will do is take a filter coffee. It is called Madras filter coffee in South India. So you take milk and decoction and mix it. Mix well and drink. Very good. Very good. And in life, we need appreciation. I appreciate Dr. Raka and Dr. Ashish for their tremendous work in bringing the program. So whenever you want to appreciate someone, just laugh. Super Raka, super Ashish. Or in the Western style also you can do. Super. If you use more appreciation, you will get better results. Okay. Then if you want to argue with someone, they say that even psychologist says that if the patient is not having very good control, you tell them with laughter, then they will know. So if your blood sugar is very high and you are not exercising, you can tell you are not exercising. You are eating too much. In my area, people say that they like the doctor because he is laughing with them. Doctor is very good because he's laughing with them. So it is one of the trade secrets. If you can laugh, they will like you. Okay. Then, and another thing is vaccination laughter. Due to COVID, we need to take vaccine. But what they say is, if you take laughter vaccine so many times a day, you will be very happy. So take the laughter vaccine with me. Take a syringe. Draw that. Very good, very good. Hey, very good, very good. Hey. And next is, whenever you see a patient's blood sugar, don't get angry. And you see the sugar and say, your sugar is 500. Your sugar is 600. So if you laugh with them, they will take. And they say that if you tell something humorously, they will do more actively. You can get better results if you laugh and tell them. Okay. And finally, my Dr. Madan Kataria's laughter symbol. This is laughing blissfully. This is the best thing you can do whenever you are tired. But you go to the other room and do it. Very good, very good. Hey. Very good, very good. Hey. Okay. Then I have few more slides and I will finish it off quickly. And keep laughing. Okay. So the inhibitory effect of laughter yoga in blood.
You have misconception about generic drug, and you see the misconceptions.
Okay, thank you. So laughter yoga, I told you it has an effect on postprandial blood glucose, and we started laughter yoga club, and what we do to promote laughter is we conduct cartoon competition, short story competition, poetry competition, and we give prizes with one local magazine called Hasyanandam. And this is a cartoon where we gave a prize. This person, he did all the things what showed on television and whatever the people say, and he became like that. So we have to educate the person. And we did first national meet on gelatology and diabetes. And these are my collaborators, Dr. Sanjay Kalra, Dr. Sridhar, Vijay Kumar, and Ram Mohan. And integrating, so humor must be employed in moderation with a careful consideration of the patient's socio-cultural background. We have to be very careful. Use it judiciously. Humor has favorable on both professionals and patients. Trust must first be established for humor to reap its positive health benefits. So what they say is in future, we may give a prescription of 15 to 20 minutes of laughter. And humor is good mood. If you are humorous, you will be happy and makes others happy. Peace means you are comfortable with yourself and others. If you have humor, you will be peace with yourself and others. And if humor is applied by everyone, it will be a better world. He told to talk about peace also. So they call it sense of humor. One should be sensible to apply and enjoy humor. Sense of humor can be learned. People with sense of humor will be more understanding, which makes the world more peaceful. People who use humor think before they talk, which is good. So humor can be learned. You can read this book. And Gandhi once remarked that if I had no sense of humor, I would long ago have committed suicide. He also used humor for peace, and peace begins with a smile. Smile 5 times a day at someone you don't really want to smile at all. Do it for peace. This is Mother Teresa words. So smiling improves peace. So smiling improves diabetes control. And I want to end with this. Om Sarve Bhavantu Sukhinaha. Sarve santu niramayah, sarve bhadrani pasyantu, ma kachit dukkha bhavet, om shanti shanti shanti. This is the Shanti Sloka, which is very good. And it is universal. It's not religious or anything. May everyone be happy. May everyone be free from all diseases. May everyone see goodness and auspiciousness in everything. May none be unhappy or distressed. Om, peace, peace. So this is a Shanti Sloka. And we have a Laughter in Diabetes Therapy study group. Please join us. Thank you, Dr. Raka and Dr. Ashish, for giving me this opportunity. Keep laughing. Very good, very good. Hey, thank you very much.
Hey. we can. It's a very good thing, Dr. Ram. We met at Sri Chitra. Yeah, in diabetic food shop. Okay,
right,
diabetic food workshop. Okay,
right.
So it's a being long journey.
And thank you. You remembered me for so long.
Dr. Bal was teacher, and we were there as a student.
Yes,
so
correct.
it was a great thing. So I am really fascinated by what you are doing, and it's really, but it's very difficult to laugh on 500 and 600 sugar at this. They will beat us. Doctor pagal ho gaya bole.
No, I'm just exaggerating things, but what you should laugh it with the friend. It's not everything should be followed, but for fun. I'm telling you. Okay, thank you very much.
Thank you.
Thank you. Good night.
Now we are going to close the session with the vote of thanks. Dr. Ram Kumar, please remain in the screen. Dr. Ashish is going to give vote of thanks to all of the persons who are here.
Yeah. Thank you, dear friends. This marathon of GDF 2022 was successful because of you people. As we come to close the day, it is actually a very mixed feelings that is coming. There's an ocean of knowledge on one side which has shared. It feels like time was too short to absorb. And yet on the other side, the variety of topics that were discussed in this fixed time frame has amazed me, and the responsibility and the possibility of this being as one of the premier conferences in the field of diabetes in India falls through. I thank the Honorable Health Minister, Mr. T.S. Singh Deo, to coming and joining us in the opening session and honoring our awardees who have done so wonderfully well in the field of human care. I thank Dr. Shrikant, the Registrar of Chhattisgarh Medical Council, for granting us credit hours. I fall short of words to express myself in front of stalwarts like Padma Shri Dr. V. Mohan, our past President Dr. Bansi Sabu, present President Dr. Vasant Kumar, and ongoing to be Dr. Makkad, Dr. Sanjay Kalra, Dr. Unni Krishnan, Dr. Yajnik, my teachers, Dr. Jyoti Dev, Dr. Anuj Maheshwari, Dr. Sunil Gupta, Dr. Bansali, all my teammates, my dear reputers, Dr. Asna, Dr. Ishita, Dr. Hina, Dr. Manisha Khande, Dr. Surajit Patra, Sachin Mishra, Sonika Lamba, Dr. Khare, Dr. Saurabh, Dr. Shailendra Mittal, to all my dear chairpersons, my dear friends, Dr. Muklesh, Dr. Praful, Dr. Aloke, Dr. Patni, Dr. Darya, who have been a part of this conference wholeheartedly. I want to thank each and every person and all the participants who have shown that this vibrant group of enthusiastic and interactive learners can help create magic out of science. Special mention of our event team, the RX team by Hardik, Nirav, Nishad, Ankit, who were at the backup for everything. My special thanks to Dr. Shikha Jaiswal and Dr. Shikha Agarwal for managing the secretariat, who cumbersomely monitored from backstage so that everything on stage looked absolutely flawless and proper. I thank all my pharma partners and our design partners, digital design partners, for their lovely designs and their cohesive support. Special thanks to dear friend Raka Shiore, the brain, the mind behind the theme, spreading happiness and joy among all, with all his mind-boggling ideas cooking in his mind for quite a long time, and our organizing chairman for making sure that these events of such a large proportion could be staged from the scratch without any glitches that got associated with an event of this scale. I must say, the managemental skills are as good as the skills in medicine. This is what I have seen personally since the time I have met. We have become a family. Thank you once again. We look forward to a wonderful session next time around. Special thanks to our lovely family members who have borne with me, especially my daughter, my wife, who used to look me and Dr. Raka working late nights. Special thanks to Dr. Raka's family for tolerating at this moment. And yes, I will not miss out about Dr. Asna and Dr. Ashish. Beyond their illness, they still took part in our conferences. And that is a very great for them. Very special thanks for our theme song singer, Dr. Shiva Shankar, and the person who wrote the lyrics, Dr. Raka, which has become so nice. Thank you, Dr. Ram Kumar, for the final dose touch of happiness and joy. I thank my Almighty Lord, and my thanks to my parents. Especially, I miss my mother because I lost her to COVID. And she would have been very happy to see me joyful and working so hard. And without her grace, it was not possible. Very soon, the next Diabetes Global Forum of Diabetes will give you valuable feedback. Whatever you have, it will be helping us to improve. So it is a tough time to normalize after this hectic activity. Thank you all for being a part of this forum. All I'll say in the end, health, happiness, together, and miles to go before we sleep.
Let's have a theme song. Let's have our theme song again.
Yes, theme song again.
Tech team, please, theme song, second one.
जो आज morning में play किया था ना.
Morning वाला. You can play both of them. चलो हम. This.
Health, happiness, harmony and peace. Health, happiness, harmony and peace. United in care of diabetes. United in care of diabetes. घर से मधुमेह के खुशियाँ ये गुम न हो. सेहत की बात हो, मुस्काने कम न हो. ऐसी ही सोच से आए हैं साथ हम. दिल में विश्वास है, करना है दूर दम. ग्लोबल डायबिटीज फोरम. ग्लोबल डायबिटीज फोरम.
Nice one.
Thank you. Why you didn't sing, Dr. Raka? You should have sang that.
Ashish sing well.
Okay.
आशीष बोलो यार, आज तो हो ही जाए, एक आध लाइन तो हो ही जाए. वो जो तुम्हारा वो था ना जिंदगी वाला, वो जो अभी तुमने लास्ट किया था, जिसमें तुम्हारी लाइफ का पार्ट झलकता है, वो वाला.
Oh, nice.
ना घर है ना ठिकाना, मुझे चलते जाना है, बस चलते जाना. एक राह रुक गई तो और जुड़ गई. मैं मुड़ा तो साथ साथ राह मुड़ गई. हवा के परों पर मेरा आशियाना. मुसाफिर नगर है ना ठिकाना.
रोज कॉन्फ्रेंस करोगे तो कहाँ घर और ठिकाना रहेगा.
Thank you. So now we end a glorious thing.
Thank you, the tech team. Please stop recording. we have
Thank
done.
you so much. Thank you, Nirav.
Recording stop.